1800 भन्दा बढी चाहिँ हामीले रिसर्च प्रोटोकलहरूलाई चाहिँ एप्रुभल गरेका छौँ। यो चाहिँ सुरुको वर्षमा 8वटा 9वटा 10वटा हुन्थ्यो। अहिले हाम्रो चाहिँ 300-400 वटा चाहिँ हरेक वर्ष चाहिँ अनुसन्धानहरू भइरहेछ। त्यो पनि स्वास्थ्य अनुसन्धान परिषदबाट स्वीकृति लिएर भइरहेको छ। त्यसैले यो 25 वर्षको दौरानमा हामीले नेपालमा स्वास्थ्य अनुसन्धानको एउटा संस्कार चाहिँ विकास गर्नको लागि चाहिँ सफल भएका छौँ।
नेपाल स्वास्थ्य अनुसन्धान परिषदको स्थापना पश्चात भने स्वास्थ्यका विषयमा अनुसन्धान गर्ने प्रवृत्ति बढ्दै गएको पाइन्छ। ठूला ठूला अनुसन्धान गर्दा पनि अनुसन्धान प्रस्ताव पेश नगर्ने मात्रै होइन, स्वीकृति बिना नै अनुसन्धान गर्ने प्रचलन थियो भने हाल परिषदको सक्रियतामा साना साना अनुसन्धानका लागि पनि स्वीकृति लिने प्रचलन बढेको छ।
हामीले विभिन्न चाहिँ सङ्घ संस्थाहरूसँग, विश्व स्वास्थ्य सङ्गठन लगायतको अनुसन्धानसँग सम्बन्धित संस्थाहरूसँग हामी मिलेर काम गर्ने कुराहरूमा पार्टनरसिपमा हामी चाहिँ थुप्रै कार्यक्रमहरू सञ्चालन गर्न सकेका छौँ। र अहिले स्वास्थ्य अनुसन्धान परिषद चाहिँ नेपालको स्वास्थ्य क्षेत्रको अनुसन्धानको एउटा चाहिँ सर्वोच्च निकाय हो भन्ने कुराहरूको चाहिँ पहिचान चिनारी बनाएको छ।
स्वास्थ्यमा सुधार ल्याउन र गुणस्तरीय स्वास्थ्य सेवा प्रदान गर्न स्वास्थ्यका क्षेत्रमा अनुसन्धान व्यापक हुन जरुरी छ। अनुसन्धानबाट निस्किएका परिणामले सरकारलाई नीति तथा कार्यक्रम गर्न समेत सहयोग गर्छ। यसलाई अझ अगाडि बढाउन सरकारले अनुसन्धानका लागि पर्याप्त बजेट छुट्याएर यसको क्षेत्र फराकिलो बढाउनु पर्नेमा विज्ञहरूको जोड छ।
गएको समयमा नेपाल हेल्थ रिसर्च काउन्सिलले रिसर्चका लागि, अनुसन्धानका लागि केही प्रायोरिटीहरू तोक्यो। तर सरसर्ती हेर्दाखेरि ती प्रायोरिटीहरू चाहिँ बढी रोगमा चाहिँ फोकस छन्, डिजिजमा चाहिँ फोकस छन् र डिजिजले चाहिँ प्रायोरिटी पाएको छ। मलाई लाग्छ यो 25 वर्षको यो जुन जुबिली मनाइराख्दाखेरि अब नेपाल हेल्थ रिसर्च काउन्सिलले आउँदा दिनहरूमा स्वास्थ्य अनुसन्धानको कुरा गर्दाखेरि अब चाहिँ हेल्थ रिसर्चले कसरी स्वास्थ्यमा एउटा सामाजिक न्यायलाई स्थापित गर्न सकिन्छ, कसरी स्वास्थ्यमा समानतालाई चाहिँ हामी स्थापित गर्न सक्छौँ र सामाजिक न्याय र यो जुन समानतामा आधारित एउटा स्वास्थ्य प्रणाली विकास गर्नलाई चाहिँ यो अनुसन्धानले चाहिँ कस्तो भूमिका निर्वाह गर्नुपर्छ भन्ने चिजमा चाहिँ फोकस गर्नुपर्छ जस्तो मलाई लाग्छ।
बजेटहरूको चाहिँ व्यवस्था गर्नु पर्यो। नेपालमा स्वास्थ्यको अहिलेसम्मको चाहिँ मैले पहिले भने जस्तै कल्चर डेभलप गर्नको लागि मात्र अनुसन्धान भइरहेका छन्। फाइन्डिङ तपाईँको चाहिँ भोलि पोलिसीमा गएर चाहिँ उतार्नको लागि चाहिँ पोलिसी लेभलमा आफ्नो फाइन्डिङहरूलाई चाहिँ युज गर्नको लागि चाहिँ त्यो लेभलको भएको छैन। त्यसले गर्दाखेरि समस्याहरूलाई पहिचान गर्ने सरकार, स्वास्थ्य अनुसन्धान परिषद दुईटै बसेर गर्न सक्छ। के समस्या छ त हामीहरूको टेक्निकल चाहिँ ग्रुपहरू बनाउन सक्छ, त्यो एक्जिस्टिङ छ र त्यसलाई चाहिँ तपाईँको चाहिँ गभर्मेन्टले आफ्नो चाहिँ बजेटको भन्न त रिसर्चमा के भन्छ भन्नुहुन्छ भने तपाईँको चाहिँ नेसनल बजेटको 2%, एटलिस्ट 2% बजेट रिसर्चमा राख्नुपर्छ, सो द्याट रिसर्च राम्रो हुन्छ र त्यसको लागि चाहिँ तपाईँको पोलिसीमा चाहिँ रेप्लिकेट गर्न सकिन्छ, पोलिसीमा चाहिँ युज गर्न सकिन्छ। त्यो हिसाबले नेपाल सरकारले र विशेष गरेर त्यसमा स्वास्थ्य मन्त्रालयले दात्री संस्थाहरूबाट आफ्नो चाहिँ फन्डबाट नेपाल हेल्थ सेन्टर अनुसन्धान परिषदलाई राम्रो बनाउनको लागि, उसको स्ट्रेन्थ, उसको क्यापेसिटी चाहिँ बढाउनको लागि चाहिँ स्वास्थ्यमा चाहिँ तपाईँको हेल्थ रिसर्चको लागि चाहिँ बजेट बढाउनु पर्ने हुन्छ, सो द्याट रिसर्चहरू चाहिँ क्वालिटी रिसर्चहरू चाहिँ हुन्।
अनुसन्धान बिना विकास सम्भव छैन, तर अनुसन्धानको लागि आवश्यक लगानी भएको छैन। जति बेलासम्म अनुसन्धानका लागि लगानी बढाउन सकिँदैन त्यति बेलासम्म गुणस्तरीय स्वास्थ्य सेवामा जनताको पहुँच वृद्धि गर्न कठिन छ। अन्तर्राष्ट्रिय स्तरमा स्वास्थ्य बजेटको 2% स्वास्थ्य अनुसन्धानमा लगाउने प्रतिबद्धता भए पनि नेपालमा यो कागजमै सीमित छ।
स्वास्थ्यको बजेट जति छ त्यसको आधारमा अनुसन्धानको बजेट स्वास्थ्य अनुसन्धान परिषदमा आयो भने हामी अलि इक्विप्ड हुन्थ्यौँ, हामी अलि सक्षम हुन्थ्यौँ र सही सूचनाहरू एकीकृत हुन्थ्यो। यसले चाहिँ लङ टर्ममा अल्टिमेट एम भनेको आम जनताको स्वास्थ्य सुधार गर्ने। आम जनताको स्वास्थ्य सुधार गर्नलाई तपाईँलाई उचित कार्यक्रम चाहियो, त्यो कार्यक्रम गर्नलाई तपाईँलाई सूचना चाहियो।
नेपाल स्वास्थ्य अनुसन्धान परिषदले स्रोत र साधनको अत्यन्तै ठूलो अभाव हुँदाहुँदै पनि मुलुकमा स्वास्थ्य अनुसन्धान क्षमता अभिवृद्धि गर्ने काम गर्दै आएको छ। हालसम्म करिब 4000 व्यक्तिहरूलाई अनुसन्धान सम्बन्धी तालिम प्रदान गरेको छ। बिस्तारै अनुसन्धान गर्ने व्यक्तिहरू र संस्थाहरू विकास भएका छन्। तर यतिले मात्रै पुग्दैन। अनुसन्धानका थुप्रै विशिष्ट पाटोहरूमा परिषदले काम गर्नुपर्नेछ।
नेपाल हेल्थ रिसर्च काउन्सिललाई एउटा नमुना रिसर्च सेन्टरको रूपमा विकसित गर्नुपर्छ। त्यसको लागि ठुलो एउटा कम्प्लेक्स छुट्याइदिनुपर्छ। रिसर्च ल्याबोरेटरी त्यहाँ इस्टाब्लिस हुनुपर्छ। रिसर्चरहरूलाई एट्र्याक्सन दिने एउटा वातावरण सिर्जना गर्नुपर्छ। पोलिटिकल कमिटमेन्ट हुनु पर्यो कि यो रिसर्चलाई चाहिँ कुनै पनि पोलिटिकल पार्टीले नचुने, त्यो साइन्टिस्टहरूलाई नै जिम्मा लाउने, उनीहरूले जुन हिसाबले अगाडि बढ्छन् त्यही हिसाबले गर्नुपर्ने। र WHO ले जुन रिकमेन्डेसन गरेको मेक्सिको 2004 को एउटा रिकमेन्डेसन छ कि रिसर्चलाई टोटल हेल्थ बजेटको कति % छुट्याइदिने भनेर, त्यो छुट्याइदिनु पर्यो। र रिसर्च साइन्टिस्टहरूलाई एट्र्याक्सनको साथसाथै उनीहरूलाई चाहिँ एउटा के गर्नु भने, गर्ने त अल्टिमेटली रिसर्च साइन्टिस्टहरू नै हो, तिनीहरूलाई एट्र्याक्सन गराउनु पर्यो र तिनीहरूलाई सेफ्टी सेक्युरिटीको वातावरण मिलाइदिनु पर्यो।
सबैलाई राम्रो गर्ने भावना रिसर्चरहरूको हुनुपर्दछ। यसको साथसाथै कसैलाई पनि नराम्रो नगर्ने भन्ने भावना हुनुपर्दछ। र सबै क्लाइन्टहरू जुन रिसर्चको विषयमा रिसर्च भइरहेको छ त्यो चाहिँ नि रिसर्च गर्नेहरूको कक्षामा लिनुपर्छ। जसको रिसर्च गर्नेको जति अधिकार हुन्छ, रिसर्च जसमाथि रिसर्च गर्छ उसको त्यति नै अधिकार हुनुपर्छ भन्ने मान्यता हो। अहिले त एनिमल्सहरूमा पनि त्यो मान्यता आइरहेको छ।
अनुसन्धान गर्नु आफ्नो उत्तरदायित्व हो र सबैलाई अनुसन्धान गर्न दिनुपर्छ, तर निगरानी चाहिँ गरिनुपर्छ। समय सँगसँगै आएका स्वास्थ्य चुनौतीहरू र समस्यालाई बेलैमा पहिचान गर्न सक्ने र त्यस्ता समस्याको ठोस समाधान गर्न सक्ने राष्ट्रिय क्षमता विकास गर्न परिषदले खास पहल गर्नुपर्छ।
रिसर्च काउन्सिल जस्तो उसमा त्यस्तो ग्याप हुनु हुँदैन। नम्बर 1, 3 वर्षसम्म रिसर्च नगरेर बस्नु त होइन। त्यो बेला रिसर्च त भयो, त्यही पनि रिसर्चको झन्झन बढाएर पो लानुपर्छ। वी कान्ट वेट फर द्याट। त्यसैले यस्तो चेन्ज नहोस् बाबा। मेरो फर्स्ट कन्टिन्युटी मस्ट बी देयर। अब रिसर्चको त अहिले जुन किसिमले गइराखेको छ त्यो राम्रो हिसाबले गइराखेको छ। हेल्थ सिस्टम रिसर्चमा पनि भइरहेको छ, सबै जुन भाषा भइराखेको छ। तर बिचमा जुन ग्याप भयो नि, त्यो पहिला थाहा छ। म पनि केही दिन त कहिले कहिले प्राइज दिन म जान्थेँ नि, खालि बुङ्ग कस्तो रमाइलो लाग्थ्यो। यस्तो ग्याप चाहिँ नहोस्।
डिफ्रेन्ट लेभल गर्दै एपिकल सिस्टममा बेस चाहिँ ठुलो बनाउनु पर्यो, बेसिक रिसर्च मेथोलोजीमा। त्यसपछि अरू ट्रेनिङ त्योभन्दा माथि गएर पिरामिड जस्तो बनाउनु पर्ने हुन्छ। त्यस कारण हामीले बेसको लागि चाहिँ काम गरेको रिसर्च काउन्सिल डाक्टर पाण्डेको पालादेखि, मत्राको पालादेखि, मेरो पालादेखि भइ नै राखेको छ। रिसर्च ट्रेनिङ वर्कसपहरू त भइरहेको छ। यहाँ धेरैजना गाइड पनि गर्नुभयो होला, पार्टिसिपेट पनि गर्नुभयो होला हामीहरूलाई। त्यस कारण त्यो एउटा चाहिँ नि कन्टिन्युस प्रोसेसको रूपमा हामीले लैजानुपर्छ।
निरन्तर प्रयासले मात्र सफलता प्राप्त गर्न सकिन्छ। नेपाल स्वास्थ्य अनुसन्धान परिषद 25 वर्षदेखि निरन्तर रूपमा अनुसन्धान क्षमता वृद्धि गर्न लागि परेको छ। यो यात्रा अविरल रहिरहनेछ।
अनि त्यो एक त मैले भन्नु त्यहीँबाट पोडियमबाट
Few months ago, most of us had never imagined that NHRC would be conducting a digital summit or organizing a virtual summit. As we learned yesterday that to enhance research culture, leadership makes a difference and it should be context-based. So does this summit is the result of a good leadership and the current context of COVID-19. Namaste, I am Dr. Vijay Bhandari, Master of Ceremony of today's first session, which is based on the theme Interdisciplinary and Implementation Research. Now, I would like to welcome to all the distinguished personalities, scholars, participants, and all the online viewers from different time zones across the globe who are joining with us by means of Facebook Live of our event page, Zoom, as well as YouTube channel of NHRC. On the second day of this virtual summit, 6th National Summit of Health and Population Scientists of Nepal, of theme addressing emerging public health issues through interdisciplinary research. To move forward, I remembered a famous saying which I would like to share here in context to research as well. It is relevant. Either suffer pain of self-discipline or suffer pain of regrets. In context to research, self-discipline will help to follow the pathway of scientific conduct of study, else scientific misconduct can lead to regret later on in the terms of various misconduct issues. Today, we are pleased to have eminent personality as chair of this session, Professor Dr. Choplal Bhushal and DG and Chief Quality and Control Division, Ministry of Health and Population, Dr. Vikas Devkota. Few words to highlight brief introduction of chairs. Professor Dr. Choplal Bhushal is Professor of Otorhinolaryngology from Institute of Medicine. He was past president of Nepal Medical Association. He also served as chairperson of Nepal Health Research Council, former ambassador of People's Republic of Bangladesh. He had many publications in national and international journal. He also served as Senate member in BP Koirala Institute of Health Sciences and National Academy of Medical Science, as well as in Patan Academy of Medical Sciences. He is board member of BP Memorial Cancer Hospital, Chiton, and he also served as member of Health Advisory Committee in Ministry of Health Population. To introduce our next chair, Dr. Vikas Devkota is currently affiliated with Quality Standard and Regulation Division Chief at Ministry of Health Population, and he is very known face to us during the pandemic. He has served the nation as a spokesperson, and day and night he has served to control and contain the COVID-19 spread across the nation. Before that, he also served the nation as Policy Planning and Control Division in Chief and other positions. And in his early career, he has served the nation in various peripheral centers like Butol, Shalyan, and other parts of the country. He has experience of more than 2 decades in serving the nation as a civil servant for 2 years in Ministry of Health Population. He had background of medical doctor in specialization in pediatrics. After the introduction of chair session, I would like to have a list of different presentators of today's first session. They are Adding Van Telzingen, Uttam Babu Shrestha, Sushil Chandra Baral, Archana Shrestha. As we know, we all are all of them are very familiar name in Nepali public health arena, and they are also the dream of many Nepali public health students they dream or think of. And before moving with to hand over this session to the chairs, I would like to call my colleague Namra Kumar Mahato, who want to share a few minutes poem regarding the COVID-19. Please, Namra Kumar Mahato. After the poem, the session will be handed over to the chairs. Thank you.
Thank you, Dr. Vikas. So, I have jotted some few lines for the COVID. So, is it a curse or a boon? When you are born, no one believed your strength. Now everyone are compelled to hold their breath. The so-called scientists thought that now their issues are only the NCTs. COVID, you came to prove them the power of the infectious disease. Yes, COVID, you came as a disaster, costing so much lives. But I doubt if it's a curse or a boon to survive. You have restricted the so-called super creatures, I mean super creatures means humans. You have restricted the so-called super creatures to their residence. On the other hand, bestowing the whole mortals beneficence. That is what we can see now, the environment getting cleaned and everything. As a researcher, you have depicted us our limitation. Now we all commit here to revamp this limitation to occasion. Now we all commit here to revamp this limitation to occasion. Thank you.
Now we should start. Good morning, the presenters and the audience participants. I welcome all the participants and the presenters of these sessions. The theme of the sessions is interdisciplinary and implementation research. Is quite relevant. Over the past few years, interdisciplinary research has grown in popularity, and not just in the field of the health and other areas of the science. So in this context, the researchers should be disciplined, should be schooled in different disciplines, and they work together and they come in conclusions. So today we are sharing the sessions, me and Dr. Devkota. We have a very limited time for these speakers, almost 15 minutes to each speakers. So the speakers will complete their deliberation in time. So with this, let's start from the first speaker. First speaker is Edwin van Teslingen. He is speaking on interdisciplinary research in global public health. Not quite straightforward. Now let me introduce Dr. Edwin. Edwin van Teensling is a sociologist, professor of reproductive health research at Bournemouth University in south of England. He has published more than 30 papers and books chapters. He is a member of various editorial boards based in South Asia, Kathmandu University, medical journals, KUMJ, Nepal Journal of Epidemiology, Journal of Asian Midwives, and the Journal of Manmohan Memorial Institute of Health Sciences. So he is going to present his paper virtually. So he is online? Yes. Please, Dr. Edwin, floor is yours.
Epistemologies are in a particular kind of field. Preferred journals and academic epistemologies are disciplinary research has become much more important. Namaste. Thank you very much for inviting me. Speaking. Namaste. Thank you very much for inviting me. Namaste. Thank you very much for inviting me. Speaking about the issues that might occur when doing interdisciplinary research under the heading Interdisciplinary Research in Global Public Health, not quite straightforward. I'm Edwin van Teylingen from Bournemouth University, and I'm speaking on behalf of my Nepali co-authors, whose names are listed. And we're speaking really from a paper we've written a year and a half ago. It published in the Nepali journal Health Prospect under the title Interdisciplinary Research in Public Health, not quite straightforward, and the link is on this slide. I would like to start with some definitions. There's different ways of looking at interdisciplinary and multidisciplinary research. The terms are often used interchangeably, but they're not the same. So cross-disciplinary is everything. It is multidisciplinary, interdisciplinary, and transdisciplinary. It is across different disciplines. So it's simply a different way of bringing disciplines together. Multidisciplinary, interdisciplinary, and transdisciplinary I put on separate slides as a picture to show what I think it means. So multidisciplinary means several disciplines, but often one lead discipline, key discipline, which are pictured here as bigger, which might be, say, a clinical discipline. Pick, for example, dermatology, a research question that is related to dermatology, to skin problems, and it brings in other disciplines to address that problem. So it might bring in statistics, and it might bring in psychology to address people's perceptions in a large population on their skin problems. Interdisciplinary is more equal, it's the disciplines are more equal, and it's more focused around a research question that covers those three disciplines. So it's not a dermatology question that needs the help of psychology. It's a question that has impact on behavior, therefore needs psychology. It has impact on clinical aspects, therefore needs a clinical discipline, and, for example, on society, and therefore anthropology or sociology. And then lastly, transdisciplinary, trans being overarching, where the problem is overarching the disciplines. So the disciplines are really contributing to the major overall research question, which could be one of those so-called wicked problems in society around the big questions about the environment, about inequality, about pollution, about COVID-19 pandemic. And each of those disciplines contribute to a research question, and the research question doesn't belong to any discipline in particular. So in terms of multidisciplinary research, bringing different projects, different disciplines together on the same project, you bring together different kind of expertise. It's often in applied research, so the Nepal Health Research Council in its nature is often dealing with applied questions that are useful for particular groups of population or particular groups of hospitals or service providers. You bring different methodological skills together: qualitative, quantitative, primary research, secondary research, statistical analytical skills, qualitative analytical skills, and in my case, sociological. Someone else's might be social geography or anthropology or epidemiology. And then obviously you need to have an interest in the topic area. So you need to have an interest in whatever the research question is. But there are a range of potential barriers to interdisciplinary research. So the first one is that this is a kind of applied research that doesn't fit all departments and doesn't fit all academics or their careers. So people who are very focused on a particular kind of aspect of sociology, very good at their job, they're not necessarily good at team working, and especially not with a different discipline that has a different look at the world. The second one is that there is a problem in that it's often a lower status. So blue sky research has a higher status on the big questions in life rather than the applied real life kind of questions. So in terms of health economics, real economists might look down on health economists who are not doing necessarily great theoretical work or methodological work, but they apply their skills and techniques in health economics to address a health question. And then there is also the notion of how others see you. So I picked, for example, nursing, that nursing might be equated, might be seen as similar to using qualitative methods. The second set of barriers are that as academics we gain status from publishing in a set of journals in our field, in our sociology field, in our anthropology field, in our dermatology field, and interdisciplinary research doesn't always fit there. Or if you're working with other people, as a sociologist, I've got quite a few papers in health journals. Don't necessarily have the same value if I apply for a promotion in a sociology job. And then also the second bullet point is that other disciplines treat problems differently, have a different perspective, different methodology, different methods, different preferred methods, and then we might look down on some of those, or some people might look down on ours, that one particular discipline's rules like others' sloppy practices. And there are opportunity costs, especially for junior researchers. If you are about to start a career and you're building a career in a particular kind of field, say psychology, then you need to publish in psychology papers, you need to use psychological kind of research in order to build your CV, your resume, and develop skills in your field. And interdisciplinary research might require slightly different kind of skills, different ways of working and building maybe a different kind of career. The fourth set of barriers on this slide is that we still think very much in disciplines, although interdisciplinary research has become much more important in the last 10 years. We still have departments that are often in a discipline. We've got sociology department, we've got anthropology departments, we've got statistics departments. We haven't got interdisciplinary departments. They are growing. We have interdisciplinary departments that are, for example, in disaster management, where they bring management people, but also people from psychology and sociology or anthropology, geography together. Textbooks are often in a discipline, ways of thinking, preferred methodologies, epistemologies are in a particular kind of field, preferred journals and academic societies. So even in the field of public health, which is in the blue books, which I think is truly interdisciplinary, we still teach our students to think in terms of public health, in terms of population, in terms of communities, which is a particular kind of way of looking at the world and not necessarily the same as general practice or mental health. So the next couple of slides are from our experience in doing interdisciplinary research and the kind of things to think about. Whose rules are you working to? Who's the lead applicant? Is this really a psychology problem and a psychology funded research project, and you're contributing as a statistician, or you're contributing as a nursing researcher? And that goes with the same in terms of the worldview, the research perspectives. Is it within a discipline and not necessarily yours? And also, what's the power between those collaborators? If you're working with practitioners as a sociologist, and the practitioners got the funding from a medical research council or a health research council, they are then also having potentially more power to set the question, to set the methods that we might want to apply. If you're working with doctors, they often have a higher status in society, which doesn't necessarily mean that everybody's absolutely equal in the research team. And then in terms of your discipline, in terms of sociology is about society, it's about power and control. We all live in society, so people might see it as an element of common sense. And the same happens to psychology in terms of behavior. If you are an interdisciplinary researcher, you need to be flexible, you need to be versatile, you need to be able to portray a different role to different people in the team or at different times in the team, different times of the research project. So I'm a medical sociologist or a sociologist of health and illness. I'm also a public health academic. I'm a qualitative researcher. I'm a mixed method researcher. And I'm a topic expert on maternity care, health and migration. And I have a different role, bring different expertise in different projects. So multidisciplinary research doesn't belong to a single discipline. I put it with a question mark, but it is clear and it is not clear, because true interdisciplinary work is obviously between those disciplines. So it's a bit of it is sociology, a bit of it is nursing, a bit of it is psychology or statistics. But it reflects that interdisciplinary kind of research. It's not part of anything. It is driven by the question, which is often applied and falling between those disciplines. It's also often using different methods, multi-methods or mixed methods, and that's often used in the same sentence, mixed methods, interdisciplinary research. But obviously that's two different ways of looking at the world. So you can have mixed method research within a single discipline. You can have a qualitative and a quantitative geographer working together. It's a geography project. It's a single discipline, but it's multi-method. And the same goes for bringing different clinicians together, bringing different methodological approaches or theoretical approaches together. You need to think about where you're going to publish. Are you going to publish in an interdisciplinary journal? Are you going to be publishing in different journals, especially if you're working in a big team? You might publish one paper in a health journal, one paper in a social science journal, one paper in a behavioral science journal from the same bigger study with different lead applicants, but also different ways of writing according to the different disciplines. As a person, you need to have an element of openness and ability to see different perspectives. You cannot work in an interdisciplinary team if you can't at least understand most of what your colleagues are talking about. You need to have a sense of diplomacy, of being able to listen, being able to make judgment, and you know, literally be a diplomat to make the team work. You need to be clued up about your own basic discipline in terms of, in my case, sociology, in someone else's case, public health or statistics. It doesn't really matter, because your team members who are from a very different discipline expect that you know all those kind of basic things that you don't necessarily know. I'm a medical sociologist. I don't know much about the sociology of religion, or I don't know much about the sociology of gender. You need to be able to defend your views and to say, you know, that's a really interesting discussion, but I think from a sociological perspective, there's something we can add. You need to think on your feet. You need to be able to, in big discussions during team meetings, to say, wait a minute, you said that, you said this, what does it mean? How can I contribute to that? And sometimes you need to be able to just keep quiet and think, yeah, I wouldn't have done it that way, but you know, the majority of the team thinks that's the best way. It's not a bad way. Let's try it. And I would leave you with a final thought that in terms of interdisciplinary research, you are representing the discipline. So as the sociologist, the dermatologist, the nurse, the public health researcher, you're translating the task, you know, of your discipline to researchers who are in other disciplines. So you explain sociology to your public health colleagues. You explain nursing and a nursing perspective to your behavioral science colleagues or your mental health colleagues. So you are the ambassador, you are the voice of the discipline, you know, be that sociology or cardiology or dermatology, whatever your discipline is. Thank you very much. I put my Twitter address on in case you're interested, and thank you very much for inviting me to this online Sixth National Summit.
Thank you, Dr. Edwin, for your nice presentation. It's very insight of the subject matter. The question and answer sessions will be at the end of the session. So you will be in online. If there are any questions, we will send you the questions and you will respond. Now, the second speaker is Uttam Babu Shrestha. Is going to talk on importance of interdisciplinary research for addressing emerging public health issues. Uttam Babu Shrestha is a director and research fellow of Global Institute of Interdisciplinary Studies. He has more than 10 years of experience in research, teaching, and project management in various organizations in the US, Australia, Germany, and Nepal. He is interested in interdisciplinary research in environmental science and sustainability. Now, he also Uttam Babu, now floor is yours. Please.
Can you allow me to share my screen? Hello? I just want to share my screen, but the host doesn't allow me to share my screen.
Now, Dr. Uttam,
yeah.
You can go.
You can see my screen now, right?
Yes, we are seeing.
Okay. All right, thank you so much for inviting me. And thank you, Chair, for introducing me. Today, I'm going to talk about the importance of interdisciplinary research for addressing emerging public health issues. Although I'm not a health practitioner, I'm an environmental scientist, but I'll try to bring some interdisciplinary perspectives in next 15 minutes. That is drawn from my learning and experience and engagement in interdisciplinary research over the last 10 years or so. So if you look at the history of science, scientific inquiry begins with questions to satisfy human curiosity. For example, we ask, why birds fly, why stars move, and what is the shape of Earth? This type of questions we initially asked. And at that time, there was no discipline at all. Only there was the questions. So when the questions is small, we can ask them and then we can answer them. But when the question is really big, and we divide them into the pieces, like when the question is bigger, like elephant, in this classic example of 5 blind people or 6 blind people and elephant, you divide elephant into the different pieces and look at the simplified version of that. And so, and try to understand the whole thing in a complete manner. But this is the big problem. If the question is big, as I said, it cannot solve because there is no dialogue between disciplines or these people, so that they define their world on their own worldview. So there is a gap between them, and and that cannot solve the big problem. So you need to go beyond the discipline to solve the big questions. Going beyond the disciplines, one of the classic examples, maybe you know this person, he's Thomas Alva Edison, and this is the classic examples moving beyond the discipline. He's an American innovator, scientist, and entrepreneur. he has developed many applications from gramophone to light bulbs, and one of these is successful invention was incandescent light bulb. And in his time, the problem Edison was facing the longevity of the filament. It's very short-lived at that time, whatever material he tried. And he tried more than 6,000 materials to increase the time of that light bulb, the longevity of the filament. And finally, he ended up with this Japanese bamboo tree. And the filament of this Japanese bamboo tree that long lasts. And after trying more than 6,000 materials, he ended up, carbonized filament of Japanese bamboo, which lasts longer than anything he tried. So this Japanese bamboo is the gift by his co-worker to him. So Edison has moved beyond his own discipline, from engineering, electricity to the botany and natural sciences to solve the problem of this light bulb. And in my research too, in my research on caterpillar fungus, I popularly known as Yarsa gumba, I use the concept of marine biology to estimate the temporal trend of caterpillar fungus. So in marine science, what happens is you estimate the stock of fish that is in the ocean. So the similar approach I try to use in my research in the Himalayas, try to estimate, how the caterpillar fungus or Yarsa gumba has been increasing or declining, try to quantify the trend. And in my research, I use the knowledge, skills, and expertise from ecology, climatology, spatial science, sociology, anthropology, and natural resource economics to solve the problem. Now, our problem today is much bigger than the problem of addition or the issue of the caterpillar fungus that I face in the Himalayas. Today's global problem is much bigger and larger and complex, interconnected, and and these problems, this from poverty, hunger to gender equality, to economic development, climate change. Those sort of problem is much bigger, larger, complex, and interconnected, and no one single discipline can solve them. So we need expertise and skills from the various disciplines and also need a greater degree of collaboration to solve the bigger problem like this. So as I said, we need to go, or we need to move beyond the disciplines and venture into the another disciplines, which we call the interdisciplinary research. So previous speaker has already, defined what is the interdisciplinary research, but I would like to just highlight interdisciplinary research is a mode of research by teams or individuals that integrates information, data, techniques, tools, and perspectives, concepts, and theories between two or more disciplines or the bodies of specialized knowledge to advance the fundamental understanding or to solve the problems. So it's going beyond the disciplines, but today's world, the interdisciplinary is more like a buzzword. But people are using, interdisciplinary, multidisciplinary, cross-disciplinary, transdisciplinary words without knowing what exactly it means. But this small cartoon makes it clear, I think, and I found it very informative. So here, it's a multidisciplinary means, working together between different disciplines, but they don't integrate each other. For example, in health science, you get help from biostatistician or computer scientist in your research, but not necessarily integrate that into your research. But interdisciplinary is kind of integrations and to producing the completely new knowledge. It's a mixing of different disciplines, different worldviews, and techniques and expertise. So the interdisciplinary research, that's why it's more rewarding and impactful and to produce the new knowledge. And the prestigious journal Nature published a special issues on interdisciplinary research in 2015. And they were showing in this graph that the paper, the scientific paper, from 1950 to 2010, and you can see in the graph that the paper which described the interdisciplinary world has been increasing. Particularly, you can see a massive increase after 2000 in the last over the 2 decades of this 21st century. So there is a continuous increase of the papers that describe the interdisciplinary research. Not only the paper, but also the focus on interdisciplinary research has been increased worldwide. And there is a greater emphasis on the collaborative work between disciplines. And the research is not question driven. It's more like solving the problem, like climate change, public health, hunger, poverty, like that. And there is a scientific body, global scientific body like IPCC, IPBES. They are now including interdisciplinary approach more than before. And also there is a rise of interdisciplinary departments in the university and teaching and thesis. And also there are more funding opportunity for interdisciplinary research like Wellcome Trust, National Institute of Health, UKRI, and even in NHRC, there is increase in the interdisciplinary research focus. So the health, the issue of health is truly interdisciplinary. In the same issue of Nature, they plotted the different disciplines to know how interdisciplinary they are. Here at the bottom, the disciplines very less interdisciplinary. At the top, it's more interdisciplinary based on these two figures. Like in x-axis, they plot the papers cited outside that discipline, and in the x-axis, the outside discipline subsequently cite its paper. So you can see health is nearly at the top, showing that health is truly a interdisciplinary subject. So because health is connected to several disciplines, and you can see, in this Sustainable Development Goals, all the 17 goals are connected with health, public health. So it shows that the promoting health is a kind of promoting sustainable development. So now come to the point why health is an interdisciplinary issue. When the disease erupts and there is an outbreak, and you can ask several questions like how a disease is started, how it is transmitted, how it is developed, and how it can be identified and affect the population, economy, and so forth, and how we can treat them. And you can add so many questions here, and you need several disciplines to answer these questions. And I outlined more than 20 disciplines here, from epidemiology to virology to medical informatics to sociology, education, and so forth. So health is truly interdisciplinary. So I think these are the critical disciplines. So now, in the case of COVID-2, it's also interdisciplinary. So this is a cartoon. You can see, from the emergence of this disease to transmission in a bigger community. So recently, National Science Foundation US, they supported one open knowledge network project, which also tried to bring interdisciplinary approach to solve, to provide the information on the COVID and to solve this crisis. And here they are talking about various disciplines, from legal aspects to social aspects, to health aspects, to informatics, to medicine, and also to environmental aspects. And I am an environmental scientist. So let me, in next couple of slides, I will be talking a little bit more about the environmental factors that is linked to the public health issues. So I think because I think the understanding of this environmental aspect is critical, not to understand the disease itself, but to prevent or treat the disease in the future. So it is very crucial, I think. And there was a paper by Smith et al., which shows the temporal pattern from 1980 to 2010 about the global outbreak of the different infectious disease from 1980 to 2010. And they outlined around 215 human infectious disease in that period. And about 2/3 of them is zoonotic disease, the disease that transform from animals to humans, wildlife to humans. So, and the next map is showing, the hotspot of the emerging zoonotic diseases even from 1940 to 2000. So it's a both temporal and a spatial pattern of zoonotic disease, showing that globally the number of zoonotic disease has been increased rapidly. And one of that is now we are facing the COVID-19. So what are the drivers of these emerging zoonotic diseases are? And mainly those diseases are, the drivers of the diseases are human activities, from forest fragmentation to habitat destruction, biodiversity loss, unsustainable agricultural intensification. If you look at the Lyme disease, it's the main underlying causes of that is forest fragmentation. For example, the Ebola is directly linked with the wildlife threat, and the Japanese encephalitis is linked with this intensification of agriculture, which is unsustainable. Now, in the world that we are living today, we are, getting closer and closer to the wildlife, which we are relatively unknown because of this pet trade and our hunger to have the different taste of different exotic meats. So we are getting closer, and also we are changing the wildlife habitat and transforming that and going closer to live to the wildlife. That makes us vulnerable to these zoonotic diseases. Not only us, our closeness to nature that also make vulnerable to wildlife. Like we are giving chimpanzees the polio's. So, and another important factor that I want to highlight is climate change and health. As we know that our temperature is changing and there is a climate change. And the climate change has impacted virtually every aspects of ecology and everything in the earth. But more importantly, that has changed the distribution of the vector that like mosquitoes distribution. So, and you might have seen the several papers like Meghnadji and others have done in Nepal too, and globally, the distribution of this mosquito has been changed. And as you know, mosquito is the most dangerous predator, killed almost like more than 30 billion people so far in the world. So, and that distribution has changed due to climate change, and that has impacted the disease like dengue and Zika and so many diseases. And another environmental factors this I want to highlight is air pollution, which kills almost 7 million people worldwide for a year. And that has impact, public health, and which is very crucial. And in the case of COVID-2, the more the polluted area is, the death of the COVID is higher. That is the findings of the study done by the colleagues from the Harvard University. So just wanted to highlight that the health issue is truly interdisciplinary issues, and we cannot rule out the importance of the environment on the issue of environment on public health. And now realizing this importance, there is a truly interdisciplinary approach, which we call One Health. And so it combines, the planetary health and different disciplines with the public health. And luckily, I wrote an op-ed piece like 3 months ago in Kantipur, Delhi, that we need healthy planet to make people healthy. So that's the argument I made in that article. If you want to look at it in the web. And luckily, just yesterday, the UN agency, they published this report, and they said that to prevent these zoonotic diseases like COVID-19, we need to take care of this planetary health. And planetary health is essential to make other people healthy. Thank you so much. This is the end of my slide. Thank you so much for listening and inviting me. If you have any questions, I'm happy to answer your questions. Thank you.
Dr. Uttam, thank you very much for your elaborative and self-explanatory presentations. It's a very nice presentation. Please stay with us. There will be questions, answer sessions at the end of the session. Stay with us now.
Good morning, everyone. We had 2 presentations, very nice presentations. Questions are there, so we request presenters to stay with your time. The questions will be at the end of the presentations, all presentations. So without any delay, I would like to invite our third presenter, Dr. Sushil Chandra Baral. Introducing him, he is an experienced health and development expert. He has a specialization in health systems strengthening and health policy and planning at the national and international level. He has 25 years of experience in research and also development in health systems and services, health policies and planning, operational research, project management, and social development sectors, especially in developing countries context, especially more in South Asia. He is working closely with Ministry of Health and Population too. So I would like to invite you, Dr. Sushil Chandra Baral, and the floor is yours now.
Thank you very much. Respected chairs, my gurus, you have been always inspiring in my throughout journey. Particular privilege to present our paper in front of my gurus who I learned very much. Namaste everyone, those people who are watching from different locations, a very warm welcome to my presentation, which is, I'm going to talk about a little bit more on the practicalities of the interdisciplinary research, how we implement it. We have heard from the previous 2 speakers, it is not a straightforward science. It is a complex, but complexities has to go to the reality and implement, understand, refine it, and come up with the answers that we are collectively looking for. With this note, I invite you in my presentation, which is about, I'm sorry, a bit. It's interdisciplinary research. We are having an approach to community-led solutions for emerging public health issues in Nepal. I'm talking about one of the research projects supported with the other colleagues, myself, Abriti, Romi, Asim, and colleagues from University of Leeds in the UK, Professor Paul Cook and Rebecca, and a lot of community people. I will start my presentation with the film developed by the community people. Please have a look, deep look about on the film that itself talks about the journey that we took in order to implement the interdisciplinary approach in terms of understanding the antibiotic resistance using One Health approach. May I request our colleague to play the video?
एन्टिबायोटिक प्रतिरोधको मारबाट नेपाली समाज अछुतो छैन, तर एन्टिबायोटिक प्रतिरोधको वास्तविक प्रभाव नेपाली समाजमा कस्तो छ भन्ने बारे स्थानीय समाधानको विषयमा थप अध्ययन हुनु जरुरी छ। यस क्रममा नेपाली समाजमा एन्टिबायोटिकको उपलब्धता, प्रयोग र एन्टिबायोटिकको प्रतिरोधको बुझाइ र स्थानीय स्तरमा यसको समाधानका बारेमा काठमाडौँ उपत्यकाका 2 नगरपालिका चन्द्रागिरी र मध्यपुर थिमीका 2 समुदायसँग 1 वर्ष अगाडि सहभागितामूलक अध्ययन प्रक्रिया सुरु गरियो। समुदायका सदस्यहरूलाई जनस्वास्थ्य समस्या, सामाजिक संस्कार तथा संरचना र सिनेमाको कलासँग परिचय गराउँदै एन्टिबायोटिक प्रतिरोधका मुद्दाहरूमा छलफल गर्दै स्थानीय स्तरमा समस्याको समाधान खोज्नु चुनौतीपूर्ण काम थियो। त्यससँगै मुलुक संघीयतामा गइसकेपछि आधारभूत स्वास्थ्य सेवाको सुनिश्चितता गर्ने जिम्मेवारी पाएको स्थानीय सरकारसँगको सहकार्यमा यो मुद्दामा काम गर्न पाउनु आफैमा अवसर पनि थियो। यी चुनौती र अवसरहरूसँगै अनुसन्धानकर्ताहरूले सहभागीलाई सक्रिय रूपमा भाग लिन अनेकन तरिकाले प्रोत्साहित गर्न थाले। सुरुमा अप्ठ्यारो माने पनि क्यारन अर्थात् कम्युनिटी आर्ट्स एगेन्स्ट एन्टिबायोटिक रेसिस्टेन्स इन नेपाल नाम दिएको यो कार्यक्रममा सहभागीमूलक क्रियाकलापका माध्यमबाट विस्तारै सहभागीहरू खुल्न थाले, रमाइलो मान्न थाले र एन्टिबायोटिक प्रतिरोधका आफ्ना भोगाइहरूका बारेमा एक आपसमा छलफल गर्न थाले। समुदायमा रहेका समस्याको पहिचान र तिनको समाधान खोज्दा समुदायको अग्रणी नेतृत्व हुनुपर्छ। समुदायले आफ्ना सदस्यलाई अनुकूल हुने गरी सामूहिक रूपमा गरेका निर्णयको सम्मान गरेमा मात्र त्यस्ता कामको स्वामित्व समुदायले सहज रूपमा लिन्छ। अनुसन्धानकर्ताहरूले यो मूल मन्त्रलाई आत्मसात गरेकाले नै समुदायका सदस्य सक्रियताका साथ संलग्न भए। क्यामेरा समेत नछुएका समुदायका अधिकांश सदस्य क्यामेरा मात्र होइन, छायाङ्कन गरिनुपर्ने सर्ट साइजका बारेमा बुझ्न थाले, कथा बुन्न थाले र पटकथाका माध्यमबाट कसरी एउटा फिल्मको विकास गर्ने भनेर सोच्न थाले। यी कथा, पटकथा र फिल्मका बारेमा छलफल हुँदा पनि मूल मुद्दा चाहिँ एन्टिबायोटिक प्रतिरोध नै रहिरह्यो। समुदायले खिचेको र बनाएको कथामा प्राविधिक टोलीले सम्पादनको काम मात्र गर्यो। यस बीचमा दुवै समुदायले आफूले दुःख गरेर बनाएको फिल्म र आफूले जानेका कुरा आफ्ना टोलबासी मात्र होइन, नगरपालिकाका पदाधिकारीलाई पनि देखाए। स्थानीय सरकारका निर्वाचित पदाधिकारीहरूले समुदायमा भएको कामको स्वामित्व लिँदै समग्र प्रक्रियालाई आत्मसात गर्नु र त्यसलाई अझ विस्तार गर्ने प्रतिबद्धता आउनु आफैमा उपलब्धि हो। आफ्ना दाजुभाइ दिदीबहिनीले बनाएको फिल्म हेर्न आएका समुदायका अन्य सदस्यहरूले फिल्मसँगै एन्टिबायोटिक प्रतिरोधका मुद्दाका बारेमा ज्ञानको दायरालाई बढाए। समुदायले फिल्म बनाएर देखाएपछि सामान्यतया कार्यक्रम सकिन्छ, तर समुदायले स्वामित्व लिएको कार्यक्रम भएकाले यो समग्र प्रक्रिया र उपलब्धि समुदायको स्वामित्व बनेको छ। त्यसैले त अझै पनि समुदायका सदस्य एन्टिबायोटिक प्रतिरोधका मुद्दामा जनचेतना जगाउन सक्रिय छन्। एन्टिबायोटिक प्रतिरोधको शिकार हुने समुदायका मानिस नै हुन्। त्यसैले उनीहरूलाई नै यो समस्या विरुद्ध परिचालित गरेर विश्वव्यापी समस्याको स्थानीय समाधान खोजिनुपर्छ।
Watching the film, let me tell a few words about this short film developed by the community people. there is a journey, there is a process involved, how we brought various multiple disciplines together in order to enhance the community engagement for a noble cause, which is antimicrobial resistance. What we learned when we conceptualized this research, we brought multiple disciplines together. One is public health, which is more about the antibiotic and how the antibiotic been used at the community level. The second is social science. There's a lot of behavioral aspects involved in terms of use or misuse of antibiotic drug in the local community without having social science discipline integrated in this research. It was unthinkable to understand the local practices. We also brought arts and humanities together. You have seen a film component, which is a co-creation by the community after having an understanding about the local issues, how they wanted to pick up the local issues, capture in these cameras and photos, and as narrated in the film, many of them never touched camera before, but they started using it very happily and made a film with the community. Also, we brought other disciplines together, which is environment and agriculture. So with this blend of multiple disciplines in an approach of interdisciplinary research, we went through the participatory community engagement. What we did, getting all disciplines together, it's easier to say than it's done, bringing multiple disciplines together, because we have been practicing working in silos. I recall the discussion from yesterday, panel discussion, as lots of panelists also said that we are enjoying silos. We have our own, we're in the same boat of research, but we row our boat on our own direction. So first is important getting all the disciplines together to understand the issue, and then blending it and making truly interdisciplinary, having extensive dialogue across the disciplines in order to inform the design and conceptualization of research. Then it leads to the understanding of the local context, which then identify the locally researchable problems, issues. This is how we did in this current project. Then what were the key considerations that we actually learned? Our lessons in this is bringing together multiple people with a different understanding, having different mindset, different skills, different behaviors, but residing in the same community. So this is not to be forgotten that this is a co-creation research with the community with their greater participation. It's not only all the researchers what they think appropriate for the community, but all the issues was basically generated by the community after having an understanding about the multidisciplinary research. Contextualization. It's very easy to say and it's defined, but how do we contextualize in reality is important. What are the approaches that we undertake in terms of contextualizing? Understanding the context and contextualizing your tools and approaches and research questions and whole the processes, considering the tailoring. I call normally it's a tailoring to the local context. Then flexibility is very important. One size doesn't fit for all. I make the decision as a team of researchers right now, and that may not be applicable. We need to be more iterative and responsive to the emerging issues and be able to flexible in your research approach, which is pretty much about the implementation research. The next colleague will be talking on that. Developing similar understanding, another great challenge, but it's a key stage of the interdisciplinary research that we experienced. And equitability in terms of all the stakeholders. We often go to the community, but forget the essence of the community in terms of integrating, in terms of really getting them. And equitable partnership in research is very important. How do we acknowledge the fact that there's a greater asset in the community that informs your research, and there is a equality in terms of sharing the research pie with the community? It's very important. The stakeholder engagement, there are multiple stakeholders in interdisciplinary research. How do we engage that? exchanging the knowledge, creating a conducive platform in terms of exchanging the knowledge. That's how your issues are more deepened and understood locally better, and then ultimately leading to community-led solutions to the global problem like antimicrobial resistance. That's what the practical considerations we found. Then what it led to, when we delivered it, it led to identifying the local issues from the multiple perspective. So we were not missing many parts of the essentials that we had to deliver. And the second is the developing the local champion. Now in these two research sites, we developed the local champion, community champions. Now they are the heroes against the antimicrobial resistance in their community. They create awareness. And there's increased ownership because greater co-creation with the community led to higher ownership by the community of the product that we developed. Stakeholder engagement, particularly the policy impact. Engaging local government in a federal context, engaging mayors, deputy mayors, and various committees at the ward level as well as the municipal level in this process has really led to the uptake of the research at the local level. Now all the product, that's 6 films been developed by the community, is been owned by the municipality and then been shown in a number of programs. Community awareness, another thing. Acceptability. Once you start knowing them and you start talking their language, you are more acceptable than just being a researcher from outsider. And the greater impact, it's community issues and applicable to local solutions, adhering to the local cultural practices. This is my second last slide. I also want to talk to challenges. It is not, as I said, interdisciplinary research. It looks very fascinating in definition when we read it. But how that is applicable in local context. What are the challenges? What we face in design and the implementation stage is the combining practical approaches from multiple disciplines. We speak our own language. Environmentalists speak their environmental language. We as a health researcher, public health researcher system, as Professor Edwin mentioned earlier in his first presentation, that we speak our own language. But combining these practical approaches and informing our tools and methodological part has been cumbersome, but we can overcome it. The ethics, given that it's an interdisciplinary nature of the study, obtaining ethical clearance. Is it NHRC? Shall we go to agriculture, NARC? Shall we go, where should we go in terms of taking the arts, filmmaking? Who provides the ethical clearance for this? It's truly interdisciplinary, but is there a single institution where we can have that? Also, the practical application of the ethical essence when we implement the research at the community level. Because this film is made by community participants and making them aware about research ethics because they take images, footages in their local community as they see that's triggering antimicrobial misuse or better use. Then ethical issue in terms of practical is also a question. The third is evaluation. We're bringing multiple approaches together, multiple disciplines together in order to deepen the understanding of the issue. So it's not straightforward to have straightforward evaluation parameters, mechanisms. Multiple methods is required to measure the impact. And how does it impact to the health? How do we measure the outcome? What are the approaches? What are the methodologies? That were the challenges. My final slide with the key message that there are difficulties, but it is feasible to implement interdisciplinary research in our context, but you need to be more adaptive to the local situation. You require interdisciplinary engagement, understanding issues from the multiple perspective rather than only looking at the public health dimension on it. Community engagement, extensively key matters here, which creates a greater accountability and ownership and appropriateness. Ultimately, that leads to the sustainability of the intervention that you develop with the community as a co-creation. Co-learning and co-creation is very important, and it has really motivated self-motivation and led to the behavior change in the community. Building on local capacity. We often talk about borrowing various things from international community. But we do have greater asset in our community. They may not speak research language, but they know their issues. They know how to tackle the issues at the local level. empowering them and making them change maker is what we learn. And community-led solutions. Yes, there are solutions at the community. What we need to design an effective approach to understand those solutions which are effectively lying at the community level. With this note, I really want to acknowledge the Ministry of Health and Population, NHRC, for ethical clearance of this research and support in terms of evidence uptake to policy. We had a big 3-day workshop, international workshop, in collaboration with NHRC. Chandragiri Municipality, local government, Lokanthali Municipality, Lokanthali is the area, but the Thimi Municipality, and all the study participants, Karen Research Team, and University of Leeds. With this note, I thank you very much. I hope I took 3 minutes more. I'm sorry for that, but thank you very much.
Thank you, Sushil. Thank you for putting very comprehensive things in a simple way. That's very interesting. So now our next speaker is Archana Shrestha. Introducing her, Dr. Archana Shrestha is an associate professor at the Department of Public Health at Kathmandu University, School of Medical Sciences. She's also assistant professor adjunct at the Department of Chronic Disease Epidemiology and Center of Methods for Implementation and Prevention Science, LA School of Public Health, New Haven, USA. She is a director of Institute of Implementation Science and Health. She is a chair of the Global Research on Implementation and Translational Science Coordination Committee, leading a consortium of 8 countries on implementation research. She will be talking about the promoting implementation research using an interdisciplinary approach. So now I would like to invite Dr. Archana Shrestha for her presentation.
Good morning, everyone, and welcome again to this session. I'm going to briefly talk about promoting implementation research as an interdisciplinary approach. First of all, I would like to give a quick introduction to implementation research. It can be defined in many ways. However, I would like to put it as the scientific methods and strategies that facilitate the uptake of research results into regular use by practitioners and policymakers to improve population health. So you might be thinking, why do we need to study methods and strategies again if research has already provided a solid evidence? Well, I would like to provide you a small glimpse of why we need to study further and beyond our research result. So here is the world map showing the distribution of child deaths. Each red dot indicates a child death. In 2003, there were 10 million child deaths. 50% of these happened in 6 countries, and 42 countries accounted for 90% of these child deaths. The main causes of child deaths were well understood. They were diarrhea, pneumonia, measles, malaria, HIV/AIDS, birth asphyxia, preterm delivery, neonatal tetanus, and neonatal sepsis. And when we look at the evidences that prevent child deaths in the same year, there were 23 evidence-based interventions that had been proven to prevent or treat all of these main causes of child deaths. However, the global coverage for the most of these interventions was below 50%. And had these interventions been scaled up to cover 90% of the children, then we would have prevented more than 6 million child deaths. So clearly there is a big gap in what we know and what we do. So if we focus the no-do gap by implementing the evidences that we already know, then we can avert child deaths 88% due to diarrhea, 65% due to pneumonia, 91% due to malaria, 100% due to measles, and 48% due to HIV/AIDS. In contrary, if we focus on inventing new technology, we would be able to avert only 40% of child deaths by diarrhea, 29% by pneumonia, 23% by malaria, 10% by measles, and 3% by HIV/AIDS. So clearly, we get most benefit in population health by implementing and scaling up the known evidence-based interventions. Unfortunately, McLean in New England Journal of Medicine reported that it takes an estimated 17 years to only 14% of new scientific discoveries to enter in day-to-day practice, and this is alarming. So coming back to my first slide about what implementation science research is. So this is the study of methods and strategies that facilitate the uptake of research results, that is what we know, into regular use by practitioners, that is what we do, to improve the population health. Thereby, it bridges the no-do gap. Multiple approaches are used in isolation or in combination for implementation research. To name some of them: surveillance, health policy research, stakeholder engagement, dissemination, impact evaluation, economic evaluation, quality improvement, social marketing, and this is not a complete list. And even after looking at only this list, it is clear that we need an interdisciplinary team to conduct an efficient and impactful implementation research. So now I'm going to briefly share with you all the implementation research capacity building program that we lead from Kathmandu University School of Medical Sciences, and how we incorporated interdisciplinary approach to implementation research. We have four main aims. The first is to create a multi-sectorial, multidisciplinary collaborative team. Second, to assess national level infrastructure and capacity. Third is to identify and prioritize health needs. And lastly, to develop an actionable implementation research plan. So if you look at the first aim itself, it guarantees the involvement and active participation of multidisciplinary team. So we started with a team of investigators from different disciplines who are established leaders in their field of work. We had leaders from clinical background, epidemiology, community medicine, qualitative research, and policy research. Through a national level competition, we selected 22 fellows to develop them as future leaders in implementation research in Nepal. And we deliberately made our selection criteria to include professionals from different disciplines, and we successfully recruited professionals from public health, clinical background, nursing, community medicine, basic science, and pharmacy. So our team was very diverse. We also had partnership with different universities and agencies in Nepal, United States, China, and India. And all of these partners brought their expertise in building this interdisciplinary network of professionals in Nepal. And these experts and fellows and investigators came together to build interdisciplinary capacity. And there was a lot of cross-disciplinary interaction. For example, a cardiologist was learning qualitative research, an epidemiologist was learning leadership and management, a nurse was learning grant writing, and so forth. And all of these people from all of these different backgrounds were learning these multiple disciplines. And at the same time, they were learning to work together. So our fellows worked as a team coming from diverse disciplines. During the course of their training, they have already had multiple publications. They've presented and advocated for bridging the no-do gap. They do implementation research workshops to build capacity of other people. They've conducted a holistic health system research to assess gaps and needs. They have engaged stakeholders in their respective areas. They have already acquired grants on implementation research. So by working in a team, they have been able to achieve at multiple levels. We work in Nepal, but we are the part of a larger global research in implementation and translation science. It's called GRIT, with other participating 7 countries. Nepal currently chair the coordination committee of GRIT, and the 8 countries, that includes India, Vietnam, Ghana, Malawi, Kenya, Rwanda, and Guatemala, work globally to build implementation research capacity through interdisciplinary approach. This is just a picture of our GRIT CC coordination committee. So lastly, to sum up our experience so far, we value 4 critical key components in promoting implementation research using an interdisciplinary approach. First, implementation research is enhanced by partnership and networking between researchers, policymakers, and program implementers from various disciplines. These partnerships establish a foundation for translation of knowledge into practice. Second, the capacity building program, so far from our experience, should be designed considering feasibility, sustainability, and local relevance, aligning with national priorities. Because implementation research is very contextual, it varies by where we do, how we do, and who does it. Third, motivated and diverse trainees commit designated time for completing courses and conducting implementation research. So they strengthen themselves as researchers, and they strengthen the system and implementation research culture. And finally, we advocate for a strong mentorship. The implementation research field is so new to this world, and the early career researchers should be really guided by experienced and competent mentors that are willing to provide guidance in the best interest of their mentees. So finally, I'm closing with this quote by Lawrence Green. If we want more evidence-based practice, we need more practice-based evidence. The floor is open for discussion.
Thank you, Dr. Archana. So now we'll have the question and answer sessions. Yes, so we'll start from
first speaker.
Yeah, okay, sir.
So again, good morning. The first speaker, Dr. Edwin van Teslingen. He has no questions, maybe because of the his presentation is quite simple and self-explanatory presentations. I think all the audience, they understand easily. So for Edwin, no questions. Thank you for your presentations. Now, the second presenter, Uttambabu Shrestha. From the audience, you have a few questions. From Jivan Bahadur Shechan, is a professor of Institute of Medicine, a retired professor. He asks about how we can obtain concrete finding from interdisciplinary study to materialize policy in Nepal. Dr. Uttambabu, you are hearing us? Dr. Uttambabu?
Yes, hello. Can you hear me?
Yes.
Oh, cool. Well, Mr. Bhusal and Dr. Sher Chand, one of the challenge, so the answer to these questions and the other questions I have seen in the chat, group chat, I'm trying to give the, the answer to that as well. This is a challenge, and the experience that I have while working in the global science and policy interface like IPBES, Intergovernmental Panel for this Biodiversity and Ecosystem Services. What I have learned, and is the previous speaker, Dr. Baral, Dr. Sushil Chandra Baral, highlighted was you know, how we can integrate this interdisciplinary researches. There is a cycle of the interdisciplinary research and the policy making. I think, and as Dr. Baral highlighted, and I would like to reiterate that, you know, we need to co-create or co-evolve the knowledge system from very early on, like while defining the problem, while defining the issues, to optic the findings. You know, there is a cycle, like you need to do scoping, and you need to define the questions, and you try to come up with the methods, and you try to synthesize them, and these are the all steps, and in every steps we need to work together, and we need to have a more dialogue and co-create or co-evolve the knowledge that will then acceptable for the policymakers and also for the all stakeholders. I think if I can answer that correctly.
Thank you, Gautam. You have some more questions. I will read all the questions, and I think they are interconnected, so you can answer all the questions in one time. In the Dr. Surya Babu Parajuli is asking, in the current context of Nepal, what are the ways to promote interdisciplinary research and at province and local levels? What are the possible approaches? How do you integrate medical colleges, academia, government, media, public, etc.? And from Ram Bahadur Khadka, he is asking how our country can easily step forward to increase the rate of interdisciplinary research from local and community levels. Uday Narayan Yadav asks, how to create a common language in multidisciplinary research team. Dinesh Bhandari, what is your call on difficulty in establishing epidemiological consensus among different stakeholders and team members in an interdisciplinary research team? And lastly, Raj Kumar Mehta, he asks, how to make interdisciplinary research acceptable from them, since there are status quo among the interdisciplinary team, mostly in our part of world. What is your take on that? What is your take on that? Please, Uttam Babu.
Thank you so much. I'm not sure if I can answer all these questions correctly, but I'll try my best to answer them. One of the thing, you know, how can we promote interdisciplinary research in Nepal? Just try to answer, you know, like it's not the problem of Nepal. It's a global problem, I think. The challenge is there. You know, we all have been talking about interdisciplinary research, but try to try to do it and try to apply it in policy is a real challenge. There are epistemological challenges, and there are so many challenges. But one thing that country like Nepal can promote interdisciplinary research is, we have to promote interdisciplinary thinking from the early on, or in our curriculum, or in our universities and colleges. One thing, which is, I think, very lacking. Like, we try to focus on producing more specialized discipline rather than the generalized kind of generalist. Generalist, I just want to emphasize two examples. One is Roger Federer, and another is the Tiger Wood. This is two typical examples. One is a kind of generalist. Roger Federer, he plays everything, which is like oval, from tennis to basketball, volleyball, everything. But the Tiger Wood, he, since early as like 2, he was focusing on only golf. So now, both are equally, impactful. But what I would like to emphasize is the generalist is more relevant, because, as I said, they will know all disciplines, and so that they can value and also recognize, and that makes them open too. So that's the one thing, try to make more Roger Federer than the Tiger Wood, if I can use this metaphor. Another thing is that one of the challenge of not in Nepal, भनिन्छ नि पोलिसी राम्रो हुन्छ तर इम्प्लिमेन्टेसन चाहिँ राम्रो हुँदैन भनेर भन्छ नि, हैन? तर मलाई चाहिँ, I always question on that notion that how can a policy is good without having an implementation, हैन? Implementation नहुने policy कहिले राम्रो हुन्छ र हुँदैन नि, हैन? We need to question that, I think. And the basic fundamental problem there is we don't engage with the diverse stakeholders in policy making. We don't like a community, policymaker, experts, and diverse experts. They don't sit together while scoping the policy to uptake of that finding. So one of the problem of the policy making of Nepal is that, so they don't sit together from early on to at the end. I think we need to practice that, and based on my experience in this intergovernmental body like IPCC, where I work to publish the global report on biodiversity and ecosystem services, that in that report, they have started engagement with the public, policymakers, all the stakeholders from early on, and now after publishing the report, and they are engaging with them for the uptake of the finding. So that's one best practice we can do. And another thing is how can we make the multidisciplinary language? I think there is a challenge, and it's not the challenge in one front. It's a multiple front challenges in multi-front. As I said, there is a challenge in the university or academia. There is a challenge in policy front. There is a challenge in funding agency. There is a challenge in job market, for example, like the interdisciplinary researcher. If you say I'm an interdisciplinary researcher without having a particular hold in particular discipline, it's very hard to get a job. So there are so many challenges, but since this is the evolving field, I would say, and so we are learning by doing, and to make a common language, I think we need to have more dialogue and openness and try to collaborate more. That's the thing I could say.
Okay.
Thank you.
Okay. Thank you, Dr. Shrestha, for your response to the questions. Now there are a couple of questions to Dr. Sushil Chandra Baral. Dr. Dev Kota will read the questions.
Okay. There are some questions for Dr. Sushil. Question from Sabi Gaudel. Excuse me if I won't pronounce correctly, Paudel or Gaudel. So for participatory community engagement, what would be the functional strategy to mobilize multi-stakeholders? So second question from Jeevan Sesson. How we can conduct such study in low-income settings like our local level or province level in districts who are really interested as a young researcher? Is it challenging? He is asking. A question from Uday Yadav. I would like to know about the engagement strategy in your research, more how you addresses the power issues while engaging large stakeholders. Question from Sheila Thapa. While talking about the interdisciplinary approach and inclusiveness, can we be assured NHRC, being the authoritative body, is following the same principles? She's asking. So another last question is from Ram Bahadur Khadka. The question is how we can conduct this type of studies in, again, local level and community level with very low cost, so its organization will support us.
Thank you, Chair and Co-Chair, and thank you very much for all the colleagues who put forward their question. Yes, things are not straightforward, as I said. सबै कुरा बुझे जतिकै सजिलो लागू गर्न नहुने रहेछ तर पनि म यहाँहरुको प्रश्नलाई I'll try to address. Community engagement, what would be the functional strategy to mobilize the multi-stakeholders? The question by Chabi Gaudel. It is important. I mean, there are a number of approaches. How do we mobilize the community? It depends on what type of community are you really going. What we learned in this is, first, instead of going with a predefined strategy to mobilize the community, we actually engaged with the community in terms of identifying the strategy by engaging them. That's why we very loud and clear, I made in presentation that it's a participatory community engagement approach. That has led to the greater ownership and accountability of the community in order to engage them. When it comes to the multi-sector, multi-stakeholder engagement, this is a challenge, but it can be doable, and there are good best practices. In our context, what we did is engaging multiple stakeholders. The first and important thing is know their interest first. Without knowing their interest, if you go with your own interest, they won't really comply with you. They won't really engage with you. So know their interest, know their scope of work, know their boundaries, know their limitations first, and then devise a strategy along with them in order to create that multi-sectorality in your research or intervention project. Professor Jeevan Sesson, another my guru, I really respect your question, and thank you very much for your nice words, saying very fruitful presentation. Yes, the question you highlighted is really pertinent. It's very good question. How do we do it at the local level, provincial level, and the district level, who are really interested, young researchers? Is it challenging? Of course, it is challenging, but challenges can be overcome. That's how I would say. In federal context, we have 3 tiers of government with the defined roles and responsibility, and the local government primarily holding the responsibility of providing basic healthcare services people. Again, understanding the mandate of different layers of authorities is very important. And with that mandate, starting to have a dialogue with those authorities, how they can deliver their given mandate for the community that they are taking care for. There are scopes at the provincial level with the engagement of Ministry of Social Development, as well as a lot of other provincial research authorities at the district level, as well as at the local level. Apart from myself, in our team, all were young researchers, I would say. When I say young researchers, they're really, really young, not only age, but in terms of their thinking. Young, but very mature thinking. young, but accepting the challenge, working with the community. It's an iterative process going through. So yes, there are a lot of young researchers in our team, and I see we have been receiving a lot of messages from young early career researchers to engage them in community practices. And I really see a value, what they can add in this research project, particularly engaging community and multi-stakeholder. These young researchers, young scientists, we need to develop a means to promote them to the next level. So it is very important that along with NHRC and other institutions devise a strategy. NHRC is already promoting, as I can see in this room as well, but it needs to go to the next level in a very organized fashion. All the institutions need to comply with that. Sila Thapa, when you talk about the NHRC and the ethical authoritative body in terms of ethical clearance, yes, as I said, this involves multiple disciplines bringing together. How do we obtain that? But we obtain that ethical clearance from NHRC by citing very clearly that these are the domains that we will be involving. And we follow the NHRC guideline. I think until unless there is another body created by the government, NHRC is the body where we seek ethical clearance for all the interdisciplinary research. The other thing is Ram Bahadur Khadkaji. So interesting topic, you said, thank you very much. But how can we conduct these type of studies from local and community with a very low cost? Yes, despite our interest, we could not do economic evaluation of this study. But what we used, 3 GoPros cameras, 3 GoPros, and 3 sound devices. Along with the time of community champions, where we involved in 3 different teams, and our researchers' time, it looked, because we production was a film, that's why it looked, oh, it can be very expensive. We thought at the beginning, but it is not. Although we haven't done a thorough economic evaluation of it, but what I understand from the research team, it is doable in given setting without bringing heavy investment on it. I'm sorry that some of you could not hear the presentation because of the sound and other things, so I request the team here to fix the sound when the presenters are presenting things. A couple of people were not able to hear it. Hope we will improve better. And thank you very much. I hope I tried to answer your question, and thank you very much. And I really salute my gurus, chairs, for giving me this opportunity, and NHRC for this opportunity to present me. Thank you very much.
So we have another questions for Dr. Archana Shrestha. The question from Rajshri. How can we promote uniform reporting guideline for reporting of the implementation outcomes, considering the research context and implementation challenges? Another question is from Dr. Gambhir. Is there any plan for similar implementation research in the area of other than CVD? And last question is from Uday Narayan Yadav. How can we expand partnerships with community members and meet their expectations in implementation research? So these 3 questions are for Dr. Archana Shrestha. I would like to request Dr. Archana Shrestha to answer this question in a few minutes. Thank you.
Yeah, thank you, Dr. Bikash, and thank you to the participants for the questions. And I would also like to take this opportunity to thank NHRC for this platform. So I think I've already addressed one question in the chat, but nevertheless, we are planning to do more interdisciplinary IR research in prevention of cervical cancer and promoting mobile health application for health promotion. And we're specifically designing the implementation research program for government employees. And it connects back to another question by Yadavji. How can we engage more people, like community level people, into implementation research? And I kind of agree with what Dr. Boral mentioned. And it just boils, and I feel like it also just boils down to how we see their role in our project. And it's not the commonly, like in the usual research setting, we investigators kind of lead the project and inform the community around the timelines. But I think, especially for all researchers, and especially for implementation research, it's very important to engage them as a decision makers from really, really early on of the project. That begins with even defining the research question. And for this, I think it's very important to engage specifically the program implementers and policymakers into this process at a very early stage. And this will also help create that kind of reporting system, monitoring and evaluation. And it is equally important to jointly evaluate the program in addition to designing and implementing it. So it's kind of a teamwork rather than like two teams, investigators and community engaging at different level. But I would like to emphasize that it's kind of one tree, and we are acting like a leaf and a fruit and trunk. So it has to be like one world where all of the questions emerge, implementation happens, and evaluation happens.
Thank you.
Yeah, thank you.
Thank you, Dr. Asana. So all presentations were very nice, comprehensive, and timely raised issues were there, especially for the COVID also. So it was a great experience from my side too, and I could learn many things from all of you. Thank you, presenters. Thank you so much, and was a great experience to sit with respected sir. Thank you very much.
Again, good morning. I must thank all the presenters. Now we are a little bit delayed about time constraint. Dr. Edwin presentations, it was very self-explanatory about the interdisciplinary research. It is some barriers on doing the interdisciplinary research, and at the same time, he gives some issues, how to combat these barriers. Thank you for your nice presentations, Dr. Edwin. Regarding Dr. Uttam Babu, again, it was also very simple and easy to understand by the audience, his presentations. Of course, there are some problems in doing the interdisciplinary researches. Although with few years we are in practice doing this interdisciplinary research, even in Nepal. And he explained about the difference between a multidisciplinary, transdisciplinary, interdisciplinary, and cross-disciplinary researches. Although they look, they sound, somebody may feel the same synonym of the interdisciplinary, but it is different from the multidisciplinary, transdisciplinary, and cross-disciplinary. And now we are facing all the problems like genetic disease from the environmental health problems, climate change. Dr. Megnath is with us. He has done a couple of researches on climate change. We are suffering from the vector-borne diseases. So all the discipline, work in the environment, work in the climate change, work in the genetic field, work in the clinical sites, they have to be in one place to address the problem of such kind of the, to combat the problem of such kind of the disease. Air pollution is another problem. So it has to be addressed not by only the clinician, not by only the environmentalist, or not by only the climate change expert, not by only from the environmentalist. So these things should be addressed by combined approach. I think the research should be diverted interdisciplinary in interdisciplinary approach. And regarding Susha's presentations, it's quite marvelous, very simple, self-explanatory. He has shown the document about the participation of the community, community. So I think Sushil is a brand in antimicrobial resistance research in tuberculosis. He has done his several work on it. And he gives the examples of the interdisciplinary researches. And he said that it has to be increased by the ownership of the community. So we have to include whole community in such researches, in collaborative researches. His presentation was very simple and self-explanatory, I said. His main theme was that we have to engage the community in all processes of the research. And regarding Dr. Arsana's presentations, yes, of course, now we are facing the problem in different fields, in child health, in maternity health, in environmental health, and other areas. The group of the single discipline, they have to sit together, group of the different discipline, they have to sit together and do the research, of course, that is interdisciplinary research. But she highlighted that the research generate the evidence, but very few evidence they are replicated in the policy and planning, so that they could be in practice. So it is the problem. It is not only the problem of Nepal. It is not only the problem of our neighbor countries. It is the problem of, it is the global problems. Usually policymakers, they don't accept the result of the evidence of the research. There must be a persuasion by the researchers and the community, of course. So with this, I think the key factors of the interdisciplinary research, I think there should be a common goal and shared values between the collaborators, regular assistance of the progress, active leadership of somebody from the discipline, allocations of the individual's roles and the contributions. It's not only the solely role of single persons, which is done usually in the single discipline, disciplinary research. There must be a good study plan, of course. Regular communications between the researchers. equitability and the equitability of all stakeholders. Of course, there must be the research should be focused on national priority. If you do the research having not the priority in, nationally, so they will not be accepted by the policy makers. So with this, I think next session should start with this. Lastly, I myself and on behalf of the Dr. Devkota, I would like to thank you, the chairpersons of the Nepal Health Research and the executive secretary of the Nepal Health Research Councils to providing us this opportunity to being with you and all the audience. Thank you very much. With this, I conclude this first session.
Thank you, chairs of this session, for your valuable remarks. Thank you, all the presentators for the informative delivery and the inspiration to move forward with implementation and interdisciplinary research at the local level and co-learning, co-doing. Similarly, without delaying, I would like to call Chair Professor Dr. Choplal Bhushal to give token of love to our presenter, Dr. Baral. As Thank you, sir. Thank you, Dr. Baral. As other presenters are not here, so we would like to give token of love via our online thank you. Similarly, I would like to call Chairperson of NHRC, Professor Dr. Anjani Jha, sir, and Member Secretary Pradeep Gawali, sir, on stage to hand over to present token of love to our chairs, Professor Dr. Choplal Bhushal and Dr. Vikas Devkota. With this, with the permission from chairs, I would like to end the first session of today's. Thank you, everyone.
Morning to you all. Namaste and a very warm good morning to you all. Distinguished delegates, ladies and gentlemen, it's my immense pleasure to welcome you all in this session. I am Asta Acharya, working in Nepal Health Research Council, and will be the host of this session today on health governance, economics, and planning and financing. For this session, I would humbly request Professor Dr. Sivaraj Adhikari and Dr. Suresh Tiwari on the stage to chair the session. Dr. Adhikari is a professor of economics at Central Department of Economics, Tribhuvan University. He has published more than 100 journal articles and book chapters in the area of health economics, development issues, and public finance. He has served as a member of the Public Expenditure Review Commission, as a senior advisor of the National Planning Commission, and also as a member of the Intergovernmental Fiscal Council. Moving on, Dr. Tiwari is the public health and public financial management professional with national and international experiences in formulating the public policy, national strategic plan, and policy evaluation. His area of expertise lies in epidemiological research, demand-side financing, social protection, and performance-based financing. He has also been involved in developing health financing strategy, developing health insurance policy and its implementation modalities, and conducting citizen budget analysis. Currently, he is a country director of Oxford Policy Management in Nepal. Moving on, we have 5 presenters for this session: Mr. Kesab Sanjel, Mr. Sivram Khatiora, Mr. Gautam Sunar, Mr. Sankar Singh Dhami, and Ms. Junu Shrestha. Thank you. Now I'd like to hand over the session to the chairs.
Thank you. Thank you for inviting us here and giving me this opportunity. Not only providing this opportunity to include the health-related issue in this conference, that is great for us. We don't have time, I think, not talking more. Maybe the mic hand over to Dr. Suresh.
Okay, so good morning all. So session is health governance, economics and financing, which is the most important and yet to be developed area in Nepal. So thank you all researchers, scientists for their interest today to present their study research in this very important topic. Without further delay, we would like to invite the first presenter of today's session, Kesab Sanjel. And Kesab is presenting on the health information system performance and associated factor in basic health facility of Karnali province, Nepal. Kesab, you are welcome.
Namaste to all. मेरो नाम केशव सञ्जेल. फर्स्ट अफ अल प्रेजेन्टेसनको यो अपर्च्युनिटीको लागि NHRCलाई धेरै धेरै धन्यवाद दिन चाहन्छौँ. Our study is about health information system performance and associated factors in basic health facilities of Karnali province in Nepal. The authors are myself, Kesab Sanjel from Strengthening Systems for Better Health, Save the Children in Nepal, Madhav Chavlagai, Samiksha Singh, and Swadesh Gurung from Strengthening Systems for Better Health, Apt Associates, Kathmandu, Nepal. Moving on to the background and objective of the paper. As evidenced, the health information systems are vital for the acquisition of data for health sector decision making. But many countries, particularly in low resource settings, lack well-functioning information systems that can support health system strengthening. So, given the evidence gap in information systems in the Nepalese context also, this study focused on measuring the information systems performance and its associated factors in the basic health facilities of resource poor setting, the Karnali province of Nepal. Moving on to the methodology. For this study, we used the data from health systems and capacity assessment, which was conducted by USAID's Strengthening Systems for Better Health activity. And the data were collected from December 2018 to June 2019. The assessment was done for 348 basic health institutions in 79 municipalities of Karnali province. And for the analysis, we used SPSS version 23. So in overall, frequency and percentage were calculated for categorical data. And for determining information system performance, we used principal component analysis that included 22 verification criteria under 4 performance standards. From principal component analysis, composite index, which was the continuous dependent variable, was created from the 6 principal components with eigenvalue more than 1, and the health information system performance status was then determined by dichotomizing the score based on the median value. And for determining the factors associated, we used chi-square test. Now, moving on to the results section, as shared in the methodology part, the assessment under health information system included 4 performance standards, 4 verification criteria, and for the first one is availability status of tools and guidelines in health facilities. Considering each of the recording and reporting tools at health facility, immunization, nutrition, CBI-MCI, and pills depot service registers are almost universally available, with 97% or more of all health facilities have these service registers. Likewise, maternal and newborn and PSC ORC service registers are available in 94% and 90% of the health facilities respectively. Likewise, HMIS reporting forms, especially HMIS 9.1, 9.2, and 9.3 are available in 87 to 91% of health facilities, and the last, the HMIS user manual, was found in 77% of the all health facilities, and which was the least available. Moving on to the next verification criteria, which is about the health facilities mechanism for data quality improvement and maintenance. With regard to specific components, at least 7 out of 10 facilities used tally sheets to compile the data, meet and discuss preparation of the monthly report, and also cross-check the report. Nevertheless, the facilities are less likely to cross-check the accuracy of records regularly. The third verification criteria was the status of review and analysis of service statistics in health facilities. Analyzing each component, the review and analysis of service statistics was relatively weak, with each component covering from 4% to 28% only. Looking at the fourth performance standard, which was about the practice of evidence-based programming at health facility level, as the diagram reflects, only minority of health facilities use the data for programming, and a component score reached from 14% to 18% only. Moving on to the next slide, which is about the overall performance status. Only 46.3% of basic health facilities had good information systems performance. And by district, the performance of health facilities in Dolpa, Mugu, and Humla were relatively poor, with 0%, 8%, and 16%. Moving on to the performance associated factors, geographical differences were clearly observed in the health information systems performance. To illustrate, good information system performance was found in the health facilities from urban and easily accessible areas. The assessment also found a good performance of the facilities conducting regular staff meetings and staff performance appraisal. Similarly, those health facilities who received recording and reporting feedback from municipality and those participated in periodic review meetings were significantly associated with good information system performance. Adding more, facilities having adequate resources for optimal management of information system are more likely to have good HIS performance compared to the institutions with resource limitation. So, in conclusion, as more than half of the basic health facilities reported poor information management status, we recommend to regularize staff meetings, progress reviews, recording and reporting feedback mechanisms, and allocating adequate resources for health information management, and for those institutions in remote and low resource settings. Now it's the time for acknowledging the contributors. We'd like to acknowledge the support from all municipalities and health facilities for their participation in the assessment. This assessment was done by a larger team from SSPS, and their contribution is duly acknowledged. This is the last slide, and if you have any queries, I will join a Q&A session shortly, and thank you so much for now.
Okay, thank you, Keshav. Yeah, to conclude your presentation on time, next presenter is Sivaram Khatioda. He is going to present direct cost of cancer in Nepal, a cross-sectional study in a tertiary cancer hospital. Okay, thank you. Go ahead.
Namaste. I'm Sivaram Khatioda. I'm going to present finding of our study. This is direct cost of cancer in Nepal. This was done in a tertiary care hospital, and our colleagues include myself, Sivaram Khatioda, Rajaram Dugana, Vishnu Prasad Sapkota, and Saraswati Singh. We all know that global burden of cancer is increasing, and in 2012, there were 14 million new cases, while this rose to be 18 million new cases in 2018. And in 2018, 9.6 million people died from cancer. And there is no good financial protection mechanism mostly in low-income countries. In developing countries, there is dominant out-of-pocket payment mechanism. That's why more suffering is said to be occurring in low-income countries. In 2010, 808 million people suffered catastrophic health spending, and according to one study, over 75% cancer patients experience death or financial catastrophe within 1 year in Southeast Asia. And government of Nepal has been providing about $1,000, 1 lakh rupees to the people with cancer for their medical care. Since we do not know exact cost required for the care of cancer, or the cost that could be, the amount that could be lost due to cancer, we wanted to know that value. That's why we carried out this study. And our objective was to estimate the direct cost of cancer among the people receiving treatment in a tertiary care hospital in Nepal. And this was descriptive cross-sectional study carried out from November 2016 to February 2017 in October Cancer Hospital, and 294 participants were included for the analysis. And the cost of illness is a method we used. This method is used to find the economic burden or economic impact of illness, and this includes direct cost and indirect cost. We only calculated direct cost. This direct cost also comprises medical cost and non-medical cost. And the medical cost includes the cost for healthcare services, For example, cost of consultation, cost of hospital stay, cost of treatment, cost of diagnosis and other care. And non-medical cost includes costs such as cost for food, accommodation, travel, etc. We use structured tool, and the result is the median age of the participant was 54 years, and 57% were female, 42% were male, and lung cancer was prevalent in about 20% participant. Then was breast cancer in 15% and cervical cancer in 14%. In other 50% participants, other cancers were present. And the mean medical cost was 313,000, 3,13,000, and non-medical cost was 73,000. Total direct cost was 387,000. This is the mean cost, 3,87,000, 87,000 चाहिँ एकजनाकोमा एभरेज cost भयो. And the cost varied significantly with age, type of cancer, treatment. And this is the cost. Direct cost 387,000, medical cost 313,000, and medical cost is 80% of the direct cost. Direct cost is hugely contributed by medical cost. And we can see the people, how they purchased health services. Mostly they relied on personal resources. They paid from their household or personal resource, paid out of pocket. 65% said they only used out of pocket, and 33% said that they also used government subsidy, and other resources were very few. 86% participants said that they were experiencing financial hardship due to health service utilization. To cope with the hardship, 78% of them had taken loan, while 47% had sold their property. And we can see that when medical cost is 313,000, but the per capita income is, at that time, it was 78,000. This could be burdensome, we can assume. And according to some literature, and in WHO and World Bank, the reports say that the threshold for catastrophic financing, health financing, is about 40% of non-subsistence needs, non-subsistence expenditure or capacity to pay. If their healthcare cost is 40% or above their capacity to pay, then this can be catastrophic. According to a 5th annual household budget survey conducted by Nepal Rashtra Bank, at that time, the 40% of capacity to pay became 69,000, about 70,000. When medical cost is 313,000, and this obviously is catastrophic. This is above the threshold of about 70,000. Hence, we conclude that the medical cost itself was catastrophic, and total direct cost was surely catastrophic in nature, and many people are bound to suffer from this. And when the cancer is increasing and maybe many people are going to suffer, we have to take some measures to prevent the suffering and of the people. And government of Nepal is really doing great job by providing 1 lakh, but this is not enough. This is not adequate. This is appreciable but not adequate. And then what can be the possible solutions to manage these financial hardships? This could be done by all of us, from our level, from community, from hospital, from government level, from policy level, and better preventive and curative services are required. We need to measure some ways of reducing out-of-pocket payment by expanding government service, government support, or through health insurance mechanism. And other ways could be avoiding low value therapies and price regulation, and maybe increasing income of the people can be a better way. Thank you very much. This and I would like to thank the Department of Community Medicine and Public Health, Maharajan Medical Campus, Bhaktapur Cancer Hospital, and the participant for supporting me in this study, and Frontiers in Public Health for publishing our study. These are the references we used in here. Thank you very much.
Okay. Thank you, Khatioda. A very interesting presentation. Maybe next time will ask some question. And then next presenter is Gautam Sundar. He is going to present in the out-of-pocket payment, pay health expenditure in tertiary hospital in Gandhigi province, Nepal, a comparative study among the insured and uninsured, I think people, consumer. Please go ahead to present your paper.
Namaste, my name is Gautam Sundar. Today I am going to present on my topic out-of-pocket healthcare expenditure in tertiary hospital of Gandhigi province, a comparative study among insured and uninsured. And during this presentation, I am going to use both English as well as Nepali language. Let me start from background. Out-of-pocket healthcare expenditure is a direct mode of payment by individual or household at a point of service. Globally, more than 800 people spend at least 10% of their household income budget on out-of-pocket healthcare expenditure. Nearly 100 million people pushed into extreme poverty each year due to healthcare costs. But in context to Nepal, more than 10% is population facing burden of healthcare cost, and they spend more than 10.71% of healthcare expenditure, where 1.67% of population pushed into extreme poverty due to healthcare cost. साउथ एसियन कन्ट्रीमा हेर्नु पर्दाखेरि हेल्थ केयर फाइनेन्सिङ सिस्टम एकदम पोर रहेको छ, जहाँ चाहिँ गभर्नमेन्टको हेल्थ केयर एक्सपेन्डिचर कम छ. नेपाल, फर इक्जाम्पल, नेपाल स्पेन्ड ओन्ली 1.11% अफ GDP on healthcare expenditure. There are many stories in our country where people died or faced problem due to healthcare cost. जस्तै गरी डेभलप कन्ट्रीहरूमा हेर्ने हो भने हेल्थ केयर कस्ट फ्री रहेको छ, जस्तै युकेमा हेल्थ केयर कस्ट फ्री रहेको छ बेस्ड अन ट्याक्स फाइनेन्सिङ मेकानिजममा. तर मोस्ट अफ लो एन्ड मिडल इन्कम कन्ट्रीहरूमा आउट अफ पकेट हेल्थ एक्सपेन्डिचर नै एउटा मेन मोड टु पे कस्ट फर हेल्थ केयर युटिलाइजेसन रहेको छ भने पोभर्टी एन्ड हाई आउट अफ पकेट हेल्थ एक्सपेन्डिचर रिमेन च्यालेन्जेस फर इक्विटेबल एक्सेस टु क्वालिटी हेल्थ केयर इन नेपाल रहेको छ भने. त्यस्तै गरी इन्सुरेन्सको कुरा गर्नुपर्दा इन्सुरेन्स एउटा फर्म अफ रिस्क म्यानेजमेन्ट हो विच प्रोभाइड प्रोटेक्सन फ्रम फाइनेन्सियल लस. डिफ्रेन्ट काइन्ड अफ हेल्थ इन्सुरेन्स प्रोग्राम वर्ल्डमा प्र्याक्टिस भएको पाइन्छ, जहाँ चाहिँ नेपालमा चाहिँ सोसियल हेल्थ इन्सुरेन्स प्र्याक्टिसमा भएको पाइएको छ, जहाँ चाहिँ जुन बेस्ड अन फाइनेन्सिङ एन्ड म्यानेजिङ हेल्थ केयर कस्ट बेस्ड अन रिस्क पुलिङ मेकानिजम एन्ड प्रिपेमेन्ट मेकानिजममा रहेको छ. त्यस्तै गरी यो चाहिँ गभर्मेन्टको एउटा मोस्ट प्रायोरिटाइज प्रोग्राम हो जुन चाहिँ नन प्रोफिट इन नेचरमा रहेको छ, जसले एसिसिएन युटिलाइजेसन अफ क्वालिटी हेल्थ केयर अन रिस्क पुलिङ एन्ड प्रिपेमेन्ट मेकानिजममा काम गरेको छ भने यसको इनरोलमेन्ट स्टार्ट भएको थियो 2016बाट 3टा डिस्ट्रिक्टबाट भने अहिले स्केल अप गरेर 49 डिस्ट्रिक्टमा पुर्याएको छ. त्यसै गरी यो सोसियल हेल्थ इन्सुरेन्स भन्दा अगाडि चाहिँ कम्युनिटी बेस्ड हेल्थ इन्सुरेन्स कुनै केही डिस्ट्रिक्ट नेपालमा भएको पाइएको छ. सोसियल हेल्थ इन्सुरेन्स इज एक्सपेक्टेड टु रिड्युस हेल्थ केयर एक्सपेन्डिचर. स्टडीको हाम्रो अब्जेक्टिभ भनेको टु फाइन्ड द इफेक्ट अफ सोसियल हेल्थ इन्सुरेन्स अन आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर एन्ड द लेभल अफ हेल्थ केयर एक्सपेन्डिचर एलोङ विथ इट्स अनइभन डिस्ट्रिब्युसन विथ इन्कम ग्रुप रहेको छ भने यसको डिजाइन चाहिँ एउटा क्रस सेक्सनल कम्पेरेटिभ स्टडी रहेको छ, जुन चाहिँ जसमा चाहिँ क्वान्टिटेटिभ स्टडी वाज डन बेस्ड अन प्राइमेरी डाटा कलेक्सन थ्रु फेस टु फेस इन्टरभ्यू विथ स्ट्रक्चर क्वेसन रहेको छ भने यो यसको युनिटको कुरा गर्नुपर्दा हस्पिटल बेस्ड ओपिडी पेसेन्ट हु सिक हेल्थ केयर फेसिलिटिज इन टर्सरी हस्पिटल अफ पोखरा भ्याली लिएको छ, जसको स्याम्पल साइज चाहिँ स्ट्याटिस्टिकल फर्मुला फर अननोन पपुलेसनबाट लिएको छ, जुन स्लाइडमा पनि देखाएको छ, जसमा चाहिँ स्याम्पल साइज 400 लिएको छ, जसमा 1:1 रेसियो इन्स्योर्ड एन्ड अनइन्स्योर्डमा डिभाइड गरेको छ भने स्ट्रेटिफाइड ऱ्यान्डम स्याम्पलिङ टेक्निक्सका आधारमा स्याम्पलिङ कलेक्सन गरेको छ भने स्ट्याटिस्टिकल टुल काई स्क्वायर मेन व्हिटनी यु टेस्ट जस्ता टुल्सहरू युज गरेर डिग्री अफ एसोसिएसन इन इच स्ट्याटम अफ बाइभेरिएन्ट र मल्टिभेरिएन्ट एनालाइसिसमा हेरिएको छ. रिजल्टको पार्टमा कुरो गर्नुपर्दाखेरि लेस देन 25,000 भएका चाहिँ 1/3 अफ रेस्पोन्डेन्टहरू भेटियो, जुन चाहिँ नेपालको एभरेज हाउसहोल्ड इन्कम भन्दा पनि कम भेटियो. त्यस्तै गरी टोटल ट्रिटमेन्ट कस्ट ओभरअल स्याम्पल साइजमा हेर्दाखेरि मेन चाहिँ 1549 देखियो विथ स्ट्यान्डर्ड डेभिएसन 2100 41.65 देखियो भने मिनिमम 0 to 18,525 टोटल ट्रिटमेन्ट कस्ट लागेको देखियो। त्यस्तै गरी बायोभेरिएन्ट एनालाइसिसमा हाम्रो आउटकम भेरिएबल थियो आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर, जुनलाई कम्पेयर मिनबाट हेरिएको थियो भने जसमा रोबस्टनेसको लागि चाहिँ मिडियन पनि दिएको थियो। आउट अफ पकेट हेल्थ एक्सपेन्डिचर बाई जेन्डरमा हेर्दाखेरि कम्पेरिटिभली मेलको आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर बढी भएको पाइयो भने एजुकेसन लेभलमा हेर्दाखेरि नो फर्मल एजुकेसनको आउट अफ पकेट हेल्थ एक्सपेन्डिचर फर्मल एजुकेसनभन्दा बढी भएको पाइयो। त्यस्तै गरी इन टर्म अफ अकुपेसनमा इन्फर्मल वर्करहरूको आउट अफ पकेट हेल्थ एक्सपेन्डिचर हाई भेटियो भने त्यसै तर फ्यामिली इन्कममा सरप्राइजिङली के देखियो भन्दाखेरि जसको लेस मन्थली इन्कम छ, मन्थली फ्यामिली इन्कम छ, त्यसको आउट अफ पकेट हेल्थ एक्सपेन्डिचर हाई भेटियो, जसलाई जुन स्टेटमेन्टलाई पर्सेभ वेल्थ स्ट्याटसले पनि सपोर्ट गर्छ। नट पोरको तुलनामा पोरले 2 times बढी आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर स्पेन्ड गरेको पाइयो ओपिडी पेसेन्टमा। त्यस्तै गरी डिजिज कन्डिसन एसिस्टेड टर्सरी हस्पिटल एन्ड युटिलाइजेसन फ्रिक्वेन्सी अल्सो हेभ सिग्निफिकेन्ट इफेक्ट अन आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर। त्यस्तै गरी इन्सुरेन्स इनरोलमेन्ट स्ट्याटसमा हेर्दाखेरि नट इनरोलको तुलनामा इनरोलले चाहिँ 4.6 times लेस आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर स्पेन्ड गरेको पाइयो, जसले चाहिँ के सजेस्ट गर्छ भन्दाखेरि आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर रिड्युस गर्नको लागि इन्सुरेन्स स्ट्याटसले सिग्निफिकेन्ट रोल खेलेको देख्न सकिन्छ। त्यस्तै गरी लिमिटेड प्याकेज भएको कारणले मोड अफ पेमेन्ट पनि रेस्पोन्डेन्टहरूले डिफ्रेन्ट गरेको पाइयो, जसमा इन्सुरेन्स सेल्फ र सेल्फ प्लस इन्सुरेन्स मोड युज गर्दाखेरि इन्सुरेन्स गर्नेको तुलनामा सेल्फ र सेल्फ प्लस इन्सुरेन्सले रेस्पेक्टिभली 4 or 2 times बढी आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर खर्च गरेको पाइयो। त्यस्तै गरी मल्टिभेरिएन्ट एनालाइसिसमा हेर्दाखेरि एज, मन्थली हाउस होल्ड इन्कम, इन्सुरेन्स स्ट्याटस, पेमेन्ट मोड आर की डिटर्मिनेन्ट अफ आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर भन्ने पाइयो, जसमा मन्थली हाउस होल्ड इन्कममा हेर्नुपर्दा लेस देन 25,000लाई रेफरेन्स मानेर हेर्दाखेरि जसको लो मन्थली हाउस होल्ड इन्कम छ त्यसको चाहिँ बढी आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर भएको पाइयो। जसको मतलब मोर बर्डन चाहिँ लो इन्कम भएकालाई चाहिँ आउट अफ पकेटको भन्ने बुझियो। त्यस्तै गरी इन्सुरेन्स स्ट्याटसको कुरा गर्नुपर्दा नट इनरोलको रेफरेन्स मानेर हेर्दाखेरि इन्सुरेन्स इनरोल भएकाले 67.2% लेस आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर स्पेन्ड गरेको पाइयो। त्यसै गरी पेमेन्ट मोडमा हेर्दाखेरि बाई इन्सुरेन्सलाई रेफरेन्स मानेर हेर्दाखेरि सेल्फ एन्ड इन्सुरेन्स एन्ड सेल्फ चाहिँ रेस्पेक्टिभली बढी आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर स्पेन्ड गरेको पाइयो भने यो डाटाको गुडनेस अफ फिट चाहिँ नियरली 70% भेटियो। हेन्स इन्सुरेन्स play a vital role to reduce out of pocket healthcare expenditure, so it is suggested that the need of social health insurance. But on the other hand, due to limited package of social health insurance, patients are enforced to rely on insurance as well as self mode of payment, so additional package for social health insurance also needed. Similarly, inverse relationship of monthly household income with out-of-pocket healthcare expenditure suggests that insurance schemes should focus to those groups with lower income group. Similarly, result also suggests that low income group and low educated group are less benefited by social health insurance program. In conclusion, social health insurance has a crucial role in financial protection to OPD patient by reducing out-of-pocket healthcare expenditure. So, highlighting social health insurance program with expansion on service packages is needed. Poor and vulnerable group are in high risk of morbidity, so insurance scheme should focus to prevent them from poverty line and financial hardship of healthcare expenditure, which was also focused by universal health coverage. Besides this, insurance अझै पनि इनिशियल फेजमा भएको हुनाले ओपीडी र आईपीडी दुईटैमा रिसर्च गरेर अझै फर्दर इन्सुरेन्स प्रोग्रामलाई फ्रुटफुल बनाउन सजेस्ट गर्ने रिसर्चहरुको अझै निड छ. These are my acknowledgement and thank you.
Elaborative presentation within the given time frame. Now we would like to call upon next presenter, Mr. Shankar Singh Dhami. He is presenting health service utilization and out-of-pocket health expenditure among insured and uninsured, a comparative study in Baglung district of Nepal.
Okay, good afternoon everyone. म शङ्कर धामी आज म यस 6th NHRC समिटमा मेरो रिसर्च प्रेजेन्टेसन गर्न गइरहेको छु. जुन मेरो MPS को थेसिसको पार्ट पनि हो, जुन 2018 मा मैले MPS को थेसिस गर्दा मैले गरेको स्टडी हो. यो अलिकति कन्टेक्चुअल नहुन सक्छ किनभने त्यति बेलाको र अहिलेको अलिकति कन्टेक्स्ट चाहिँ केही चेन्ज भएको हुनसक्छ। यद्यपि म यसलाई कन्टेक्चुअलाइज गर्ने कोसिस चाहिँ गर्नेछु। मेरो अनुसन्धानको टपिक चाहिँ हेल्थ सर्भिस युटिलाइजेसन एन्ड आउट अफ pocket health expenditure among insured and uninsured under the National Health Insurance Program रहेको छ। यो जुन चाहिँ बागलुङ जिल्लामा चाहिँ मैले रिसर्च गरेको थिएँ। यहाँ मुनि फुटरमा तपाईहरुले यो रिसर्चमा इन्भल्भ भएको कन्ट्रिब्युटर्सहरुको नाम चाहिँ देख्न सक्नुहुन्छ। यो चाहिँ आउटलाइन अफ माई प्रेजेन्टेसन हो। यो चाहिँ आजको यस प्रेजेन्टेसनको जसमा चाहिँ ब्याकग्राउन्ड, स्टडी अब्जेक्टिभ, मेथोडोलोजी, रिजल्ट, कन्क्लुजन र रिकमेन्डेसन रहेको छ। त्यसैगरी यो चाहिँ ब्याकग्राउन्ड छ जसमा चाहिँ अब यो नेपालमा हामीले देख्न सक्छौं हाम्रो यो नेपालको कन्टेक्स्टमा यहाँ चाहिँ थुप्रो हेल्थ सर्भिस युटिलाइजेसनमा डिस्प्यारिटिजहरु छ, यहाँ चाहिँ डिफरेन्सेसहरु छ। त्यसलाई चाहिँ कम गर्न, त्यसलाई ब्रिज गर्न बेला बेलामा विभिन्न किसिमका पोलिसिजहरु, प्लानहरु आए। त्यो सँगै हाम्रो संवैधानिक व्यवस्था जुन इन्टेरियम कन्स्टिट्युसन आयो 2007 मा त्यसले पनि व्यवस्था गर्यो। त्यसै अनुरूप 2013 मा जुन चाहिँ हाम्रो हेल्थ इन्स्योरेन्स पोलिसी आयो यसले पनि यसलाई केही चाहिँ अब फुलफिल गर्ने कोसिस गर्यो। यसै अनुरूप चाहिँ हाम्रो पास्टको थुप्रो एक्सपिरियन्सेसहरु छ। विभिन्न किसिमका इन्स्योरेन्स प्रोग्रामहरुको सिकाइबाट चाहिँ 2015 मा नेशनल हेल्थ इन्स्योरेन्स प्रोग्राम आइसकेपछि 2016 बाट यो 3 वटा जिल्लामा पहिलो फेजमा जसमा चाहिँ कैलाली, बागलुङ र हाम्रो चाहिँ इलामबाट पहिलो फेजमा चाहिँ यो सुरु गरियो। र यो स्टडीले यही अब जुन नेशनल हेल्थ इन्स्योरेन्स प्रोग्राम छ यसले चाहिँ हेल्थ सर्भिस युटिलाइजेसनमा के चाहिँ प्रभाव पारेको छ, यसले आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचरमा के प्रभाव पारेको छ भनेर मैले चाहिँ यो स्टडी गरेको थिएँ। यो चाहिँ अब्जेक्टिभ रहेको छ। यहाँ चाहिँ यसमा विशेष गरी यो अब्जेक्टिभमा चाहिँ हेल्थ इन्स्योरेन्स र अनइन्स्योर्ड पपुलेसनमा हेल्थ सर्भिस युटिलाइजेसन कस्तो छ र आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर कस्तो छ भनेर मैले हेर्न खोजेको छु। यो स्टडी डिजाइन चाहिँ यहाँ तपाईहरुले हेर्न सक्नुहुन्छ। स्टडी डिजाइनमा चाहिँ कम्पेरेटिभ क्रस सेक्सनल डिजाइन चाहिँ हो। यो स्टडी मेथडमा क्वान्टिटेटिभ मेथड हो यो चाहिँ, जसमा चाहिँ फेस टु फेस इन्टरभ्यूबाट चाहिँ स्ट्रक्चर्ड क्वेसनरको मद्दतले हामीले चाहिँ यो डाटा कलेक्सन गरेका थियौं। त्यति बेला चाहिँ स्टडी सेटिङ चाहिँ यो बागलुङ जिल्लाको चाहिँ बागलुङ म्युनिसिपालिटी लिएका थियौं। यो बागलुङ म्युनिसिपालिटी अथवा बागलुङ जिल्ला चुज गर्ने कारण चाहिँ एउटा त बागलुङ चाहिँ फर्स्ट फेजमा जहाँ चाहिँ इम्प्लिमेन्ट भयो त्यसमध्ये त्यो 3 वटा जिल्ला मध्ये एउटा हो। अर्को चाहिँ बागलुङमा हामीले स्टडी गर्दा को बेलासम्म 2 फेज रिन्युअबल कम्प्लिट भएको थियो र अर्को यो मैले अगाडि पनि भने यो मेरो मास्टर्सको थेसिसको पार्ट भएको भएर अलिकति रिसोर्स कन्स्ट्रेन्ट टाइम लिमिटेसनको कारणले गर्दा मैले बागलुङ म्युनिसिपालिटी चुज गरेको हो। यसैगरी स्टडी युनिटमा चाहिँ हाउसहोल्ड एज अ स्टडी युनिटको रूपमा हामीले लिएका छौं। यो किन हाउसहोल्ड लियो भन्दाखेरि हाम्रो हेल्थ इन्स्योरेन्समा यो हाउसहोल्डलाई इनरोलमेन्ट युनिटको रूपमा चाहिँ लिएको भएर हामीले यसमा पनि हाउसहोल्डलाई एज अ स्टडी युनिटको रूपमा लिएका छौं। स्टडी ग्रुपमा चाहिँ हाम्रो इन्स्योर्ड र अनइन्स्योर्ड अन्डर द नेशनल हेल्थ इन्स्योरेन्स प्रोग्राम दुईवटा हाम्रो चाहिँ कम्पेरिटिभ भएको कारणले गर्दा हामीले इन्स्योर्ड र अनइन्स्योर्ड चाहिँ पपुलेसनहरु लिएका छौं। त्यसैगरी यो स्याम्पलिङमा हामीले यो इन्स्योर्ड पपुलेसनका लागि चाहिँ विशेष गरी र्यान्डम स्याम्पल मेथडबाट चाहिँ 2 वटा स्टेजमा हामीले र्यान्डम स्याम्पल गरेर यो चाहिँ स्याम्पलिङ गरेका छौं र अनइन्स्योर्ड पपुलेसनका लागि नेबरहुड उसको नजिकको अनइन्स्योर्ड हाउसहोल्ड र त्यसमा पनि 2 वटा हामीले एउटा इथनिसिटी र अर्को अकुपेसनको आधारमा चाहिँ म्याचिङ गरेर अनइन्स्योर्ड हाउसहोल्ड चाहिँ चुज गरेका छौं र 1:1 कम्पेरिजन चाहिँ रेशियो चाहिँ 1:1 रहेको छ यसमा चाहिँ। त्यसैगरी अर्को चाहिँ हाम्रो यो डिटर्मिनेसन अफ स्याम्पल साइजमा चाहिँ हामीले स्याम्पल साइज चाहिँ कम्पेयर टु प्रोपोर्सन फर्मुलाबाट चाहिँ हामीले गरेका छौं, जसमा चाहिँ 225 इच ग्रुपमा ओभरअल 450 हाम्रो चाहिँ स्याम्पल रहेको थियो। यो चाहिँ हाम्रो जुन मैले अगाडि नै कुरा गरे हाम्रो स्याम्पलिङ प्रोसिडियरको 2 स्टेज र्यान्डम स्याम्पलिङ भनेको थिए। फर्स्टमा बागलुङ म्युनिसिपालिटीबाट यहाँ हेर्न सक्छौं हामीले 7 वटा वार्ड चाहिँ हामीले र्यान्डमली चुज गरेका छौं। त्यो 7 वटा वार्डबाट पनि त्यहाँ भित्र भएको जुन चाहिँ इन्स्योर्ड हाउसहोल्ड छ त्यसको प्रोपोर्सनको आधारमा चाहिँ हामीले 7 वटाबाट फेरि अर्को स्टेजमा चाहिँ हामीले त्यो इन्स्योर्ड हाउसहोल्ड चाहिँ स्याम्पल गर्यौं र प्रत्येक इन्स्योर्ड हाउसहोल्डका लागि हामीले एउटा अनइन्स्योर्ड हाउसहोल्ड मैले अगाडि पनि भने यसमा चाहिँ हामीले नेबरहुड चाहिँ दुईवटा कुरा म्याचिङ गरेर उसको अकुपेसन र उसको एथनिसिटी म्याचिङ गरेर अनइन्स्योर्ड हाउसहोल्ड चाहिँ लिएका छौँ। अब रिजल्टमा चाहिँ यो स्लाइड चाहिँ विशेष गरी अब यो अब्जेक्टिभलाई धेरै नै कभर गर्छ। योले चाहिँ यसमा चाहिँ हामीले देख्न सक्छौँ हेल्थ इन्सुरेन्सको हेल्थ सर्भिस युटिलाइजेसनमा कस्तो एसोसिएसन छ भनेर यहाँ चाहिँ हामीले हेर्न सक्छौँ। इन्स्योर्ड र अनइन्स्योर्ड ग्रुप छ। यहाँ चाहिँ इन्स्योर्डलाई हेर्दा अनइन्स्योर्डको तुलनामा चाहिँ इन्स्योर्डले मोर हेल्थ सर्भिस युटिलाइज गरेको पाइयो, जुनमा चाहिँ अड्स रेसियो बाइनरी लजिस्टिक रिग्रेसनबाट हामीले कम्प्युट गरेका थियौँ 1.774 छ र यहाँ पी भ्यालु पनि हामीले सिग्निफिकेन्ट पायौँ। यसै गरी यो कम्पेरिजन अफ आउट अफ पकेट हेल्थ एक्सपेन्डिचर विथ इन्सुरेन्स स्टेटस भनेका छौँ। यसमा पनि हामीले के चाहिँ देख्न सक्छौँ भने यो इन्सुरेन्स स्टेटस अथवा इन्स्योर्ड पपुलेसनमा अनइन्स्योर्ड भन्दा धेरै नै कम यो आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर पाएका छौँ। यसको पनि पी भ्यालु चाहिँ हाइली नै सिग्निफिकेन्ट छ। यो मेन यु टेस्टबाट कम्प्युट गरेका थियौँ र यसले चाहिँ इन्डाइरेक्ट कस्ट मात्रै कभर गरेको छ, यसले डाइरेक्ट कस्ट चाहिँ कभर गर्दैन। र हामीले यो जुन चाहिँ आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर लियौँ यो हामीले स्टडी गर्नुभन्दा 1 महिना अगाडिसम्मको मात्रै अब यो कस्टहरू लिएका थियौँ। त्योभन्दा अगाडिको हामीले अब रिकल बाइस हुन सक्छ, उहाँहरूले बिर्सिन सक्नुहुन्छ भनेर त्योभन्दा अगाडिको चाहिँ कभर गरेको छैन, यो 1 महिनाको मात्रै हो। त्यसै गरी अब यो एसोसिएसन अफ इन्डिपेन्डेन्ट भेरिएबल विथ हेल्थ सर्भिस युटिलाइजेसन डिफ्रेन्ट भेरिएबलहरूको बोथ इन्स्योर्ड र अनइन्स्योर्ड ग्रुपमा हामीले सेपरेटली क्यालकुलेसन गरेका छौँ डिफ्रेन्ट भेरिएबलहरूको एसोसिएसन। अब यहाँ हेर्दा चाहिँ के पाइयो भने इन्स्योर्ड ग्रुपमा कुनै पनि भेरिएबलहरू चाहिँ स्ट्याटिस्टिकली सिग्निफिकेन्ट रूपमा चाहिँ एसोसिएटेड पाइएन। तर अनइन्स्योर्डमा यहाँ इथनिसिटी यहाँ हेर्न सक्नुहुन्छ तपाईँले, यहाँ पी भ्यालु होइन, यता चाहिँ यसको अड्स रेसियो 2.846 छ होइन, पी भ्यालु पनि सिग्निफिकेन्ट छ। यसै गरी सेम यो अकुपेसनको हकमा पनि र यस्तै चाहिँ वेल्थ स्टेटसको हकमा पनि सेम छ। अब योले के चाहिँ हामीले भन्न सक्छौँ भने अब यो इन्स्योर्ड ग्रुपमा इन्सुरेन्स स्टेटसले गर्दा त्यो अब डिफ्रेन्ट ग्रुपहरूमा जस्तै वेल्थ स्टेटस अकुपेसन उनीहरूको इथनिसिटीले खासै प्रभाव पर्दैन। योले त्यो ग्याप चाहिँ भित्रको ग्याप चाहिँ ब्रिज गर्यो। तर इन केस अफ अनइन्स्योर्डमा त्यो ग्याप चाहिँ देखियो, त्यो डिफ्रेन्स चाहिँ देखियो यहाँ चाहिँ। र यो कम्पेरिजन अफ आउट अफ पकेट हेल्थ एक्सपेन्डिचर विथ डिफ्रेन्ट भेरिएबल हामीले छुट्टै छुट्टै गरेका छौँ यसमा पनि इन्स्योर्ड र अनइन्स्योर्ड। अगाडि हाम्रो चाहिँ के थियो भने यसमा चाहिँ हामीले इन्स्योर्ड र नन इन्स्योर्डमा गर्दा चाहिँ सिग्निफिकेन्ट पाएका थियौँ, त्यो स्ट्याटिस्टिकली त्यो डिफ्रेन्ट पाएका थियौँ। तर यहाँ चाहिँ खासै त्यस्तो अब स्ट्याटिस्टिकली सिग्निफिकेन्ट छैन। तर केही अब्जर्भ डिफ्रेन्सेसहरू चाहिँ हामीले यहाँ चाहिँ दुईटै ग्रुपमा इन्स्योर्ड ग्रुपमा पनि देख्न सक्छौँ, अनइन्स्योर्ड ग्रुपमा पनि देख्न सक्छौँ। यो चाहिँ अब मल्टिभेरिएट एनालाइसिस हो। अगाडिको जुन बायोभेरिएटमा हामीले सिग्निफिकेन्ट पाएका थियौँ केही भेरिएबलहरू, तिनीहरूलाई हामीले मल्टिभेरिएट अब मल्टिपल लजिस्टिक रिग्रेसन हामीलेबाट कम्प्युट गरेका थियौँ। त्यसमा फेरि इन्सुरेन्स स्टेटस चाहिँ स्ट्याटिस्टिकली सिग्निफिकेन्ट रहेको पाइयो, जसमा चाहिँ 0.031 यसको पी भ्यालु छ र यहाँ अड्स रेसियो पनि हेर्न सक्छौँ हामी चाहिँ 1.938। त्यसै गरी इथनिसिटी अकुपेसन र वेल्थ इन्डेक्स यहाँ चाहिँ यिनीहरूको खासै एसोसिएसन अब सिग्निफिकेन्ट एसोसिएसन पाइएन। अब चाहिँ कन्क्लुजन र रिकमेन्डेसन भनेर छ, यो लास्ट स्लाइड हो मेरो। यसमा चाहिँ विशेष गरी हाम्रो अब्जेक्टिभ अनुसार एउटा मेजर कन्क्लुजन के हो भने इन्सुरेन्सले हेल्थ सर्भिस युटिलाइजेसन बढाएको पाइयो, सँगै आउट अफ पकेट हेल्थ केयर एक्सपेन्डिचर घटाएको पाइयो। त्यही भएर यो चाहिँ नेसन वाइड अब इम्प्लिमेन्टेसनकै फेजमा छ। अहिले नेसन वाइड इम्प्लिमेन्टेसन गर्ने भनेर अब 2020 सम्म चाहिँ यो गरिसक्ने भन्ने छ। यद्यपि अब अहिले मलाई लाग्छ 50+ डिस्ट्रिक्टहरूमा इम्प्लिमेन्ट भएको छ। यो ढुक्क भएर यो चाहिँ गर्दा हुन्छ भन्ने यसको फाइन्डिङले यो रिसर्चको फाइन्डिङले देखाएको छ। यद्यपि यसमा केही चाहिँ एमेन्ड गर्नुपर्ने देखिन्छ जुन पोलिसी प्रोभिजनहरू छ, जस्तै अब लिमिटेड सर्भिस साइटहरू छ, त्यसले गर्दा अब त्यो जुन चाहिँ इनरोल्ड अब त्यो बिरामी हो तिनीहरूलाई चाहिँ हिँडेर जान टाढा छ, उनीहरू चाहिँ के बाध्य छन् भने इन्स्योर्ड हुँदाहुँदै पनि प्राइभेटबाट उपचार गराउन बाध्य छन्, प्राइभेट हस्पिटल क्लिनिकहरूबाट। सँगै चाहिँ यो जुन प्याकेज छ यसको प्याकेज पनि अलिकति कम्प्रिहेन्सिभ भएन भन्ने किसिमको कुरा आयो हाम्रो रिसर्चबाट। यो जुन हेल्थ इन्सुरेन्सको प्याकेज छ यसको समेट्ने त्यो चाहिँ अलिकति ब्रड बनाउनु पर्छ भन्ने यसको चाहिँ कन्क्लुजन हो, यो रिकमेन्डेसन हो। त्यसै गरी अर्को चाहिँ एउटा हाई प्रिमियम र अब जुन चाहिँ हाम्रो सब्सिडाइज प्रिमियम चाहिँ अथवा प्याकेज ल्याउने चाहिँ भनियो, त्यो इम्प्लिमेन्ट गर्ने भनियो, तर अहिलेसम्म पनि त्यो हामीले इम्प्लिमेन्ट गर्न सकेका छैनौँ। र अर्को चाहिँ हामीले अब 25बाट 3500 जुन प्रिमियम बनायौँ यो बढाउने बित्तिकै अब सबैले त्यो 3500 एफोर्ड गर्न सक्छ भन्ने त छैन। यो चाहिँ अब हाम्रो स्टडीले एउटा के पनि रिकमेन्ड गर्छ भने यो चाहिँ हाम्रो इन्डिभिजुअल इन्कम बेस्ड हुनुपर्छ भन्ने यसले रिकमेन्ड गर्छ। र लास्ट पोइन्ट चाहिँ अवेरनेस पनि अलिकति लिमिटेड पाइयो, त्यहाँ चाहिँ अब सफिसियन्ट अवेरनेस पाइएन त्यो जुन चाहिँ इभन इनरोल्ड पपुलेसनहरूमा पनि त्यो इनरोल चाहिँ गरियो। जुन चाहिँ हाम्रो हेल्थ इन्सुरेन्स का त्यो इनरोलमेन्ट एसिस्टेन्टहरू छन् उहाँहरूको पर्सनल रिलेसन उहाँको इन्फ्लुएन्सले गर्दा इनरोल चाहिँ भएको, तर सर्भिसको प्याकेज के हो, कहाँबाट रिसिभ गर्ने होइन, रिन्यू कसरी गर्ने, यी विभिन्न कुराहरूको ग्याप देखियो। त्यसैले अब इन्टेन्सिभ रूपले अब अलिकति इनोभेटिभ रूपले चाहिँ कम्युनिटी बेस्ड अवेरनेस प्याकेजहरू ल्याउन जरुरी छ, जसमा चाहिँ लोकल लेभल, डिस्ट्रिक्ट लेभल अथवा प्रोभिन्सलाई इन्भल्भ गराएर हामी यो चाहिँ यस्ता यी प्रोग्रामहरू चाहिँ हामी इम्प्लिमेन्ट गर्न सक्छौँ। हस्, थ्याङ्क यू। यहाँहरूको फिडब्याक।
Sankarji, you brought very important questions that we still, Professor Adhikari and we can recall that we haven't introduced the insurance system in Nepal that long. But the increasing number of the scientists, the professional like you, have shown the interest to study how insurance is moving in this country. I think you are giving some very good policy messages to the policymaker. Our next presenter is Ms. Junu Shrestha, the single female presenter of the day. We would like to call upon you. You are presenting today pattern of refractive error and actual willingness to pay for spectacle, sorry for my English, in patient visiting optical of tertiary hospital in Kathmandu Valley. Junuji, you are welcome.
Today I'm here with my presentation, Pattern of Refractive Error and Actual Willingness to Pay for Spectacles in Patient Visiting Optical of Tertiary Hospitals in Kathmandu Valley. Here goes the outline of my presentation. Coming to background, refractive error is the second major cause of blindness and first major cause of visual impairment in the world. And in Nepal, also 15% of the Nepalese population are visually impaired at near or at distance. And spectacles are primarily used for correction of refractive error. The social health insurance benefit package has a provisioned amount of Rs 1,000 for spectacles for one person in 1 year. Willingness to pay is the price at or below a customer will buy a service or a product. It's measured by two methods, revealed preference method and stated preference method. Revealed preference method, it depicts the real scenario of purchasing good, and it is dependent on two assumptions, rationality and consistency. The market price of a product or service is directly related to its attributes or a particular combination of attributes. The willingness to pay is calculated in this revealed preference method by hedonic model. My objective of the study is to determine the pattern of refractive error and actual willingness to pay for spectacles in patient visiting optical of tertiary hospitals in Kathmandu Valley and to identify the preference to spectacle attributes. These are my different study variables, including the spectacle attributes. They are frame material, lens type, other variables like socio-demographic variables, spectacle wear, and attitude on spectacles. So I have implied quantitative cross-sectional design, and the study population are the patients who purchase spectacles from the optical inside the hospital premise. It has implied two stages cluster random sampling, first being hospital and second being the patient. Sample size was 605 with number of cluster 15, and face-to-face interview was implied as a study technique. Coming to result, total 567 participants were enrolled in the study, in which 51% were female. The age of participants ranged from 18 to 70 years with mean age of 36.83 years. Participants belonging to Janjati were majority in this study. Similarly, more than 70% of the participants had education above primary level. Service was the main occupation of the participants, and approximately 90% of the participants lived in urban areas. The patients who were wearing since more than 3 years occupied the largest number of patients, which was above 45%, and those who replaced spectacles within 1 year was highest, comprising more than 35% of total participants. Similarly, reading and writing was the major task demanding spectacles. The attitude towards spectacle was calculated by the 7 statement on 5-point Likert scale, which is presented in this error bar diagram. This shows that the third statement has the highest average of 4.55, and the fourth statement has lowest mean value of 2.88. The willingness to pay for spectacle was 1,781.89 rupees, and it ranged from 300 to 10,200 rupees. Astigmatism was the most prevalent pattern of refractive error, which comprised of 45% of total participants, followed by myopia and then hyperopia. Presbyopia was present in 64% of the participants. This is the regression analysis of willingness to pay with spectacle attributes. The honest adjusted beta coefficient takes into consideration of all the variables, whereas adjusted beta coefficient is adjusted for age, sex, education, occupation, spectacle wear history, wealth quintile, sum of attitudes, tax, and tax requiring spectacles. The beta coefficient was 715.4, which is presented in this regression line, and also this is presented in this graph, where the blue line shows the baseline or the provisioned amount in the social health insurance, which is rupees 1,000. And we can see from this graph that the basic spectacles and CR with tint lens type and bifocal lens type, these 3 kind of spectacles are only covered by the provisioned amount of social health insurance. Basic spectacle is the one with plastic frame injection, and the lens material of CR with hard coat, and lens type unifocal. The preference to spectacle attribute was also measured, in which the progressive type of lens was highest ranked preference of the participants, and in the lens material, PC with Blu-ray coat was highly preferred. Similarly, plastic frame TR was highly preferred in the frame material. And this shows that the CR with tint lens material was least preferred among the participants. So to the conclusion of my presentation, the provisioned amount is sufficient for basic spectacles, bifocal and CR tinted spectacles. This may not ensure durability and meet the patient preference, which can affect in compliance to correction of refractive error. So all the techniques might be sought for the financing, healthcare financing, like case-based financing also, case-based payment. These are the conclusion of my presentation. Thank you.
Thank you, Junuji. A very nice presentation, and again you beautifully scientifically linked how the reimbursement mechanism and how the unit cost provision through the social health insurance corroborates in terms of basic spectacle that you describe here. And it's nice to hear that the reimbursement, the amount is sufficient to offset the cost of the care, which is really interesting. And with this, I think this session is now over. That's the final presentation we have today. And we're quickly going through the questions that we received from the various scientists, the researchers, students, and the professional to our valued presenters. So let us quickly walk through the questions that we received from various people. The first question goes to Kesav Sanjayal. Kesavji, are you there? You have two questions. The two questions to Keshav Sanjel. One is on the use of health information system that you presented. The question is 53% poor health information system used in the Karnali province tells that the system and information use is very poor in Karnali province. The question to you here is, do you have any specific recommendation how the system use can be improved? What are the ways to use the system by the health worker? Keshav.
Really frustrating for governance system with to health information system performance. Yeah, as studies suggested, we have to focus on all system building blocks. Health information system is just one block of the health. So overall, we have to integrate all the system blocks for improvement and for strengthening the health information performance. As study suggested, we have to integrate all the verification criteria that we presented earlier, and that's the major point to improve performance, I think. Thank you.
So you got the two questions. Next question is, health worker in Karnali do not seem to know much about the program. Its p-value is 0.47, but the service provided by the health worker is good. Okay? It's your p-value is less than 0.01 or it's just 0.47. Can you clarify?
Thank you. This is the question from Birbadur sir. Thank you so much. Yeah, I agree with you that performance status was not associated with health staffs who were aware about their duty. But considering the staff's performance appraisal, those health facilities doing staff performance appraisal were associated with health performance. That's the good point that raised by sir. Thank you, sir.
So one quick suggestion from us to you is, you basically analyze the supply side indicators using the basically HMIS data. It would be useful if you could see, okay, the forms on the nutrition not being used by, not being entered by the health worker, but how it impact on the utilization, whether the number of nutrition service user reduced because of not having the forms or not. That could be useful in the future. Maybe you have done already, and if you write next paper, maybe good to compare how the demand and supply side indicator works in terms of health system strengthening in Karnali. Thank you. It's a very good attempt.
Thank you so much.
Okay, Sivaram Khatiwada. तपाईलाई तीनवटा क्वेसन छ। जीवन बहादुर श्रेचन अनि छवि अनि श्रीबहादुर पराजुलीले सोध्नु भएको छ। पहिलो क्वेसन छ, रुरल अर्बन डिफरेन्सेस केही पाइयो कि पाइएन क्यान्सरको केसमा, अनि कस्ट चाहिँ त्यसमा फरक थियो कि थिएन, अनि फ्यामिलीको सपोर्टमा केही फरक थियो कि भन्ने छ। मैले एकैचोटि क्वेसन सोधेँ। अनि दोस्रो चाहिँ अब इन्कम कसरी बढाउने हो त क्यान्सर चाहिँ को कस्ट चाहिँ कभर गर्नलाई भनेर हाम्रो छवि सरले सोध्नु भएको छ। अनि त्यसपछि डाक्टर श्रीबहादुर पराजुलीले चाहिँ सब्सिडी एमाउन्ट चाहिँ क्याल्कुलेसन गर्नुभयो भनेर सोध्नु भएको छ। तीनवटा यो आयो। प्लस मैले अलिकता यही मौकामा अलिकता जोड्न चाहेँ, तपाईँले 3,87,000 चाहिँ कस्ट लाग्यो भनेर सोध्नु भएको थियो। लङ टर्म केयरको केसमा हामी चाहिँ टोटल कस्ट भन्दा पनि पर एपिसोड कस्ट मार्जिनल कस्ट भन्छौँ, त्यसलाई क्याल्कुलेसन गर्छौँ। किनभने तपाईँले अहिले क्याल्कुलेसन गरेको यसपछिका लाइफमा हुने कस्ट पनि चाहिँ फेरि बढी भइरहेकै हुन्छन्। त्यो हुनाले लङ टर्म केयरको केसमा अहिले जति बेला तपाईँले स्टडी गर्नुहुन्छ त्यति बेला मात्रै क्वेसन सोधेर स्टडी गर्यो भने त्यो बायसनेस आउँछ। त्यो हुनाले तपाईँले के मार्जिनल कस्ट हो यो अथवा टोटल कस्ट हो, यसमा पनि अलिकता क्लियर भयो भने राम्रो हुन्छ होला। हुन्छ, ल तपाईँलाई चाहिँ फ्लोर दिएँ।
Thank you for your comments and your queries. Rural urban कोमा त्यति खासै सिग्निफिकेन्ट डिफरेन्स देखिएको छैन र फ्यामिली सपोर्टको कुरा पनि मैले चाहिँ उठाएर रहेनछ। अनि त्यस्तै अब सब्सिडी एमाउन्ट भनेर टोटलमा मैले हेरेको छैन, सब्सिडी युज गरेको र युज नगरेको मात्रै मैले खोजेको हो त्यो स्टडीमा। अनि त्यस्तै सरले भन्नुभएको छ कि यो मार्जिनल हो कि टोटल हो, हामीले चाहिँ त्यो एट द टाइम अफ स्टडीमा चाहिँ सर्भिस युटिलाइजेसनको त्यो क्वेसन सोध्ने बेलासम्मको कस्ट मात्रै हेरेका छौँ भनेपछि अझै सर्भिस युजरहरूले अझै सर्भिस युज गरिरहनु भएको थियो भनेपछि उहाँहरूको कस्ट त्योभन्दा पनि धेरै आउन सक्छ। र यसमा अन्य कुराहरू पनि मैले भन्नुपर्छ होला, जस्तै हामीले स्टडी गरेको सेन्टर चाहिँ अलिकति नन प्रफिट अर्गनाइजेसनले चलाएको सेन्टर हो भनेपछि अन्य सेन्टरमा उपचार गर्दा वा विदेशमा उपचार गर्दा अभियसली कस्ट एकदम धेरै हाई हुन्छ। भनेपछि क्यान्सरले साधारणतया गभर्मेन्ट वा कम्युनिटी अर्गनाइजेसनहरूले रन गरेको हस्पिटलमा पनि बर्डनसम छ भने अरू सेन्टरमा चाहिँ धेरै बर्डनयुक्त हुनसक्छ। त्यसकारण हामीले प्रिभेन्टिभ मेजरहरू अन्य मेजरहरूलाई पनि ध्यान दिनुपर्छ। त्यस्तै इन्कम जेनेरेसनको कुरा छ। इन्कम जेनेरेसन त अब यो एउटा ब्रोड र भेग टर्म भयो, हाम्रो स्टडीले एउटा त्यो पनि हुनसक्छ कि भनेर हामीले चाहिँ रिकमेन्डेसनमा गरेको, जबकि हाम्रो इन्टरनेसनल्ली हेर्दाखेरि हाम्रो इन्कम लेभल एकदम कम तर कस्ट चाहिँ हामीले चाहिँ इन्टरनेसनल जस्तै जस्तै बियर गर्नुपर्ने हुनसक्ने। जस्तै अब हामीले ट्रिटमेन्ट लिन्छौँ विदेशमा बनेको केमोथेरापीहरू आउँछ भनेपछि हामीलाई यो बर्डनसम छ, यसलाई हामीले विभिन्न मल्टिपल एङ्गलबाट एड्रेस गर्ने कोसिस गर्नुपर्छ जस्तो लाग्छ।
हस्, धन्यवाद। होइन मैले पनि अलिकता सजेसन दिएँ होइन, यसरी टोटल कस्ट निकाल्दा कहिलेकाहीँ मिसलिड गर्छ। त्यो हुनाले पर एपिसोड कस्ट भन्छौँ, पर भिजिट कस्ट भन्छौँ। त्यसरी पर भिजिटको कस्ट निकाल्ने अनि नम्बर अफ भिजिट पोसिबल कति हुन्छ त्यसपछि प्रोजेक्सन गरेर हामीले कस्ट निकाल्नुपर्ने हुन्छ। यसरी निकाल्यो भने कहिलेकाहीँ हामीले मिसलिड गर्छ। तर चाहिँ खुसी केमा छौँ भने जस हेल्थ इकोनोमिक्सको एरियामा कस्टिङको एरियामा तपाईँको इन्ट्रेस्ट देखियो, तपाईँले काम गर्नुभएको छ, यसको लागि धन्यवाद।
Thank you sir for your nice suggestion. Thank you.
साथै यहाँलाई if you need further any support, you can reach out to Professor Adhikari and myself, because we involved ourselves, engaged ourselves from the very beginning in designing health insurance in Nepal, and know little bit about the science around health economics. You are welcome. Next question, Gautam Jilai cha prashna. प्रश्नले के भन्दैछ भने यो गण्डकी प्रदेशमा त धेरै इन्स्योरेन्सले काम गरेन जस्तो देखियो तपाईको प्रस्तुतिबाट। यो गण्डकी प्रदेशमा स्वास्थ्य बिमाको अवस्थालाई सुधार गर्न के गर्न सकिन्छ होला भन्ने हाम्रो प्रश्न छ। तपाईलाई छविजीले सोध्नु भएको छ। Is there any specific the question तपाईले बागलुङमा गर्नुभयो, the question coming is like how to improve the implementation of health insurance program in Gandaki province.
Basically यो कास्कीको केसमा हेर्नु पर्दाखेरि अझै पनि हेल्थ इन्स्योरेन्सको अवेरनेसको प्रोग्रामहरु अलि कम भएको हुनाले चाहिँ त्यसमा चाहिँ धेरै नै हेल्थ इन्स्योरेन्स मान्छेहरु बढी भए पनि युजमा प्रब्लम आएको देखिन्छ। त्यसमा त्यसैगरी लिमिटेड प्याकेज र सर्भिसको कारणले गर्दा पनि मान्छेहरु इन्स्योरेन्सबाट मात्र नभई सेल्फ र इन्स्योरेन्स दुईटै मोड अफ पेमेन्ट युज गर्नुभएको कारणले पनि त्यसलाई पनि सुधार गर्ने सकिन्छ जस्तो लाग्छ। प्याकेजलाई र सर्भिस कभरेजलाई बढाएर त्यस्तै गरी अर्को अपरेसन लेभलमा कतिपय पेसेन्टहरुमा चाहिँ हेल्थ इन्स्योरेन्सबाट ट्रिटमेन्ट गर्दाखेरि टाइममा बढी स्पेन्ड भएको कारणले पनि डिसेटिस्फाई भएको कुराहरू पनि पाइयो। ती कुराहरूले चाहिँ ओभरअल चाहिँ अवेरनेस प्रोग्राम प्याकेज र सर्भिस प्याकेज बढाउनुलाई चाहिँ म चाहिँ हेल्थ इन्स्योरेन्समा चाहिँ बढी रिकमेन्ड गर्न चाहन्छु।
गौतमजी, तपाईँको राम्रो प्रेजेन्टेसन थियो। मसित एउटा क्वेसन आयो। जस्तै तपाईँको नन इन्सुरेन्सको चाहिँ लगभग कति 2212 रुपियाँ जति खर्च गरेर रहेछ, इन्सुरेन्सको चाहिँ 814 जति, अनि इन्सुरेन्सको मान्छेले त 3500 पनि खर्च गरे हुन्छ भनेपछि त तपाईँको फाइनेन्सले के देखायो भने 3500 प्लस 814 हो भने त नन इन्सुरेन्स गर्दा बढी फाइदा हुने हो कि जस्तो पो देखियो त यहाँ, होइन? त्यसो हुनाले मान्छेले त आफ्नो क्यालकुलेसन पनि गर्छ। के हामीले चाहिँ नेगेटिभ लिस्ट चाहिँ बढी राखेर यस्तो क्वेसन आएको हो? तपाईँलाई कस्तो लाग्यो?
यो चाहिँ ओपिडी पेसेन्टमा गरिएको रिसर्च हो सर। यो वान टाइम गर्दाखेरि चाहिँ एउटा डिजिजको लागि चाहिँ एक टाइम प्रचलन जाँदाखेरि आएको ओभरअल कस्ट हो सर। यसमा के देखिएछ भन्दाखेरि इन्सुरेन्स गरेकै मान्छेको कम 4.6 टाइम्स लेस देखिएछ सर यसमा चाहिँ। स्पेसली म चाहिँ मेरो विचारमा, मेरो एकोर्डिङ टु माई डाटा, स्पेसली इन्सुरेन्सलाई नै घटाएको पाइएको छ सर।
अनि मेरो पनि एउटा जिज्ञासा तपाईँलाई, राम्रो छ प्रस्तुति। हामीले तपाईँले हेल्थ इकोनोमिक्स पढ्नुभएछ, एकदम खुसी लागेको छ कि हामीलाई। अब अझै पढ्ने यात्रा जारी होस्। साथसाथै प्रश्न के हो भने आउट अफ पकेट पनि एड्रेस भयो समाउ भन्ने आयो कुरा, होइन? अनि इन्सुरेन्स युजर भन्दा नन युजर भन्दा युजरले सर्भिस पनि युटिलाइजेसन गरेको भन्ने आयो। एउटा क्वेसन चाहिँ अलिकति के पनि ध्यान दिनु पर्ला ओभर द टाइम भन्दा, आर वी टेन टु इन्क्रिज द ओभरअल हेल्थ टिएचई, टोटल हेल्थ एक्सपेन्डिचर? कतै हाम्रो इन्सुरेन्सले एउटा सिक पुलमा पुगेर टिएचईलाई पो प्रमोट गरिरहेको छ कि? तपाईँले कतै हेर्नु भएको थियो भने त्यो भन्दा भयो, नत्र फ्युचरको क्वेसन यो हुनसक्छ है।
हजुर, हस्, थ्याङ्क यू सर।
शङ्कर सिंह धामीलाई चाहिँ दुईवटा क्वेसन रहेछ। हाम्रो डाक्टर सूर्य पराजुली र विनोद कुमारको। तपाईँको इन्सुरेन्स चाहिँ जुन अभाइलेबिलिटी छ त्यसमा चाहिँ मान्छेहरू सेटिस्फाई कस्तो थियो, के थियो भन्ने कुरा आयो। अर्को चाहिँ सोसियल हेल्थ इन्सुरेन्स कर्णालीमा डिस्ट्रिक्टमा के होला अथवा अरू क्षेत्रमा इम्प्लिमेन्टेसन गर्दा कस्तो होला भन्ने खालको चाहिँ पनि क्वेसन आइरहेछ। र साथै तपाईँलाई चाहिँ અહીંकै क्वेसन चाहिँ फेरि चाहिँ तपाईँको पनि के आछ भने हेल्थ इन्सुरेन्सको चाहिँ इन्स्योर र नन इन्स्योरको केसमा इन्स्योर केसले चाहिँ सर्टेन एमाउन्ट मात्रै घटायो, पुवर र नन पुवर हेर्नुभयो कि हेर्नु भएन? यसलाई पनि चाहिँ जोडेर उत्तर दिनु होला धामीजी। हो ल धामीजी, फेरि है म दुईवटा क्वेसन छ तपाईँलाई, होइन? ए अफलाइन, ओके।
अब
ल ठिकै छ, होइन?
एउटा अन्तिम प्रश्न चाहिँ हाम्रो जुनुजीलाई पनि आएको छ। ल म अलि डाक्टर साहब टाढा भएको हुँदा पढेर सुनाउँछु उहाँलाई। The question here is, what is the source of 15% population is visually impaired? Was there any national census about the people with a disability? It is more of the epidemiological question. Dosro question, Junu, can you elaborate more on the progressive as number one preferred attributes? Let me understand this question. Are people prefer costly items than cheaper, or interpretation is something different than that? So the basically question is what people preferred. Is it quality, is it cheaper, or the flashy, the options? The first one on the epidemiology, second one on the cost. Could it, over Januji.
Thank you for the question.
The first one, 15% of visual disability, the source for that. I have taken this source from the report from the Nepal Netrajyoti Sangh survey. I think that can be comparable in Nepal because other surveys for visual impairment in Nepal for all age group population is not available. The other surveys that are available only covers the older age groups. And the next is the question is the most preferred one, that is the progressive. Progressive lens type is the one which includes both the distance and near power and without any transition in between that. The similar type of the lens type is the bifocal lens, which we can clearly understand, which includes the near and distance with transition, but progressive is the one without any transition. So that spectacle looks like the simple glasses, but it includes both the power at distance and near. So from my study, the progressive was found to be the most preferred lens type. And over the next question, cheaper or costly, which was preferred mostly by the participants? I think the answer would be mixed because from the analysis it was calculated that the costly was most preferred. But looking into the quantity, also the basic spectacle types, which was covered by the provisioned amount in social health insurance, was also preferred by the participants. Thank you.
Okay, Junuji, thanks. एउटा जिज्ञासा हामीबाट पनि के छ भने when we sometimes say about offset the cost, we need to think about what does that actually means, whether it really cover the indirect cost, direct cost only, whether it covers the inflation, if it is offsetting now, was it making the profit last year? These are the questions when you go when you dive down the detail of the naughty health economics. Yeah, but you have done wonderful exercise study. Keep it up, and it's really needed such kind of study in Nepal. You don't need to answer this, but just intuition from our side. Thank you.
Thank you, sir. Thank you, sir.
So shall we conclude quickly? This session been very informative, though quite focused presentations, governance one, and most of the health economics related, health financing related, most interestingly, the social health insurance related presentations were there. We aim that by this time or a bit earlier next year, NHRC will be conducting similar scientific forum where we expect more presentation in governance and health financing, because we really need to put our eyes and mind focused exercise on how Nepal healthcare system should be financed. Is it enough, and what is enough, and what are the ways of telling? For example, people are telling about cost effectiveness threshold. Today, our country, we are still struggling, what is it? And whether a rupee added in through the Ministry of Finance really help in bringing more people into the system and help reduce the morbidity and mortality in the country. That level of scientific rigor and exercise is need of today. We will call, together with Professor Adhikari, I would like to call all of the scientists across the world, let's have a more rigor, science-based health financing, health economics related study. We want to be part of with you. Let's work together and give some specific recommendation to our country. Thank you. Over to Professor Adhikari.
Thank you, Dr. Suresh. Yeah, my expectation is there should be the one paper on impact on economic impact of COVID-19. I think it will be more interesting. I hope that next year we'll have such type of paper. र मैले यो बिचमा चाहिँ काम पनि अलिकता गर्नु गएको थिएँ, त्यो हुनाले अलिकता थोरै सेयर गर्नु पनि चाहेँ सर्टली। हामीले हिजोसम्म के भन्दै थियौँ भने हेल्थ सेक्टरमा चाहिँ अरू सेक्टर के बिग्रियो भने हेल्थ सेक्टरमा इम्प्याक्ट आउँछ, अरू सेक्टर कहीँ चाहिँ इनएफिसियन्सी आयो भने हेल्थ सेक्टरमा इफेक्ट आउँछ भन्दै थियौँ। यो मात्रै होइन रहेछ, अहिले त लेसन के देखायो भने हेल्थ सेक्टर पनि बिग्रियो भने त इकोनोमीमा पो आउने रहेछ होइन, इफेक्ट त त्यसरी पो हेर्नु पर्ने रहेछ भन्ने देखियो। र हेल्थ र इकोनोमी चाहिँ ट्रेड अफ पनि देखियो। तर कहीँ न कहीँ ट्रेड अफ मात्रै होइन, कोरिलेसन कहाँनिर देखियो फेरि कोभिड-19 पनि अलि हेल्थ विक भएको मान्छेहरूलाई अथवा चाहिँ त्यो समुदायलाई चाहिँ एट्याक गर्ने रहेछ, इकोनोमी पनि जहाँ विक छ त्यहीँ नै एट्याक गर्ने रहेछ, त्यहाँनिर कोरिलेसन चाहिँ देखियो। यसै सन्दर्भमा चाहिँ अलिकता यो अर्थ मन्त्रालयले एउटा स्टडी गर्नु पठाएको थियो बिफोर बजेट एनाउन्सिङ द बजेट। त्यो केसमा हेर्दाखेरिमा त्यसमा म डाइरेक्ट इन्भल्भ भएको हुनाले अलिकता सेयरिङ गर्न चाहिँ सजिलो होला भनेर, पोभर्टी चाहिँ बढ्यो कोभिड-19 को कारणले चाहिँ अहिलेसम्मको हेर्दा 1देखि 1.5देखि 2%सम्म पोभर्टी बढिरहेछ। जुन नन पुवर थियो तिनीहरू पुवर भए, लगभग 12 लाख मान्छेहरू बेरोजगार देखियो यही अवस्थाले। त्यति मात्रै होइन, एग्रिकल्चरमा पनि लेबर चाहिँ फोर्स चाहिँ 13%ले चाहिँ बर्डन थपियो बाहिरबाट त्यहाँ एग्रिकल्चरमा थपिएको छ। त्यस्तै गरी चाहिँ के देखियो भन्दा हेल्थ बाहेक, हेल्थले जति इकोनोमिक ग्रोथमा पनि कन्ट्रिब्युसन गर्छ, हेल्थले गरेको कन्ट्रिब्युसन चाहिँ लगभग 1.5%ले इन्क्रिज भयो यो कोभिड पछि, तर अरू सेक्टरमा सबैमा चाहिँ ग्रोथ चाहिँ डिक्रिज भयो। त्यो हुनाले अरू सेक्टरमा नेगेटिभ इम्प्याक्ट पर्यो, तर हेल्थ सेक्टरभित्र ग्रोथमा चाहिँ इम्प्याक्ट चाहिँ, किनभने हेल्थ सेक्टरको मान्छेहरू बढी मेहनत गर्नुभयो, बढी काम गर्नुभयो होइन, क्वारेन्टाइन बनायो, के बनायो चाहिँ होइन, पहिला नबनाएका चिजहरू बनायो, त्यो हुनाले त्यसले ग्रोथमा चाहिँ इफेक्ट गर्यो। ओभरअलमा चाहिँ के देखियो भन्दा अलमोस्ट 5%ले चाहिँ नेगेटिभ भनौँ, जुन एक्सपेक्टेसन थियो त्योभन्दा 5%ले चाहिँ ग्रोथ घट्यो। त्यो हुनाले कोभिडको इम्प्याक्ट चाहिँ हेल्थ इकोनोमीमा अथवा यसमा चाहिँ बढी नै देखिन्छ। र अहिले चाहिँ इस्यु के आयो भने हेल्थ मात्रै होइन, अब इकोनोमिक्स अथवा यो इस्युहरूमा पनि सँगै जानुपर्ने रहेछ, यसलाई पनि चाहिँ प्रायोरिटीमा राखौँ भन्ने देखियो। योभन्दा बढी छलफल नगरौँ होइन, टाइम चाहिँ होइन अलिक कम छ। र सबै पेपरहरू राम्रो थियो र राम्रो पनि छ र इन्ट्रेस्ट पनि जागिरहेछ र सकेसम्म चाहिँ 2टा सेसन जति बनाउनु पायो भने अर्कोचोटि अलिकता यो इस्युलाई अलिक फरक हुन्छ होला भन्ने लाग्छ। तर यसको अर्थ म हेल्थ इकोनोमिक्समा लागेको हुनाले भने होइन कि सिस्टमले डिमान्ड गर्छ भनेको। यति भन्दै यहाँहरू सबैले चाहिँ टाइम पनि दिनुभयो, हामीलाई होइन जुन हाम्रो कुरा सुनिदिनु भयो, हामीलाई अवसर दिनुभयो, यसको लागि धन्यवाद। हामी सँगै छौँ, सुरेश सरले भने जस्तै हामी सँगै छौँ, हामी बाहिर भए पनि होइन, सिस्टमभित्र भए पनि, जहाँ पनि सबैलाई, रिसर्चरलाई र सिस्टमलाई दुवैलाई सहयोग गर्न तयार छौँ। धन्यवाद।
Thank you so much, Professor Dr. Sivaraj Adhikari, Dr. Suresh Tiwari, and all the presenters for making the session vibrant. Finally, to wrap up the session, I would like to invite Vice Chairperson of NHRC, Dr. Vojrad Adhikari, and our Executive Chief, Dr. Pradeep Gewali, to hand over the token of love to our respected chairs, Dr. Sivaraj Adhikari. Dr. Suresh Tiwari. Thank you.
break. Sorry. Good afternoon all. Hope you all are enjoying the program. Myself Ranjita Subedi, Research Officer. I will be the host for this session. Today, the world is moving towards digitalization. With the current COVID-19 pandemic, the need of digital technology in health has become even more demanding. Environmental health and biomedical science are also emerging issues in this current scenario. Hence, now we are going to conduct a very interesting session on digital health, environmental health, and biomedical research. I am sure that this session will be very informative. To initiate the session, I would like to invite Dr. Krishna Prasad Adhikari and Professor Dr. Yogendra Prasad Singh as chairs. Please welcome our respected chairs with huge round of applause. Dr. Krishna Prasad Adhikari is a registrar and a spokesperson at Nepal Medical Council, chairman and radiologist at Helping Hands Nepal, and visiting professor of radiology and community medicine at 3 George University Medical College, China. He has also been the former chairperson at Nepal Health Research Council. He has done MBBS, Doctor of Medicine, and MPH from Tribhuvan University. He has a lot of experience working as an advisor for WHO and Ministry of Health and Population. He has more than 20 years of teaching and management experience. It's our honor to have you here, sir.
Thank you.
Dr. Yogendra Prasad Singh is a professor of surgical oncology and research director at Tribhuvan University Teaching Hospital, IUM. He has completed MBBS from TU and MD from Kansai Medical Institute, Osaka, Japan, and has done PhD. Dr. Singh has published more than 50 articles in peer-reviewed journal and is one of the nationally renowned physicians with expertise on breast cancer. He has also supported us on establishing population-based cancer registry in Nepal. It's our privilege to have you here, sir. We have 4 presenters in this session: Ramesh Shrestha, Dinesh Pandari, Roshan Pandit, and Sanjay Prasad Gupta. I would like to welcome our presenters in this session. and we will display their recorded presentation. However, they are required to remain online throughout the session. At the end of the session, we will have Q&A where the comments obtained via Zoom will be addressed accordingly. Now, with this, I would like to hand over this session to our respected chairs. Thank you.
Thank you for your nice words. This session is almost a 1 hour session. There are 4 papers, and as mentioned, this is of diverse field, maybe starting with digital health, environmental health, and biomedical research and so. So we have 4 very informative papers, and we like to call upon the first speaker, Ramesh Shrestha, who is talking on this acceptability, feasibility of digital technology for community health workers to deliver community-based healthcare in rural Nepal. Maybe this is a very pertinent topic of digital health because of this COVID-19 pandemic also. This is one of the paper. So may I invite Ramesh Shrestha to present his paper.
यहाँहरु सम्पूर्णमा S6 नेशनल समिट अफ हेल्थ एन्ड पपुलेसन साइन्टिस्ट नेपालका निर्णायक मण्डलजीहरु त्यसै गरी यहाँ उपस्थित विशिष्ट व्यक्तित्वहरुमा हार्दिक नमस्कार साथसाथै स्वागत गर्न चाहन्छु। रमेश श्रेष्ठ हेल्थ नेपालको प्रतिनिधित्व गर्दै हामीले गरेको स्टडीको बारेमा यहाँहरु माझमा चाहिँ प्रस्तुतिकरण गर्न गइरहेको छु। हाम्रो स्टडीको टाइटल छ एसेबिलिटी एन्ड फिजिबिलिटी अफ डिजिटल टेक्नोलोजी फर कम्युनिटी हेल्थ वर्कर टु डेलिभर कम्युनिटी बेस्ड हेल्थ केयर इन रुरल नेपाल भनेको छ। यहाँहरुले देख्न सक्नुहुन्छ आउट हाम्रो प्रेजेन्टेसनको चाहिँ 5 वटा क्याटेगोराइज गरेका छौं। त्यो क्याटेगोराइज अनुसार चाहिँ म प्रस्तुतिकरण गर्न गइरहेको छु। साथसाथै भन्नुपर्दाखेरि चाहिँ डिजिटल प्लेटफर्म चाहिँ एउटा विभिन्न अध्ययनले देखाए अनुसार चाहिँ एकदमै यो चाहिँ एउटा युजफुल प्लेटफर्म हो र जसले चाहिँ हेल्थ केयर डेलिभरी गर्न चाहिँ रुरल नेपालमा चाहिँ एकदम सहज गर्छ भन्ने कुरा देखाएको छ। त्यसको लागि चाहिँ कम्केयर आफैमा एउटा डिजिटल प्लेटफर्म हो, एउटा ओपन सोर्स हो, जसले गर्दाखेरि चाहिँ यो चाहिँ एउटा कस्टमाइज पनि गर्न मिल्छ मोबाइल डिजिटल प्लेटफर्म भएको हुनाले, जसले जस अन्तर्गत चाहिँ फ्रन्टलाइनमा रहेको बसेर काम गर्ने हेल्थ वर्करको लागि चाहिँ लो रिसोर्स सेटिङमा चाहिँ काम गर्नेले सहज गराउँछ। हामीले चाहिँ कम्युनिटी हेल्थ वर्कर दोलखा र अछामको लागि चाहिँ यो प्लेटफर्महरु चाहिँ हामीले प्रोवाइड गरेका छौं र यस अन्तर्गत चाहिँ उहाँहरूले चाहिँ सर्भिसहरु प्रोवाइड गरिराख्नु भएको छ। स्पेशली रिप्रोडक्टिभ, म्याटर्नल, नियोनेटल एन्ड चाइल्ड हेल्थमा सीएचडब्ल्यूहरु चाहिँ त्यहीँको लोकल स्थानीय हुनुहुन्छ, उहाँहरूको मिनिमम एजुकेसन एसएलसी पासहरु हुनुहुन्छ, उहाँहरूलाई चाहिँ पेएबल हुनुहुन्छ, स्यालेरिड हुनुहुन्छ, ट्रेन हुनुहुन्छ र डब्ल्युएचओ गाइडलाइन अनुसार चाहिँ हामीले चाहिँ सुपरभाइज पनि गरिरहेका छौं। हाम्रो स्टडीको मेन उद्देश्य भनेको चाहिँ टु एक्सप्लोर एसेबिलिटी एन्ड फिजिबिलिटी अफ युजिङ कम केयर फर कम्युनिटी हेल्थ वर्कर टु डेलिभर कम्युनिटी बेस्ड हेल्थ केयर हो। जस अन्तर्गत नै हामीले यो अब्जेक्टिभ राखेर चाहिँ हामीले हाम्रो अध्ययनलाई चाहिँ अगाडि बढाएका छौं। मेनली चाहिँ सीएचडब्ल्यूहरुले चाहिँ मेन फोकस चाहिँ कन्टिन्युअस सर्भिलेन्स गर्नुहुन्छ प्रेग्नेन्ट वुमेनको, त्यस्तै गरी होम बेस्ड केयरहरु प्रोवाइड गर्नुहुन्छ। एएनसी, पीएनसी अन्डर 2, सीबीएनसी प्रोटोकल अनुसार गर्नुहुन्छ, सर्भिस प्रोवाइड गर्नुहुन्छ अन्डर 2 लाई। साथसाथै पेसेन्ट सेन्टर कन्ट्रासेप्टिभ काउन्सिलिङहरु पनि सम्बन्धित काउन्सिलिङहरु परामर्शहरु चाहिँ प्रोवाइड गर्नुहुन्छ। यहाँले देख्नु भएको छ कम्प्युटरको फिचर्सहरु हामीले चाहिँ प्रत्येक घरलाई चाहिँ युनिक आइडी दिएका छौं। त्यो अनुसार चाहिँ सीएचडब्ल्यूहरुले चाहिँ घर दर्ता, परिवार दर्ता, व्यक्ति दर्ता स्याच प्रोवाइड गर्नुहुन्छ। सेवाको लागि चाहिँ हामीले विभिन्न कोडहरु बनाएका छौं। यहाँले देखिरहनु भएको छ स्लाइडमा। त्यो अनुसार चाहिँ हामीले चाहिँ फर्म्सहरु, क्वेशनहरु डेभलप गरेका छौं र परामर्शको लागि भनेर चाहिँ विभिन्न मेसेजहरु चाहिँ इन्क्लुड गरेका छौं यसमा। त्यही अनुसारै सीएचडब्ल्यूहरुले चाहिँ सर्भिसहरु चाहिँ प्रोवाइड गर्नुहुन्छ। हाम्रो स्टडी सेटिङ भने दुईटा ठाउँमा गरेका छौं, अछाम र दोलखा डिस्ट्रिक्टमा दुईटा ठाउँमा चाहिँ गरेर यो स्टडीहरु गरिरहेका छौं। र मेथोडोलोजीको कुराहरु गर्नु पर्दाखेरि चाहिँ हामीले चाहिँ मिक्स मेथड पर्सपेक्टिभ स्टडी चाहिँ प्रयोग गरेका छौं। यो एउटा इम्प्लिमेन्टेसन रिसर्चको चाहिँ पार्ट हो, जसमा त यसमा चाहिँ हामीले आरएमएनसीएस काउन्सिलिङको लागि चाहिँ विभिन्न फर्म्सहरु डेभलपहरु गरेका छौं केयर डेलिभरीको लागि। कम्प्युटरमा चाहिँ सीएचडब्ल्यूहरुलाई हामीले 1 विकदेखि 7 डेजसम्म चाहिँ हामीले चाहिँ विभिन्न ट्रेनिङहरु दिएर वर्कफ्लोको बारेमा, फर्म्सहरुको बारेमा चाहिँ उहाँहरूलाई चाहिँ कोचिङहरु गराएका थियौं। साथसाथै मेन्टरिङहरु पनि गरेका। र कुनै पनि एक चिज रोल आउट गर्नु भन्दाखेरि चाहिँ उहाँहरूको चाहिँ म्यानेजर या सुपरभाइजर चाहिँ कम्युनिटी हेल्थ नर्स हुनुहुन्छ, उहाँहरूले क्लोज सुपरभिजनमा चाहिँ यो कुराहरु चाहिँ उहाँहरूले चाहिँ मेन्टरिङहरु गर्नुहुन्छ। र साथसाथै यो कुनै पनि इरर आयो भने चाहिँ हामी बाइकली या मन्थली रिभ्यू मिटिङमा चाहिँ डिस्कसन गरेर सर्ट आउट गर्ने गर्छौं। हामीले 102 सीएचडब्ल्यूहरु ल्याएको थियौं जुन सबै CSWहरूले ल्याएको थियौँ अछाम र दोलखाको र हाम्रो स्टडी पिरियड चाहिँ हाम्रो उहाँहरूले डेटा कलेक्ट गरेको इन्फर्मेसन कलेक्ट गरेको मार्च 2017 देखि फेब्रुअरी 2020 सम्मको कुराहरूलाई चाहिँ हामीले समावेश गरेका छौँ क्वान्टिटेटिभको हिसाबमा एनालाइसिसमा। त्यस्तै क्वालिटेटिभको कुराहरूमा चाहिँ 3टा SGT र 3टा इनडेप्थ इन्टरभ्यू गरेका थियौँ उहाँहरूको म्यानेजरसँग चाहिँ। CSWहरू चाहिँ 20 देखि 30 इयर्सको हुनुहुन्छ मेजोरिटीमा चाहिँ, अनि त्यस्तै गरी लेस देन 5 इयर्सको हुनुहुन्छ सर्भिस गरिराख्नु भएको छ। उहाँहरूको मिन एज भनेको 27 छ र मिन अफ एक्सपिरियन्स भनेको 3.09 इयर्स छ। हेल्थ ब्याकग्राउन्डको चाहिँ उहाँहरू 26.50% हुनुहुन्छ। उहाँहरूको भनेको हेल्थ ब्याकग्राउन्ड भनेको चाहिँ एनएम अएबहरू हुनुहुन्छ। उहाँले टोटल फर्म्सहरू डेभलप गरे फर्म फिलअप गर्नु भनेको 5,73,623 फर्म्सहरू फिलअपहरू गर्नुभएको छ र त्यसै गरी इरोड अब्जर्भ गरेको भनेको 0.09% देखि 9.63%हरू छ। म्याक्सिमम इरोड गर्नुभएको उहाँहरूले जस्तै गरी डुप्लिकेसन्स अफ आइडी फर्म्सहरू गलत इन्फर्मेसनहरू चाहिँ गरेको चाहिँ हामीले चाहिँ यसलाई चाहिँ इरोडको रूपमा ल्याएको छौँ र 99%हरूले चाहिँ मिनिमम र एभरेज इरोडहरू गर्नुभएको छ। हामीले एसोसिएसन पनि हेरेका थियौँ र एज र CSWको एज इयर अफ एक्सपिरियन्स उहाँहरूको एजुकेसन ब्याकग्राउन्डले कतिको असर गर्छ त यो इरोडहरू गर्नलाई कतिको गरिरहेछ भन्ने कुरामा हेर्दाखेरि चाहिँ कुनै पनि एसोसिएसन सिग्निफिकेन्ट एसोसिएसन देखिएको थिएन। अनि क्वालिटेटिभ रिजल्टको कुरा गर्नुपर्दाखेरि चाहिँ हामीले चाहिँ एनालाइसिसको कुरा गर्नुपर्दा हामीले एसएसपी र फिजिबिलिटीमा मोर फोकस गरेका थियौँ र यसले गर्दाखेरि चाहिँ CSWहरूलाई एकदमै सहज युजफुल भएको छ, काउन्सिलिङहरू गर्न सहज बनाएको छ र यहाँ भएको अडियो भिडियो मेसेजहरूले चाहिँ एकदम पार्टिसिपेटहरूलाई पार्टिसिपेटेड गराएको छ र यो कम्पेयरमा भएको अटोमेटिक जुन आज भेटेको बेनिफिसियल अर्को नेक्स्ट टाइम भेट्दाखेरि चाहिँ फ्युचर भिजिटमा भेट्दाखेरि चाहिँ टाइम अटोमेटिक दिनु सहज बनाएको छ र एउटा कुरा चाहिँ म CSWले भनेको कुराहरू चाहिँ राख्न चाहन्छु। सजिलो बनाएको छ, सर्वेमा सजिलो छ, बिग्रेमा मात्रै समस्या बनाउँछ। समस्या कहिलेकाहीँ मात्रै हो, कम्पेयरमा त अब कहिले भेट्ने कसलाई भेट्ने सबै देख्न सकिन्छ। गाइड गरिरहेको छ यसले त हामीले भनेर भन्छु कुराहरू चाहिँ एक्सप्रेस गर्नुभएको थियो। सपोर्ट एन्ड सुपरभिजन अनसाइट कोचिङहरू गर्नुहुन्छ उहाँको म्यानेजरले, कम्युनिटी हेल्थ नर्सले विकली बेसिसमा त्यहीँ फिल्डमा गएर कुनै त्यस्तो प्रब्लम भएर तुरुन्त सल्भ आउट गर्नुहुन्छ। कन्टिन्युस सपोर्टहरू पनि गर्नुहुन्छ, जस्तै बाइब्लिक मिटिङमा के कस्तो भइरहेछ, कम्पेयरमा कस्तो इस्युहरू च्यालेन्जहरू आएको भन्ने कुराहरू पनि गर्नुहुन्छ। एउटा कोड छ यहाँहरूले देखिराख्नु भएको छ। त्यस्तै गरी मोनिटरिङ एसोसिएट पनि हुनुहुन्छ। मोनिटरिङ एसोसिएटले उहाँहरूले गरेको कलेक्ट गरेको डाटाहरू जुन सर्भरमा आएको कुराहरूलाई एनालाइसिस गर्ने एडिटिङ गर्ने कामहरू गर्नुहुन्छ। 1 आवरदेखि 2 आवरसम्म हामीले चाहिँ सेपरेट गरेको हुन्छ टाइम, अनि त्यो टाइममा चाहिँ सबै लास्ट 1 मन्थको अवस्था, लास्ट CSW मिटिङदेखि उहाँले आउनुभएको टाइम सबैको सम्मको चाहिँ हामीले डाटा क्वालिटीहरू चाहिँ चेक गर्छौँ। त्यसमा के कुराहरू उहाँहरूले गरिराख्नु भएको छ, के कुराहरू इरोड गरिराख्नु भएको छ, इरोड चाहिँ किन भइरहेको छ र विगत टाइममा त्यो इरोड थियो कि थिएन, प्रश्नकर्तामा भन्ने कुराहरू चाहिँ लास्ट टाइम किन भइरहेको छ भन्ने कुराहरू चाहिँ हामीले उहाँहरूसँग डिस्कसन गर्छौँ भनेर जुन मोनिटरिङ एसोसिएट हुन्छ उहाँले त्यो गर्नु। त्यस्तै गरी फिजिबिलिटीको कुराहरूमा पावर ब्याङ्क, त्यस्तै गरी इन्टरनेट डिभाइसहरू उहाँलाई दिएको भएको हुनाले चाहिँ डाटाहरू सिङ्क गर्न, मोबाइलहरू चार्ज गर्न चाहिँ एकदम सहज भएको कुराहरू चाहिँ एक्सप्रेस गर्नुभएको छ। त्यही भएर फिजिबल भएको कुराहरू, जस्तै गरी बाइकलिङ मिटिङमा आउँदाखेरि उहाँले डाटा सिङ्क गर्दा चाहिँ एकदमै सहज भएको कुराहरू चाहिँ गर्नुभएको थियो, एक्सप्रेस गर्नुभएको थियो। विभिन्न जुन हाम्रो क्वान्टिटेटिभ क्वालिटेटिभ जुन हामीले डाटाहरू एनालाइसिस गऱ्यौँ त्यसको आधारमा चाहिँ हामीले निष्कर्षहरू चाहिँ निकालेका छौँ र जुन निष्कर्षहरूमा चाहिँ हामीले के पायौँ भन्दाखेरि चाहिँ कम्पेयर चाहिँ एकदम एक्सेप्टेबल फिजिबलहरू एकदम फिजिबल छ। जुन कम्युनिटी बेसमा हेल्थ केयर सर्भिस प्रोभाइड गर्नको लागि कम्युनिटी हेल्थ वर्करको माध्यमबाट, त्यस्तै गरी ट्रेनिङ, क्लोज सुपरभिजन, मोनिटरिङ, बाइब्ली एन्ड मन्थली चेक इन आर द की टु एसेप्टेबिलिटी, यी कुराहरूले चाहिँ एकदम एक्सेप्टेबल छ ट्रेनिङहरूले गर्दा भन्ने कुराहरूसम्म पुग्यो। त्यस्तै गरी विभिन्न च्यालेन्जहरू छ रिमोटनेसमा, त्यसलाई मिटिगेट गर्नको लागि चाहिँ हामीले चाहिँ केही कुराहरूमा सपोर्ट गर्नुपर्ने रहेछ भन्ने कुराहरू पनि हामी निष्कर्षमा पुग्यौँ। जस्तै पावर ब्याङ्क, इन्टरनेट अप्सन्सहरू चाहिँ दिनुपर्ने रहेछ टु प्रमोट फिजिबिलिटी अफ डिजिटल टुलको लागि भन्ने कुरा एउटा निष्कर्ष निकाल्यौँ। दोस्रो कुरा भनेको चाहिँ विथ कन्स्ट्यान्ट सपोर्ट द युज अफ डिजिटल टेक्नोलोजी टु प्रोभाइड हेल्थ केयर सर्भिस एट कम्युनिटी लेभल सिम टु बी फिजिबल एन्ड एक्सेप्टेबल इन रुरल नेपाल भन्ने कुराहरू चाहिँ हामी निष्कर्षमा पुग्यौँ। यति नै हो निष्कर्षको 4वटा पूर्ण बुदामा चाहिँ हामीले यसलाई कन्क्लुड गऱ्यौँ र यति नै हो मेरो प्रस्तुतिकरण। यहाँहरूलाई धेरै धेरै धन्यवाद। यहाँहरूको केही सल्लाह सुझाव कुनै प्रश्नहरू छ भने यहाँहरू राख्न सक्नुहुन्छ। यहाँहरूलाई धेरै धेरै धन्यवाद भन्दै फ्लोर ओपन गर्न चाहे। हस्त धन्यवाद।
थ्याङ्क यू। धेरै राम्रो प्रेजेन्टेसन। अब सायद क्वेसन एन्सर लास्टमा गरौँला। Stay with us.
Yeah, it was very timely. 2 minutes, almost 3 minutes before deadline. Our Dinesh Pandari, temperature dependent transmission of rotavirus infection in Kathmandu, Nepal. Now you can start.
with my presentation entitled Temperature-Dependent Transmission of Rotavirus Infection in Kathmandu, Nepal. So let's begin with the introduction first. Rotavirus remains one of the leading causes of death among children below 5 years of age globally. In 2016 alone, more than 128,000 deaths were recorded among children below 5 years of age due to rotavirus. In context of Nepal, the overall prevalence of rotavirus has been found to be between 22 to 33%, and death has been recorded to be around 50 to 100 deaths for 1 lakh infected cases. So what role does meteorological factor play in transmission of rotavirus? This is the important question that we're going to answer through this research. So the research carried out throughout the world, what it has reported is like in temperate region, there is increased transmission of rotavirus in winter, whereas in tropical region, the prevalence of rotavirus is, overall year round. So in this study, what we are going to do is we are going to discern the role of meteorological factor in rotavirus transmission in Nepal, and we aim to provide very crucial information to the Infection Control Planning Division to control the infection of rotavirus in context of Nepal. So the study setting for this study is Kathmandu district, which has which lies in warm temperate zone and has humid subtropical to subtropical highland type of climate. That means the average summer temperature for Kathmandu is between 28 to 30 degrees Celsius, and winter temperature is between 8 to 10 degrees Celsius. And it receives nearly 1400 millimeter rain throughout the year. And the overall population of children under 5 years of age, which was recorded in 2011, was somewhere around 111,000. That means the density of under 5 years population in Kathmandu is somewhere around 4,000 per square kilometer. So the data that we have analyzed for this study were obtained from Public Health Research Laboratory, which is the only surveillance laboratory, a part of Global Rotavirus Surveillance Network in Nepal. We collected weekly count of laboratory confirmed data during the study period 2013 and 16. And similarly, corresponding climate data for the study period were obtained from Department of Hydrology and Meteorology. So we carried out ecological time series study design fitted with distributed lag nonlinear model. And we studied the effect of 3 different temperature indices on transmission of rotavirus infection. And our models were adjusted for seasonality, long-term variation, as well as other confounding meteorological variables, including humidity and rainfall. So this graph over here shows the overall distribution of the study variables recorded during the study period. So I'll go more deep into this graph and present some summary in the following slide. So the maximum temperature recorded during the study period was 33 degrees Celsius, whereas the lowest minimum temperature was around -8 degrees. And the highest number of weekly rotavirus cases detected during the study period was 11 and lowest was 1. So when we fitted the distributed lag nonlinear model, we got this result. So the left panel over here shows the 3-dimensional image of rotavirus risks versus different temperature indices and lag. And the one on the right, it's exposure response curve for rotavirus infection versus various temperature. So when we look into this graph at the right panel, the topmost graph for maximum temperature, what it shows is that towards the lower percentile of temperature, that means when we move towards the lower temperature, the increase of rotavirus risk increases. Whereas when we move towards the right side, the risk of rotavirus infection decreases. This is moreover consistent for all 3 temperature indices. But when we look at the maximum temperature graph, we see that the risk slightly tends to increase when the temperature is above 30 degrees Celsius. However, the result is not statistically significant. And what we observed was during those study period, the rainfall amount was very low and it was very dry with low humidity. So maybe that could explain this aberrant result that we obtained for maximum temperature. So let's delve more detail into this. So what I have done in this graph is extracted rotavirus risks versus different temperature percentile. as we see, when we move towards the higher temperature percentile for all three temperature indices, the risk of rotavirus infection decreases. That is, higher temperature is protective. Whereas when we move towards the lower temperature percentile, which is 10th and 25th, represented by green and red in this forest plot, the risk of rotavirus infection tends to increase. So this is the extracted result for different percentile of temperature versus risk of rotavirus infection. So what we have found, what is the take-home message from this research is that lower temperature poses high risk for rotavirus transmission in Kathmandu. We didn't observe any association between rainfall and relative humidity. And our finding is very much in line with previous literature, I mean studies carried out elsewhere in the world, which have reported 1 to 10 degree decrease in rotavirus infection cases for 1 degree rise in minimum temperature. So the plausible explanation for our findings, maybe it's due to increased survival of virus in low temperature, or maybe due to reduced hygiene practice, such as hand washing during winter, or maybe due to overcrowded living condition. As we see in Kathmandu, we are living in very highly overcrowded condition, which means increased proximity tends to increase the risk of virus transmission. So the significance of this study is that our findings can inform infection control planning, especially considering the role of temperature in transmission of rotavirus risk in Kathmandu. And the future research in this sector can be carried out to identify the appropriate transmission pathway. As we have seen, there is association, means there is some interaction going on between the host and environmental factor that is easing or facilitating the transmission of rotavirus during cold days or winter season, whatever we call. And the limitation of this study was low sample size and the use of data from only single surveillance site. That is, we have only one surveillance site for rotavirus infection in Kathmandu, which was during this study period. Maybe it's changed. So this is all I have to present at the moment, and any questions and queries, they are welcome. I'm very much happy to answer your questions and queries. Thank you very much.
Thank you, Dinesh Bhandari. Your time management again, very good, within 7 minutes. Okay, we move to next presenter. Roshan Pandit, distribution of hemoglobinopathies in Nepalese population, result of sickle cell surveillance 2019.
Good morning, all the delegates. My name is Roshan Pandit. I am presenting a research article that was carried out in 2019 when I was at National Public Health Laboratory. The topic is distribution of hemoglobinopathies in Nepalese population, result of sickle cell surveillance 2019. The work was carried out by the entire team of National Public Health Laboratory, and following are the authors associated with the research. Professor Dr. Harish Chandra Upreti as the principal investigator, and authors are Roshan Pandit, I myself, Uday Kumar Yadav, Ramesh Ruja Das, Dr. Rekha Manandar Shrestha, and Associate Professor Dr. Vinod Kumar Yadav. Talking about the hemoglobinopathies, it is a genetic disorder that is transferred from parents to the offspring. It is a hemoglobin disorder, and it includes both the thalassemia and other hemoglobin variants. Thalassemia means reduced rate of hemoglobin chain synthesis, where the synthesis of a structurally abnormal hemoglobin molecule includes sickle cell. A study suggests that approximately 7% of the world population are carrier of hemoglobinopathy. Among various hemoglobinopathies, sickle cell and thalassemia are the major types that is common in foreign countries as well as in Nepal. Thalassemia is a condition in which production of normal hemoglobin is partially or completely suppressed, whereas sickle cell is a condition caused due to formation of sickle cell hemoglobin. Sickle cell hemoglobin is formed due to replacement of glutamic acid by valine in position 6 of beta chain of the hemoglobin molecule. Glutamic acid and valine are the amino acid. Previous study in Nepal shows that sickle cell is prevalent in indigenous Tharo population. So in this scenario, we carried out this study with the objective of finding the distribution of hemoglobinopathies in Nepalese population. For this purpose, we carried out a retrospective study at 5 different sites of Nepal government that uses capillary electrophoresis for the screening of hemoglobin disorders. Those sites were located in the 5 different major cities of Nepal, namely Kathmandu, Chitwan, Budval, Nepalganj, and Dhangari. A study was carried out from January to March 2019. Data was collected from all the sites. All the data from starting of the test till December 2018 were included in the study. So diagnosis in all those sites were made based on electrophoregrams generated by capillary electrophoresis along with complete blood count parameters and peripheral blood smear findings. All the collected data were firstly entered into Microsoft Excel, which was then transferred to a statistical package for social sciences and analyzed via SIM SPSS version 20. So we found that a total of 4,018 cases during the period, among which 1,470 cases were found diagnosed of hemoglobinopathy-related disorder. Among those 1,470 cases, female were 54.6% and the rest were males. This pie chart shows the province-wise distribution of the cases. It is clear that province 5 has higher number of cases, followed by province 7. Province 1, 2, and 3 has similar number of cases. This table further illustrates the frequency of hemoglobinopathy types, and it shows that sickle cell, beta thalassemia, and compound heterozygous state of sickle cell and beta thalassemia are the major hemoglobin variants prevailing in Nepal. These are the data of 1,470 cases diagnosed of hemoglobinopathy-related disorders. This table further shows the distribution, frequency, and distribution of hemoglobinopathy disorders in all the provinces. We noticed that in province 5, 6, and 7, sickle cell is most prevalent. Similarly, beta thalassemia is prevalent in all those provinces, and one unique unique data was that we noticed was that in province 1, heterozygous SVE was the major hemoglobin variants, major hemoglobinopathy types. This is a bar diagram representing all the provinces and frequency distribution and frequency of major hemoglobin variants in all the provinces. So here we notice that in province 1, 2, 3, and 4, beta thalassemia is the major hemoglobinopathy types, while in province 6, 7, 5, 6, and 7, sickle cell is the major hemoglobinopathy types. The figure further, this is the map of Nepal showing frequency and the number of cases of hemoglobinopathy, major hemoglobinopathy in all the districts, different districts. Here we notice that in the districts of southwestern Nepal, namely Dang, Banki Bardia, Kailali, and Kanchanpur, marked red. There are number of cases of hemoglobinopathy is more than 100. And the star sign indicates that those major number of cases are of shipping disorder. The districts marked with blue indicates they have 10 to 100 cases of hemoglobinopathy, while the district marked with green indicates they have less than 10 cases of hemoglobinopathy. When we compare different ethnicity and frequency of major hemoglobinopathy, that is sickling disorder and beta thalassemia, we notice among Tharu population, sickling disorder is the major hemoglobin variant, while but sickling disorder is not only limited to Tharu, but it is present in all the different ethnicity, namely Nevar, Kshetri, Brahmin, Muslim, and Rajvanshi. While beta thalassemia is distributed in all the ethnic group of population, and unlike this, SVE SBE is distributed only, SBE was found in Rajvanshi population as a major category. 87.2% of the Rajvanshi population only had SBE percentage. So what we conclude from the data that sickle cell is most prevalent among Tharo communities in Western Nepal, but not only limited to Tharo community, but also prevalent in other ethnicity. While beta thalassemia is concentrated toward eastern part of the Nepal among different ethnicity group, and also beta thalassemia is not only concentrated towards eastern, but is distributed throughout the country among different ethnic groups, including Tharo. So for this work, we would like to acknowledge all the staffs of National Public Health Laboratory who have supported a lot for this work, and some of the technical staffs from the different sites. These are the references, and thank you.
We invite our next speaker is Dr. Sanjay Prasad Gupta, presenting on association between Sela Turcica bridging and hypodontia, a radiographic study. Sanjay Prasad Gupta.
Namaste, everyone. I'm going to present a study entitled Association between Sela Turcica Bridging and Hypodontia, a radiographic study. The contents of my presentation are background, objective, methodology, results, and conclusion. The Sela Turcica, it is located intracranially into the bony depressions, which is located in the midline of the sphenoid bone, where the pituitary gland is located. As orthodontists are mainly dealt with the Sela Turcica on lateral cephalogram during diagnosis and planning. So orthodontists should be able to recognize any morphologic deviations that might reflect the pathology conditions. The Sela Turcica bridging, it is the common developmental anomaly of the Sela Turcica due to excessive ossification of the dura mater between anterior and the posterior clinoid process. The prevalence of Sela Turcica is 1.1% to 13% in healthy individuals, whereas the percentage of the Sela Turcica bridging is more in case of patients with the severe craniofacial deviations. According to a study, the prevalence of dental agenesis is 7.48%, which is from our study published last year. This was the study among orthodontic patients. The dental agenesis means absence of teeth. Dental agenesis is considered as the major clinical problem that affects the inarticulate pronunciations, reduced chewing ability, and anesthetic appearance, which ultimately affects the self-esteem, communication behavior, and professional performance. The area of Sela Turcica is considered as the critical point for the migration of neural cells to the frontonasal and the maxillary area during embryonic development. Hence, the neural cells are responsible for the development of the Sela Turcica and teeth. It is believed that the genomic mutations in homeobox gene expression within the neural cells that leads to the faulty signaling pathways that affects ultimately the development of the teeth, midface, and Sela Turcica. According to many studies, about half of the patients with cleft lip and palate and with malocclusion has Sela Turcica abnormalities, which confirms the genetic basis of the Sela Turcica bridging. So the anatomic deviations of the Sela Turcica could be associated with the dental alterations, which is the area of interest for many researchers. Though there are several studies that link the cell-arterial breathing and the dental anomalies such as tooth transposition and palatal canine impaction. However, there is little research is available on the association between hypodontia and cell-arterial breathing. The objective of this study was to determine the association between breathing of the cell-arterial and hypodontia. So this is a cross-sectional analytical study where the records of orthodontic patients who came for orthodontic treatment from 2016 to 2018 collected from the archive of the orthodontic unit, 2 dental teaching hospital, and 1 private orthodontic clinic. And the ethical approval was taken from Institutional Review Committee of IOM, TU, before conducting this study. So for a study population, the clinical records along with the good quality of lateral cephalogram and orthopantomogram of 40 subjects and those are affected by dental hypodontia were collected. And the panoramic radiographs was used to evaluate the missing teeth. A tooth was diagnosed as congenitally missing if the mineralization of the crown could not be identified except the thermolars. The exclusion criteria were systemic disease or craniofacial anomalies, congenital syndromes, missing teeth due to decay process, avulsion or extracted for orthodontic purpose or other reasons, and poor quality of radiographs were excluded from this study. For control group, the control group consisted of 120 subjects matched for the age and gender without the hypodontia, that's the absence of teeth, were randomly selected at the same place and the time frame. And to quantify the extent of the cell-arterial breathing from each lateral cephalogram, the contour of the pituitary fossa traced on the transparent assisted sheet using a 0.5 mm lead pencil and was measured manually by one observer. And the cell-arterial length, it is represented by the black line from tuberculum sella and the dorsum sella, whereas the greatest anterior posterior diameter is represented by the dashed line from TS to PS. To evaluate an extent of the level of the breathing by using the standard scoring scale, which was given by Leonardi et al. In 2006, they categorized the cell-arterial breathing into type 1, type 2, and type 3. In type 1, no breathing when the length of the sella was greater than 3/4 of the greatest anterior posterior diameter. Type 2, when it is also known as partial breathing, when the length of the sella was either equal to or less than 3/4 of the greatest anterior posterior diameter. Type 3, it is also known as complete breathing when there are radiographically visible diaphragmatic sella. So type 1, no breathing; type 2, partial breathing; type 3, complete breathing. No breathing in patients having missing upper lateral incisors. On left side, the cell-arterial is not calcified, that is no breathing. And the partial breathing in patients with the missing upper left lateral incisor. Complete breathing in patients having the all missing second premolars. For statistical analysis, data obtained were transferred to MS Excel sheet. The data were verified and analyzed statistically using SPSS software version 21. And the data were discretely analyzed. The association between cell-arterial breathing and the hypodontia, as well as between the genders, were estimated using the chi-square test. And for the reliability of the measurements, the duplicate tracing of the radiographs selected randomly with a 2 weeks interval, and the random error was assessed. And the sella measurement error for both length and diameter between both the measurements ranged from 0.1 to 0.19 mm were considered non-significant. Regarding the gender distribution, out of 40 patients with hypodontia, 12 were male, whereas 28 were female. And out of 120 control subjects, 38 were male and 82 were female. This is the table showing the degree of calcification of the cell-arterial patients with hypodontia and controls among the genders. The chi-square test showed that there is no gender difference between the amount of breathing between male and female. This figure shows the degree of calcification of the cell-arterial in a subject with and without hypodontia. And the test chi-square test showed that The patients having the hypotensia showed the more chances of breathing, partial breathing and the complete breathing than the patients without the hypotensia. And it is concluded that Sella turcica breathing is significantly associated with the hypotensia, and there is no dependence between the degree of calcification and the gender. As the Sella turcica breeze appear early in the life, it should alert the clinician as a useful diagnostic predictor to the possible development of the tooth anomalies later in the life. I would like to thank all the patients and their guardians for providing their radiographs for the study. These are the references. Thank you all. Especially, I would like to thank the organizing committee of this summit for providing me this platform to present our work. Thank you. Thank you all.
Thank you for your nice presentation. Now presentation is over, and we have got multiple questions for our speakers. So maybe we start with first presenter, Ramesh Shrestha. Yeah. We connect to Ramesh Shrestha? Yes. Ramesh Shrestha ji. We got one question from Bir Bahadur Rawal for you. And which kind of report would be better to collect, integrated reporting system or individual reporting system, which is a good health solution for reporting in all the institutions in Nepal, through digital system, or if possible, why? You got the questions? सुन्नुभयो? हजुर? Offline? Yeah, fine. Okay. Next question, Dinesh.
Sure. Okay. Dinesh ji, are you there? Yeah. Right. Do you hear?
Yes, sir, I can hear you.
You hear me?
Yes, sir, I can hear you.
Yeah, sure. You have one question that did you analyze rotavirus transmission with respect to temperature range, minimum to maximum? If so, please say.
Well, yes, we did analyze transmission risk of rotavirus infection for different temperature ranges. And we have recently submitted the revised version of our manuscript to a journal, Science of Total Environment, and which I assume should be accepted very soon. So as soon as it gets published, I will personally email Professor Vandana Pradhan the copy, PDF copy of our research work.
Thank you.
I will ask you the same questions that there was an important report from my institute, Tribhuvan University Teaching Hospital. Similar report by one of the researchers that this is a seasonal variation. So in the month of March, rotavirus infection is very common. So maybe the similar one. No? Your study also showed that although there is a rotavirus infection all year, through all year around, but this is more common in winter. So,
yeah, the high risk,
yeah, this is most common in month of March. So same region, maybe this is cold weather that leads to this infection, not the rainfall or humidity, no?
Yes, we didn't see any association with rainfall and humidity with the data that we analyzed for Kathmandu Valley. And so far, what I have seen in the literature, I mean, most of the studies conducted around the world, they have barely reported any association between rainfall and humidity, except for 2 studies conducted in Bangladesh. So maybe that's due to the different climatic conditions in Bangladesh compared to ours.
Okay.
Any more questions? Okay.
So we have.
So we do some comments from our side. No more questions. I don't know whether Ramesh Shrestha is listening us or not, but still. You should mention that who developed this software and the basic difference in this software and the present reporting system. अहिले पनि हाम्रो HMIS चलिरहेको छ, त्यो भन्दा के फरक हुने भन्ने कुरा त्यति प्रश्न आएन. And then to
he's connected? No.
Thank you
to
so much, sir.
Okay,
Cheers, and thank you for your questions also. सुनिराख्नु भएको छ?
Yes. सुन्दैछौँ.
हेलो.
सुन्दैछौँ.
सर सुनिरहेको छ हजुरको क्वेसन. आन्सर चाहियो हो. हेलो रमेश सुरेश सर.
हेलो.
Okay.
भएन, कनेक्सन
भएन भने अब ओके
तेस्रोमा
एकपटक फेरि क्वेसन सोधिदिनु न, म यसको रिप्लाई चाहिँ म दिन्छु.
सरी
म पनि एउटै टिमबाट.
ओके.
यो रमेश सरलाई सोध्ने मैले सोधे हो, म सोध्न सक्छु सर?
रमेश जी अवेलेबल हुनुहुन्न, त्यही भएर
त्यही त उहाँको टिमलाई सोध्न सकिन्छ सर. म वीरबहादुर रावल बोले.
हुन्छ,
टिमको
यु क्यान आन्सर.
मैले सोध्ने हो सर, मैले त क्वेसन सोधे.
अब हामी पनि सोध्ने, तपाईँ पनि सोध्ने भयो. एनिवे अब नेक्स्ट टु दिनेश भण्डारीजी सुन्दै हुनुहुन्छ?
सुनिरहेछु सर.
दिनेशजीलाई चाहिँ के भने तपाईँको प्रेजेन्टेसनमा त्यो ग्राफ जुन देखाउनु भयो त्यो नबुझिने भयो, साह्रै सानो हो, त्यो नदेखिने. त्यो तपाईँले चाहिँ भए जति एकै ठाउँमा हाल्नुभयो, पन्नामा हालेको भए राम्रो हुन्थ्यो मेरो सल्लाह. त्यो ग्राफ देखाउनु भयो नि, त्यो बुझिएन एउटा. अब दोस्रो यसको सिग्निफिकेन्ट के भयो त? तपाईँले त रिजल्ट त जस्तो अब काठमाडौँमा चाहिँ जाडोमा वासिङ हुँदैन होला भन्नुभयो, अथवा भिड हुन्छ होला त्यस कारण बढ्यो भन्नुभयो होइन. तर वाट क्यान वी डु, अब के गर्ने?
त्यही त, अब सिग्निफिकेन्स के छ भन्दाखेरि अल्टिमेटली एक मात्र प्रिभेन्सन मेजर रोटा भाइरसको भनेको चाहिँ भ्याक्सिनेसन हो. यो हामीले स्टडी गर्नु पिरियडमा चाहिँ यो लास्ट इयर अगस्ततिर सकेको स्टडी हो. त्यो टाइममा चाहिँ रोटा भाइरस भ्याक्सिनेसन नेपालमा सुरु भइसकेको थिएन. तर यो विकबाट चाहिँ नेपालमा चाहिँ रोटा भाइरस भ्याक्सिनेसन सुरु भइसकेको छ. तर हाम्रो उद्देश्य के थियो भन्दाखेरि यदि हामीसँग प्रिभेन्टिभ मेजर जस्तो भ्याक्सिनेसन छैन भने हामीले अरू हाम्रो बिहेभियरल चेन्जमा चाहिँ हामीले ध्यान दिने हो भने चाहिँ रोटा भाइरसको सङ्क्रमणबाट चाहिँ बच्न सकिन्छ कि भन्ने उद्देश्यले यो गरिएको. अब त के देखिएछ भन्दाखेरि यो चाहिँ धेरै जस्तो हाइजिन रिलेटेड हुने कुरा, हाइजिन रिलेटेड रोग भएको कारणले गर्दाखेरि हाई रिस्क पिरियड विन्टरमा भएपछि अब हामीले चाहिँ पर्सनल हाइजिन अनि जुन त्यो केयर गिभरले चाहिँ त्यो चिल्ड्रेनहरूलाई चाहिँ जुन तरिकाले यो पिरियडमा स्याहार सुसार दिनुपर्ने हो, यो पिरियडमा चाहिँ बढी चाहिँ सतर्क भएर हुन्छ नि आफ्नो पर्सनल हाइजिन लगायतको कुराहरूलाई चाहिँ ध्यान दिने हो भने चाहिँ केही हदसम्म चाहिँ न्यूनीकरण गर्न सकिन्छ कि रोटा भाइरसको इन्फेक्सनको भन्ने चाहिँ मेसेज चाहिँ हाम्रो स्टडीबाट लिन सकिन्छ सर.
थ्याङ्क यू. हुन त त्यो युनिभर्सलै हो, जाडो होस् कि गर्मी होस् केही छैन। सो नि अब अर्को चाहिँ रोशन पण्डितजी एभाइलेबल हुनुहुन्छ? अब स्टडी जुन डिस्ट्रिब्युसनको स्टडी हुन्छ त्यसमा धेरै प्रश्न हुँदैन, किनभने त्यो तपाईँले डेमोग्राफी देखाउनुहुन्छ यस्तो छ भन्ने हो। तर पनि के देखियो भने बिटा थ्यालेसेमिया पूर्वमा चाहिँ 52मा धेरै, पश्चिममा राजवंशी धेरै, तर जस्टिफाई के गर्न सक्नु भएन भने तपाईँले लिएको स्याम्पल पनि त धेरै थियो नि, द मोर स्याम्पल्स, तर पर्सेन्टेज वाइज त्यस्तो धेरै ठुलो फरक पनि देखाउन सकिएन। किनभने तपाईँले चाहिँ अर्को के भन्नुभयो, स्याम्पलिङको केही इफेक्ट थियो कि और त्यस्तो बायसनेस थियो कि, अथवा तपाईँले लिने स्याम्पल चाहिँ जे भेट्यो त्यही राखेको हो कि, अथवा तपाईँले नम्बर बेस्ड अन दि प्रिभेलेन्स अफ द डिजिज के थियो, कसरी स्याम्पल कलेक्सन गर्नु?
सर यो स्याम्पल कलेक्सनको कुरा गर्दाखेरि हामीले कलेक्सन साइट जुन हाम्रो डिजाइन गरिएको थियो नेपाल गभर्मेन्टको, तिनीहरूमा रेकर्ड भएको स्याम्पल लिएको हो। यो डाटाको लागि स्पेसल साइट भन्दा पनि टेस्ट सुरु भएको अवस्थादेखि 2018 को डिसेम्बरसम्म जति पनि केस रेकर्ड गरिएको थियो त्यो सबैलाई एक ठाउँमा कलेक्सन गरेर ती सबै पेसेन्टलाई सेग्रिगेट गर्यो, फलानु पेसेन्ट कुन डिस्ट्रिक्टको हो, कहाँ पर्मानेन्ट एड्रेसको अनुसारमा, अनि त्यो ती पेसेन्टहरूमा कुन के चाहिँ पुष्टि भएको छ, कुन प्रकारको हिमोग्लोबिनोप्याथिस भएको छ, त्यो अनुसारमा यो फाइन्डिङमा पुगेको हो सर।
3 महिनाको मात्रै हो
होइन सर, 2 वर्षभन्दा बढी 2016 देखि 2018 सम्म।
तर यो तपाईँले अघि सुरुमा त 3 महिना मात्रै भन्नुभएको थियो, हामीले सुनेको
3 महिनासम्म डाटा कलेक्सन गरियो सर। जनवरीदेखि मार्चसम्म गएर यो 5वटै साइटमा गएर हाम्रो टिम गएर डाटा कलेक्सन गरियो, डाटा लियो त्यहाँबाट, र त्यो 3 महिनाको बेलासम्म डिसेम्बरसम्मको डाटा लियो, 2018 को डिसेम्बरसम्मको डाटा लियो।
ओके,
अहिले नेपाल गभर्मेन्टले नि मेबी अब यसको त सिकल सेल एनेमिया र थ्यालेसेमियाको त थुप्रै स्टडी भइराखेको छ, धेरै रिपोर्टेड छ। देयर इज अ विङ, इभन नेपाल हेल्थ रिसर्च काउन्सिलले पनि एउटा स्टडीमा कन्डक्ट गरेको थियो कि, र मोस्टली स्टडीले अहिलेसम्म के देखायो भने दिस इज अब थारू बेस्ड मात्रै होइन, इथनिक ग्रुप मात्रै रिलेटेड छैन, अरू इथनिक ग्रुपमा पनि पाइन्छ। मेबी वी हेभ टु फोकस अन वर्षा चाहिँ थारू कम्युनिटीमा छ, तर अरू कम्युनिटीमा नभएको होइन
होइन त्यही छ मान्यता। सिकल सेलको मान्यता अहिलेसम्म धेरै जसो थारूमा मात्रै देखिन्छ भन्ने थियो, तर हाम्रो सर्भिलेन्सले के डाटा निकाल्यो भने त्यो सिकल सेल थारूमा धेरै जसो छ नै, तर सिकल सेल थारूमा मात्रै नभएर थारू बाहेक अन्य इथनिक ग्रुपहरूमा पनि पाइयो। त्यो भएर यो थारूमा मात्रै यो लक्षित नगरेर नेपाल सरकारको कार्यक्रम अन्यतिर पनि सिकल सेलको सिकल सेल प्रेजेन्ट छ अन्य इथनिक ग्रुपहरूमा पनि यसले पुष्टि गर्यो। यो भन्दा पहिले चाहिँ प्रमाण सिकल सेल थारूभन्दा बाहिरको मान्छेमा पनि छ भने प्रमाण साथ थिएन, यसले चाहिँ देखायो।
अब यो स्टडीले यसको सिग्निफिकेन्स के हुन्छ त
सर? सिग्निफिकेन्स यसको के छ भने नेपाल अहिले 5वटा जुन साइट तोकिएको छ हिमोग्लोबिनोप्याथी टेस्टिङको लागि, त्यो जेनरली 3-4वटा पश्चिम नेपालमा केन्द्रित छ, वेस्टर्न नेपालतिर, र यो स्टडी अनुसार चाहिँ बिटा थ्यालेसेमिया पूर्वी नेपाल इस्टर्न तराई रिजनमा पनि देखिएकोले त्यो थप साइटहरू, थप सर्भिलेन्सको साइटहरू, टेस्टिङ साइटहरू इस्टर्न नेपालतिर पनि इस्टाब्लिस गर्नुपर्ने आवश्यकता देखियो।
इस्टाब्लिस गरेर त पत्ता लगाउँछ होइन, यसलाई प्रिभेन्सन अथवा केही गर्न सक्ने हुन्छ त?
केस फाइन्डिङ डायग्नोज गरेर थ्यालेसेमियाको केस डायग्नोज गरिसकेपछि त्यसको पहिला केही व्यवस्थापन हुन्छ। पहिला आइडेन्टिफाई नै हिडन केस पनि सोसाइटीमा धेरै भएकोले पहिला त पत्ता लगाउनै आवश्यक छ, त्यसपछि फर्दर केही गभर्मेन्टको पोलिसी होला तिनीहरूलाई कन्ट्रोल गर्ने, त्यो अर्को पाटो हो। तर
डायग्नोज सोध्नु भएको होइन, सरले सोध्नु भएको के भने तपाईँको स्टडीले के नयाँ दियो हामीलाई? थारूमा धेर छ त हामीलाई थाहै छ नि।
धेरै छ त्यो त जानकारी भएकै हो, तर थारूमा मात्रै होइन, थारू बाहेक अरूमा पनि देखायो यो स्टडीले।
ओके, थ्याङ्क यू। अब सञ्जय गुप्ताजीलाई एउटा मेरो क्वेसन छ। एउटा टेस्टमा 0.6 पी भ्यालु आयो, सिग्निफिकेन्ट भएन, काई स्क्वायर टेस्ट चाहिँ सिग्निफिकेन्ट भयो। अब सेला टर्सीका ब्रिज भयो भने दाँत हेर्ने कि दाँत हेरेपछि सेला टर्सीका ब्रिजिङ गर्ने, के गर्ने सर? वाट्स द भ्यालु अफ दिस स्टडी?
यसमा चाहिँ कस्तो भयो भने सर, जस्तै अब अर्ली प्रेडिक्टर भनेर चाहिँ अब सेला टर्सीका ब्रिजिङ र हाइपोडोन्सियाको चाहिँ रिलेसन चाहिँ देखियो। त्यो हुँदाखेरि चाहिँ हामीले चाहिँ यदि सेला टर्सीका ब्रिजिङ चाहिँ हामीले अर्ली लाइफमै डिटेक्ट गर्ने भएकोले पछि गएर चाहिँ यो केसमा चाहिँ अब त्योसँग एसोसिएटेड जेनेटिक एब्नोर्मालिटिजहरू जस्तै अब हाइपोडोन्सिया हुन सक्ने चान्सेस, अर्को ट्रान्सपोजिसन हुन सक्ने चान्सेस, अर्को चाहिँ क्यानाइन इम्प्याक्सन हुन सक्ने चान्सेस चाहिँ हुँदो रहेछ भन्ने चाहिँ हामीले चाहिँ एउटा
यस्तो भन्न सकिन्छ इन्सिडेन्सियल भेटियो भने के अरे सेला टर्सीका ब्रिजिङ भेटियो भने अरू हेरौँ भन्ने कुरा त भयो, तर स्क्रिनिङै गर्न अथवा त्यसैको लागि टेस्ट गर्न त सकिँदैन होला नि? के छ रिकमेन्डेसन? सेला टर्सीका ब्रिजिङ त स्क्रिनिङ त हुँदैन त्यसको, हामी त्यो एक्सपोजर त गराउँदैनौँ रेडियोलोजीमा। त्यस कारणले देखियो भने हेर्ने, ठिक छ, त्यो एसोसिएसन वी गट इट। त्यो यसलाई के डायग्नोस्टिक भ्यालुको लागि अरू केही भनौँ न, दाँत हेर्न सजिलो कि सेला टर्सीका सजिलो मात्रै भनेको मैले खास?
जस्तै हामीले प्रिडिक्सनहरू चाहिँ अब गर्न सजिलो भयो नि सर, अर्ली लाइफमा चाहिँ यदि रहेछ भने चाहिँ कहिलेकाहीँ हामी प्लानिङ कस्तो हुन्छ भने सर, जस्तै हाइपोडोन्सिया भएको केसहरूमा यदि हामीले अगाडि नै थाहा पायो भने चाहिँ हामीले पर्मानेन्ट दाँत आउनुभन्दा अगाडि नै हामीले चाहिँ प्लानिङहरूमा चाहिँ त्यसले चाहिँ अब फरक पार्ने रहेछ। त्यही भएर चाहिँ यदि एक्सिडेन्टली पनि यदि ब्रिजिङ रहेछ भने चाहिँ हामीले वी मे सस्पेक्ट द्याट कि पछि गएर चाहिँ कुनै त्यस्तो भयो भने चाहिँ हामीले यसरी म्यानेज गर्नुपर्छ, एउटा उसको लागि चाहिँ हुन्छ।
हाइपोडोन्सियाको कुनै इन्टरभेन्सन छ, मतलब थाहा पाएपछि केही गर्ने
छैन सर?
छैन।
हाइपोडोन्सिया थाहा पाएपछि पनि अब ट्रिटमेन्ट प्लान चेन्ज हुन्छ सर। त्यो चाहिँ अब कस्तो खालको कन्डिसन्स हो, कस्तो खालको मालग्लुजन्स हो, कहिलेकाहीँ हामीले चाहिँ हाइपोडोन्सिया छ भने चाहिँ हामीले we have to gain a space for the prosthesis, or either we have to close the space by orthodontic means.
मैले सेम क्वेसन त्यही जोड्न लागेँ कि अब यो एज ए क्लिनिसियन यसको सिग्निफिकेन्स के चाहियो भने यो थाहा पाएर अब गर्न पनि नसक्ने मेबी एलर्ट गर्छ कि के गर्छ?
एलर्ट गर्छ क्लिनिसियनलाई चाहिँ। अब
क्लिनिसियनलाई
अब जस्तै हाइपोडोन्सिया थाहा पाउने भनेको हामीले चाहिँ अलिकति पछि गएर हामीले जस्तै अब अर्थोडोन्टिक ट्रिटमेन्ट यदि हामीले चाहिएछ भने 11-12 वर्षमा, वा चाहिँ सर्टेन कुनै त्यस्तै कुनै प्याथोलोजीहरू देखियो भने 8-9 वर्षमा हो भने, सेला टर्सीको ब्रिजिङ त हाम्रो अर्ली लाइफ भनेको अब 1-2 वर्षमा पनि यदि एक्सिडेन्टली कुनै किसिमले यदि हामीले एक्सपोज भयो भने हेर्न सकिने चाहिँ एउटा चाहिँ
तर यो जुन छ नि यो ब्रिजिङलाई
चाहिँ सजिलो हुन्छ भने
पार्शियल ब्रिजिङ र कम्प्लिट ब्रिजिङ भन्नुभयो होइन?
हजुर।
इट्स बिकज अफ क्याल्सिफिकेसन। क्याल्सिफिकेसनको कजहरू पत्ता लगाउन मिल्छ।
ड्युरा क्याल्सिफिकेसन
कोजहरू चाहिँ यसको पत्ता लगाउनलाई चाहिँ अब यसको चाहिँ सेला टर्सीका ब्रिजिङ चाहिँ अब जेनेटिक नै इटियोलोजी हो भनेर चाहिँ अब अलमोस्ट प्रुफ जस्तै हो। अब हाइपोडोन्सिया पनि अब जेनेटिक नै हो भने, किनकि न्युरोकेस माइग्रेसन भएर यो म्याक्सिलोफेसियल रिजनको डेभलपमेन्ट भएको कारणले गर्दा चाहिँ यो दुईटामा चाहिँ एसोसिएसन छ कि छैन भन्ने कुरा यो स्टडीमा चाहिँ हेर्न लागेको छ।
सो थ्याङ्क यू डाक्टर साहब।
Thank you so much, sir.
This session is very interactive and informative one, and we have short of time, so maybe with maybe this is a diverse field of research. Maybe we have to be starting with digital health and environmental health associated with rotavirus infection in Kathmandu, and study on hemoglobinopathy in Nepal, and lastly we have a study on hypodontia and selar trachea bridging.
त्यो भन्दा नि अब NHRC ले चाहिँ यसैको रिसर्च गर्नु पर्ला जस्तो छ। यो डिजिटल प्लेटफर्म जुन युज गर्दै छौं यसको इफिकेसी नै चाहिँ महत्त्वपूर्ण होला जस्तो छ। हिजो हाम्रो अध्यक्षले नि भन्नुभयो खर्चदेखि पार्टिसिपेसनको इफिकेसी। यस, यो पनि हेर्दै जाउँला। हस्, थ्याङ्क यू।
Thank you.
Thank you so much, sir, for your very valuable remarks and making this session very interactive. I would also like to thank the presenters for providing insightful evidence on different aspects of digital health, environmental health, and biomedical science. And also thanks to the participants for their questions. Now, it's time to appreciate our cheers with token of love. For this, I would like to request Executive Chief of Nepal Health Research Council, Dr. Pradeep Gewali sir, to appreciate our cheers with token of love. Professor Dr. Yogendra Prasad Singh. Dr. Krishna Prasad Adhikari. Thank you. Now with this, we complete this session. We'll have our next session on mental health, disabilities and emergency. I would like to invite my friend Dr. Pallavi Koirala for this session.
Thank you, Ranjita ma'am. Good afternoon to everyone, our audiences back home, our esteemed guests who have graced us with their presence today. Now we move on to the next session of the summit, which will be on mental health, disabilities, and emergency. For this session, we have two eminent personalities as our chairs. They are Professor Dr. Saroj Prasad Ojha and Associate Professor Durga Kharka Mishra. Professor Dr. Saroj Prasad Ojha, he is the Professor and Head of Department of Psychiatry at the Institute of Medicine, Tribhuvan University Teaching Hospital. He was also the past Vice President of the Nepal Medical Association and the past President of Psychiatrists Association of Nepal. In addition to this, Professor Ojha is also the Principal Investigator of the National Mental Health Survey, which is being conducted by the Nepal Health Research Council and which is the first survey of its kind in Nepal. Professor Ojha has over 40 peer-reviewed national and international publications. He has supervised the thesis research of more than 25 postgraduate MD psychiatry residents, MPhil clinical psychology candidates, as well as PhD candidates. Professor Ojha has received numerous awards from esteemed institutes like the Institute of Medicine, National Medias, the AMDA International, and Norwegian Psychiatrists Association. Welcome, Professor Ojha. Our next chair is Associate Professor Durga Kharka Mishra. Associate Professor Mishra is the Head of Department of the Department of Public Health at the Manmohan Memorial Institute of Health Sciences. She is also currently a PhD scholar at the Tribhuvan University. Associate Professor Mishra has been affiliated with the Tribhuvan University, various INGOs, and UN organizations for the past 32 years. She has conducted over 25 researches, and she has been published in national and international journals. Welcome, ma'am. For this session, we have three presenters. They are Rakesh Khimire, Gaurav Devkota, and Sharada Prasad Wasi. I would like to welcome our participants to the session. With this, I hand over the session on to our chairs. Thank you.
Well, thank you, Pallavi. Thank you, Nepal Health Research Council, Government of Nepal, for inviting us. And with the permission of our honorary chair, I would like to start our today's sessions. I think if you see that time, I think it's supposed to start at 1:20 p.m. Nepal's time. And we are almost on time. And thank you, organizers. And when we talk about COVID-19 and mental health issues, I think this is going to be one of the major issues. And if you see this 6th National Summit of Health and Population Scientists in Nepal, the theme is addressing emerging public health issues through interdisciplinary research. So when we talk about the public health issues, the issues of mental health service, issues of suicides, issues of migrant health workers. So these are major issues which we are going to talk. So I think without wasting the time, I would like to request our honorary chair, Dr. Ms. Durga Mishra Khadka, to proceed our sessions. And I'm sure that all the 3 presenters are online. And after 30 minutes presentations, we'll have a 20 minutes discussions with final conclusion of today's presentation. So I hope this presentation will be live and more participatory and with some meaningful discussions. With this, I would like to request and to proceed our sessions by Ms. Manju.
Sir Durga. Thank you. Namaskar. Very good afternoon. Thanks to organizer Nepal Health Research Council for organizing such a very nice and very wonderful, and this is the first ever such type of digitalized summit is happening in our country. So as we all know, there is no health without mental health, and thanks to my co-chair, without delay, we are going to start our presentation. I think all our presenters they are going to do by virtually, they are going to present their research work. Then now I would like to invite the first presenter. As we all know that you all presenters have 10 minutes presentation time. Then after all 3 presentations, we'll collect your participants' queries. Then we'll discuss in the discussion session. First of all, Rakesh Ghimire, and he's going to present about burden of fatal intentional pesticide poisoning in Nepal, current situation and opportunities for improvement. Rakesh Ghimire.
Suicide is one of the major public health problems worldwide, including Nepal. Poisoning is the second most common mode of suicide after hanging in Nepal. Among all the suicide related to poisoning, pesticide poisoning is the most common poisoning for suicide in Nepal. Namaste everyone. Myself, I'm Dr. Rakesh Ghimire. I'm working as an assistant professor in the Department of Clinical Pharmacology, Institute of Medicine, Tribhuvan University. The topic of my presentation today is burden of fatal intentional pesticide poisoning in Nepal, its current situation, and opportunities for its improvement. So these are the list of my co-authors. Intentional pesticide poisoning is a major clinical and public health problem in agricultural communities in low middle income countries like Nepal. According to World Health Organization, in the year 2014, Nepal had the 7th highest suicide rate in the world, that is 24.9 per 100,000 population. Pesticide poisoning is the most common poisoning for suicide in the country. Therefore, it would be useful to know which pesticides are commonly used for self-harm and suicide and are fatal, with the expectation that such knowledge will guide us the regulation of highly hazardous pesticide and their removal from the agriculture use. The objective of this Hope Grid study, which is conducted by Center for Pesticide Suicide Prevention, University of Edinburgh, in collaboration with Nepal Public Health Foundation, is to identify the burden of pesticide poisoning and the highly hazardous pesticide, currently responsible for the majority of pesticide suicides from the selected hospitals and the 2 existing toxicological laboratories of Nepal. Methodology. A quantitative study was done in the 9 tertiary care hospitals of Kathmandu, Lalitpur, Kabri-Palanchok, Banke, Chitwan, Rupandehi, Janakpur, Kaske district of Nepal, and existing 2 toxicological laboratories. Study duration, we reviewed up to 2 years data from April 2017 to April 2019 on all the pesticide-related admitted cases in the 9 major hospitals of the country. We also reviewed 2 years data from the 2 existing forensic science laboratories of the country. A study population. All the cases of pesticide poisoning presented in the study hospitals and the samples sent to the toxicology laboratories to identify the pesticide responsible for death. So this is the map of Nepal, denoting the different study sites. In this map of Nepal, red triangle denotes province-wise location of participating hospitals, and the purple colored star denotes the location of toxicology laboratories. Data collection technique. Data on demographics, poison, and patient outcome were recorded on a data collection sheet. Hospital data was collected from anonymized medical records and was recorded in an unique fashion. Toxicological laboratories data was obtained from the record file. Researchers were trained in recognition of the various types of pesticides, and the poison was identified from the history, referral note, clinical toxidrome, and the laboratory analysis. Simple descriptive analysis was done, and the approval was obtained from Nepal Health Research Council. So this is the result of the hospital-based data. And among all the cases, that is 3,609 cases, there were more women as compared to men. Here you can see there were 60% female and 40% male. The two, in the circumstances of poisoning, the two most commonly recorded circumstances of poisoning were intentional poisoning, pesticide poisoning, suicide, followed by the accidental. Here you can see in about 61%, the circumstances of poisoning was intentional, and in about 3%, the circumstances of poisoning was accidental. However, data were not available in about 36% of cases where we could not find the circumstances of poisoning. So looking at the hospital data and the outcome, here we can see of all the pesticide poisoning patients admitted to the hospitals, case fatality was 3%, and here also the outcome was missing in about 52.6%. Poisoning agents responsible for death. So as there was case fatality was 3%, we looked for the poisoning agents that was responsible for the death of the patient. And the findings showed aluminum phosphide, about 33% was the key pesticide identified, and followed by chlorpyrifos, dichlorvus, dimethiate, methylparathion, zinc phosphide, and in about 49% of fatal cases, the pesticide was unknown. We also reviewed the 2 years data from the National Forensic Science Laboratory and the Central Police Forensic Science Laboratory. And looking at the data from the National Forensic Science Laboratory, total number of positive samples of pesticide poisoning were found to be 242. Total number of active ingredients identified were 17. Most common pesticide was found to be organophosphorus, followed by aluminum phosphide. And among the organophosphorus compound, the most common organophosphorus compound was found to be dichlorvus. So looking at the data on the different poisoning agents from the National Forensic Science Laboratory, of all the cases from the National Forensic Science Laboratory, total number of recorded cases were 242, and here we can see the dichlorvus was the key pesticide identified, followed by the phosphine, chlorpyrifos, cypermethrin, and so forth. So looking at the data from the Central Police Forensic Science Laboratory, of all the cases recorded in the Central Police Forensic Science Laboratory, about 2,293 organophosphorus was the most common compound to be ingested for suicide, followed by phosphine gas, organochlorine, pyrethroid, and carbamates. So combining the results of both the existing 2 toxicology laboratories of the country, it was seen that about the most common compound to be ingested for suicide was found to be organophosphorus, which accounts for 58%, followed by phosphine gas, which accounts for about 26%, followed by organochlorines and carbamates and pyrethroids. And we looked for the poisoning agents as from combining the 2 toxicology results. We found that organophosphorus was the most common compound to be ingested for suicide. And looking at the which organic phosphorus compound was responsible for the majority of deaths, it was seen that dichlorous was the most common compound to be ingested, which accounts for 56%, followed by chlorpyrifos, which accounts for 20.1%. Sometimes this chlorpyrifos is in combination with the pyrethroids. And this result shows previously banned organophosphorus insecticide were rarely detected, indicating the ban success. Pesticide self-poisoning is one of the means of suicide in Nepal. Exact hospital burden of pesticide poisoning is not known. Therefore, there is a need of proper medical record system in the tertiary care hospital of Nepal. As you can see, this is the real scenario of our the hospital of our country, where we can see the poor medical record system. Therefore, introducing and implementing computerized information record system can aid in the improved hospital data that can eventually help in the identification of highly hazardous pesticide. In conclusion, organophosphorus insecticide and aluminum phosphide were responsible for most pesticide suicides in Nepal. There may be an opportunities to improve management of poison patient if the poison is identified on admission. Encouraging toxicological laboratories to identify the individual compound can provide data to guide further pesticide regulation, as has been successfully performed previously. From our study, it clearly indicates that since poisoning is the second most common method of suicide in the country, there could be huge burden of suicide due to pesticide ingestion. However, exact data is lacking. Many hospital data were missing, as shown in our study. For instance, if we know the particular pesticide which is being used for suicide, it can provide the basis for regulation of highly hazardous pesticides, which can decrease the burden of pesticide self-harm from the country. So I would like to thank Center for Pesticide Suicide Prevention, University of Edinburgh, and the Nepal Public Health Foundation. And a special note of thanks to Professor Michael Elstone, who is a clinical toxicologist at the University of Edinburgh, for his continued support and the encouragement. As you all know, suicide is preventable, and multi-sectoral involvement play a key role. There are evidences which are based on the researches that regulating highly hazardous pesticides have shown to decrease in suicide. Therefore, let's put our hands together to help prevent suicide-related self-harm in the country. Thank you, everyone. Namaste.
Thank you so much. You are in time, Dr. Rakesh Kimire. You have done, and your team have done very well job. The question and other things we'll do in the last of our session. Now, I would like to call the second presenter, Gaurav Devkota, and he's going to present on mental health service utilization from primary healthcare facilities. The stigma is still a major barrier. Mr. Gaurav Devkota.
Namaste, everyone. Today I am going to present on mental health service utilization from primary healthcare facilities. Stigma is still a major barrier. This was a part of the thesis research which was conducted by me, as well as others co-authors who were Ms. Puspa Basnet, Dr. Vijay Thapa, and Professor Madhusudan Subedi. And this was a part of the thesis which was done in School of Public Health, Patan Academy of Health Science, Nepal, for as a partial fulfillment of a degree of MPH. On the we have seen that mental health service utilization has different factors affecting as barriers and facilitators, and these factors can be differentiated into different socio-ecological levels, like individual, interpersonal, community, organizational, and political levels, policy levels. However, stigma and lack of awareness in the community have been identified as the major barrier for mental health service demand and access throughout the world. So the aim of this study was to explore the different factors at different socio-ecological levels that affects mental health service utilization from primary healthcare facilities of Arghasai district, which is the western hilly district of Nepal. The study was a cross-sectional qualitative study which was conducted in Arghezi district in July and August 2019. The study collected information from different categories of participants through face-to-face interviews. The different categories of participants were nearest caretakers of people with mental illnesses, healthcare service providers of primary healthcare facilities, health administrators or elected representatives of Arghezi district. And these categories were selected judgmentally so as to provide information and factors affecting mental health service utilization from PSC facilities at all the socio-ecological levels. From these three categories of participants, a total of 32 participants were selected purposively, in which 16 participants were nearest caretakers of people with mental illnesses, with whom in-depth interviews was conducted, and 8 healthcare service providers of private healthcare facilities, and 8 health administrators and elected representatives were selected purposively, with whom key informant interviews were conducted. And these interviews were conducted using a face and content validated interview guidelines. The interview were conducted after a written consent was provided by the participants for the interview. The recorded interview were translated into English, and these translated transcripts were validated by a person with qualitative knowledge of qualitative analysis. Also, summary of from some of the interviews were analyzed. Some of the interviews were analyzed, and short results were provided to some of the participants who participate in the study, and thus the member checking was done, in which they complied with the results, and also an interval percent agreement was performed for maintaining rigor in the study, of which the following table has provided with the positive percent agreement between 2 quarters, and the positive percent agreement was 70.59%. The thematic analysis was done using the Brown and Class 6 steps, in which first the translated transcript were thoroughly read and reread, with quotes generated from the translated transcripts, and these quotes were placed into a common group of themes, and the themes were the 5 socio-ecological levels, socio-ecological levels, and this thematic analysis was performed using the RQDA package for ZR software. The table shows the socio-demographics of the participants. Here we can see that the quotes were provided to all the participants, and other socio-demographics have been provided in the table. After the thematic analysis, different factors affecting mental health service utilization were identified in different socio-ecological levels. Here we can see that the different factors in different socio-ecological level, like individual level, interpersonal level, organizational level, community level, and policy level. Furthermore, in these 5 socio-ecological levels, the factors were further differentiated into barriers, facilitators, or both. And we can see that the following factors were identified as barriers. Some were identified as both facilitator and barriers, and some were identified as facilitators. Also, mental health stigma and inadequate awareness, which were identified at the community level, were reported as the major barriers for mental health service utilization. The following verbatim can also shows that that mental health stigma and inadequate awareness were the major barriers for mental health service utilization. Also, the stigma and inadequate awareness, which were identified as barriers at community level, They also influence different factors at different other socio-ecological levels to act as barriers for mental health service utilization from PSC facilities of Arghezi district, like self-stigmatization and limiting to self at individual levels, and lack of support from family and community at interpersonal level, fear of lack of privacy at organizational level, and discrimination and neglect at community level. Participants were also asked about their recommendation on increasing service utilization from primary healthcare facilities of Arghezi district, and most of the participants responded that awareness and comprehensive availability of comprehensive mental health services within the district would increase the service utilization of mental health services from the PSC facilities of Arghezi district. Finally, through the research, we have concluded that awareness in the community by forming mental illness support groups and inclusion of mental health education in the curriculum could help reduce and or eliminate mental health stigma from the community. Also, accessibility of health facilities and availability of comprehensive mental health services in the PSC facilities could help increase service utilization from the PSC facilities. I would like to acknowledge all the peoples and organizations who have supported me in the research. Thank you.
Thank you, Gaurav Devkota, for your timely presentation. I think our participants and many others have put their queries in the chat box here. We'll discuss later. The third presenter or last presenter of this session, Sarda Prasad Osti, and he's going to present on exploring health issues of Nepalese migrant workers and families, a qualitative study. Please, Sarda Prasad Osti.
Okay, namaskar. So thank you very much. I am Sarada Osti. My research topic is exploring health issue of Nepalese migration worker as a working in the migration health research in Nepal. Yes, globally migration health is a priority research agenda, and it is recognized globally in public health issue. And day by day we can see in our daily news portals in Nepali, number of migrant issues have the different health and well-being issues, and even in Latvian families. So in this regard, our research is prioritized. So this paper is only explore the health and well-being related issues among the migrant returning from the Gulf state. And this is a qualitative research, and explore both male and female returning migrants and purposely recruited the participants. And this study was conducted in Thakre municipality, rural municipality of Dhading, one of the municipality district, and which was our project partner implementing site also there. So we interviewed only 20 participants. Among these, in-depth interview with returning migrant, female migrant wife, and KII with the different stakeholders. And all the interview were in Nepali and recorded in audio recorded, and the best quotes were presented in the text for the results. So both University Sussex, IRB, and Nepal Health Research Council ethical approval was obtained, and the individual informed consent was also obtained. So majority of my participants were male, and in the working age until the age of 37, and almost all were married and intention to return in the same country. And most of them work in the manual level, work in the like drivers, security guard, or waiter, etc. So my research, the key findings I derived in the three key themes like health and behavioral related issues, system related, and healthcare access related issues in the both destination and the origin country. So majority of the health related behaviors is the physical health related issues. That was the common health issues too, like workplace violence, abuse, and sexual violence, and some even faced in the unintended pregnancy also. So few quotes are also there. So due to the hot temperature, and most of them were working in the manual levels. we have the problem. And second issue is the mental health related issues, which most of the participants explore that they have some loneliness, depression, anxiety over there, and even in the return in who are in the left behind family, in the family side also, both the due to the absence of the husband, the family also the face same problems. And another is the behavioral and societal related issues and misconceptions. So common is about this mental health realities in the migration like that. We have the difficulty to manage in a home. They intend to send in the Middle East, and their son or daughter will be okay for to work, or the who are unmarried and went in the migrant working over there and returning in Nepal, and the community and society raised the concern to the returning female migrant about her virginity or fertility, so different work-related issues also there. And another issue is system-related barriers in both original in Nepal and in destination countries. That's the main related in the medical test report, who are fit in Nepal, but they are not fit in a destination country, and if they are bound to return in Nepal. And they raise the concern about the pre-departure training package also, which is not suitable to all. And in the destination country, they have the problem in getting the appropriate wage and what they knew in Nepal prior to the flight, but they didn't get in the exact wages over there. And in destination country, Nepalese embassy also they didn't support when they raised the concern about this type of salary and workplace related issues. And another issue is the insurance coverage, which is the insurance is they have the insurance, but they have the partial coverage of the insurance, which is not covered for their full employer full health service, seeking the health services. That's also the major issue in the health seeking issue over there. There is the concern. And health care access related issues in the destination is the language barrier of our migrant workers, who are not able to speak in either English or Arabic language, and they are hesitant to visit to the health facility when they have the problem in the health, despite of they having the insurance and access of the health facility also. So my conclusion is that we need the one progressive policy to both the destination and origin countries to work in the workplace safety. And another is a full, every migrant workers must have the full package insurance coverage, and provided in the Nepal this pre-departure training should be prepared to target it for the particular country issue, health, occupational health and safety related issue. And then even we need to be consider about the left behind families, targeting about their health and well-being related issues. So I'd like to acknowledge to all the participants who provided the information, and COSMIN project where I'm working and working for this project, and NHRC who provided the ethical permission, and Thakre municipality who provided the access of there, and others, our partners, Bintara Nepal, University of Sussex, Brighton Department, and Central Department of English, who are working in the review of the Nepalese migration stories in Nepali literature. So thank you very much.
Thank you, Sarda Prasad Ostiji. Actually, you are also in time, before time I have to say. Then we have finished all the presentation. Now the time is for discussion. I think we have collected many questions, issues, and our participants have put their issues in the chat box also. I think all the respective presenters will go through that chat box if they have access. I think they must have access to read out all these issues. So that now we are proceeding for the discussion. From the first presenter, Dr. Rakesh Ghimire. I think okay, you are here. Thank you so much. There are questions. Okay, there are some questions to you. I think from Dr. Samir Lamichhane, he has put his question as, has this descriptive study generated any sorts of hypothesis that can further be tested?
Yes, thank you, Dr. Sabir, for this question. So yes, knowing the highly hazardous compound by this research would give an insight to the policymaker for the regulation of the highly hazardous pesticides. So afterward, we can check again, go through the next research level, comparing the banning of the pesticide before and after.
Okay, thank you. He has second question also.
Okay.
What suggestion would you give to the policymakers to mitigate pesticide poisoning in Nepal?
Okay. Thank you for this question, Dr. Samir again. From this research, our main aim is to identify the highly hazardous pesticide which is responsible for majority of death in the country. So knowing the particular pesticide which is responsible for the death of the patient could help the policymaker to regulate the pesticide, and after the regulation of the pesticide, it would lead to the less approachable to the people who used to take it. So I think mitigation could be starting from the government, and that could lead to the less affordable to the patient or the victims, so that it can decrease the suicide from the country. Yes.
Okay, thank you. I think a similar question from Professor Bandana Pradhan. The role of government in controlling organophosphorus like pesticides in the market. I think you have, do you want to give?
Thank you, Bandana ma'am, for your questions again. So there has been many efforts that has been given from the Minister of Agriculture to mitigate the pesticide poisoning as well, though they are more concentrated in the agriculture based use of pesticide. So recently, there are many, more than 5 pesticides has been banned by the Ministry of Agriculture in 2019. So I think the government are keeping this in mind in consideration that banning the pesticide could help reduce in the suicide without harming any agricultural product. Yeah.
Okay, thank you. From Chavi Paudel, he has put his issue as the effects of pesticide in human or public health is a major problem. What would be the alternative solution to stop pesticide in institutions and community level?
Okay, well, again, thank you for the question. So this is the main aim of our study, to mitigate the pesticide poisoning, to decrease the use of pesticide. First, we should identify again the highly hazardous pesticide. So through research, finding the highly hazardous pesticide which is responsible for death, and regulating and giving the data to the regulatory stakeholders, and again banning the highly hazardous pesticide is the only solution that the government can do and keeping in mind that it won't harm any agriculture product, increase in agricultural product.
Okay, thank you. From Mr. Bir Bahadur Raul, he's in HMI section in management division, and he has put his issue as it is learned that the medical recording system of suicide is not good.
Yeah.
And dear sir, what kind of medical recorder system is necessary for Nepal? Can your study give some suggestions? For your kind information, the management division of DOHS is preparing a roadmap for HMIS. We would like to be helpful if you can give some proper suggestions.
Okay,
Yeah.
so I'm very thankful for this question, and I'm very knowing the fact that the Nepal has for now. The hospital has very, I mustn't say it's poor. It's like very, the data many data are missing. As I have shown in my presentation that about in the case fatality rate, there was 3%, and the outcome, among all the deaths, the outcome was missing in about 56.2%. So having said this, obviously increasing the, improving the medical record system would certainly help in the regulation, in the decrease of the suicide in the country. So for that, we do have some results coming up. So certainly we'll communicate with you and try to work together to improve the record system of Nepal.
Okay, thank you. There is the last question. I think, from Ghulam Khan. And he has put his issue as, you have mentioned source of organophosphorus poisoning good. Better to highlight month, days, exact timing is important in the poison case. So identification of poison source, quality, quantity of poison, comparison between 2 years may be useful like that. Some suggestion he has given to you.
Yeah, again, so thank you for the question. So the main problem for us to collect the data is the problem with the medical record system. You know, we do have many missing data in the record file. So this is the constraint for our. We wanted to know as much information as possible to know the cause of death and anything we could get from the hospital record. The limitation of this study was that many data were missing in the hospital data. So as the sir from DOHS has come up with the new HMAIS system in the government very soon in Nepal. So maybe after a few years we can get this information in Nepal. Thank you.
Okay, thank you. It is reduce your time for next standing in the quorum. So I have some question to you. Okay. Because I'm doing my PhD in suicide also. Okay. So mental health was in my MPhil. So I have some query to you. As this pesticides or fatal use of this pesticide, and it can cause mortality among the people in our country, and female are more vulnerable for that, and my participants are also reproductive women. So here, but I'm exploring for the causes, many factors, but factors may be hanging and other factors for this suicide may be various reasons, but your purpose is mainly focus on the this organophosphorus or this pesticides use, and it is also related with our environmental dimension of our health also. In this context, how can we compare that what is the fatality rate of from hanging, and there are many ways to commit suicide. Have you gone through those factors?
Yeah. So 2 years back, I was doing a research for 3 years on the different mode of suicide in the country. So from this research finding, it was found that the hanging was the most common mode of suicide, followed by poisoning, and others, they were burning, fall injury, from drowning, and so forth. So the two most common mode of suicide was found to be hanging. First was hanging. Even now, it's hanging, followed by this poisoning. And the problem with this is the poisoning, like the data from the police, they don't mention whether it is pesticide poisoning or it is due to drug overdose or it is due to snake bite. So for now, I can say hanging is the most common mode of suicide, followed by poisoning. And among the different poisoning, pesticide poisoning is for sure is one of the most common poisoning in the country.
Thank you. And last suggestion for all the presenters. Now we have adopted new map of the country. So let's try before going to the printing of our this abstract book. Please do that. Thank you so much.
Thank you, ma'am, for your suggestion. Thank you.
Thank you, Ramesh. I think it's very good because we are in a limited time. Okay. There are another questions for another speaker. Thank you. So you can take your seat. Gaurav Devkota, I think if you are with us, just one Chavi Gaudel has asked the question, how to analyze the barriers, not only of mental health stigma, but also of all types of stigma, including disabilities. Do you want to say anything about these questions? Gaurav Devkota? Okay, so we will talk later. And the final questions to Sarda Prasad Wasti, again by the Chavi Gaudel. Migrant workers are facing psychosocial problems. How to overcome from these problems? Sarda Prasad Wasti. Are you with us?
Thank you very much, sir. Thank you, sir. And thank you, Chaviji, for your question. Yes, I highlighted number of issues which are the contributing factor for this psychosocial aspect. And we all know that health is determined by the number of layer of the factors, not in only one aspect. We cannot say that. So whatever that I highlighted, and whatever that this Middle East, my participants are mostly in the Gulf states. So whatever the issues I highlighted, we need to be at least migrant need to be know the basic things like the language barrier. They are not. They have the insurance card, but due to the language barrier, they are not going to access the health services when they need the health services. So this type of basic information, basic things, and if they will get or if they will fully equip on that will be the most effective source or preventive measure to overcome the psychosocial aspect. But we cannot say that only one thing will inject and then overcome of those things. But there are number of layer of the factors, even in the not in the medical test report, who they are fit and fine to work in the abroad, but when they go and they retest in their work site, they are not fit and they are bound to return in the fall, and they lost their time, their money, their cost, and then that is the associated on that part. So the migrant, they need to be fully equipped before travel or before abroad, before travel to the destination country. That's the main thing I will suggest for that.
Okay, thank you very much. So I think we are coming to the final part of our today's presentations. My co-chairpersons wants to say, and then we'll conclude.
Thank you, Chair. All the presentation actually mainly focuses on mental health, disabilities, and emergency. It is a very pertinent issue in the globe as well as in our country. And before COVID-19, many people were suffering from mental health problem, and there is it is a environmental emergency also. Due to that, it is hampering human health. It is a public health emergency also. So. The first, relating to the first presentation about fatal intestinal pesticide poisoning, there was a study was done by Dr. Abhinav Vaidya and his team in 2015 in Chittagong. It was found that the case fatality rate of that time was 3.8%, and the first this burden fatal intestinal pesticide was also similar. So in Nepal, we can say that the case fatality rate from the this insecticide or rodenticide or pesticide, and it is intestinal was about 3 and between 3 and 4%. So it is very necessary to recommend properly regulate the population, regulate the policy in the community level, in the marketplace, as well in the policy making level and community level. Then some population-based study needs to be done, and I think after 2015 study, the following study, it has covered a lot of people, means population, and it should be representative also. So all the multi-sectoral approach to address this problem is necessary in my opinion. For the second issue about the barrier for utilization of the mental health services in the primary healthcare centers, actually there are other reasons for getting services in the community level health institution or peripheral level health institution. Even in our center level, we have very less number of health provider for mental health seeking people, and the other factors may be not only the stigma, there is barriers of financial, lack of health care providers in the peripheral level also, and stigmatization obviously is there, and discrimination behavior is equally there. And as we all know, due to this, people are not coming to the services, and as we all know that it is coming in the news that during this lockdown means it has saved many lives. At the same time, many suicidal cases were recorded in all the provincial means all the districts, more than 1,500 suicide had happened, and people are not getting proper services, and it is very alarming. And World Health Organization and our government. There are other factors like poor working environment, and it was done some research previously. Also, it has found that perceived health risk of the people, and the accommodation, lifestyle, risk-taking behavior, and work environment, and support from local organization in the destination country, and health service utilization. All are the major Nepalese migrants workers are facing those problems in their destination country, and once they come back to the our origin country, and they are actually suffering, and they are seeking for the services, but still we have to do a long way to go for reducing all these issues. Thank you so much for all the presenters and the participants who have put their issues, and the presenters, they have addressed their question properly. Thank you so much. This all from my side. Now I would like to hand over this session to my chair and to conclude this session. Thank you so much.
Thank you, Ms. Durga Mishra Kharka. And I would like to congratulate all three speakers. Without wasting time, coming to the first today's presentations by Rakesh Kimire. If you see the police records, last 5 years police record, more than 25,000 suicide in Nepal. Among them, more than 6,000 were in the form of poison. That means every day 3 persons commit suicides every day in Nepal by ingestion of the pesticides. That statistic itself is huge. Why the people ingest pesticides? The reason because, especially Nepal, India, SAARC country regions, the reason because the pesticide is easily available. It is cheapest, and it is the quickest way of. Although the females, if you see the statistic suicide, the males commit suicide by hanging, and the females commit suicide by pesticides, more common than male. So every day around 3 persons commit suicides with these pesticides. If it is so, because this is easily available, it is cheapest, and the most important pesticide is the organophosphorus, as Ramesh Kimire has mentioned. And our country is agriculture country, and should we ban pesticides? So this is the questions, and this is the questions for our policy makers. But if we see the research-based strategy of different countries, especially banning highly hazardous pesticides like organophosphorus will be successful in reducing suicides without affecting agriculture product. So probably the easy accessibility and cheapest methods, I think we need to think of this pesticides mode of suicides, and thank you very much, Ramesh. The second presentations, mental health service utilization for primary health PSC facilities, stigma still a major barrier. This is WHO documents, mental health in primary health care, illusion or inclusion. So you have already mentioned inclusion or illusions. You know what is illusions. And according to his presentations, the major barrier is the stigma, discriminations. And if we see the WHO study, country like Nepal, low and middle income countries, where the people, especially those who attend primary health centers, more than 85% of Nepalese people are not getting mental health service from the primary health centers. This is itself is the context why this is important. And if there is because of stigma discriminations, people are not attending, and this is making our people, more than 85% people, their seeking treatment is late, their diagnosis is late, and this will lead to their impairment of daily activities, rehabilitations, recovery, and this will decrease the opportunity in their future life. So has been mentioned that 10 to 50% of people with mental health problems are only getting evidence-based treatments. And one most important part is, as he has mentioned, is the stigma discrimination. Why stigma? The stigma is because of the combination of lack of knowledge, because of the negative attitudes and the discriminations. And so, WHO has already recommended that mental health is important element of health of well-being in primary health care centers. They are common problems in PSC. Half of the mental health problems will start at the age of 14 years, and most of them are undetected or untreated, and there are stigma discrimination, and most of them are treatable. So the mental health service at PSC should be integrated. And the third speakers regarding the exploring health issues of Nepalese migrant health workers and the families. This is a quality study from Sarada Prasad Wasti. Thank you very much, because Nepal is one of the largest suppliers of the laborers. And migrant health has become a great public health issues. And when he has mentioned that there are so many issues, migrant health issues, physical health issues, mental health issues, behavior issues, compensation, insurance issues, I think from this presentations, we need to, the policymaker has to make some recommendations, some policy, so that our people can be, our health will be better. So finally, what I think, we are living with the COVID-19, and thank you very much, Dr. Gyamali is here, Dr. Gyamali is here, and Health Research Council conducted this type of the seminar, virtual seminar. I think this is for the first time. This is how we are also trying living with the COVID. So we are trying to learn how to live with the COVID-19. But don't forget, mental health is there. Mental health and the psychological well-being is an integral part of a person's capacity to fulfill their life, their relationships, the study, work, performances, employments, and other activities. Exposed to the stressors can lead to the mental health problems, especially COVID-19 is as a stressors, and we are getting so many mental health problems. But my conclusion for today's presentation is, we need to manage our stress. We need to live with the COVID-19. So for that, the important part is get adequate sleep. हामीहरु कम से कम 6 देखि 8 घण्टा राति सुतौं. Get adequate exercise at home by maintaining social distance. Very important aspect. At least 45 minutes dekhi 1 hour. We should do some form of exercise, because exercise will metabolize our negative hormone, especially cortisol hormone and adrenal hormone. Very important aspect. Have a balanced diet. Very important aspect, especially vitamin C, multivitamins, B complex with vitamins D. This will also increase our immunity power. And avoid alcohol, illegal substance, and maintain our routine the way we are doing it. Think positive, develop positive attitudes. Last but not least, if we are having stress, because presenters are now on stress, the organizers are on stress, we are in stress, but if you are having stress, just go and see deep breathing exercise from YouTube. So anytime, at any time, even I can do now, the breathing exercise, that will decrease our stress. This is how we have to cope the stress of COVID-19 and live with the COVID-19 and manage our stress. Thank you very much, all the speakers. Thank you very much, Pallavi. So I would like to hand over you. Thank you.
Thank you, sir. Now we come towards the end of the session on mental health, disabilities, and emergencies. And I would like to thank our chairpersons for lending their time and expertise for the session on mental health for our summit. I would also like to thank all the participants for sharing their research on our platform. Last but not the least, I would like to thank all the summit participants who are in attendance virtually and for joining our session through Zoom, Facebook, or YouTube. Thank you all so much. Now I'd like to invite on stage our Executive Chief, Dr. Pradeep Kewali, to present a token of love to our chairpersons as a show of our gratitude and appreciation. Since we have one of the presenters with us here today, we would first provide a token of appreciation for our presenter. I would like to invite our chairs onto the stage. Dr. Rakesh Kimiri. To our other participants, we would like to thank virtually for their presentations. Thank you both. Now I'd like to invite Dr. Pradeep Kewali to hand over the token of appreciation to our chairs. Professor Dr. Saroj Ojan. Associate Professor Durga Khadka Mishra. Thank you, sir. Thank you, ma'am. So now, with the permission of our chairs, I would like to conclude this session. We will take a short... Now, we move on to the next presentation, and the next session of the summit, which will be on non-communicable diseases. Sorry for the technical error. We will decide. Okay. We move on to a short break of 2 minutes before we continue with the next session on non-communicable diseases. Please stay with us. We will be back shortly. Namaste and a very good afternoon to all our distinguished guests, session chairs, and participants joining us online. I'm Dr. Kriti Adhikari, Research Officer at Nepal Health Research Council, and it gives me a great pleasure to be your Master of Ceremony for the session Non-Communicable Diseases. In this session, we have altogether of 6 presentations, which will be followed by question and answer session, followed by remarks by chairs, like earlier sessions. So without further ado, I would like to take this glorious opportunity to welcome prominent personalities on the dais, Professor Dr. Bhagwan Koirala and Professor Dr. Abhinav Vaidya to chair this session. Dr. Koirala is known for pioneering the open heart surgery program in Nepal since 1997. He has led the Nepal's first heart hospital, Shahid Gangalal National Heart Center, and as the executive director. Apart from serving as the executive director at 2 national heart centers, he is the executive director of Trivandrum University Teaching Hospital. Dr. Corella has served as the executive vice chair of Health Profession Education Commission. He has also served as a member of Policy Advisory Committee of the Ministry of Health of Nepal and facilitated the inclusion of non-communicable diseases as a policy agenda in the National Health Policy. He has been awarded with the Supraval Gorkha Dakshin Bahu 4, Birendra Aishwarya Medal for Outstanding Service in 2001, Manager of the Year Award 2008 from Management Association of Nepal, Supraval Jana Sewa Shri 3 in 2012, and Sukirti Maya Rashtradeep 3 in 2019 from the President of Nepal. Currently, he holds a position of Head of Department of Cardiothoracic and Vascular Surgery at the Institute of Medicine, Trivandrum University, and serves as a national co-chair of Nepal NCDI Poverty Commission. Welcome, sir. And Dr. Vaidya is a professor of community medicine at Kathmandu Medical College under Kathmandu University. He has been involved in NCD-related research, academics, policy development, projects, advocacy, and health promotion. He is the principal investigator of NIH-funded BRISC project that aimed to build research capacity for prevention and control of NCD risk factors. He is a lone scholar in cardiovascular health at Harvard T.H. Chan School of Public Health. He functions as the member secretary of Nepal NCD Alliance and as the National Commissioner for Lancet Commissioned NCDI Poverty Commission. He was the thematic committee member of Nepal's multi-sectoral action plan for prevention and control of NCDs, technical committee member of WHO staff surveys, and NCD pen package. Welcome, sir. Thank you, chairs. It's an honor to have you with us. Moving further, I would also like to welcome our presenters for this session, Binod Kumar Yadav, Rajaram Dungana, Gagan Neopane, Kalpana Sharma, Saruna Gimire, and Rashri Thapa. Without further delay, I would now like to hand over the session to our chairs. Over to you, sir. Thank you.
Thank you very much, Kriti. It's indeed a matter of great pleasure to be back and to be sitting like this with everyone. I think the sessions are going great, and except for the loud applause that we used to hear from the audience, I think everything else is basically the same. So with permission of Dr. Koirala, and I must say that it's a privilege to be standing, or sitting rather, alongside him. So just looking at the 6 presentations that we have lined up today, I think it's a great set of presentations, and it's mixed, I would say, in the sense that many of them are cross-sectional, many are interventional, some have, worked on the secondary data and like that. So it's a good mix, I would say. And also from gender perspective, I was actually thinking about it when Dr. Suresh Tiwari mentioned it, like in that session there was only one female presenter. I think this session is a great balanced in terms of gender as well. So we have 3 male and 3 female presenters, but rather, but on a slight lighter note, both the female presenters are in the second half of the presentations. Anyway, so I think if you permit, sir, we can start with the first presentation, and I would like to invite Binod Kumar Yadav, who is going to tell us about the impact of type 2 diabetes mellitus on erectile dysfunction and sex hormone levels, and what physicians need to know. So let's get on with it. Thank you.
Namaste, everyone. So here I am going to discuss the impact of the diabetes mellitus on the erectile dysfunction and its association with the sex hormone, which the treating physician of the diabetes should know. It was done at the Institute of Medicine. So as you know, the diabetes is one of the most prevalent metabolic disease, which is characterized by the hyperglycemia, which is one of the top 5 non-communicable diseases, and it is characterized by the either resistance of the excess of insulin or inadequate compensating insulin secretary. In Nepal, the 2016 data shows 9.1% of the general population have the diabetes. So as beside this other complication that you can see over here, the psychosocial impact of the erectile dysfunction is also one of the worth looking into. So So among that, this is the testosterone regulatory in nearly every component of erectile dysfunction in all the human beings. And several studies have shown 30 to 50% men with the type 2 diabetes have testosterone deficiency. And among them, 75% have the sexual dysfunction. So the reported frequencies show the very different. That is one. So this is the International Index of Erectile Dysfunctions. Is a multidisciplinary validated questionnaire with 15 questions. With that questions, we find out the different 5 domains, and among these 5 domains, we can see we have characterized this type of the questions here, and then we finally score the erectile dysfunction, which is less than 21 is taken as no erectile dysfunction, more than 20 is taken as the erectile dysfunctions. So this is the questions over here. We have given these questions and asked the attending participant, and we categorize this one as the score over here, and finally we total, and then we categorize the less than ED and more than 21 ED and less than 21 ED. On the basis of that, we categorize erectile dysfunction is present or not. So this is the hypothesis you can see over here. Any type of the diabetes that is because of the either insulin resistance or even you can see their function. This insulin resistance may be because of the obesity also, and these both can cause the androgen deficiency. This obesity can cause the metabolic disorder syndrome also, and this metabolic syndrome, obesity and insulin can cause the androgen deficiency, and this finally lead to the erectile dysfunction. That is here you can see the testosterone hormones. So several studies have shown the association of the diabetes with erectile dysfunction with HbA1c and the duration of the diabetes. Similarly here, we can start this study, we can hypothesize this type of the study has not been done in Nepal. No single study has been done the association of the testosterone, free testosterone, and this knowledge of this magnitude is the enable physician to identify such problem, and that will help them to support the quality of the diabetes patient. So that's why physicians should know the cause of these things. So the study objective was simply when we evaluate the impact of the type 2 diabetes on erectile dysfunction. For that one, we find that this androgen hormone, testosterone, free testosterone, SSBG, erectile dysfunctions, and their association with this one. So this is the criteria we set in the. We choose the diabetes patient 13 to 16. We exclude any type of the other disorder with them. So among this, we can find over here, this is a general finding in this study. Among this, here you can see the more than 50% are the obese patient. And even in that one, more than, you can say the 67% has the any type of the erectile dysfunction. Here you can see the mild, moderate, and this is the mild to moderate and the severe. So this is the type of the, among them, around 50% have this mild erectile dysfunctions. So then we can also check over there the type of the disease. Then you can find the diabetes with the hypertension. 74. This is the 26% of diabetes hypertension. Then similarly, the around 66% of the duration of diabetes less than 5 years, and 11% at the 10 years. Then another habit we can see over here: 89% non-smoker, while 11% are the smoker among the study group. Now this is our actual finding on the sex hormones. You can see over here among this participant, the total testosterone. You can see over here the erectile dysfunction have the significantly lower than the erectile not erectile group. Similarly here the free testosterone again you can see the significantly lower among the erectile dysfunction group. Same way you can see where the HbA1c is also significantly playing a role, significantly high among the erectile dysfunction group among the study group. Similarly, the duration of diabetes is more among the erectile dysfunction group. So these all factors are the causative, we can say, the causes of the erectile dysfunction among the study group. Similarly, you can find, we set the one of the cutoff value like the 300 nanogram the testosterone as per the USA Endocrine Society. Among this, you can see where higher the BMI, lower the cutoff value, lower the we can find over the testosterone. Similarly, here the erectile dysfunction has the significant low cutoff value. So similarly, the duration of diabetes, higher the duration of diabetes, significantly this low the testosterone value. So these are again, it depends upon the erectile dysfunction upon the BMI, then the erectile, this is the duration, you can say the cutoff value, and then the duration of the diabetes. Then we can again find the association of this our finding with the diabetes and other symptoms. Like we have in the study group, diabetes and hypertension. So we find over here, this waist circumference is significantly higher with the diabetes and the hypertension. Similarly, the IFS score is lower in the diabetes and the hypertension. So this is again the cause, the diabetes and hypertension synergistic cause for the cause of the erectile dysfunction. So this way you can say the hypertension and the waist circumference is higher, and the diabetes and hypertension can cause again the erectile dysfunction. Same we can find another, analyze the serum testosterone, free testosterone, IF score, and this hormone, sex hormone binding protein with the different this duration of the diabetes. So in all find you can say higher, like in this one, more the duration of the diabetes, lower the value. So this way you can say this is the again significantly different among them. Free testosterone same way here, higher this one, then we are getting the lower value. But most of the study you can see more than this 10 years have the significantly lower value than the more than 10. It may be because of the sample size low over here. Similarly, IF score you can see the same one. So this is the these three things we have seen over here, higher, significantly different between the these three our endocrine markers, or you can say the hormonal markers. So again, now we find the correlation. We can see over the BMI, duration of diabetes, waist circumference, and HbA1c are the negatively correlated the testosterone level. So that means if these values are high, suppose BMI is high, low value of the testosterone, duration of diabetes is high, low value of this one, HbA1c is high, the low value of this testosterone. So these are all ultimately affecting the this we can say the erectile dysfunction cause. So then again we find here you can see the HbA1c is again higher in the case of the erectile dysfunction. They are significantly high with the other parameters. So the take-home message you can say from this finding, total testosterone, free testosterone, and sex hormone binding is this is the value for the Nepalese population for this number of the sample. But this is cannot be generalized because it is a single center study. So most of the study have shown the overweight is one of the category for the BMI and the waist hip ratio, and these are significantly low in the case of the testosterone, and which is the one cause of the erectile dysfunction in diabetic patient. Similarly, glycated hemoglobin was higher, then higher HbA1c was observed in the patient with erectile dysfunction. So that means we have to control our diabetes, the cause you can say the HbA1c. If HbA1c is the this is the normal, then you can say the erectile dysfunction possibility will be low. So the conclusion of my study you can see over here, the serum testosterone and the free testosterone value of the HbA1c are studied with the highly likely of the erectile dysfunction diabetic patient. So it is important to address glycemic control when attempting to treat the erectile dysfunction. This is the message for the treating endocrinologist for the diabetic patient. So we are this type of the things in our developing country, the patients are not expressing their view to the physician. So then the physician has to take extra action, extra questionnaire to them also. They have some type of this erectile dysfunction present or not. Also, you have seen over in our study, body mass index is also associated with the lower testosterone value, free testosterone value. So this is again taken the consideration while treating. So you have to control your body mass index. That means the weight and the weight ratio, because these all things we have seen, they are associated with the finding. So above that, this is the finding of the one center study, so we cannot make this is the generalized for the Nepalese population. This is hospital based, so that is the limitation of our study. So to make generalized, this study has to be done in the large population, then you can make the generalization. So here we have two things, not to keep in the secret. So the hidden things should come in the discussion, because discussion will give us solution at least one day. So that's why don't hide anything to our physician, and physician also sometimes, because we are living in the developing country, we should take these things in, especially while treating the diabetes patient. Physician or endocrinologist has to ask this type of the symptom they have or not. So this is the all, and I would like to acknowledge the IOM Institute of Medicine, Department of Biochemistry, NHRC for the grant of this study, then the Manglunim who have supported for the reagent, and then all the participation which make this study the successful. So thank you for this listening. If any question and query, the most welcome. Thank you.
So we'll keep the question and answer session at the end, right? So, okay, so shall we move to the next presentation? We have all set. Okay, the next presentation will be by Dr. Rajaram Dhungana. Impact of a structured yoga program on blood pressure reduction among hypertensive patients in Nepal, findings from randomized multi-center trial. It's an interesting paper. Let's hear what he has to say, and then we'll keep questions at the end. Rajaram Dhungana, please.
नमस्ते, म राजाराम ढुङ्गाना, म लगायत अन्य
15 अनुसन्धानकर्ताहरूले गर्नुभएको अध्ययन इफेक्टिभनेस अफ योगा इन्टरभेन्सन अन ब्लड प्रेसर रिडक्सन को बारेमा आज म केही भन्न गइरहेको छु। If you can't understand Nepali and if you want to know anything about this study, please feel free to contact me via email or with any social medias. अबको 10 मिनट्समा म तपाईहरुलाई यस अनुसन्धानको पृष्ठभूमि त्यसपछि मेथड्स र यो स्टडीको फाइन्डिङ्स बारेमा भन्न गइरहेको छु। 2019 गत वर्ष एउटा मेटा एनालाइसिस पब्लिश गरेको थियो मायो क्लिनिक प्रोसिडिङ्समा, जसले चाहिँ 49 वटा योगा र हाइपरटेन्सन सम्बन्धित कन्ट्रोल ट्रायललाई मिलाएर रिजल्ट निकालेको थियो र निष्कर्ष के थियो भन्दा योगले उच्च रक्तचापका बिरामीहरूको रक्तचाप घटाउनलाई सहयोग गर्दछ। तर ती अनुसन्धानहरू प्राय कन्ट्रोल इन्भाइरोमेन्टमा गरिएको र त्यस्तो कन्ट्रोल इन्भाइरोमेन्टमा गरिएको अनुसन्धानहरू कहिलेकाहीँ रियल ओल्ड क्लिनिकल सेटिङमा जस्तै जिल्ला अस्पताल, जिल्ला आयुर्वेद स्वास्थ्य केन्द्र, प्राथमिक उपचार केन्द्रहरूमा लागू गर्दाखेरिमा जुन इफेक्ट हुनुपर्ने हो त्यो नहुन पनि सक्ने भएको भएर इफेक्ट नहुन पनि सक्छ र त्यसका विभिन्न कारणहरू हुन्छ, कन्टेक्चुअल फ्याक्टरहरू भन्छौँ जसलाई हामी। तीमध्ये जस्तै एक्जाम्पलको लागि लागू गर्ने संस्थाहरूको वस्तुस्थिति, रिसर्चमा भाग लिने पार्टिसिपेन्ट्सहरूको उहाँहरूको धारणा र सरकारको प्रोग्राम र पोलिसिजहरूले गर्दाखेरिमा पनि असर पार्छ। त्यही भएर चाहिँ हामीले योग र उच्च रक्तचाप को अनुसन्धान चाहिँ रियल वर्ल्ड क्लिनिकल सेटिङ, प्राइमेरी केयर सेटिङमा चाहिँ योगले रक्तचाप घटाउनलाई कतिको सहयोग गर्छ भनेर गरेका हौं। यो अनुसन्धान चाहिँ हामीले 7 वटा जिल्लामा रहेको जिल्ला आयुर्वेद स्वास्थ्य केन्द्र अथवा अञ्चल आयुर्वेद स्वास्थ्य केन्द्रहरूमा गरेका हौं र यसको स्टडी पिरियड अध्ययन अवधि भनेको 2017 देखि 2018 सम्मको हो। यसमा सहभागी भएका बिरामीहरूको बारेमा भन्दाखेरिमा उहाँहरू चाहिँ ती अनुसन्धान केन्द्रहरूमा आफ्नो उच्च रक्तचापको लागि उपस्थित हुनुभएका, जसको उच्च रक्तचाप चाहिँ प्रारम्भिक अवस्थामा रहेको र जसलाई डायबिटिस अथवा क्रोनिक किडनी डिजिज नभएको अवस्थामा उहाँहरूलाई हामीले अनुसन्धानको लागि छानेका थियौं। 7 वटा सेन्टरबाट हामीले जम्मा 121 जना सहभागीहरू छानेका थियौं र ती सहभागीहरूलाई निष्पक्ष हिसाबले योग गर्ने ग्रुप र योग नगर्ने समूहमा हामीले विभाजित गरेका थियौं। योग गर्ने समूहमा 61 जना, योग नगर्ने समूहमा 60 जना थिए। त्यसपछि योग गर्ने समूहका बिरामीहरूलाई हामीले 5 दिनसम्म योग ट्रेनिङ दिएका थियौं र 90 दिनको लागि घरमै बसेर दिनको एक पटक 30 मिनट, हप्ताको 5 पटक उहाँहरूलाई योग गर्नको लागि अनुरोध गरेका थियौं भने दुवै योग गर्ने समूह र योग नगर्ने समूहको लागि 2 घण्टाको उच्च रक्तचाप सम्बन्धी सन्देशमूलक क्लासहरू पनि लिएका थियौं र योगको प्याकेज चाहिँ 30 मिनटको थियो। त्यसको सुरुको अवस्था 9 मिनटमा चाहिँ 9 मिनटमा चाहिँ सूक्ष्म व्यायाम र आसनहरू थिए भने त्यस पछाडिका 9 मिनटमा प्राणायाम थिए र बाँकी 12 मिनटको लागि भने मेडिटेसन र रिल्याक्सिङ पोस्चरहरू गर्नुपर्ने थियो। हामीले अनुसन्धान सुरु भएको पहिलो दिन र अनुसन्धान सकिएको अथवा अनुसन्धानको अन्तिम दिनमा तथ्याङ्कहरू सङ्कलन गरेका थियौं र ती तथ्याङ्कहरूलाई विभिन्न र साइन्टिफिक वे वैज्ञानिक तरिकाबाट एनालाइसिस गरेका थियौँ र त्यो एनालाइसिस गरिसकेको परिणामले के देखाउँछ भन्दाखेरि योगले सिस्टोलिक ब्लड प्रेसर 7.4 mmHg सम्म घटाउन सक्छ, डायस्टोलिक ब्लड प्रेसर 3.5 mmHg सम्म घटाउन सक्छ। उदाहरणको लागि यदि कसैमा 136 mmHg सिस्टोलिक ब्लड प्रेसर छ भन्दाखेरि योगले गर्दाखेरिमा 128-29 को लेभलमा ल्याउन सक्छ सिस्टोलिक ब्लड प्रेसर। डायस्टोलिक ब्लड प्रेसर उदाहरणको लागि 85 छ भने 82 तिर ल्याउन सक्ने अवस्था रहन्छ। योगको परिणाम अथवा इफेक्ट जुन देखिएको थियो त्यो औषधि खाने अथवा नखाने, महिला अथवा पुरुष, धूम्रपान गर्ने अथवा नगर्ने, रक्सी खाने अथवा नखाने सबै समूहको लागि उस्तै प्रकारको प्रभाव रहेको देखाउँछ। यसबाट के निष्कर्ष निकाल्न सकिन्छ भन्दाखेरि स्वास्थ्य कर्मीहरूद्वारा नै सञ्चालित योग ट्रेनिङ र 3 महिनाको घरमा बसेर गरिएको अनुसन्धानले उच्च रक्तचापका बिरामीहरूको रक्तचाप घटाउनलाई सहयोग गर्दछ। यसकारण उच्च रक्तचापका बिरामीहरूलाई उच्च रक्तचाप सम्बन्धी औषधि सँगसँगै योग पनि सिकाउने र घरमा गर्नलाई सल्लाह दिने हो भने उहाँहरूले अझ धेरै फाइदा पाउनु सक्नुहुनेछ। यो अनुसन्धान चाहिँ हामीले 7वटा सेन्टरमा मात्रै गरेका थियौँ र 7वटा सेन्टर बाहेक अथवा 7वटा जिल्ला बाहेक अरू जिल्ला र अन्य स्वास्थ्य संस्थाहरूमा गर्नु पूर्व चाहिँ त्यहाँको ती संस्थाहरूको वस्तुस्थितिको थप जानकारी हुनु आवश्यक रहने भएकोले हामीले अर्को एउटा छुट्टै अनुसन्धान गरिरहेका छौँ जसले ती संस्थाहरूमा यो अनुसन्धान पछि गएर लागू गर्दाखेरिमा यसले इफेक्टिभ रिजल्ट दिन सक्छ कि सक्दैन भनेर हामीले बुझिरहेका छौँ। त्यो अनुसन्धान चाहिँ अहिले अहिले सञ्चालनमा छ। यति भन्दा भन्दै छुटाउन नहुने कुरा के भन्दाखेरि यो अनुसन्धानमा पनि केही लिमिटेसनहरू छन्। ती लिमिटेसन मध्ये चाहिँ प्रमुख लिमिटेसन भनेको यो अनुसन्धानमा 90 दिनमा घरमा योगाभ्यास गराउँदाखेरिमा सहभागीहरूले नियमित गरे अथवा गरेनन् अथवा कति दिन गरे भन्ने विषयवस्तुको जानकारी छैन। तर त्यस लगत्तै हामीले 18 जना बिरामी अथवा सहभागीहरूमा गरेको सोधखोज अथवा इन्टरभ्यूमा चाहिँ उहाँहरूले गरेको भनेर जानकारी दिनुभएको छ। साथसाथै यो अनुसन्धानले चाहिँ योगले उच्च रक्तचापमा कसरी काम गर्यो भनेर त्यसको बारेमा केही थप जानकारी दिन यो अनुसन्धान चाहिँ समर्थ हुँदैन। त्यसको लागि अन्य अनुसन्धानहरूको आवश्यकता पर्दछ। यति भन्दा भन्दै मैले यो अनुसन्धानको बारेमा तपाईहरूलाई जानकारी दिएँ। तपाईहरूलाई त्यस्तो कुनै विषयमा प्रश्नहरू राख्नु छ भने तपाईँले प्रश्न सोध्नुहुन्छ, प्रश्न अहिले सोध्नुहुन्छ अथवा पछि पनि केही प्रश्नहरू छ भने तपाईँलाई सुरुको स्लाइडमा देखाएको एड्रेसहरूमा तपाईँले मलाई कन्ट्याक्ट गर्न सक्नुहुनेछ। तपाईँको उत्तर दिनको लागि म सधैँ खुसी हुनेछु।
राजारामले सुनिरहेछ कि छैन? थ्याङ्क यू भेरी मच राजाराम। यो इन्ट्रेस्टिङ एउटा हाम्रो आरसिटीको जुन सेयरिङ भयो, यसपछि अब हामी नेक्स्ट प्रेजेन्टेसनमा जाँदैछौँ विच इज बाई गगन न्युपाने र हि इज गोइङ टु प्रेजेन्ट अन प्रिलिमिनरी फाइन्डिङ्स फ्रम नन कम्युनिकेबल डिजिज इन नेपाल एनसिडी नेपाल स्टडी। उहाँको के छ प्रस्तुति हामी सुनौँ अब। थ्याङ्क यू।
Good afternoon and namaste. My name is Dr. Gagan Neupane. I'm one of the volunteer physicians at Health Foundation Nepal, and I'm an incoming PGY1 internal medicine resident at Florida Atlantic University. On behalf of NCD Nepal team, today I'll be talking about our preliminary findings on non-communicable disease in Nepal study, the NCD Nepal study. Here's a list of our authors and affiliations. We declare we don't have any conflicts of interest. Our funding comes from unrestricted support from a non-profit health foundation in Nepal. A little bit of background on non-communicable diseases. We all know these are the leading causes of death globally, with more than 2/3 of death per year. Of them, cardiovascular disease is the #1 cause of death from NCDs, followed by cancer, respiratory disease, and diabetes. It's a chart from IHME 2017, which compares 2007 with 2017 top causes of death in Nepal. Ischemic heart disease remains to be the #1 cause of death in both in 2007 and 2017. However, if we go down the list, we can see a shift in the burden of national burden paradigm from more from infectious towards more towards non-communicable diseases. In the context of Nepal, there are very limited studies on non-communicable disease, and those which are present in Nepal are only mostly cross-sectional in design with limited sample size, and they do not incorporate laboratory investigations. It is expected that out of total years of life lost due to premature deaths, 49% are due to non-communicable diseases in Nepal. So in view of this, there is an increasing call for implementation epidemiological study of non-communicable diseases in Nepal, and also a national policy is required to identify and treat people with NCD at earlier stages. So far, this is what we are doing. This is a community-based and longitudinal prospective study to understand the epidemiology of non-communicable diseases and to test the effectiveness of community-based implementation approaches in rural Nepal. Yeah, this slide shows the same thing. The objectives are also to foster research and education and to aid clinical practice of non-communicable disease management. The study site is Dang District, Province 5, Gorai Sub-Metropolitan City, Ward number 3, 4, 6, and 7. Here we often get questions regarding the sample size selection, and here I'd like to clarify that we'd like to enroll all the people, eligible participants from Ward number 3, 4, 6, and 7. And in the future, we'd like to expand to the adjoining wards. Any residents aged 40 to 75 years old are eligible to participate in the study. And based on the census of 2018, there is an estimate of total of 7,000 eligible participants. So our study on methods of NCD Nepal study has been published in April 2020, and it's available in PubMed. It's basically shows what we have been doing and how we have been doing all this. I'll not go into the study setting details, but this is a summary of what we have been doing. We perform validated questionnaire interview and physical exams, and then based on comprehensive risk factor assessment, we send laboratory investigations in high-risk participants. From the initial visit, there are 3 pathways for follow-up. If the patient is at risk, we follow up in 1 year. I mean, if the participant is at risk, we follow him or her up in 1 year's time. And then if without any non-communicable disease, we follow them in 2 years' time. And if with non-communicable disease, we follow them frequently based on our protocol. These are the list of study variables. Altogether, there are 320 variables from the initial visit and 122 variables from the follow-up visit. This is the broader working protocol that we have been following. I'll not be going into the details, but this is what we have been doing. We have seriously dedicated protocols and to manage non-communicable disease like hypertension, diabetes, hyperlipidemia, tobacco cessation. So let me talk a bit about study challenges and future directions. Though we receive unrestricted support from Health Foundation Nepal in terms of financial support, we do have challenges in sustainability of financial support and staff recruitment. In future, we expect support from the government and other stakeholders, including Nepal Health Research Councils and other researchers. So till December 2019, we enrolled a total of 1,232 participants, and this is just a preliminary report of what we enrolled. We are still enrolling the participants. Based on the demographic findings, the average age was 54 years. there were 63% females. The average monthly income was less than $100, and most of the people studied up to primary or secondary levels. The average body mass index was 24 kg per meter square. The average waist circumference was 82 centimeters. 14.2% of the people were current active smokers, and 14.5% were unhealthy alcohol users. The average daily salt intake was 13.4 grams per day, which is much higher than what is recommended by American Heart Association. And the average daily fruit and vegetable intakes were respectively 1.1 and 1.6 servings per day. This table shows the level of physical activities. There's a bunch of data here, but what I would like to highlight is about 17% of the people, participants, were involved in the vigorous activities, which means more than 6 metabolic equivalents, and more than 16% of the people were involved in work-related vigorous activities. In selected high-risk group of individuals, we performed laboratory investigation, including lipid profile. These are the average of lipid profile, total cholesterol. And here I would like to highlight 213 mg per deciliter was the average triglyceride level, which is much higher than the normal range. Similarly, the random glucose level average was 126 milligrams per deciliter. The average fasting glucose was 123, and hemoglobin A1C average was 7% in selected group of individuals. These are all average values of laboratory data. So now the prevalence of diabetes was 7.5%. However, 16.3% of the people were not aware that they have diabetes. Likewise, 27.3% were had diabetes or elevated glucose level, and a lot of people were not aware about their findings. So the prevalence of hypertension was much higher than I expected. It was 30.2%, and 46.5% were not aware of those findings. So we also calculated the average systolic and diastolic blood pressure, which are found to be 124/77 millimeters of mercury. The prevalence of coronary artery disease was 1.1, which was a little bit higher in males compared to females, and the prevalence of congestive heart failure, stroke, and peripheral arterial disease was less than 1% each. So this brings us to the conclusion. The NCD Nepal study will help better understand the epidemiology in Nepal, and we believe it can help develop guidance in framing national policy in addressing non-communicable diseases. We'd like to acknowledge Health Foundation Nepal, a non-profit US-based organization run by more than 100 US trained physicians. Basically, non-communicable disease project is one of the projects of Health Foundation Nepal. We'd like to thank all the team members of Health Foundation Nepal for this support. Thank you.
With non-communicable disease in a medical college, Chitwan. Kalpana Sharma, please.
Namaskar, Kalpana Sharma, working as an associate professor in Chitwan Medical College. First of all, I would like to welcome you all in this presentation. The title of my study is Psychiatric Morbidity in Patients with Non-Communicable Disease in a Medical College, Chitwan. Regarding background, non-communicable diseases are emerging as a leading cause of death globally and Southeast Asian region as well. It accounts 68% of all death in 2012, and 74% of this death occur in low and middle income country. In Nepal, NCD prevalence is 31% according to the hospital-based study, and it accounts 66% of national death in 2016. And psychiatric morbidity such as depression and anxiety are high in NCD patients. They are collectively responsible for 72% of all death. One study in India shows 19.1% anxiety, 29.1% depression, and 35.1% symptom of somatization in NCD patients. This coexistence of psychiatric disorder with various NCDs have important implications in terms of quality of life, general well-being, cost of treatment, and general longevity of the patient. And these conditions are usually underdiagnosed and undertreated due to stigma and discrimination, as well as there are dearth of information regarding the topic. So our objective was to find out the psychiatric morbidity in patients with NCDs in a medical college, Chittagong. And specific objectives were to identify the severity of psychiatric morbidity in patients with NCD, to measure the association between psychiatric morbidity and selected variable of patient, and to identify the factors associated with psychiatric morbidity in patients with NCD. For this, we use cross-sectional survey and population of the study where those patients who were suffering from chronic NCD such as type 2 diabetic mellitus, hypertension, coronary artery disease, chronic kidney disease, and chronic obstructive pulmonary disease, either alone or combination, and they were suffering from this disease for at least 1 year and admitted in the hospital for the treatment. And this study was conducted in inpatient medical department of Chittagong Medical College Teaching Hospital. And calculated sample size was 926, and it was calculated based on the prevalence of 31.7% according to Sangwa et al. 2009. And samples were selected purposively, and patient health questionnaire was used to collect the data, and this questionnaire consists of 3 sections: PHQ-9 for depression, GAD-7 for anxiety, and PHQ-15 for somatic symptom. And data was collected through face-to-face interview methods from 15 June 2018 to 17 September 2019. And prior to data collection, ethical approval was obtained from CMC IRC, and informed consent was obtained from the participants. And obtained data were analyzed in IBM SPSS version 24 window. Descriptive statistic and bivariate analysis were performed, and ordinal logistic regression was performed for all the variables with p-value less than 0.10 in bivariate analysis by controlling the confounding and multicollinearity to analyze the associated factor. Regarding result, this table shows the socio-demographic characteristic of the patient, and the highest proportion of patients were 50 to 69 years, and more than half were female and literate. More than 2/3 of the patients were urban residents and living in joint family structure, and common occupation was agriculture. And this table shows the clinical characteristic of the patient, where 57.8% of the patient disease duration was less than 5 years. And these are the type of NCD we included, where more than 1/3 of the patient have mixed NCD, and 64.3% of the patient have history of hospital admission in the last 1 year. This table shows the level of anxiety among NCD patient, and out of 926 patients, 34.4% of the patient have some level of anxiety disorder. Among them, 17.7% has mild, 13.8% moderate, and 2.9% has severe anxiety disorder. And among 5 illnesses, diabetic and CKD patients have higher anxiety disorder compared to other illness. Likewise, depression is also common among the diabetic and CKD patient. And out of 926 patients, 40.9% have some level of depression. Among them, 18.0% have moderate and 1.7% has severe depression. And this table shows the symptom of somatization, where 66.1% of the patients have symptom of somatization. Among them, 21.4% had moderate and 5.8% had severe symptom of somatization, and these symptom of somatization are also common among diabetic, hypertensive, and CKD patients. And this table shows the predictor of level of depression among patients, where patients who were staying in the nuclear family were more likelihood to depression. Likewise, those patients who were engaged in agriculture, homemade work, and cash payment were more likely to protective against depression than the other. Likewise, those patients who has illness impact on job, who has other diseases along with NCDs and who have history of NCD in the family were more likely to have depression, whereas those patients who were satisfied with their current medical treatment were more likely to protective against depression. Likewise, in the level of anxiety, those patients who were involved in agriculture and homemade work were more likely to protective against anxiety, whereas those patients who experiences illness impact on job were more likelihood to anxiety disorder. Similarly, those patients who were Brahmin and Kshetri and Janjati ethnicity were more likelihood to protective against anxiety disorder, whereas patients who have other diseases and history of NCD in the family were more likely to have anxiety disorder. In conclusion, psychiatric morbidity is common among the patients suffering from NCD. Patients with mixed NCD tend to have higher psychiatric morbidity compared to patients with single diseases. Psychiatric morbidity are influenced by many factors such as age, occupation, illness, impact on job, presence of other diseases, satisfaction with current medical treatment, and history of NCD in family. Hence, regular screening services for risk group are needed to identify and treat the psychiatric morbidity in all levels of healthcare center. And we would like to acknowledge University Grant Commission, Chiton Medical College, and all the participants of this study. These are our references. Thank you.
Thank you, Dr. Sarma, for your nice presentation. We'll now move ahead with another presentation. In the last few years, we have witnessed a lot of studies and publications that have worked on the secondary data, and especially with the open access to STEP survey, for example, or to NDHS data. I think we are now able to look at many correlates of the associations which were otherwise, quite not that much explored in the past. One such example is the next presentation that Ms. Saruna Ghimire is going to present to us, and it's about association of altitude and urbanization with hypertension and obesity in Nepal, and it's an analysis done from the NDHS 2016 data. So let's hear from Ms. Ghimire. Thank you.
Namaste everyone, my name is Saruna and I'm assistant professor in the Department of Sociology and Gerontology at Miami University in Oxford, Ohio. I want to thank NHRC for providing me this opportunity to share the finding of one of my study that I did with team member, which are listed in here. I want to acknowledge Suresh Mehta, Nipun Shrestha, Emily Atkins, Deepak Kumar Karki, and Sivraj Misra, who are also co-author in this paper. The title of the presentation is Association of Altitude and Urbanization with Hypertension and Obesity. This is one of the study, excuse me, we did using NDHS, that is Nepal Demographic and Health Survey 2016 data. So for today, given the limited amount of time, I will be only focusing briefly on background, methodology, the major findings of my study, and conclusion. I have to disclose here that we did a lot of analysis, and given the limitation of time, we were not able to include everything in 10 minutes, but if anybody is interested, the paper is almost close to being published publicly, so I would be more than happy to share link of the paper. So let me start with giving a brief background on why do we really care about this topic, and that relates back to the increasing burden of non-communicable disease in our country. So in the back in the days, we were thinking more about infectious disease and how it had toll on death. But if you see the recent trends, NCDs are taking over communicable disease, and in 2017, cardiovascular disease was the top cause of death in our country. Now, a little bit on what are the common risk factors for NCDs or the major cause of death in Nepal. So we have both non-modifiable risk factor like age, sex, family history that we can barely even have control over. So a best strategy would be to prevent all those preventable risk factors that we have control upon. And these are some of those 8 commonly identified NCDs risk factor. Of the 8, we are mostly focusing on, in our study, or to raise presentation on the raised blood pressure or hypertension and overweight, obesity. According to STEPS survey of 2013 that was published in 2015, it showed only 0.4% of the Nepalese adult population were free of one of these 8 preventable risk factors for NCDs. That clearly demonstrates that we have a high burden of these risk factors that could have been easily avoided. And these are some of the risk factors that are the major cause of death among the Nepalese. So when you rank risk factor according to cause of death and disability in Nepal, hypertension and high body mass or overweight, obesity are the top 10 risk factor for death. And this justifies why it is really important risk factor to focus on. So if we talk about the prevalence of hypertension and or overweight, obesity in Nepal, so there are 2 major nationwide surveys, STEPS 2019 and Selected NCDs 2019. These were the latest nationwide survey that provides estimate for both of these. And as we can see in the table, it's pretty high. Both hypertension as well as overweight and obesity is pretty high. So now talking about why we are concerned about the altitude and urbanization, or why did we select these 2 as our potential exposure factor. So we all are very proud of our mountains. And when I'm in the abroad and some of my friends from here, whenever I tell them I'm from Nepal, the only thing that I hear from them is either they just say, where is it? Because they just don't know about Nepal. Or if they do, they would just ask me, are you from the Himalaya? Have you been to the Himalaya? So Himalaya is, or high altitude is really important for Nepalese. And a lot of, there are some of the tallest mountains or peaks are in the world lies in Nepal. And huge population of Nepalese also live in higher altitude. And according to latest data we have, it's about almost 21% of the people live between 3,000 to 5,000 meters above the sea level in Nepal. In terms of urbanization, we all are very much familiar with the situation of urbanization in Kathmandu. And I think it's, we all have experience, so we know like how urbanization is happening in Nepal and how that has consequences for our health. So based on all this background, we selected this topic where we have multi-fold research question, but I'm trying to summarize it into one study aim. So on one side, we are looking if altitude and urbanization is associated with hypertension. On the other side, we are looking at if altitude and urbanization are related to overweight and obesity. So what we know from the literature, so there has been a couple of studies published already, but a lot of these studies are from Tibetan region. They are looking into residents of Tibetan region and have pretty much predominated the literature. There are 1 or 2 from Nepal. So when we put all these published previous studies in one bucket, we found like there was geographical disparity. The finding from Tibetan region could not be implied in our context. Moreover, a lot of these studies have limitation in terms of small sample size, and their measure of altitude is proxy and not more rigorous. So that gives us enough room to explore more on this topic. In terms of altitude and BMI, it is hypothesized that people living in higher altitude, they have less energy requirement and subsequently lower BMI. In terms of urbanization, urbanization is inversely associated with both, directly associated with higher burden of both hypertension and overweight and obesity. So talking briefly about the methodology, we use NDHS 2016 data. I will not go into very depth of the methodology, but this PDF details a lot about NDHS methodology. So if anybody is interested, please refer to this document, or we will be in the Q&A session. So if you have any question, please feel free to ask, and I'll try my best to answer those. The sample size for our study was close to 10,500, and we limited our study to only those who were 25 years and old and had blood pressure measurement in NDHS. Hypertension was defined in terms of systolic and diastolic blood pressure, and this is pretty common way of defining it. We also added people who said they were on antihypertensive medication in that category. This is a commonly used CDC defined definition for classifying BMI into different weight categories. For altitude, GPS coordinator of participant resident was captured. Urbanization was defined into metropolitan, municipality, and the rural areas. We did all this analysis in Stata using the SPY, which is survey function. That means we took consideration of all those sampling parameters that NDHS uses. We used binary Poisson regression for both our outcome variable, that is hypertension and overweight obesity. We calculated crude and adjusted prevalence ratios. The adjusted were controlled for age, sex, education, marital status with quintile, and urbanization or altitude if the outcome is, if the exposure is urbanization. So let's take a moment to talk about what did we find in the result. So the first, prevalence of our outcome variable. So almost a quarter of our population had, or the study population had, hypertension. In terms of overweight, 19.6% were overweight and 4.8 or roughly 5% were obese. Let's talk about how urbanization and altitude were related with our outcome. So first I'll talk about altitude. We found significant association of altitude with both hypertension and overweight obesity. However, I just want to point out here, the estimate were marginal because we saw only 2% and 3% increase for hypertension and overweight obesity respectively. So we should take our finding with a little bit of caution. In terms of metropolitan, the finding were more rigorous because there were people living in metropolitan compared to the rural areas who had 30% higher odds of being overweight or obesity. So in conclusion, using the nationwide cross-sectional study or NDHS, we found a high prevalence of hypertension as well as overweight and obesity among the Nepalese adults, and these are consistent with previous finding from the STEPS or selected NCDs in Nepal. In terms of association with altitude hypertension or altitude with overweight obesity, we found significant, but only a marginal, when you look at the estimate itself, only a marginal association of altitude with both our outcome. In terms of urbanization, people living in metropolitan, and that will include people living in Kathmandu metropolitan as well, they had 30% higher likelihood of being overweight and obese. And this concludes my presentation, and I will be available for Q&A session. And if you have any question, please feel free to be there, or the paper will be published shortly. It has already been accepted and it should be in the print very shortly. So I recommend you read the paper if you are interested in more findings. Thank you so much and have a good day.
Thank you. I think we'll quickly move on to the next presentation, and that will be done by Rajshree Thapa. And she's going to present on the distribution of multiple cardiometabolic risk factors in South Asia, a pooled analysis from Nepal, India, and Bangladesh. Rajshree, please.
Hello, namaste. First of all, I'd like to thank the organizing committee for having me for this presentation on distribution of multiple cardiovascular risk factors in South Asia. And this is a pooled analysis from Nepal, India, and Bangladesh. I'm Rashri Thapa, and my co-authors include Sivraj Mishra, who is from University of Queensland, and we have Dr. Aisa Jenging and Professor Amanda Thri from Department of Medicine, Monash University. Talking about the background, looking at the socioeconomic distribution of non-communicable disease in South Asia, we have evidence that mortality due to various cardiovascular disease in this region is quite high. And not only the South Asian have a greater risk of cardiovascular disease, but they are also occurring at a very young age. If you can see this figure, we can see that the proportion of mortality rate of cardiovascular disease is higher among the Asian Indians, both in male and female. So, so on this background, backdrop, and there's also evidence that the greater prevalence of hypertension is found among the people with diabetes. So there's a large benefit achieved when multiple risk factors can be addressed simultaneously. So the objective of this paper is to determine the status of major risk factors for NCDs and the social gradients in Bangladesh, India, and Nepal. This is a brief analysis of how data pooling has been done. So we had multiple files in our country level DHS data. So from the individual's file, we pulled socioeconomic variables, data on blood pressure or blood glucose. And from the male or female specific files, we pulled data for smoking, ethnicity, or alcohol use. And the data were pulled at a country level. So for Nepal, we have like 15,000 people, and for Bangladesh, it's around 8,000, and for India, it's 781, 122 participants. So finally, merging data for these three countries gives us a final data set of 804, 124 people or participants. So as I already mentioned, this is a cross-sectional analysis from the data pulled from Demographic Health Survey, and sample weights have been applied to determine the prevalence estimates. And multivariate logistic regression appropriate for complex survey design was used to determine the association for type 2 diabetes mellitus, hypertension, and obesity with adjustment for age, sex, wealth quantile, and location of residence. Now, moving into the results sections, so as I already mentioned that we had like 804, 124 participants, and majority of them were female, that is 85% of the participants were female, and the mean is like 30 with 10 standard deviations, and the data shows like males were a bit older than the female participants, and majority of them resided in rural area, the 66%. And we also had we also saw that there were 25% of participants who were literate. And if we see the male-female distribution in terms of literacy, female were more likely to be illiterate than the male. And talking about the poorest wealth quantile, we see like 18% of people were living at the poorest wealth quantile, and 11% of participants had a BMI more than 25 kg per meter square, meaning 11% of participants were obese. So now focusing on the prevalence of risk factors for NCDs. So we found that 2.4% of people had diabetes. Similarly, 11% had obesity, and also like 13% had hypertension. And almost 1% had both the conditions, diabetes and hypertension. And very interestingly, the 22%, I think that's 1 in 5 people had at least one condition, either diabetes, obesity, or hypertension. And now focusing on factors associated with hypertension and diabetes, what we found is that the people who were, participants who were at the older age group, that's more than 45 years plus, they're almost 4 times more likely to have hypertension. And similarly, those who were obese were almost threefold more likely to have hypertension. And female were less likely to have hypertension than compared to the male counterparts. And when we go for diabetes, similar to the hypertension, those participants who were in the older age group, they had higher odds of having diabetes. Similarly, those who were obese were almost they had almost threefold higher odds of having diabetes than that of non-obese participants. And unlike hypertension, wealth quantile was found to be associated with diabetes, meaning those who were at the highest wealth quantile were 1.5-fold, 5-fold more likely to have diabetes than those in the poorest wealth quantile. And as for similar to that of hypertension, female were less likely to have diabetes than the male counterparts. And interestingly, what we didn't find a significant, where our study did not detect a difference between rural or urban residents for hypertension, but then for diabetes, those residing in rural areas had almost 22% less chances, or they were 22% less likely to have diabetes than those residing in urban areas. So finally, to conclude, risk factors for chronic disease often occur in clusters in countries such as Bangladesh, India, and Nepal. So due to the shared social and biological determinants, these multiple risk factors can be addressed simultaneously using multi-component community-based intervention in South Asia. So finally, I'd like to conclude I conclude by saying that we need to use the continuum of care approach for addressing NCDs in South Asia. Thank you.
Rasri and everybody else who presented. All the presenters, please stay connected. We will ask you questions on behalf of the audience. And you may choose to answer each question after we ask. Or actually, we can give all the questions together if there are not too many of them. So what we will do now is direct questions to the presenters in the order of presentation. Once he or she responds and completes the answers, then we move to the next presentation, okay? So let me start directing the questions to the first presenter, Binod Kumar Yadav. There is a question from Dr. Surya Parazuli, and the question is, regarding sexual dysfunction of diabetic clients, which department is responsible to manage such problems? Do you think interdisciplinary approach is the new need of Nepal? That's the question one. I think you may want to respond to that, and I'll actually ask one more question from my own side. Binod, are you there? Can you hear us?
I think he's speaking, but we cannot hear him.
Is he muted or his camera's off? We cannot hear you. Can you just hold on a second, fix the problem first? Are you connected to the audio or not, Binod? All right, maybe you know what, we're going to move on to the next presenter and we'll come back to you once we fix the problem. Binod, can you hear us? If you hear, please just wave your hands so that we understand that you're listening.
I think he's already started to answer.
this one. So
Okay.
there is no doubt that the responsible is the treating physician is over there.
Vinod, I'm sorry. I will ask you to repeat the answer to the first question because we didn't hear it here, so we presume nobody else heard in the audience. Can you respond again in the first question?
Physician is responsible for the treating the patient, and biochemistry department is only the supporting in diagnosis the things when they are requesting to do the test.
Okay. I think that's fair enough, at least for now. There is one more question that I actually wanted to ask you. What is the cause and the effect? Is it diabetes as a primary cause for erectile dysfunction, or is it just the correlation, coincidental correlation between these two? And what do you say about the autonomic neuropathy that always happens with these diabetic patients? Does that contribute to this, apart from the hormonal changes, particularly in testosterone level in diabetic patients?
Yeah, thank you, sir, for your valuable questions. Yes, this is even you can say the pathophysiology of this disease is basically, we all know it is because of the insulin mechanism over there. There are so many studies has been done. Insulin played the role for the productions of the testosterone as well, and even the vice versa. Testosterone deficiency also may cause for the insulin dysfunction over there. So it's not there is a clear cut which is playing the role, but in the pathophysiology it is shown over there. Both are playing the role, but definitely insulin has the major role in the decreasing the level of the testosterone over there.
There's one more question to you. Dr. Avinav is going to ask you that, okay? Just to hold on to the,
yes.
Hang in there.
Thank you, Dr. Vinod, for your presentation. I wanted to know about the analysis part, and correct me if I missed it. Somehow I didn't see the A's in your analysis, and I believe that it would be a good confounder in this case because it's linked both with erectile dysfunction as well as with diabetes. So have you taken care of, did you take care of A's while you did your analysis?
Well, Abhinav sir, we have already taken in our study, the age group is the 30 to 63 age. 30 to 60. So
No,
this is basically both for the both purpose, not only for the diabetes, it is only for the sexual function also. So this is the active age, which is more than 30 years, and even in the married, we have already included only the married individual in the group. As we have already asked the sexual dysfunctions in that, and we have the questions here.
Got that.
So we have taken both things in our study, age as well as the sexual function age also.
Yeah, but even within that group, if you could see, for example, those who are closer to 30 versus those who are closer to 60, maybe you could see a bit of difference. Even if it's, you have taken this particular age group, I think it's still worthwhile taking care of age factor into this analysis.
But we can do, we have the data.
Yeah,
we can analyze again which age is going to be more responsible for the low testosterone level over there.
Yeah.
Okay, sir, thanks for your suggestion. I will do that.
Okay, thank you very much.
Thank you.
Now we'll move on to questions directed towards our second speaker. Rajaram, I hope you are still awake. Maybe you'll finish this and then go to sleep. Thank you for your presentation, Rajaram. It was good listening to you. And we have a question. We don't know who asked this question, but the question is about the person wants to know how the researcher's bias was answered in this trial. That is one part. And the second part is there are many yoga asanas that hypertensive patients should not do without guidance. How this had been addressed in the home settings. So there are two questions, one on researcher's bias and second on some, potentially harmful yoga positions.
Okay, thank you, Abhinav sir, for question. Actually, I'm currently now in Dading, so it's daylight here. Okay. And namaste to Bhagwan sir as well.
Namaste.
if we talk about the researcher bias, there might be various kind of biases, but I don't want to go on that specific areas, but the way we conducted the research was a standard like it's a randomized control trial. So that means the methods helps us to minimize the biases during the participants' recruitment to the analysis process. More than that, we applied intention to treat analysis, which is like a type of actually researcher. That's the type of like we can minimize the bias from that as well. So from my side, from the principal investigator, I can assure that we tried our best to minimize the biases, different type of biases, but the paper is under review in BMC Public Health. Once it is published, then I would like to share you for further discussion. Regarding your second question, sorry, I forgot you, sorry.
The second question was about some harmful, potentially harmful yoga asanas that may be there that the hypertensive patients should not do without guidance or supervision. So how was this addressed in the home settings of the patients?
The way we develop the package is based on the evidences. Prior to our study, there have been more than 4 or 5 meta-analyses where they analyzed the control trial based those actually investigated the yoga and hypertension, and they have summarized the types of yoga posture which is likely to give maximum benefit without any adverse reaction. So based on that, we developed our yoga packages, which actually we thought we should have less adverse events. And I actually forgot to mention that we didn't have any report of adverse events in our study. And no participants actually reported any adverse events during the study period.
Great. Thanks. I also have one small question to ask. Though you partially, talked about it in your presentation itself, about the compliance, and you, I think, interviewed about 18 people afterwards, whether they followed the yoga practices or not. I think this is something that we need to consider when we are doing some sort of health promotional interventions. We may be telling people what to do, but we may not be really following whether they are really doing it or not. So this compliance part as a part of this process evaluation is very crucial. And I think if you're going to write a paper on that, I'm sure this would come as in the discussion part as well. Our reviewers will definitely bring it up. So this is something I would say, like all of us as researchers need to think about whether we are just asking people to do it, or we are really ensuring that they are doing what we are saying that they should be doing. Thank you, Rajaram. Maybe sorry, do you want to say something about it again?
Yeah, actually, I agree with your point. It's valid, actually. Actually, the study was based on pragmatic clinical trial, so we may not give as much as focus as other clinical trial for compliance, but we retrospectively designed one evaluation study, which I talked at the end of the slide or in conclusion section, that retrospectively designed evaluation study is there to assess the compliance or like the factors or like whether there were any challenges during home-based yoga practices. So we are going to explore that things in our upcoming research, and maybe we may able to share that finding by next 2 months.
Yeah, great. Thank you, Rajaram. So we'll leave you at that, and then hope to see you sometime. We'll now move on to the next presenter that we had, Dr. Gagan Nupani. Dr. Gagan, are you around?
Yes, hello. Thank you so much. I'm really honored to be part of this program. Thank you very much.
So we're honored to have you as well. And there's a question from Dr. Prasant Paudyal. I will kind of rephrase the question for you. So, according to him, you talked about the global burden of disease in terms of mortality. What about in terms of morbidity or DALYs? So his question is, has NCT study in Nepal plan to survey in disabling hearing loss, which is the second most common cause of morbidity as per the global burden of disease studies. So his emphasis is on looking at the conditions that give us high DALYs in terms of morbidity as well. And his interest is to hear about, it's ironic a little bit, to hear about the disabling hearing loss.
Okay,
Over to you,
thank you very much for your question. We try to incorporate, thank you very much. Thank you very much for your question. We try to incorporate years of life lost due to non-communicable disease that was really high, around 49% of 49% of all the burden was due to non-communicable diseases. That was according to 2017 based on global burden of disease. And based on IHME data. And we do have data that from 2017, non-communicable diseases account for 60% of all disability or adjusted life years in Nepal. Having said this, we do not have any, currently we do not have any plans of incorporating hearing disabled people into our study, but then yes, it is one of the most important causes of disability in terms of non-communicable diseases. I really appreciate that you had this question in your mind.
Yeah.
But currently, we are not enrolling those kind of participants. Thank you.
I agree to your point. So you have a couple of other questions as well. So there is a question from Dr. Gambhir Shrestha. So he thinks that the NCT Nepal study is a very comprehensive study. The question is, what intervention are you planning to undertake in order to test the effectiveness? I'm not sure if the question has come through very clearly or not. So basically he's asking, what interventions are you planning to undertake in order to test the effectiveness?
Okay. Well, thank you very much, Dr. Gambhir, for your question. Yes, in fact, this study is a very comprehensive study. I must say, we have implementation, intervention approaches, protocols for many different diseases, including hypertension, diabetes, tobacco situation, dyslipidemia. We plan to test the effectiveness by following the participants, those who are at risk, on the basis of comprehensive risk factor assessment. We have, as already I mentioned in the slide, we have a follow-up protocols. We call them according to the personalized follow-up plan. So we assess them with questionnaires, pre-tested questionnaire. We assess lifestyle modifications, how they plan to change their lifestyle. For example, if they previously smoked, have they quitted smoking or not? Also about their drug adherence, compliance to drugs, and also the control of diseases, including the control of blood pressure, control of blood sugar. So we plan to test the effectiveness by following up with the question with the participant themselves, and we will also get an idea of cost effectiveness of these community-based approaches. I hope I answered your question.
Yeah, if not, then I think Gambhir can write to you later to clarify things. There's one more question for you. This is from Dr. Surya Bahadur Parazuli. So he wants to know, which method did you use to measure salt intake? One of the difficulties that we face in city survey is salt intake, how to measure that. So how did you do it?
Okay, we have a, thank you very much. It's really an important question. We have a set of questionnaires which are previously pre-tested. So what we do is we ask the participants about the number of packet of salt they consume in a certain period of time. For example, say a month or wigs. And then since each packet weighs 1 kilograms, we divide the number of packets by the number of family members. This is just a rough average of salt intake. But having said this, we do have some bias here. We do have some problems here. We do have problems of recall bias, since most of the since not all participants remember how many packets of salt they consume. We do have this problem.
Yeah, I agree, Dr. Gagan. Sometimes that's the only way that we can ask or find out about salt intake, unless we have some biochemical methods to do that. So if there are, I think there are no further questions here. So we thank you again, Dr. Nupane, and all the best with everything that you're doing. We now move to Chitwan and to Dr. Kalpana Sharma. Dr. Sharma, are you able to hear us?
Yes, sir, I'm here.
Okay, namaste. There is one question that is a little long, but I'll try to shorten it for you. It says that every individual, and it's from Mr. Chabi Gaurel, it says every individual has 10% mental disorder, and if it goes over 10, it means 10 plus 1%, then it becomes some kind of psychiatric disorder. So it means that we probably, all of us have some amount of risk, and then when something adds to it, we probably turn into a psychiatric patient. So in the context of Nepal, how can we address the issues of such problem? So one question is that, and there is a follow-up and part 2 of the question as well. The coronavirus has been affecting neurotrophic factors in the human brain. What could be the steps to address these problems? I think this was well answered also in the previous session by Dr. Oza, but I think we would like to hear from you again on these 2 points. One is like, if somebody's already having some amount of mental problem, and then it can be pushed. So how can this be addressed? And second is about staying sane in the era of coronavirus.
Thank you for valuable question. As there is a problem in psychiatric disorder, and there is stigma and discrimination also in the community. So it is necessary to increase awareness program to the individual people, as well as there is need to provide collaborative care to the patient who are suffering from psychiatric disorder. If the people become aware, then it will definitely be stigma and discrimination will be reduced, and that will be helpful for the prevention of psychiatric morbidity. In this corona context, people are suffering from the mental disorder, as well as it has effect on neurological problems. So it is necessary to provide emotional support, as well as counseling and other awareness program to the general people as well. These all are my first question. Answer for first question.
Okay.
Thank you, sir.
Okay, I think in interest of time, we'll try to wrap this sooner. There is one question to you as well from Dr. Surya Parazuli regarding informed consent. Did you take only from the patients of psychiatric morbidities? I guess he wants to ask if the psychiatric patients themselves gave the consent, or maybe the family members or others.
A valuable question. Actually, our participants were non-communicable disease patients, and we are doing screening or evaluation for the psychiatric morbidities. So we took consent from the patient, and they were able to provide consent because they don't have any mental, they were not already diagnosed as a mental problem.
All right, so that, thank you very much, Dr. Kalpana Sharma. We actually didn't get any questions for Ms. Saruna Kimire and Rashri Thapa. So nonetheless, we thank you very much once again for your contributions towards this session and towards the summit. I would like to hand over the mic to Dr. Koirala, who shall be then closing the session for us. Thank you.
Yeah, I would like to thank every presenter for very interesting topics that they brought up and some very important questions that we needed to, get answers for. I think despite minor technical issues, we conducted the session well, and I thank my co-chair and all the audience here and in the virtual world listening to us for being with us and making this virtual summit successful. Thank you all presenters again. With this, I like to close this session and ask everybody to be online for the next session after several minutes that the Master of Ceremony will announce. Thank you very much.
Thank you, Chairs, for your valuable remarks. I would also like to thank all the presenters who presented virtually for their very informative and comprehensive presentation. So now that we're at the end of the session, I would like to take this moment to appreciate our chairs. So I'd like to request Dr. Pradeep Gyawali, Executive Chief of NHRC, to present the token of love to our session chairs. Dr. Bhavan Koirala and Dr. Abhinav Vaidya, can we have you on stage, please? Dr. Bhavan Koirala. And Dr. Abhinav Vaidya. Thank you, sir. Well, ladies and gentlemen, this brings us to the end of this session. And we would like to thank all the participants who joined us live through various online platforms. And I hope this session was fruitful for you. Now, we will be having today's last session on nutrition, maternal and child health. And for this, I would like to invite Ms. Sashi Shilwal to take over the session. I wish you all a pleasant evening. Thank you very much.
Namaste, from Kathmandu, Nepal. It's me, Sashi Silwal, Research Officer from Nepal Health Research Council, Master of Ceremony of this session. Distinguished delegate, this gives me an immense pleasure to invite profound figure to be the chair for this session entitled Nutrition, Maternal and Child Health in the historical conference organized by Nepal Health Research Council. Nepal Health Research Council has been providing platform to many researchers and is making tremendous effort to generate the evidence to solve at the population level through the research and development. Having considering all this effort and motivating young researchers, our chairperson have accepted our invitation and it's really revitalizing. Thank you, ma'am, for being here. Therefore, I would humbly request Professor Dr. Madhu Dixit Tekpota and Professor Dr. Sudha Bosnet to chair the session jointly. Ladies and gentlemen, please put your hands together for Professor Dr. Madhu Dixit Tekpota and Professor Dr. Sudha Bosnet on the chair. On the brief, Professor Dr. Madhu Dixit Tekpota is a professor of public health of the Institute of Medicine with over 30 years of experience in teaching and guiding medical as well as public health students. She is a maternal and neonatal advisory on health and nutrition at MRSP, member of high-level nutrition and food security steering committee at National Planning Commission, board member at Nepal Health Research Council, executive chairperson at Upendra Tipkota Memorial National Institute of Neurological and Allied Science. Moreover, she has a noteworthy contribution for the government of Nepal on drafting health sector policy, strategy, and guideline in the area of nutrition and reproductive health. Moreover, she is an avid gardener and a passionate mother. Moving to Professor Dr. Sudha Basnet, MD Pediatric, PhD, is a professor at the Department of Pediatric, Maharajganj Medical College, Institute of Medicine. She has worked as a medical doctor for 25 years and a pediatrician for past 15 years in Nepal. She is also a researcher and has been actively involved in design, implementation, analysis, and dissemination of 3 large randomized clinical trials in Nepal and contribute to pursue her interest in research on important issues related to the child health and from more low and middle income countries. Thank you, ma'am, for here. And also we have 4 presenters in these sessions. Dear presenter, please be online throughout the session. Please be informed that we will have only 20-minute Q&A discussion round at the end of the sessions. And let me notify you that this is the last session of 2 days parallel, 2 days sessions of the summit. Now I would like to pass this session to our eminent chair. Thank you.
Thank you, Ms. Silval, for introducing. Just like to clarify that I had wonderful time. You know, I spent more than 35 years at a very prestigious institute of Medicine, but not anymore. I have since retired. Thank you. Thank you for being so kind. And it's a pleasure to have Dr. Sudha Basnet with me as co-chair. We connect many, many years, and it's lovely to reconnect with you. Thank you, organizers, for this session, which I believe is very interesting, and for selection of these 4 papers, 2 of which deal with further analysis of the Nepal Demographic Health Surveys of 2016, interestingly, 2 had to deal with perinatal mortality, and I'm sure we'll learn, and Dr. Sudha would have lots to contribute on them. And there's one on double burden of malnutrition, which again, as you know, is a very pertinent and upcoming topic. And I'm sure those of you who are interested in maternal health know that Lancet publication actually dedicated the December 2019 volume, to double burden of malnutrition. So I'm really pleased that these papers are selected. Last but not the least, the 4th presenter, Mr. Ajay Acharya, is going to be talking about factors influencing health mothers groups participation. And he, very interestingly, he uses a mixed method to study the topic. So I'll certainly look forward to this session. Thank you for having me. Dr. Sudha.
Thank you. Thank you, Dr. Madhu, and it's really nice to see you again. And thank you to NHRC for having me over to chair this session. And as Professor Madhu has said, they are very interesting papers, and I look forward to the presenters and see what they have to offer. And I think without much ado, because it's the end of the day and people are getting tired, so we should start with the session.
Namaste everyone, my name is Preksha and I have recently passed Bachelor's in Public Health. So the report that I'm presenting today is a part of my thesis work. Before starting this presentation, I would like to thank Mr. Saroj Bandari, who was the supervisor and helped in completion of this report. And also I'd like to extend my gratitude towards the medical superintendent and chief of department of obstetrics and gynecologist of Midwestern Regional Hospital for providing us the data and information and allowing us to do this research. Without them, this research would not have been possible. The study studies the association of age and parity with the maternal and perinatal outcomes. Every year, millions of women becomes pregnant, and it is not necessary that the pregnancy ends in a happy result. There can be several unexpected and sad outcomes of it. There are many factors that influence those outcomes, but one of the major outcomes are parity and maternal age. Parity is simply defined as the number of times a woman delivers after completing a gestational age of at least 24 weeks. Parity is further classified as primiparity, multiparity, and grand multiparity, whereas maternal age is simply the age of mother at the time of delivery. There has been several studies that shows that parity and maternal age has effect on the pregnancy outcome or effect at the health of a newly born child. Studies have shown that there's complication in pregnancy and childbirth are higher among the adolescent girls and the older women. In present world, there is increase in trend of delaying pregnancy and having multiple pregnancy as an advanced age, due to which there are several outcomes. So the need of this study is more now than ever. If we talk about Nepal, the median is for first marriage among women in 17.9 years, and that is women married at very young age, and they start childbearing at very young age as well. 17% of the women starts childbearing at the young age of 15 to 19. Maternal and child health program are one of the priority program of Nepal, and there has been several programs that are designed and implemented to decrease the mortality ratios of mother and a child. There are tremendous progress in case of maternal mortality ratio, but the indicators are still high. If we look into the specific indicators of Midwestern development region, the indicators are higher than other development region. For example, the perinatal mortality rates are high in this region. The low birth weight of children are also high in this region. So it is necessary to study about the effects of parity and age among the mothers. The study assesses the maternal and perinatal consequences of age and parity separately. It also studies the socio-demographic factors. The study is an analytical cross-sectional study which are performed upon the data collected from the registered maintenance of obstetric and gynecological department. There were 3,694 data collected. The women visiting the Midwestern Regional Hospital at the fiscal year of 2073-74 were included in this study. These data were analyzed using SPSS, and several tests were performed. The socio and demographic variables are age, parity in the city and place of residence, while as the exposure variable are parity and maternal age. Parity in this study is classified into two categories, primiparity and multiparity. Multiparity is defined as having delivery more than 2 or more times. Maternal age is then classified into 4 groups, in which the mothers of age group 20 to 24 years are the reference group. The maternal outcomes are gestational age, induction of labor, if the induction of labor was necessary or not, delivery type, if the delivery was vaginal delivery or breech delivery or cesarean section. Cesarean section was further classified into emergency cesarean section and elective cesarean section. For perinatal outcome, ABGAR score was collected. ABGAR score is a convenient method of reporting the status of newly born child. In ABGAR score, the children are scored based on the 5 categories: appearance, pulse, grimace, activity, and repulse. The other outcomes studied in perinatal outcomes are birth weight and fetal status. The study showed that majority of women were of Brahmin and Kshetri. Most of the people were from Surkhet, followed by Dailek, Jazarkot, Salyan, and Kailali, etc. More than half of the women that were included in the study were multiparous, and majority of them belong to the age group of 20 to 24 years. They were in fact 40% of them. And around 21% of this total sample population were the younger mothers or the adolescent mothers of age group less than 20 years. And even among them, 16% were multiparous. This table shows the relation between parity and maternal and perinatal outcomes. Only the significant results are shown in this study. It shows that the multiparous women are less likely to undergo cesarean section, and the odds of scoring less than 6 in ABGAR test is reduced by 38% among the multiparous women, whereas multiparous women are more likely to have babies weighing more than 3,000 grams in comparison to the primiparous woman. Now this table shows the association between the mothers of age group less than 19 years, less than 20 years, with the maternal and perinatal outcomes. It shows that the younger mothers are at the higher risk of delivering, having preterm delivery, that is, they deliver before the gestational completion of the gestational week, but they are less likely to undergo cesarean section delivery. The chances of having babies weighing more than 3,000 grams are also less among the younger mothers of age group below 20 years. If we look into the result of mothers of age group below 20 years and that of mothers of age group 25 to 29 years, the results are exactly opposite. Here the mothers are at reduced risk of delivering pretermly or having delivery less than 34 weeks. However, they are more likely to undergo cesarean section and have baby weighing more than 35,000 grams. For the mothers of advanced age or age more than 30 years, they are more likely to, they are twice as likely to undergo cesarean section, and children born to them are at increased risk of scoring low ABGAR score after 5 minutes than the mothers of age group 20 to 24 years. For conclusion, we can say that with multiparity, the chances of having cesarean section decreases. Multiparity is in fact protective against factors like preterm delivery or having low ABGAR score or low birth weight children. However, there are risks of having babies weighing more than 3,000 grams. For the mothers or younger mothers of age less than 20 years, they are at the higher risk of having preterm delivery. The study shows the association between the maternal age and birth weight of babies. With increasing in maternal age, the risk of delivering babies weighing more than 3,000 grams increases. Child born to the mothers of age group less than 19 years or to the mothers of more than 30 years are at the risk of having low ABGAR score. It is seen that the cesarean, with the increase in maternal age, the chance of the odds of having cesarean section also increases. As the study has shown the relation between age, parity, and outcomes, it would be better if the programs developed for the pregnant woman are updated, designed, and appropriate in terms of age and parity. The woman or the health professionals, especially those who provide ANC care and support to the pregnant woman, should be more sensitized about these issues of age and parity, and there are ways for more research to collect stronger evidence. These outcomes could be broadened, or the parity itself can be classified into different groups in further studies. Thank you.
Thank you, Ms. Preksha Bimali. I think we'll have the questions towards the end of the session. So now I would like to invite Ms. Sunita Dharel to give her presentation on inequity in perinatal mortality in Nepal, a further analysis of 2016 Nepal Demographic and Health Survey. So please go ahead.
Okay. Namaste, I am Sunita Dharel. I am very pleased to share about my analysis in this NHRC summit. My topic of analysis is inequity in perinatal mortality in Nepal, based on the Nepal Demographic and Health Survey 2016. यसमा चाहिँ मैले फर्स्ट इन्ट्रोडक्सनमा चाहिँ पेरिनेटल मोर्टालिटीलाई चाहिँ किन मैले स्टडी गर्न लागेको अथवा यसको लागि किन मैले स्टडी गरेँ भन्नेमा चाहिँ इट इज द एज कम्पेयर टु द अदर पार्ट like neonatal and infant, it is the neglected area of child health. As we know, perinatal mortality is a combination of stillbirth and early neonatal death, and calculated as 1,000 live births per live births. अनि अर्को कुरा चाहिँ पेरिनेटल मोर्टालिटी रेट चाहिँ टाइममै इन्टरभेन्सनहरू गर्न सक्यो, कुन प्लेसमा कुन पपुलेसनमा चाहिँ बढी देखिएको छ भनेर यदि थाहा भयो भने चाहिँ त्यसलाई चाहिँ बेलामै टाइममै प्रिभेन्टेबल, मोस्ट अफ देम आर चाहिँ प्रिभेन्टेबल भएको कारणले गर्दाखेरि पनि यो अर्को इम्पोर्टेन्स भयो। तर यसमा चाहिँ अर्को चाहिँ एकदम लिमिटेड स्टडिजहरू मात्रै भएको छ जुन चाहिँ पेरिनेटल मोर्टालिटीको डिटर्मिनेन्टहरू चाहिँ एनालाइज गर्नको लागि, र मलाई चाहिँ यसमा चाहिँ अझै धेरै एक्सप्लोर गर्न मन लागेको कारणले गर्दाखेरि चाहिँ पेरिनेटल मोर्टालिटीको बारेमा चाहिँ स्टडी गरेको। अनि अर्को चाहिँ जुन चाहिँ हामीले यदि यो पेरिनेटल मोर्टालिटी रेटलाई चाहिँ डिक्रिज गराउन सक्यौँ र पेरिनेटल सर्भाइभललाई चाहिँ इन्क्रिज गर्न सक्यौँ भने चाहिँ सस्टेनेबल डेभलपमेन्ट गोलको एउटा एम चाहिँ प्रिभेन्टेबल डेथलाई चाहिँ इन्ड गराउने हो, त्यसलाई चाहिँ डाइरेक्टली कन्ट्रिब्युट गर्न सक्छ। My objective of the study is to analyze the magnitude and inequity level of the perinatal mortality in Nepal. मेथोडोलोजीमा चाहिँ मैले एनालाइसिसको लागि चाहिँ 2016 को NDHS डेटा चाहिँ DHS वेबसाइटबाट चाहिँ डाउनलोड गरेको थिएँ। त्यसपछि चाहिँ त्यसमा भएका केही भेरिएबलहरूलाई चाहिँ रिकोडेड र रिएनालाइज गरेको थिएँ। जस्तै बर्थ स्पेसिङलाई चाहिँ डाइकोटमाइज गरेर लेस देन 24 मन्थ्स र 24 अथवा त्योभन्दा बढी मन्थ्सको लागि चाहिँ डाइकोटमाइज गरेर चाहिँ एनालाइसिस गरेको छु। र यो एनालाइसिस गर्दाखेरि चाहिँ DHS प्रोग्राममा भएको जुन गाइडलाइन छ त्यो गाइडलाइनलाई फलो गरेर चाहिँ एनालाइसिस गरेको छु भने अर्को चाहिँ फ्रिक्वेन्सी डिस्ट्रिब्युसन र कन्फिडेन्स इन्टरभल चाहिँ स्टाटा सफ्टवेयर युज गरेर गरिएको छ। अब चाहिँ रिजल्टको पार्टमा चाहिँ यसलाई पेरिनेटल मोर्टालिटीलाई एफेक्ट गर्ने फ्याक्टर्सहरूलाई चाहिँ क्याटेगोराइज गरेर गरिएको छ। र यसमा फर्स्टमा चाहिँ सोसियो इकोनोमिक फ्याक्टर जस अन्तर्गत चाहिँ इथनिसिटी, फादर एजुकेसन, मदर एजुकेसन र वेल्थ स्टेटसलाई चाहिँ फोकस गरिएको छ भने इथनिसिटीमा चाहिँ जुन DHS डेटाबेसमा भएको डेटालाई चाहिँ एनालाइसिस गर्दाखेरि चाहिँ मैले दुईवटा ग्रुपमा क्लासिफाइड गरेको छु। त्यसमा चाहिँ डिसएडभान्टेज र नन डिसएडभान्टेज। डिसएडभान्टेज अन्तर्गत चाहिँ दलित, मुस्लिम र तराईको जनजातिहरू पर्छन् भने नन डिसएडभान्टेज ग्रुपमा चाहिँ बाहुन क्षेत्री र हिल्ली एरियाका जनजातिहरू पर्छन्। त्यसै गरेर वेल्थ स्टेटस हेर्दाखेरि चाहिँ पुवर पिपलहरूमा चाहिँ पेरिनेटल मोर्टालिटी चाहिँ हायर भएको पाइएको छ भने अर्को चाहिँ मदर्स र फादर्स एजुकेसनहरू चाहिँ जुन मदर्स फादर्स चाहिँ अनएजुकेटेड छ उनीहरूबाट जन्मिने बच्चाहरूमा चाहिँ पेरिनेटल मोर्टालिटी चाहिँ हायर पाइएको छ। र यो ग्रुपलाई हेर्दाखेरि चाहिँ जस्तै वेल्थ स्टेटसलाई हेर्नु पर्यो भने जुन पेरिनेटल मोर्टालिटी चाहिँ रिचर पपुलेसनमा चाहिँ 26 मात्रै छ भने त्यही पेरिनेटल मोर्टालिटी चाहिँ पोर पपुलेसनमा हेर्दाखेरि चाहिँ 39 देखिएको छ। यसले गर्दाखेरि चाहिँ पेरिनेटल मोर्टालिटीको डिफरेन्सेस चाहिँ रिच र पोअरमा चाहिँ 13 per 1000 लाइफ बर्थ देखिएको छ। यसले गर्दाखेरि चाहिँ यसमा चाहिँ इनिक्विटी छ है भनेर चाहिँ देखाउन खोजेको छ। अनि अर्को सेक्सनमा चाहिँ मेजर म्याटर्नल फ्याक्टर्स द्याट एफेक्टेड टु द पेरिनेटल मोर्टालिटीलाई चाहिँ एक्सप्लेन गर्न खोजेको छ भने त्यसमा चाहिँ एज, बर्थ अर्डर र बर्थ इन्टरभल छ। एजमा चाहिँ जुन आमाहरू चाहिँ 18 वर्षभन्दा कम हुनुहुन्छ र उहाँबाट जन्मेका बच्चाहरूमा चाहिँ पेरिनेटल मोर्टालिटी चाहिँ हायर देखिएको छ, जसमा चाहिँ 58 per 1000 लाइफ बर्थ देखिएको छ। र यसको कन्फिडेन्स इन्टरभल पनि हाई छ किनभने स्याम्पल साइज चाहिँ कम भएको कारणले गर्दाखेरि कन्फिडेन्स इन्टरभल चाहिँ हाई देखिएको हो। र अर्को बर्थ अर्डर पनि एनालाइसिस गरेको थियो, यसमा चाहिँ खासै फरक देखिएको छैन। अर्को बर्थ इन्टरभलमा चाहिँ जुन आमाले चाहिँ आफ्नो बर्थ स्पेसिङ चाहिँ लेस देन 24 गरेको थियो बच्चा जन्मिँदाखेरि त्यस्तो बच्चाहरूमा चाहिँ पेरिनेटल डेथ चाहिँ हाइएस्ट देखिएको छ र यो चाहिँ स्ट्याटिस्टिकल्ली पनि सिग्निफिकेन्ट देखिएको छ। अर्को चाहिँ अर्को फ्याक्टर छ मेजर सर्भिस युटिलाइजेसन फ्याक्टर फर पेरिनेटल मोर्टालिटी। त्यसमा चाहिँ प्लेस अफ डेलिभरी र नम्बर अफ एन्टिनेटल भिजिट छ। प्लेस अफ डेलिभरीमा चाहिँ पेरिनेटल मोर्टालिटी इज हायर अमोङ दोज who are not born in the health institution and एन्टिनेटल भिजिटमा चाहिँ जो आमाहरूले 4 भन्दा बढी पटक चाहिँ एन्टिनेटल भिजिटहरू गराउनु भयो त्यो आमाहरूबाट जन्मिने बच्चाहरूमा चाहिँ पेरिनेटल मोर्टालिटी चाहिँ कम देखिएको छ। र प्रोभिन्स र एरिया वाइज पनि पेरिनेटल मोर्टालिटी चाहिँ डिसएग्रिगेट गरिएको छ। प्रोभिन्स वाइज हेर्दाखेरि चाहिँ प्रोभिन्स नम्बर 4 मा चाहिँ सबैभन्दा बढी कम पेरिनेटल मोर्टालिटी देखिएको छ, जसमा चाहिँ 20 मात्रै देखिएको छ भने सबैभन्दा धेरै चाहिँ कर्णाली प्रोभिन्स जहाँ चाहिँ 42 देखिएको छ। यसको रिजनमा चाहिँ जियोग्राफिकल रिजन, अरू सर्भिस अभाइलिटी, अनि वेल्थ स्टेटस, युटिलाइजेसन अफ सर्भिस, त्यसपछि अरू पनि फ्याक्टरहरूले गर्दाखेरि चाहिँ यसलाई एफेक्ट गरेको हुनसक्छ। यसमा चाहिँ म दैलेखमा बसेर काम गर्दाखेरि पनि मैले फिल गरेको चाहिँ त्यहाँको जियोग्राफिक स्ट्याटस अनि मदर्स एजुकेसन र सर्भिस युटिलाइजेसन अभाइलिटीले गर्दाखेरि पनि यो फ्याक्टर्सलाई चाहिँ एफेक्ट गरेको हुनसक्छ। र अर्को चाहिँ एरिया अफ रेजिडेन्समा हेर्दाखेरि चाहिँ रुरल पपुलेसनमा भएको आमाहरूबाट जन्मिने बच्चामा चाहिँ बढी पेरिनेटल मोर्टालिटी देखिएको छ। लेट मी कन्क्लुड माई रिजल्ट अफ एनालाइसिस। यति भनिसकेपछि हामीले के कन्क्लुजन गर्न सक्छौँ भने पेरिनेटल मोर्टालिटी इज हायर अमोङ the mother without education, those from the poorer families, those from the disadvantaged family, and those are the younger mother less than 18 years. And if the delivery is non-institutional, and among the mothers with less antenatal visit, and those with inadequate birth spacing less than 24 months, etc. यति कुराहरूले चाहिँ एफेक्ट गर्छ भने यसमा सबै भेरिएबलहरुमा चाहिँ सबै डेटाहरुमा चाहिँ स्ट्याटिस्टिकल्ली सिग्निफिकेन्ट छैन, एक्सेप्ट बर्थ स्पेसिङमा मात्रै स्ट्याटिस्टिकल्ली सिग्निफिकेन्ट देखिएको छ। अब यति कुरा थाहा भइसकेपछि हामीलाई रिजल्ट एनालाइसिसको बारेमा थाहा भइसकेपछि चाहिँ हामीले यसको हाई रिस्क ग्रुपहरु के हो र अनि त्यसलाई चाहिँ कुन कुन फ्याक्टरले अन्डरलाइन कजहरु के हुन् त्यसमा पेरिनेटल मोर्टालिटी रेट हुनको र त्यसलाई चाहिँ राम्रोसँग बुझेर त्यो अनुसारको फोकस इफेक्टिभ इन्टरभेन्सनहरु गर्यो भने चाहिँ पेरिनेटल सर्भाइभललाई चाहिँ घटाउन सकिन्छ भनेर चाहिँ रिकमेन्ड गर्न सक्छौं। अनि अर्को कुरा चाहिँ हाम्रो जुन एसडीजी को टार्गेट 3.2 छ इन्डिङ प्रिभेन्टेबल डेथ, यदि हामीले यो सबै एक्टिभिटिजहरु गर्यौं भने चाहिँ त्यो पेरिनेटल मोर्टालिटीलाई घटाउँदाखेरि यो एसडीजी को एउटा अब्जेक्टिभ चाहिँ अथवा एउटा एम चाहिँ पूरा हुनलाई चाहिँ यसले डाइरेक्टली कन्ट्रिब्युट गरेको हुन्छ। अब यसमा चाहिँ मैले लास्टमा चाहिँ एउटा लेभल एन्ड ट्रेन अफ चाइल्ड मोर्टालिटी भन्ने रिपोर्टको स्टेटमेन्टबाट चाहिँ आफ्नो प्रेजेन्टेसन चाहिँ कन्क्लुड गर्न गइरहेको छु। यसमा चाहिँ के भनेको छ भन्दाखेरि इट इज पोसिबल टु इम्प्रुभ सर्भाइभल एन्ड health of newborn and in preventable stillbirth by reaching high coverage of quality antenatal care, skill care at birth, postnatal care of mother and baby, and care of small and sick newborns। यो कुराहरुले गर्दाखेरि चाहिँ पेरिनेटल मोर्टालिटीलाई घटाउन सकिन्छ र पेरिनेटल सर्भाइभल चाहिँ इन्क्रिज गर्न सकिन्छ भनेर जुन जिस्ट दिएको छ। यो फाइन्डिङ्स चाहिँ अथवा यो स्टेटमेन्ट चाहिँ मेरो यो एनालाइसिससँग पनि मिल्दोजुल्दो भएको कारणले गर्दाखेरि यी सबै कुराहरुलाई म्यानेज गर्न सकियो भने चाहिँ पेरिनेटल मोर्टालिटीलाई चाहिँ घटाउन सकिन्छ भन्ने चाहिँ यसको मेन समराइज हो। यति मेरो प्रेजेन्टेसन चाहिँ यति नै हो। इफ यु हैव एनी क्वेशन आई विल रेडी टु आन्सर। थ्यांक यू।
थ्याङ्क यू सुनिता धरेलजी। तपाईँ एकछिन बस्दै गर्नु होला, हामीले यो क्वेसन्सहरू वी विल टेक इट टुवर्ड्स द एन्ड। त्यही भएर आई थिङ्क म्याम आई विल लाइक यु टु इन्ट्रोड्युस द नेक्स्ट वान प्लिज।
Okay, our next presenter Devram Sunwarji hununcha. He is going to talk about factors associated with double burden of malnutrition among mothers and children in Nepal, and his findings are based on Demographic Health Survey 2016.
Respected Chairperson, dignitaries and participants, Namaste. Namaste, I am Devram Sunwar. On behalf of co-author, I am going to share this paper entitled Factor Associated with Double Burden of Malnutrition Among Mothers and Children in Nepal. Malnutrition in mothers and children is a significant public health problem in developing countries like Nepal, although undernutrition in children has been gradually declined. At the same time, different form of malnutrition has been increasing. Various studies have highlighted the maternal overweight, obesity, and child undernutrition among mother-child pairs. It's thought to be the results of interaction of changes related to socio-demographic and economic status, and dietary habit and intensity of physical activity. These are my outline of presentation. Double burden of malnutrition. What is it? Double burden of malnutrition can exist in the individual, individual, household, and the country level. In this paper, we examined the double burden of malnutrition at the household level. Overnutrition, undernutrition, and macronutrient deficiency equally the risk of various health problems. In the previous days, undernutrition was common in the developing countries, but nowadays, overweight and obesity also a public health challenge in the developing world. This graph shows the trend of malnutrition indicators such as stunting, underweight, and overweight. In the global scenario, we can see here that the prevalence of undernutrition, that means the stunting, underweight, and wasting, has been declined among the under 5-year-old children from the 1990 to 2014. At the same time, maternal overweight obesity has been increasing in trend. This graph also shows the child undernutrition and maternal overweight obesity trend in the context of Nepal. Both, we can see here that both stunting and underweight has been declined over 2 decades. On the other hand, maternal overweight and obesity has been increasing since past in 1.5 decade in Nepal. Coexistence of different forms of malnutrition among mothers and children has continued to rise globally, including in Nepal. Mother overweight, obesity, child undernutrition among the mother child pairs within the same household has not yet been explored using nationally representative data in the context of Nepal. So the main objective of our study was to explore the coexistence of double burden of malnutrition associated factors among mother child pairs decided in the same household in the Nepal methodology. This study was based on the Nepal Demographic and Health Survey secondary data, and this which is utilize a stratified two-stage cluster sampling design to provide representative estimates for 7 provinces and 3 ecological zones. A total of 2,261 mother-child pairs were included in this analysis. Study variables and data analysis. Data were extracted from the DHS website after open request, and anthropometric measurement and body mass index were taken for children and mothers. We dichotomized the double burden of malnutrition as a dependent variable into the presence coded one if there is a overweight obese mother and undernourished child. That means the undernourished child means the stunted or wasted or underweight, and we coded 0 if there is not overweight obese mother and not undernourished child. And finally, this dependent behavioral will categorize into presence coded 1 for presence double burden of malnutrition and 0 for absence of double burden of malnutrition. The bivariate and multivariable logistic regression analysis were used in this analysis, and data were performed using Stata version 14.1. This table shows the plan for data coding description of the study variables and result and discussion. This figure shows the socio-demographic characteristics of the respondent. About half of the respondent were 24 to 34 years age groups, and the mean age of mothers was 26 years old. About 34% of the mothers had no education. That means the uneducated. Majority of the mothers were uneducated in this study. Similarly, more than 1/3 of mothers belonging to the poor wealth status family and 90% of the mothers had normal height. Majority of the mothers had agriculture as their occupation, and more, that means the 26% of the respondent were resided from the province number 2, followed by province number 1 and province number 3, that means the Bagmati province. Slightly less than 1/4 of children were below 12 months of age groups, and more than half of children were male. This map shows the prevalence of double burden of malnutrition by province and number of double burden malnutrition by province. We can see here that the prevalence of double burden of malnutrition was higher in province number 1, followed by province number 2 and province number 5. I think this possible reason could be that these 3 provinces are more developed provinces among the 7 provinces in Nepal. The overall prevalence of double burden of malnutrition was 6.59% in this in the context of Nepal. This table shows the regression analysis of this study, and mothers older than 35 years old had a higher odds of double burden of malnutrition compared to younger age. And similarly, mothers who came from province number 2 were found to have a lower odds of double burden of malnutrition compared to province number 3. I think this possible reason could be that mothers from province number 2 are more likely to be lower socioeconomic status and consuming a less diverse diet, resulting in decreasing likelihood of being overweight and obesity in the context of province number 2. Likewise, mothers having at least secondary level of education and richer wealth family, and mothers who had short stature compared to normal height had found to have higher odds of double burden of malnutrition in this regression analysis. Finally, in conclusion, this study highlighted double burden of malnutrition exists but low prevalence in Nepal. However, this prevalence will increase in near future. The government of Nepal implemented nationwide maternal child health and nutrition program. Although maternal health promotion and nutrition education program would be a good strategy to prevent double burden of malnutrition in Nepal. Also, our finding also indicate that wealthier socioeconomic families should not be neglected in the prevention strategies of double burden of malnutrition. So further research is required to identify these causal relationship risk factors of double burden of malnutrition among mother-child pairs in the context of Nepal. This paper has already published in BMC Public Health Journal. If you want to know more about this paper, please go through this this link. Finally, I would like to thank the Nepal Health Research Council Organizing Committee for giving me an opportunity to share our scientific work. Thank you, and thank you very much.
Thank you, Mr. Sunwar. Now we come to the last paper of the session, and it is going to be presented by Mr. Ajay Acharya. This is on factors that influence mothers' group participation, health mothers' group participation, using a mixed method study.
Hello all. First, I would like to thank all of you for the opportunity to present our research at virtual conference organized by Nepal Health Research Council. We have used both quantitative and qualitative method to explore factors influencing health mothers group participation in Nepal. My name is Ajay Acharya, and I'm presenting on behalf of other co-authors Amy Westman and Mario Chen from FHI 360. Health mothers groups are a primary means of delivering health and nutrition services in Nepal since 1990. The HMG meets monthly, and the meeting is led by female community health volunteers. It targets all women of reproductive age, but particularly 1,000-day women from marginalized communities are encouraged to participate. During the meeting, participants discuss a wide range of maternal and child health topics, including nutrition. Each FCSB is affiliated with one HMG consisting of 10 to 15 members, and there are more than 52,000 FCSBs working in Nepal. Despite being an important service delivery platform, HMGs are underutilized channel in Nepal. A survey in 2010 showed that only about half of the women aged 15 to 49 years knew HMG exists in their communities, and 1 in 10 who knew HMG exists had participated in the meeting in last 6 months. Similarly, less than half, 46% of FCSB reported routinely conducting HMG meeting as per the FCSB National Survey of 2014. The aim of our study was to examine both the barriers and facilitators that affect Health Mothers Group participation using the primary qualitative data and secondary analysis of Nepal Demographic Health Survey 2016. Our qualitative study is conducted at Sangja, which was purposefully selected and has 6 urban and 5 rural municipalities. Sangja was selected because it is one of the Suara Second district, and this research is conducted as a part of Suara Second. The district team selected 1 rural, Kaligandaki, and 1 urban, Chapakot ward based on the implementation of service-related intervention. The selected ward has 1 health facility. The study population include health facility staff, FCSB, 1000-day woman, and household decision maker. All the health facility staff and the FCSB of the selected ward were included. Health facility in charge selected 1 active and less active FCSB based on performance assessment. The selected FCSB was asked to select first 5,000-day women from their Health Mother Group registry, and then those 5 selected 1000-day women referred 1 additional mother from their community. Each 1000-day woman who completed interview identified all adult decision makers such as husband, mother-in-law, father-in-law from their household and were included in the study. We conducted 35 in-depth interviews with 1000-day women, health facility staff and FCSBs, and 8 focus group discussion with health facility staff, FCSB, and male and female decision makers separately. All the IDIs and FGDs were audio recorded, transcribed, and translated. Initial themes and codebook were developed from 8 transcribed using NVivo 12. Framework matrix was developed and data was analyzed, producing analytical memos. Any similarities, differences by data collection site and categories of participants was noted. Following the round of analysis, study sites were visited, again to validate and share the emerging finding and explore their perceptions and agreement and disagreement about the finding related to 1000-day women. Study was approved by Nepal Health Research Council and FHI 360 Protection of Human Subject Committee. All the study participants provided informed consent both for interview and recording. For the quantitative part, secondary analysis of the NDHS 2016 data was conducted. All the participating women were asked if they know Health Mothers Group exists in their ward, and among those who knew that HMG exists were asked about their participation. Out of nearly 13,000 women, only 36% responded that HMG exists in their communities and is the sample for this analysis. To assess the association, logistic regression was used using the sampling weights, and the data are presented at odds ratio and 95% confidence interval. Regarding the results, in the qualitative analysis, we found that study participants put high value in Health Mothers Group meeting, and most of them were aware about its presence and the services that are offered. In the study side, HMG meeting is on fixed date and runs up to 3 hours. Some mothers mentioned that sometimes the meeting starts late and run for longer period of time, making them difficult to allocate the time. We observed the particular concern about the venue. Most of the meeting venues were in open space, which is influenced by the noise, dust, and external influence. Women also mentioned that they hesitate to discuss on sensitive topics such as family planning, as there will be a people known to them and sit near the meeting venue. The main barriers from the HMG participation obtained from the data analysis were agricultural season, where meetings were either cancelled, postponed, and there is no system of substitute for the cancelled or postponed meeting. Another main barrier reported by the study participant was about the lack of information or reminders about the meeting. Most of the women knew that there is HMG meeting every month, but they reported that most of the time they forgot the date because of household chores, and most women likely to be informed and invited for the meeting formally. Also, the educational difference seems to be one of the barriers. Majority of the FCSBs reported that some of the women do not attend to HMG meeting despite their repeated invitation, as those women think that they are better educated than FCSB. Also in the raining season, the meeting conducting in open space were more likely to postpone or cancel or had lower participation. Regarding the facilitators, we found that family support, especially by support by husband, was one of the main facilitators for HMG participation. Also, learning was another factor for the participation. This suggests that HMG should primarily focus on the learning topic than the saving component. Women also prefer that if the discussion topic is known in advance, that would make them easier to convince the family members. Collaborating with other meetings such as saving forest group was also seemed to be facilitator. However, FCSBs were concerned that this would not result enough time for the discussion. The data from the quantitative showed that only about 28% out of nearly 4,700 women who knew HMG exists had participated in the meeting in last 6 months. The majority who were participated were in 25 to 29 years age with no education level and had 3 or more living children. Also, women in poorest wealth quintile and with larger family size having joint household decision were more likely to participate. However, women in 15 to 19 years having higher education and richest wealth quintile were less likely to participate. Similarly, household size and number of children also affect the participation. In the adjusted analysis, educational years, number of children, and employment showed the positive effect on the participation, whereas women belonging to the Janjati compared to Brahmins living in the rural area and belonging to richest wealth quintile were less likely to participate. Regarding the discussion, HMG is valuable meeting for low educated and women in poorer wealth quintile. We observed that the information about the HMG meeting, date and place, and discussion topic are essential to improve participation. In the current practice, there is no such established formal mechanism of inviting the women to the meeting and inform them about the discussion topic prior to the meeting. Different trials have shown that well-functioning mother group is important health service delivery platform to improve maternal and child health. The study also shows that HMGs are underutilized channel and new specific interventions are needed to improve the participation of disadvantaged women. As the other part of this research, we had assessed the flexibility and interest in using the text messages to improve participation. We found that women are interested and had sufficient skills to understand the text messages, including FCSBs. The study has various limitations. First, we select the district proposably, and it is the Hill district. The barriers and facilitators found may be quite different into the Tarai part. Also, a study was conducted in the project implementation district, so the study participants may have a more awareness about HMG. Similarly, NDHS is a cross-sectional data that limits our ability about casual inferences about the exposure factors and the HMG participation. Finally, to conclude, specific innovative interventions targeting the disadvantaged women is essential to improve participation. This research is a part of What Kids Research Grant from FHI 360, and I would like to thank all of the people involved with this research. Thanks for listening. Thank
you.
Thank you, Ajay Acharya ji. I think we are done with the session.
Yeah.
And
we go to the question and answer.
Now I think we can go to the question and answers. So I am going to first address the questions that have been sent for Ms. Preksha Bimali. Are you online?
Yes, I am online.
Okay. Thank you, Preksha ji. And I think you raised, you did a very, your study was very interesting. And you looked at the effect of parity and age on maternal and perinatal factors. And there are some questions that I want to just put forward to you. So the first question is from Ajay Acharya. And his question reads, what might be causes that cesarean section is higher with the age and in multiparous? Is this consistent with other Southeast regions?
Thank you for the question, Ajayji. अब यो consistent with South Asian regions भनेर भन्ने हो भने चाहिँ if you look into the data of WHO को recommendation अनुसार नै 10 to 15% भनेर भन्नुभएको छ हैन त्यो recommendation अनुसार चाहिँ हाम्रो स्टडीमा चाहिँ धेरै नै आएको हो cesarean section but अझ प्राइभेट सेटिङ्स एन्ड अर्बन सेटिङ्सहरूको स्टडीहरूमा चाहिँ यो cesarean sectionको रेटहरू चाहिँ अझ नै हाई छ के जुन यो स्टडीमा देखायो त्यो भन्दा पनि धेरै नै हाई छ अनि साउथ एसियन कन्टेक्स्ट अथवा ग्लोबल कन्टेक्स्टमा पनि यो cesarean section चाहिँ हाई नै देखिन्छ देखिन चाहिँ अब अनफर्चुनेटली हाम्रो स्टडीले कजेसहरू चाहिँ एनालाइसिस गरेन cesarean section किन भयो भनेर तर सिमिलर ब्याकग्राउन्डमा भएको स्टडीहरूमा हेर्दाखेरि चाहिँ फिटल डिस्ट्रेसको कारणले गर्दाखेरि चाहिँ धेरै cesarean section हुने गर्छ अनि cesarean sectionमा चाहिँ एज अ मोर सेफ अप्सनको रूपमा चाहिँ लिने गरेको भएर चाहिँ धेरै चाहिँ cesarean section हुन्छ अनि अर्को भनेको चाहिँ मल्टिप्यारस वुमनहरुमा चाहिँ प्रिभियसली उहाँहरूले cesarean sectionहरु गर्नुभएको छ भने फर्स्ट टाइमको लागि अथवा अगाडिको टाइमहरुमा चाहिँ त्यो टाइममा चाहिँ cesarean section चाहिँ धेरै चुज गर्नु हुँदै रहेछ त्यही भएर चाहिँ मल्टिप्यारस वुमनहरुमा चाहिँ cesarean sectionको केसेसहरु चाहिँ धेरै देखिने
So I hope you have answered the question to the person who posed that question. The second question is from Chabi Gauril. And Chabi Gauril has to say that it is a challenge that 17% of childbearing by the age between 15 to 19 years. How to reduce this data and what is your recommendation to the policymakers as well as community level?
17% childbearing at the age of 15 to 19, so yeah, this is challenging. हाम्रो जस्तो देशमा जहाँ legal age is 20 years भनेको छ म्यारेजको लागि त्यो टाइममा 15 to 19 years भित्र म्यारेज भएर 17 years भनौँ न median age for marriage अनि त्यसमा पनि childbearing अझ multiparous हुने त्यो challenging हो यसको लागि चाहिँ I think education is the main key हैन गभर्नमेन्टले legal age तोकिसक्यो अब त्यसपछि पनि हुँदैन भने we have to more focus on education and awareness अब प्रोभिन्स 2 मा जसरी बेटी बचाओ बेटी पढाओ भनेर जुन क्याम्पेनहरु स्टार्ट भइराछ जसको चाहिँ मेन प्राइमरी मोटिभ भनेको गर्ल्स एजुकेसन अनि त्यहाँ चाहिँ डाउरी सिस्टम स्टप गर्ने हो डाउरी सिस्टम रिड्युस गर्ने हो जुन चाहिँ अर्ली म्यारेजको लागि चाहिँ एकदम मेजर कज हो डाउरी सिस्टम त्यो प्रोभिन्समा त्यस्तै खालको क्याम्पेनहरु जुन चाहिँ गर्ल्स एजुकेसनहरुमा बढी फोकस गर्ने क्याम्पेनहरु ले चाहिँ यो च्यालेन्जलाई चाहिँ एड्रेस गर्न सक्छ होला जस्तो लाग्छ मलाई that would be my recommendation to create to design some age appropriate अनि मेजरली गर्ल्सलाई फोकस गरेर चाहिँ गर्ल एजुकेसनमा फोकस गरेर चाहिँ कुनै एजुकेसन क्याम्पेन अथवा यस्तै के क्याम्पेन्सहरुले चाहिँ यो जुन म्यारेज एन्ड डिलेइङ प्रेग्नेन्सीहरु चाहिँ हुन्छ होला
थ्यांक यू आई थिंक तपाईले भनेको रेकमेन्डेसन भन्नु चाहिँ भयो मेबी इट्स बिकज यु डिडन्ट project it and you didn't say that this would be a recommendation that the question is coming up. So paper lekhnu bhako chaina bhane this is probably something you need to include in your recommendations in your paper. Haina?
Thank you.
Mero pani aba I have something to ask you. Hai? So you have talked about the perinatal outcomes and you are looking at age and parity. Tapaile adjusted odds ratios bhaneर निकाल्नु भयो. You didn't tell us what you adjusted for, okay, which variables you adjusted for. I find something missing in between, okay, because just age le garदाखेरि त्यो outcome भयो भन्दाखेरि you're missing something, a lot of factors in between that come. You know, it's not only age that causes that outcome. There are a lot of things that come in between. तपाईको जसरी भन्नु भएको छ नि यो पहिलै क्वेशनमा cesarean section rates are higher in older women. Why? You know, so what did you adjust for and how did you get that adjusted odd ratio is what I am interested in.
Okay. Adjustment चाहिँ अब हामीले स्टडी गर्दा चाहिँ हामीले अरु लिटरेचरहरु हेरेर त्यहाँ भएको फ्याक्टर्सहरुलाई चाहिँ एडजस्ट गरेको हो हैन अब एभ्री प्यारिटीको आउटकम्सको लागि चाहिँ हामीले एज सँग एडजस्ट गरेको छौं अनि एभ्री एजको आउटकमहरुको लागि चाहिँ हामीले प्यारिटी सँग एडजस्ट गरेको छौं हैन अनि त्यसबाहेक पनि अरु हामीले इन्डिभिजुअल अब एकैछिन म सायद टाइम लिएर भन्छु होला हैन अब हामीले एडजस्टमेन्ट चाहिँ इच फ्याक्टरको लागि चाहिँ पोसिबल हाम्रो जुन अरु भेरिएबल्सहरुलाई चाहिँ एकअर्कासँग हामीले एडजस्ट गरेको छौं जस्तै
that would be interesting to know to the audience and to whoever's listening or reading your paper or listening to your presentation. Tapale ke factors la adjust garnu bhayo bhane it is important to know, right? Because there are so many confounding variables that can come in between. So I guess that is something you need to consider.
जस्तो कि सिजरियन सेक्सन्समा चाहिँ धेरै क्वेसन आएको भएरमा सिजरियन सेक्सन डेलिभरी टाइपलाई चाहिँ केले एडजस्ट गर्यो भनेर चाहिँ म अहिले भन्न सक्छु हैन जुन मैले भने एज एन्ड प्यारिटी त्यो बाहेक डेलिभरी सेक्सन टाइपको लागि चाहिँ हामीले एडजस्ट
एज एन्ड प्यारिटी त अलरेडी तपाईको एक्सपोजर भेरिएबल्स भइहाल्यो नि हैन
हजुर हजुर
अरु केलाई एडजस्ट गरेर तपाईले एडजस्टेड
अरु चाहिँ हामी जेस्टेसन एजसँग गरेको छौं त्यसलाई एडजस्ट अनि लेबर इन्डक्सन अफ लेबर भयो कि भएन त्योसँग एडजस्ट गरेको छौं
ओके well maybe some other factors you could consider is maternal illness consider garnu सक्नुहुन्छ pregnancy ma ke bhayo हैन so maybe if you haven't written the paper or you still have some analysis to do maybe that is something you can concentrate on त्यो चाहिँ मेरो feedback हो I mean just see whether that is possible
thank you so much
may I just मेरो प्रेक्षा जी तपाईलाई मेरो सानो एउटा सजेसन के छ भने I can imagine that you were so involved in your research there was a lot of emotional engagement as well I presume तपाईको चाहिँ recommendations were they were not all supported by your findings so I would request you to put those recommendations when you put it on paper which you have the findings to support with am I able?
Yes.
Thank you.
Yeah, I got that.
Thank you, Preksha ji. I think we now want to go on to Ms. Sunita Dharel. Sunita ji, online हुनुहुन्छ?
हजुर.
हुन्छ. Thank you. तपाईको यो again I think this study and what you looked at was very very important. Inequity हेर्नु भएको छ तपाईले perinatal mortality को inequity के छ what are the issues and you have come up with something very significant findings and thank you for that तपाईसँग questions त हैन एउटा recommendation चाहिँ आछ छवि गौडेलले यहाँलाई के recommendation गर्नु भएको छ भने the definition of disadvantage and not disadvantaged group should not be according to the caste. A so-called Dalit Janjati can have a high potential and a so-called Brahmin may not have high potential भनेर उनीलाई चाहिँ त्यसरी marginalized जनजाति भन्ने बित्तिकै marginalized हुन्छ भनेर त्यो चाहिँ अलिकति maybe you're sort of giving them a label भनेर maybe that is something you should not use भनेर उहाँको suggestion छ तपाईलाई है त
थ्यांक यू तर मैले यसमा चाहिँ कास्टकै आधारमा चाहिँ बेसिस मानेर मार्जिनलाइज भन्न खोजेको चाहिँ हैन यसमा चाहिँ फर्दर अरु एनालाइसिसहरु पहिलाको ट्रेन हेर्दा
We can come back to her later if she joins us.
हजुर I think Sunita ji अहिले अलिकति टेक्निकल प्रब्लम भयो तपाईले सुन्नु भएको छ कि छैन त्यही भएर हामी will come back to your presentation and your discussion अहिले I think we'll take the next presenter go Thank you ma'am over to you
Devram ji lai there are no questions Ajay ji lai चाहिँ there is a question from Mr Chabi Godel म त्यो प्रश्न पढ्छु Third-party monitoring report of 1000 Golden Days program says that nutrition program is not effective in Nepal. There was high corruption in program implementation level. How to improve at implementation level? यो उहाँले भन्नुभएको छ अब clearly this is beyond your paper what you presented Mr. Acharya. Would you like to respond or what do you say?
नमस्ते म्याम दुईटै म्यामलाई यो मेरो फिल्डको चाहिँ परेन र मैले यो रिपोर्ट पनि हेरेर चाहिँ अब कति इफेक्टिभ कति अनइफेक्टिभ अब के सेन्समा भन्ने अब त्यो हिसाबले आई थिङ्क आई एम नट इन पोजिसन टु रेस्पोन्ड द्याट सो
I take your point on that. Okay. मलाई एउटा दुईटा कुरा भन्न मन लागेको थियो हाम्रो मिस्टर सुनवारलाई पनि मलाई कस्तो लागेको थियो भने मिस्टर सुनवार, are you there? Thank you for taking up this very topical issue. There's been a lot, नेपालमा हामी डबल बर्डन पहिलादेखि कुरा गरिरहेको हो र तपाईले चाहिँ गभर्नमेन्ट अफ नेपालको मटर्नल अन्डर न्युट्रिसनको मालन्युट्रिसनको स्ट्र्याटेजी हेर्नुभयो भने त्यहाँ पनि यसको मेन्सन छ। दुई चारवटा कुरा चाहिँ तपाईलाई म सजेस्ट गर्छु, हुन त तपाईले पेपर पब्लिश गरिसक्नु भएको छ, बट इभन देन आई थिङ्क इट विल बी अफ इन्ट्रेस्ट। त्यो चाहिँ के छ भने नेपालमा चाहिँ क्रस ओभर भइसकेको छ। You see, the reduction of maternal undernutrition has been superseded by increase of overnutrition. And visually you could have presented in a very effective manner. Miss gare. Arko kura चाहिँ introduction ma for the audience, you explained what double burden was. तर मैले चाहिँ त्यसको चाहिँ जुन चारवटा क्याटेगोरी छ त्यसमा एउटा चाहिँ लाइफ साइकलको कुरा। एउटा बच्चा चाहिँ is born small for gestational age and later because of the various factors becomes obese and develops non-communicable diseases. त्यसमा पनि एउटा relationship चाहिँ लाइफ साइकलको मा पनि छ। त्यो चाहिँ तपाईको इन्ट्रोडक्सनमा अलिकति मिस भए जस्तो लाग्यो मलाई। So I would just like to point that out for the sake of the audience who may be listening to us. Similarly, in the recommendation, double duty of actions, it would make it more complete. So thank you so much for your presentation, Mr. Sunwar. Thank you. एउटा प्रश्न मैले चाहिँ अजयजीलाई पनि सोध्न मलाई मन लागेको थियो। त्यो चाहिँ के भने उहाँले अजयजी हुनुहुन्छ?
Yes, I'm listening.
Okay. When I read your title and you said mixed method, I was really hoping that you would try to juxtapose quantitative findings with your qualitative data and tell us, compare the two to make it interesting. तपाईले चाहिँ क्वान्टिटेटिभ डेटा उल्लेख चाहिँ गर्नुभयो तर आजको प्रेजेन्टेसनमा खासै आएन। हामीलाई चाहिँ अलिकति बताइदिनु हुन्छ? I mean, because the whole beauty of doing this mixed method is that you would bring the real voices of the participants and ground it in the amidst the quantitative findings and explain why there are differences or similarities. Because you were involved in this research, मलाई चाहिँ त्यो सोध्न मन लाग्यो। किनभने अर्को कुरा के छ भने तपाईले खासै वर्बाटिम्सहरु राख्नु भएन तपाईको फाइन्डिङ्समा। त्यसले गर्दाखेरि पनि मलाई अलिकति हाम्रो स्वयंसेविका बहिनीहरुको आवाज सुन्न मन लाग्यो। के शेयर गर्न चाहनुहुन्छ? Especially quantitative जुन फाइन्डिङ्स छ त्यो र क्वालिटेटिभ को डिफरेन्सेस बारेमा।
Sir, thank you for the question. यो क्वालिटेटिभ को चाहिँ कुन सेन्समा थियो भने हामीले खासमा त्यो एम हेल्थ को फिजिबिलिटी स्टडी गर्दाखेरि हेल्थ मदर ग्रुप को पार्टिसिपेन्ट जुन 1000 डे वुमन हुनुहुन्छ उहाँसँग त्यो एसएमएस कति एक्सेप्टेबल हुन्छ भनेर गराएको थियौं। त्यही बेलामा चाहिँ यो एचएमजी को पनि ब्यारी फेसिलिटेटर्स अनि के कामहरु राम्रोसँग भइराखेको छ के भइराखेको छैन भनेर चाहिँ स्टडी गरेको हो। र एफसीएलएसपी र 1000 डे वुमन को लगभग ब्यारियर जुन पोइन्ट आउट उहाँहरूले गर्नु भएको छ त्यो लगभग सिमिलर जस्तै नै। तर एउटा मोस्ट इन्ट्रेस्टिङ पार्ट के छ भन्दाखेरि जुन हामीले अलिकति कमनली प्रिजन गरेको चाहिँ अब जुन अनट्रस्ट को कुरा थियो 1000 डे वुमनले एफसीएचबीलाई अनि एफसीएचबीले चाहिँ 1000 डे वुमनलाई त्यो चाहिँ हाम्रो एजम्पसन भन्दा फरक भनौं न। दे आर हाइली ट्रस्टेड एमङ इच अदर। अझै पनि त्यो रिलेसन एकदम इनबिल्ड छ भन्नुभन्दा जुन त्यो कामको एक्नोलेजमेन्ट अनि उहाँले बोलाएको मिटिङमा जाने अनि त्यो फ्यामिली सपोर्टहरु चाहिँ हैन
तर कहीँ न कहीँ अरू फ्याक्टरहरू जस्तो भनौँ न, जस्तै मिटिङहरू अरूसँग कोलाबोरेसन गरेर गर्ने मिटिङहरू होइन, र केही ठाउँमा चाहिँ नि अब केही थाउजन्ड वुमन र एफसिएसबीको केही इस्युजहरू आफ्नै पर्सनल अथवा केही कल्चरल इस्युजहरूले चाहिँ नि पार्टिसिपेसनलाई चाहिँ के गरेको छ। नभए त्यो उहाँहरूको दुईटाको चाहिँ जुन मैले यो अलिकति हामीले डिटेलमा अरू पनि गर्दैछौँ, त्यही भएर त्यो पेपर ननिस्केको भएर कारणले गर्दा पेपरमा अझै बढी डिटेलमा चाहिँ आउँछ होइन। तर यो मेजर ब्यारियर अफ एक्टिभिटिजहरू मैले जुन त्यसमा राखेको थिएँ, जुन लिस्ट आउट गरेको थिएँ, तिनीहरू चाहिँ त्यही हो। र त्यो भर्बिटम चाहिँ नि त्यो स्लाइडमा अलिकति नमिल्ने भएको कारणले गर्दाखेरि थोरै मैले त्यसमा इन्क्लुड गरिनँ, बट इट्स अ भेरी हेल्पफुल suggestions. I'll try to include all those.
Yeah, that's what makes qualitative research interesting, you know, because we can feel the reality of the participants. So I would request you to consider that, certainly. I'm sure you'll do it. Has. Thank you. So do we go back to Sunita? Or
I have one question for
sure,
Devram.
Sure.
Hello, हाम्रो देवरामजी हुनुहुन्छ?
Yes, ma'am.
हजुर हुन्छ. Thank you, Devramji. तपाईँको presentation was very interesting. तपाईँको title was double burden. तर मलाई कस्तो interesting लाग्यो भने त्यो double burden मा तपाईँले mothers मा obesity र overweight मात्रै हेर्नुभयो र children मा undernutrition मात्रै हेर्नुभयो के. So I don't know where the double burden is here, because I always thought that double burden meant children ma obesity as well as undernutrition and mothers ma obesity as well as undernutrition. Tapaile obesity ra overweight mothers heruma, why did you look for childhood undernutrition and why not overnutrition? Is what I was trying to get from your paper. Ke kina ekachoti tapaile you just went across the spectrum. I just wanted to ask you that question.
म्याम यो क्वेसनको लागि धेरै धेरै धन्यवाद म्याम हजुरलाई। यो डबल बर्डन मालन्युट्रिसन चाहिँ खास यो तीनटा लेभलमा चाहिँ एक्जिस्ट हुन्छ, नेसनल, हाउसहोल्ड र इन्डिभिजुअल लेभलमा। अब नेसनल लेभलमा चाहिँ कोइस्टिङ प्रिभेलेन्स अफ मालन्युट्रिसन इन द सेम कन्ट्री, त्यसमा चाहिँ अब जस्तै हजुरले भन्नुभएको थियो एउटा अन्डर न्युट्रिसन बच्चा भयो, त्यस्तै गरी ओभरवेट बच्चा हुनसक्छ अथवा एनिमिक चाइल्ड हुनसक्छ। मैले चाहिँ खास यो हेर्न खोजेको चाहिँ हाउसहोल्ड लेभललाई मैले फोकस गरेको। हाउसहोल्ड लेभलमा चाहिँ हामीले स्पेसिफिकल्ली यो WHO को चाहिँ डेफिनेसनहरू अनुसार चाहिँ म्याटरनल ओभरवेट, ओबेसिटी, चाइल्ड अन्डर न्युट्रिसन। चाइल्ड अन्डर न्युट्रिसन भन्ने बित्तिकै चाहिँ तीनटा त्यसका चाहिँ इन्डिकेटरहरू पर्छन्, वेस्टिङ, अन्डरवेट अनि स्टन्टिङ। त्यो खालि मैले चाहिँ हाउसहोल्ड लेभलमा मात्रै फोकस गरेको हुनाले चाहिँ यो अहिलेको चाहिँ ओभरवेट ओबेस मदर विथ चाइल्ड अन्डर न्युट्रिसन मदर चाइल्ड पेयर्समा भयो। अब हामीले चाहिँ अब यो निकट भविष्यमा चाहिँ अब नेसनल लेभल, इन्डिभिजुअल लेभलमा पनि यो चाहिँ प्लान चाहिँ गरिरहेको छौँ म्याम।
किनभने तपाईँले मदरको ओभरवेट, ओबेसिटी भन्ने बित्तिकै चाइल्डको कुन चाहिँ एज ग्रुपमा तपाईँले अन्डर न्युट्रिसन हेर्नुभयो, त्यो पनि इम्पोर्टेन्ट भयो नि त
म्याम। यो चाहिँ रिप्रोडक्टिभ एज वुमन अनि त्यही बच्चाको चाहिँ
बच्चा कति एज ग्रुपसम्म
5 देखि अन्डर 5 चिल्ड्रेनलाई चाहिँ हेरेको। कोएक्सिस्टेन्ट हो त्यो एउटै घरमा। भन्न खोजेको एउटै घरमा चाहिँ आमा ओभरवेट ओबेसिटी छ, उसैको बच्चा चाहिँ अन्डर न्युरिस भनेको चाहिँ कुनै न कुनै फर्ममा हुनु पर्यो, या त स्टन्टेड हुनु पर्यो, या त अन्डरवेट हुनु पर्यो, या त चाहिँ उसको चाहिँ वेस्टेड हुनु पर्यो। त्यो एउटै आमा मोटो घाटो छ, बच्चा चाहिँ उसको चाहिँ अन्डर न्युट्रिसन छ। यो चाहिँ हाउसहोल्ड लेभलमा चाहिँ हेरेको हामीले।
somehow I don't know, because हाउसहोल्डमा आमा बाउ मोटो भयो भने बच्चा पनि मोटो हुन्छ कि युजुअली। तपाईँको यो स्टडीमा तपाईँले अन्डर न्युट्रिसन हेर्ने हो भने ओभरवेट र ओबिज मदर्समा तपाईँले अन्डर न्युट्रिसन हेर्नु भने अर्ली इन्फेन्सीमा हेर्नुभयो भने मेबी यु विल गेट सम आन्सर्स, तर अन्डर 5 सम्म चाहिँ मेबी नट। सो मेबी अलिकति रिथिङ्क हुन्छ। तपाईँको पेपर पब्लिस भइसकेको छ, बट त्यो चाहिँ मेरो आई वाज जस्ट थिङ्किङ अफ द्याट। त्यही भएर मैले तपाईँसित कुरा गरेँ मात्रै हो। थ्याङ्क यू। सुनिताजी हुनुहुन्छ तपाईँ? सुनिता धरेलजी तपाईँको अघि सिद्धिया थिएन कि यो इन्टरनेटको तपाईँको अलि डिस्कनेक्ट भयो। डु यु वान्ट टु कन्टिन्यू विथ योर आन्सर? मैले यो क्वेसन फेरि भनिदिउँ कि
होइन? हजुर मैले बुझेको छु।
हजुर,
त्यसमा चाहिँ मैले के गर्न खोजेको भने उहाँले क्वेसन गर्न खोज्नु भएको चाहिँ जस्तो डिसएडभान्टेज भन्ने बित्तिकै, दलित भन्ने बित्तिकै डिसएडभान्टेज हुन्छन् भनेर चाहिँ होइन, त्यसमा उनीहरू पनि राम्रो गरिरहेछन् अथवा उहाँहरू हायर लेभलमा हुनुहुन्छ त्यो मलाई थाहा छ। तर त्यसमा चाहिँ मैले भन्न खोजेको चाहिँ अथवा गर्न खोजेको चाहिँ के हो भने पहिलाको स्टडीहरूमा पनि अनि पहिला गरेको एनालाइसिसहरूमा पनि यही प्याटर्नमा चाहिँ स्टडीहरूमा एनालाइसिस भएको र त्यसैलाई फलो गरेको मात्रै हो। र अनि अर्को चाहिँ त्यसलाई मात्रै नहेरिकन अर्को चाहिँ वेल्थ स्टेटसलाई पनि हेरेको छु नि त, हाइएस्ट मिडियम लो भनेर। त्यसले गर्दाखेरि कास्टलाई मात्रै बेस मानेर एनालाइसिस चाहिँ गरेको होइन, त्यही मात्रै भन्न खोजेको। तर थ्याङ्क यू फर द रिकमेन्डेसन।
I think yes, I'll wrap it up and then yeah, sure. तपाईको I found it very very interesting तपाईले जे हेर्नु भयो नि, किनभने अहिले इनइक्विटी इज द थिङ इन नेपाल होइन। कसरी चाहिँ त्यो डिसएडभान्टेजमा सबै गभर्नमेन्टको प्रोग्राम्सहरू पुर्याउने, कसरी के अरे अन्डर प्रिभिलेज मार्जिनर्सलाई पुर्याउने, र तपाईँले त्यो लास्टमा गएर समराइज गर्दाखेरि जुन चाहिँ एसडिजीको अनि पछाडि तपाईँले त्यो डेफिनेसन पनि दिनुभयो नि, वाट द गभर्नमेन्ट इज टार्गेटिङ भनेर। आई थट द्याट वाज भेरी गुड। सो आई थिङ्क द्याट वाज अ भेरी गुड प्रेजेन्टेसन। अब यसलाई अझै अलिक अघि बढाउनु भयो भने झन् राम्रो हुन्छ जस्तो लाग्यो। एन्ड म्यामले पनि सी वान्ट्स टु हेभ अ फलोअप suggestion for you, so I'm handing over to ma'am.
Suggestion banda pani, I would just maybe just an academic challenge. What if I say that you know, instead of saying inequity in perinatal mortality, what if I tell you, Sunita, that your paper is about determinants of perinatal mortality? How would you like to defend your stand?
यसमा चाहिँ खास हेर्दाखेरि पेपर हेर्दाखेरि चाहिँ आफैलाई पनि लागेको चाहिँ मैले डिटर्मिनेन्ट पनि हेरिरहेको छु जस्तो फिल भइरहेको थियो होइन। तर त्यसमा चाहिँ मैले चाहिँ यसलाई कसरी बुझेको छु भने जस्तै मैले कर्णाली प्रोभिन्सको चाहिँ म्याटर्नल पेरिनेटल मोर्टालिटी हेरेको छु भने त्यो मैले अरू प्रोभिन्ससँग कम्पेयर भन्दा नि त्यही प्रोभिन्सको पपुलेसनमा चाहिँ त्यति पर्सेन्टलाई चाहिँ पेरिनेटल मोर्टालिटी त्यति छ भनेर भनेको छु भने अरू ठाउँमा चाहिँ पपुलेसन धेरै भएको ठाउँमा थोरै पेरिनेटल मोर्टालिटी देखिएको छ, अथवा जहाँको पपुलेसन छ त्यो पपुलेसनको बेसमा चाहिँ पेरिनेटल मोर्टालिटी देखिएको छ। खालि मैले त्यसमा चाहिँ इक्वालिटी भन्दा नि इक्विटीको आधारमा चाहिँ पेरिनेटल मोर्टालिटी चाहिँ हाई लो जस्तै रिच र पोअरहरूमा डिसएडभान्टेज र नन डिसएडभान्टेज ग्रुपहरूमा, त्यसले गर्दाखेरि चाहिँ मैले यसमा अलिकति चाहिँ इनिक्विटी देख्दाखेरि डिटर्मिनेन्ट जस्तो देखिन्छ, तर मैले खास हेर्न खोजेको चाहिँ इनिक्विटी नै हो।
किनभने गभर्नमेन्ट अफ नेपालले चाहिँ इनइक्विटीलाई राम्ररी डिफाइन गराएको छ र गभर्नमेन्टको पोलिसी नै छ हाउ टु एड्रेस इनइक्विटी भनेर, रिचिङ द अनरिच्ड भन्ने स्ट्राटेजी छ गभर्नमेन्ट अफ नेपालको। म त्यसलाई पनि सोचिरहेको थिएँ कि तपाईँले जुन एङ्गलले प्रेजेन्ट गर्नुभयो र त्यसमा पनि मलाई चाहिँ त्यसमा टेक्नुभन्दा पनि तपाईँले चाहिँ एक्चुअली द्याट इज अ प्रब्लम अफ सेकेन्डरी डेटा। तपाईँले सेकेन्डरी डेटा एनालाइज गर्नुभएको छ, त्यो सबै कुरा आफ्नो ठाउँमा छ। तपाईँले चाहिँ यु नो इफ यु वर कलेक्टिङ प्राइमरी डेटा आई एम स्योर युड बी लुकिङ एट अदर इन्डिकेटर्स of inequity as well. So thank you for your presentation.
Thank you, ma'am.
I think, yeah. So with this, I would like to announce the closure of this very important session. Thank you, NHRC, for providing both Professor Sudha Bosneth and myself the opportunity to chair this session. Thank you, the audience who are online. This is a very novel experience, and to not have a big crowd before us, but you know, we live and we learn. So let's hope we only become better at it. So thank you.
Thank you, ma'am, Sudha ma'am and Madhu ma'am for valuable remarks. And this is our so privileged to be our chairperson in this stage to have you. And thank you so much, ma'am, for being here. And once again, I would like to thank you, Professor Dr. Madhu Dixit Depkota and Professor Dr. Sudha Bosneth and the presenter for making this session more vibrant and more informative, and hope this is much more fruitful to all of us and the researcher. Now I would like to request our chairman of Nepal Health Research Council, Professor Dr. Anjani Kumar Jha, to present the token of love. Dear ma'am, can we please have you on a stage to receive the token of love? Professor Dr. Madhu Dixit Tepota.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. Professor Dr. Sudha Vasneet. Thank you, ma'am. Finally, we are at the end of the session, and after that, Dr. Meghnad Dhimal, Chief of the Research Section, will continue the remaining sessions, and this will be the closing sessions. And at closing sessions, Migrenda Samaj Medical Trust oration by Sanduk Rohit, who will be presented at that session, and also there will be an award announcement program, and this will be run by the Master of Ceremony, Dr. Meghnad Dhimal. Thank you. After 10 minutes, we'll continue the session. Thank you.
डाक्टर साहब सुन्नुहुन्छ मृगेन्द्र डाक्टर साहब सुन्नुहुन्छ हजुरको म्युट छ अनम्युट गर्नु त यताबाट गर्दैन नि त डाक्टर साहब
हजुर भयो
भयो डाक्टर साहब अब हामी हजुरहरूले बोल्नलाई रिक्वेस्ट गर्छौँ पछि अहिले हजुर अनलाइनमा बस्दिनु मात्रै है डाक्टर साहब हस् डाक्टर साहब हस्
नेपाल स्वास्थ्य अनुसन्धान परिषदको स्थापना विक्रम सम्वत 2047 साल चैत 29 गते भएको थियो। यसभन्दा अघि विक्रम सम्वत 2039 सालमै स्वास्थ्य अनुसन्धान समितिका रूपमा स्थापना भई यसले काम सुरु गरिसकेको थियो। यसको मुख्य उद्देश्य स्वास्थ्यका क्षेत्रमा अनुसन्धानलाई बढाउँदै लाने, अनुसन्धानबाट आएका तथ्यलाई ध्यानमा राख्दै सरकारलाई नीति तथा कार्यक्रम बनाउन सहयोग गर्ने थियो। यसको स्थापनाको कठिनाइलाई प्राध्यापक डाक्टर मृगेन्द्र राज पाण्डे यसरी सम्झिनुहुन्छ।
हामी केही डाक्टरहरूलाई र उनीहरूलाई के लाग्यो भनेदेखि नेपालको स्वास्थ्य परिस्थिति, स्वास्थ्य स्थिति ज्यादै नराम्रो थियो। त्यसलाई इम्प्रुभ गर्नलाई नेपाल सरकारले कोसिस त गरिरहेको छ, तर अनुसन्धानको पक्षमा चाहिँ ज्यादै नै पिछडिया हुनाले यसलाई प्रोत्साहन दिनु पर्यो भनेर र फेरि नेबरिङ कन्ट्रिजहरूमा जस्तो त्यही बेलामा भारतमा इन्डियन काउन्सिल अफ मेडिकल रिसर्च बनेको 70-80 वर्ष भइसकेको थियो। हामी कहाँ केही थिएन। अब काउन्सिलै बनाउनु त एकैचोटि आँट्न त गाह्रो हुन्थ्यो, किनभने एक्ट चाहिन्थ्यो, पार्लियामेन्टको एक्ट। तर एउटा कमिटी भएन बनोस् न भनेर हामीले एउटा मौका सोच्यौँ। WHO को डिरेक्टर्स अफ मेडिकल रिसर्च काउन्सिलको मिटिङभन्दा अगाडि एउटा मान्छेहरूलाई त्यहाँ पठाउनु पर्यो यो सबै कुराको निम्ति। हामीले को कसरी को जाने भन्ने कुराको त्यहाँ भइरहेको थियो, के गर्ने भन्ने कुरामा कसलाई पठाउने भनेर कहिले को एउटा हेपाजात थियो। त्यही बेलामा हामीले के भन्यौँ भनेदेखि त्यो हेपाजात हुँदाखेरि त्यति बेला इफेक्टिभ पनि हुँदैन क्या। एउटा उता बनाउनुहोस् न सचिवज्यू, हजुरकै अध्यक्षतामा बनाउनुहोस् न, तपाईँकै अध्यक्षतामा बनाउनुहोस् न, एउटा कमिटी बनाऊ। अनि त्यो कमिटी चाहिँ नेपाल हेल्थ रिसर्च कमिटी, त्यो अधिकार तपाईँसँग छ, सचिवसँग छ, मन्त्रीसम्म लगेर उ गर्नु पर्ला। अनि केही व्यक्तिहरूलाई राख्नुहोस् भन्दाखेरि हामीहरू 5-7 जनालाई राखेर उहाँको अध्यक्षता यो पहिले 1981 मा बनेको हो।
नेपाल स्वास्थ्य अनुसन्धान परिषदको स्थापना अघि स्वास्थ्यका क्षेत्रमा अनुसन्धान नभएका भने होइनन्। त्यसबेला अनुसन्धान गरे पनि व्यवस्थित भने हुन सकेको थिएन। यही कुरालाई ध्यानमा राख्दै स्वास्थ्य जस्तो संवेदनशील क्षेत्रमा अनुसन्धान गर्न जरुरी रहेको महसुस गरी परिषद स्थापना भएको सम्झिनुहुन्छ डाक्टर मथुरा प्रसाद श्रेष्ठ।
47 सालमा मन्त्री हुँदाखेरि त्यति बेला जाने अनुसन्धान परिषद, त्योभन्दा अगाडि पनि अनुसन्धान परिषदको निम्ति हामीले धेरै किसिमबाट ट्राई गऱ्यौँ, तर सफल नभएको अवस्था थियो। र त्यति बेला चाहिँ नै म चाहिँ नै अब मेरो आफ्नै इच्छा नभए पनि मन्त्री बने, स्वास्थ्य मन्त्री हुँदाखेरि स्वास्थ्य अनुसन्धान परिषद खोल्नु पर्यो भन्ने कुराहरू मन्त्रीमण्डलबाट पनि निर्णय गराइयो। र चाहिँ नै के भयो भने त्यति बेला एउटा त्यसको विधान पनि थिएन होइन। पहिला त कसैले बनाउने ऊ कुरा भयो, इन्ट्रेस्टै नभएपछि कहाँ बन्थ्यो। र विधान बनाउनको निम्ति अब धेरै अलिक गाह्रो भयो। अनि डाक्टरहरूलाई जिम्मा भयो। अब यो सेकेन्डरी जब जस्तो मान्यो। अनि डाक्टर मृगेन्द्र राज पाण्डे निकै लगनशील मान्छे हुन्छ, तपाईँहरूले चिन्नु पनि हुन्छ होला। उहाँलाई जिम्मा दियौँ। उहाँले चाहिँ नि अब हुन त अब त्यहाँ अब सुरुमा ल्यायो। अब हाम्रो पनि 1 वर्षको मात्रै अवधिको भएको हुनाले छिटो गर्नु थियो। जे जस्तो भयो पनि हामीहरूले त्यसलाई पास गरेर मृगेन्द्र राजकै अध्यक्षतामा हामीहरूले गठन गर्यौँ।
अनुसन्धान जथाभावी गर्नु भएन र अनुसन्धानकर्ता र अनुसन्धानमा सहभागी व्यक्ति वा समुदाय बराबर हुन् र पूर्ण सम्मानका साथ अनुसन्धान गर्नुपर्छ भन्ने संस्कारको विकास गर्नुपर्ने आवश्यकतालाई पूरा गर्ने गरी परिषदको गठन भएको हो।
यहाँसम्म आइसक्दाखेरि अब हामीले स्वास्थ्य क्षेत्रमा हुने सूचनाहरूलाई डिजिटलाइज गर्ने, सूचनालाई एकीकृत गर्ने, युवा वैज्ञानिकहरूलाई प्रोत्साहन गर्ने, रिसर्चको प्रायोरिटी भन्नाले त्यसको प्राथमिकताहरू तोक्ने, काम गरिरहेका छौँ र अब अहिले पछिल्लो कालमा तपाईँले हेर्नुहुन्छ भने अहिले हाम्रोमा विश्वविद्यालयहरू बढिरहेका, शिक्षकहरूको सङ्ख्या बढिरहेको, स्पेसली मेडिकल एजुकेसनमा हेर्दाखेरि र विश्वविद्यालयले पनि के भन्यो भने अब तपाईँलाई प्रमोसन वृद्धि विकासको लागि पनि तपाईँले कुनै न कुनै अनुसन्धानमूलक कार्य गर्नुपर्ने, त्यसको रेकर्ड हुनुपर्ने भन्नाले जर्नलमा पब्लिस हुनुपर्ने, अनि त्यो जर्नलमा पब्लिस हुनलाई हामीले चाहिँ इथिकल क्लियरेन्स भएपछि मात्रै छाप्न पाउने विधि विधान गरेको हुनाले अहिले हामीले चाहिँ पहिलाभन्दा अलि बेसी काम गरिरहेका छौँ। एउटा जस्तो उदाहरणको लागि इथिकल रिभ्यू बोर्डको मिटिङ बेला बेलामा बस्थ्यो भने अहिले अलि त्योभन्दा रेगुलर बस्छ, चाहियो भने हप्तै पछि बस्छ। यो प्रगति हो। र अब अर्को प्रगति भनेको चाहिँ के छ भने अहिले हामीले युवा वैज्ञानिकहरूलाई प्रोत्साहित गर्ने काम गरिरहेका छौँ।
अहिले अनुसन्धान आचार संहिता पालना गराउने राष्ट्रिय रूपमा इथिकल रिभ्यू बोर्ड छ र यसका 22वटा शाखाहरू विभिन्न विश्वविद्यालय र अनुसन्धान संस्थामा गठन गरिएका छन्। यसले स्वास्थ्य अनुसन्धानलाई नियमन गर्ने मात्रै होइन, अनुसन्धानको संस्कार विकास भएको छ।
अब यो नेपाल स्वास्थ्य अनुसन्धान परिषद चाहिँ बडो एउटा अप्ठ्यारो परिस्थितिमा आजभन्दा 25 वर्ष अगाडि डाक्टर मृगनराज पाण्डेको नेतृत्वमा चाहिँ स्थापना भएको एउटा राष्ट्रिय संस्था हो र स्वास्थ्यको अनुसन्धान गर्ने अनुसन्धानकर्ताहरूलाई सहयोग गर्ने र सँगसँगै चाहिँ अनुसन्धानलाई नियमन गर्ने र अनुसन्धानको एउटा चाहिँ संस्कारलाई विकास गर्ने खालको उद्देश्यबाट यो संस्था चाहिँ स्थापना भएको हो। र अब यो चाहिँ 25 वर्षको दौरानमा आउँदाखेरि हामीले धेरै प्रगति गरेका छौँ। जस्तो उदाहरणको लागि 4000 भन्दा बढी चाहिँ हामीले वैज्ञानिकहरूलाई चाहिँ तालिम दिएका छौँ। स्वास्थ्यको अनुसन्धान गर्नको लागि क्षमता अभिवृद्धि गरेका छौँ। 1800 भन्दा बढी चाहिँ हामीले रिसर्च प्रोटोकलहरूलाई चाहिँ एप्रुभल गरेका छौँ। यो चाहिँ सुरुमा त सुरुको वर्षमा 8वटा 9वटा 10वटा हुन्थ्यो। अहिले हाम्रो चाहिँ 300-400वटा चाहिँ हरेक वर्ष चाहिँ अनुसन्धानहरू भइरहेछ। त्यो पनि स्वास्थ्य अनुसन्धान परिषदबाट स्वीकृति लिएर भइरहेको छ। त्यसैले यो 25 वर्षको दौरानमा हामीले नेपालमा स्वास्थ्य अनुसन्धानको एउटा संस्कार चाहिँ विकास गर्नको लागि चाहिँ सफल भएका छौँ।
नेपाल स्वास्थ्य अनुसन्धान परिषदको स्थापना पश्चात भने स्वास्थ्यका विषयमा अनुसन्धान गर्ने प्रवृत्ति बढ्दै गएको पाइन्छ। ठूला ठूला अनुसन्धान गर्दा पनि अनुसन्धान प्रस्ताव पेश नगर्ने मात्रै होइन, स्वीकृति बिना नै अनुसन्धान गर्ने प्रचलन थियो भने हाल परिषदको सक्रियतामा साना साना अनुसन्धानका लागि पनि स्वीकृति लिने प्रचलन बढेको छ।
हामीले विभिन्न चाहिँ सङ्घ संस्थाहरूसँग, विश्व स्वास्थ्य सङ्गठन लगायतको अनुसन्धानसँग सम्बन्धित संस्थाहरूसँग हामी मिलेर काम गर्ने कुराहरूमा पार्टनरसिपमा हामी चाहिँ थुप्रै कार्यक्रमहरू सञ्चालन गर्न सकेका छौँ। र अहिले स्वास्थ्य अनुसन्धान परिषद चाहिँ नेपालको स्वास्थ्य क्षेत्रको अनुसन्धानको एउटा चाहिँ सर्वोच्च निकाय हो भन्ने कुराहरूको चाहिँ पहिचान चिनारी बनाएको छ।
स्वास्थ्यमा सुधार ल्याउन र गुणस्तरीय स्वास्थ्य सेवा प्रदान गर्न स्वास्थ्यका क्षेत्रमा अनुसन्धान व्यापक हुन जरुरी छ। अनुसन्धानबाट निस्किएका परिणामले सरकारलाई नीति तथा कार्यक्रम गर्न समेत सहयोग गर्छ। यसलाई अझ अगाडि बढाउन सरकारले अनुसन्धानका लागि पर्याप्त बजेट छुट्याएर यसको क्षेत्र फराकिलो बढाउनु पर्नेमा विज्ञहरूको जोड छ।
गएको समयमा नेपाल हेल्थ रिसर्च काउन्सिलले रिसर्चका लागि, अनुसन्धानका लागि केही प्रायोरिटीहरू तोक्यो। तर सरसर्ती हेर्दाखेरि ती प्रायोरिटीहरू चाहिँ बढी रोगमा चाहिँ फोकस छन्, डिजिजमा चाहिँ फोकस छन् र डिजिजले चाहिँ प्रायोरिटी पाएको छ। मलाई लाग्छ यो 25 वर्षको यो जुन जुबिली मनाइराख्दाखेरि अब नेपाल हेल्थ रिसर्च काउन्सिलले आउँदा दिनहरूमा स्वास्थ्य अनुसन्धानको कुरा गर्दाखेरि अब चाहिँ हेल्थ रिसर्चले कसरी स्वास्थ्यमा एउटा सामाजिक न्यायलाई स्थापित गर्न सकिन्छ, कसरी स्वास्थ्यमा समानतालाई चाहिँ हामी स्थापित गर्न सक्छौँ र सामाजिक न्याय र यो जुन समानतामा आधारित एउटा स्वास्थ्य प्रणाली विकास गर्नलाई चाहिँ यो अनुसन्धानले चाहिँ कस्तो भूमिका निर्वाह गर्नुपर्छ भन्ने चिजमा चाहिँ फोकस गर्नुपर्छ जस्तो मलाई लाग्छ।
बजेटहरूको चाहिँ व्यवस्था गर्नु पर्यो। नेपालमा स्वास्थ्यको अहिलेसम्मको चाहिँ मैले पहिले भने जस्तै कल्चर डेभलप गर्नको लागि मात्र अनुसन्धान भइरहेका छन्। फाइन्डिङ तपाईँको चाहिँ भोलि पोलिसीमा गएर चाहिँ उतार्नको लागि चाहिँ पोलिसी लेभलमा आफ्नो फाइन्डिङहरूलाई चाहिँ नि युज गर्नको लागि चाहिँ त्यो लेभलको भएको छैन। त्यसले गर्दाखेरि समस्याहरूलाई पहिचान गर्ने सरकार स्वास्थ्य अनुसन्धान परिषद दुइटै बसेर गर्न सक्छ। के समस्या छ त हामीहरूको टेक्निकल चाहिँ ग्रुपहरू बनाउन सक्छ, त्यो एक्जिस्टिङ छ र त्यसलाई चाहिँ तपाईँको चाहिँ गभर्मेन्टले आफ्नो चाहिँ बजेटको भन्न त रिसर्चमा के भन्छ भन्नुहुन्छ भने तपाईँको चाहिँ नेसनल बजेटको 2% एटलिस्ट 2% बजेट रिसर्चमा राख्नुपर्छ, सो द्याट रिसर्च राम्रो हुन्छ र त्यसको लागि चाहिँ तपाईँको पोलिसीमा चाहिँ रेप्लिकेट गर्न सकिन्छ, पोलिसीमा चाहिँ युज गर्न सकिन्छ। त्यो हिसाबले नेपाल सरकारले र विशेष गरेर त्यसमा स्वास्थ्य मन्त्रालयले दात्री संस्थाहरूबाट आफ्नो चाहिँ फन्डबाट नेपाल हेल्थ सेन्टर अनुसन्धान परिषदलाई राम्रो बनाउनको लागि, उसको स्ट्रेन्थ, उसको क्यापेसिटी चाहिँ बढाउनको लागि चाहिँ स्वास्थ्यमा चाहिँ तपाईँको हेल्थ रिसर्चको लागि चाहिँ बजेट बढाउनु पर्ने हुन्छ, सो द्याट रिसर्चहरू चाहिँ क्वालिटी रिसर्चहरू चाहिँ हुन्।
अनुसन्धान बिना विकास सम्भव छैन, तर अनुसन्धानको लागि आवश्यक लगानी भएको छैन। जति बेलासम्म अनुसन्धानका लागि लगानी बढाउन सकिँदैन त्यति बेलासम्म गुणस्तरीय स्वास्थ्य सेवामा जनताको पहुँच वृद्धि गर्न कठिन छ। अन्तर्राष्ट्रिय स्तरमा स्वास्थ्य बजेटको 2% स्वास्थ्य अनुसन्धानमा लगाउने प्रतिबद्धता भए पनि नेपालमा यो कागजमै सीमित छ।
स्वास्थ्यको बजेट जति छ त्यसको आधारमा अनुसन्धानको बजेट स्वास्थ्य अनुसन्धान परिषदमा आयो भने हामी अलि इक्विप्ड हुन्थ्यौँ, हामी अलि सक्षम हुन्थ्यौँ र सही सूचनाहरू एकीकृत हुन्थ्यो। यसले चाहिँ लङ टर्ममा अल्टिमेट एम भनेको आम जनताको स्वास्थ्य सुधार गर्ने। आम जनताको स्वास्थ्य सुधार गर्नलाई तपाईँलाई उचित कार्यक्रम चाहियो, त्यो कार्यक्रम गर्नलाई तपाईँलाई सूचना चाहियो।
नेपाल स्वास्थ्य अनुसन्धान परिषदले स्रोत र साधनको अत्यन्तै ठूलो अभाव हुँदाहुँदै पनि मुलुकमा स्वास्थ्य अनुसन्धान क्षमता अभिवृद्धि गर्ने काम गर्दै आएको छ। हालसम्म करिब 4000 व्यक्तिहरूलाई अनुसन्धान सम्बन्धी तालिम प्रदान गरेको छ। बिस्तारै अनुसन्धान गर्ने व्यक्तिहरू र संस्थाहरू विकास भएका छन्, तर यतिले मात्रै पुग्दैन। अनुसन्धानका थुप्रै विशिष्ट पाटोहरूमा परिषदले काम गर्नुपर्नेछ।
नेपाल हेल्थ रिसर्च काउन्सिललाई एउटा नमुना रिसर्च सेन्टरको रूपमा विकसित गर्नुपर्छ। त्यसको लागि ठुलो एउटा कम्प्लेक्स छुट्याइदिनुपर्छ। रिसर्च ल्याबोरेटरी त्यहाँ इस्टाब्लिस हुनुपर्छ। रिसर्चरहरूलाई एट्र्याक्सन दिने एउटा वातावरण सिर्जना गर्नुपर्छ। पोलिटिकल कमिटमेन्ट हुनु पर्यो कि यो रिसर्चलाई चाहिँ कुनै पनि पोलिटिकल पार्टीले नछुने, त्यो साइन्टिस्टहरूलाई नै जिम्मा लाउने, उनीहरूले जुन हिसाबले अगाडि बढ्छन् त्यही हिसाबले गर्नुपर्ने। र WHO ले जुन रिकमेन्डेसन गरेको मेक्सिको 2004 को एउटा रिकमेन्डेसन छ कि रिसर्चलाई टोटल हेल्थ बजेटको कति % छुट्याइदिने भनेर, त्यो छुट्याइदिनु पर्यो। र रिसर्च साइन्टिस्टहरूलाई एट्र्याक्सनको साथसाथै उनीहरूलाई चाहिँ एउटा के गर्नुपर्ने, गर्ने त अल्टिमेटली रिसर्च साइन्टिस्टहरू नै हो, तिनीहरूलाई एट्र्याक्सन गराउनु पर्यो र तिनीहरूलाई सेक्युरिटीको वातावरण मिलाइदिनु पर्यो।
सबैलाई राम्रो गर्ने भावना रिसर्चरहरूको हुनुपर्दछ। यसको साथसाथै कसैलाई पनि नराम्रो नगर्ने भन्ने भावना हुनुपर्दछ र सबै क्लाइन्टहरू जुन रिसर्चको विषयमा रिसर्च भइरहेको छ त्यो चाहिँ नि रिसर्च गर्नेहरूको कक्षामा लिनुपर्छ। जसको रिसर्च गर्नेको जति अधिकार हुन्छ, रिसर्च जसमाथि रिसर्च गर्छ उसको पनि त्यति नै अधिकार हुनुपर्छ भन्ने मान्यता हो। अहिले त एनिमल्सहरूमा पनि त्यो मान्यता आइरहेको छ भने
अनुसन्धान गर्नु आफ्नो उत्तरदायित्व हो र सबैलाई अनुसन्धान गर्न दिनुपर्छ, तर निगरानी चाहिँ गरिनुपर्छ। समय सँगसँगै आएका स्वास्थ्य चुनौतीहरू र समस्यालाई बेलैमा पहिचान गर्न सक्ने र त्यस्ता समस्याको ठोस समाधान गर्न सक्ने राष्ट्रिय क्षमता विकास गर्न परिषदले खास पहल गर्नुपर्छ।
रिसर्च काउन्सिल जस्तो उसमा त्यस्तो ग्याप हुनु हुँदैन। नम्बर 1, 3 वर्षसम्म रिसर्च नगरेर बस्नु त होइन, त्यो बेला रिसर्च त भयो, त्यही पनि रिसर्चको झन्झन बढाएर पो लानुपर्छ। वी कान्ट वेट फर द्याट। त्यसैले यस्तो चेन्ज नहोस् बाबा, मेरो फर्स्ट कन्टिन्युटी मस्ट बी देयर। अब रिसर्चको त अहिले जुन किसिमले गइरहेको छ त्यो राम्रो हिसाबले गइरहेको छ। हेल्थ सिस्टम रिसर्चमा पनि भइरहेको छ, सबै जुन भाषा भइरहेको छ। तर बिचमा जुन ग्याप भयो नि, त्यो पहिला थाहा छ। म पनि केही दिन त कहिले प्राइज दिन म जान्थेँ नि, खालि बुङ्ग कस्तो नरमाइलो लाग्थ्यो। यस्तो ग्याप चाहिँ नहोस्।
डिफ्रेन्ट लेभल गर्दै एप्लिकल सिस्टममा बेस चाहिँ ठुलो बनाउनु पर्यो, बेसिक रिसर्च मेथोडोलोजीमा, त्यसपछि अरू ट्रेनिङ त्योभन्दा माथि गएर पिरामिड जस्तो बनाउनु पर्ने हुन्छ। त्यही हामीले बेसको लागि चाहिँ काम गरेको रिसर्च काउन्सिल डाक्टर पाण्डेको पालादेखि, मत्राको पालादेखि, मेरो पालादेखि भइ नै राखेको छ। रिसर्च ट्रेनिङ वर्कसपहरू त भइरहेको छ, यहाँ धेरैजना गाइड पनि गर्नुभयो होला, पार्टिसिपेट पनि गर्नुभयो होला हामीहरूलाई। त्यस कारण त्यो एउटा चाहिँ नि कन्टिन्युस प्रोसेसको रूपमा हामीले लैजानुपर्छ।
निरन्तर प्रयासले मात्र सफलता प्राप्त गर्न सकिन्छ। नेपाल स्वास्थ्य अनुसन्धान परिषद 25 वर्षदेखि निरन्तर रूपमा अनुसन्धान क्षमता वृद्धि गर्न लागि परेको छ। यो यात्रा अविरल रहिरहनेछ।
नमस्कार। यस नेपाल हेल्थ रिसर्च काउन्सिल द्वारा अर्गनाइज हेल्थ एंड पपुलेशन साइंटिस्ट को 6औं शिखर सम्मेलन में वर्चुअली र फिजिकली प्रेजेंट संपूर्ण श्रोता दर्शक र सहभागीहरूलाई यो अंतिम सत्र में स्वागत गर्न पाउँदा मलाई खुशी लागेको छ। म प्राध्यापक डाक्टर प्रकाश घिमिरे इथिकल रिव्यू बोर्ड को चेयरपर्सन छु यहाँ र यो सन्दर्भ में अंतिम क्लोजिंग सेरेमनी सुरु गर्नुभन्दा पहिला सभापतित्व गरिदिनु हुन यस स्वास्थ्य अनुसन्धान परिषद का अध्यक्ष प्राध्यापक डाक्टर अंजनी कुमार झालाई सभा को अंतिम सत्र को सभापतित्व गरिदिनु हुन अनुरोध गर्दछु। सदा झै स्वास्थ्य अनुसन्धान परिषद को असाध्य अनन्य मित्र, सहयोगी, एडभाइजर, जहिले पनि सहयोग गर्ने स्वास्थ्य मन्त्रालय का तर्फबाट विशेषज्ञ डाक्टर रोशन पोखरेललाई प्रमुख अतिथि को आसन ग्रहण गरिदिनु हुन अनुरोध गर्दछु। आसन ग्रहण के क्रम अगाडि बढाउँदै जाँदा यस स्वास्थ्य अनुसन्धान परिषद का उपाध्यक्ष डाक्टर भोजराज अधिकारीज्यूलाई आसन ग्रहण को लागि अनुरोध गर्दछु। त्यस्तै यस कार्यक्रम को माउ व्यक्तित्व र यस संस्था का सदस्य सचिव डाक्टर प्रदीप गेवालीज्यूलाई आसन ग्रहण को लागि अनुरोध गर्दछु। आसन ग्रहणकै क्रम अगाडि बढाउँदै गर्दा म हाम्रो अगाडि नेपाल मेडिकल काउन्सिलका अध्यक्ष प्राध्यापक डाक्टर भगवान कोइरालालाई अगाडि देख्दैछु। सरलाई अगाडि आएर आसन ग्रहण गरिदिनु हुन अनुरोध गर्दछु। अब यो अन्तिम सत्र सुरु सत्रदेखि नै आउँदाखेरि अन्तिमसम्म असाध्य जरुरी सत्र हो। त्यस सत्रमा यस नेपाल हेल्थ रिसर्च काउन्सिलका एक्जिक्युटिभ बोर्डको मेम्बर प्राध्यापक डाक्टर मधु दीक्षित देवकोटालाई पनि अगाडि आएर आसन ग्रहण गरिदिनु हुन अनुरोध गर्दछु। सन् 1991 देखि अहिलेसम्म 29 वर्षको वयस्क भइसकेको संस्था जसले स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको स्वास्थ्य अनुसन्धान र इथिकल रिसर्चमा प्रवर्धनको धेरै कार्य गरेको छ। त्यही सन्दर्भमा केही वैज्ञानिकलाई हरेक वर्ष प्रोत्साहन गर्ने सन्दर्भमा हेल्थ रिसर्च काउन्सिलले केही अवार्डहरू प्रदान गर्ने गरेको छ। ती अवार्डहरू प्रदान गर्ने क्रममा अवार्ड सेलेक्सन कमिटीले केही क्राइटेरिया र सेलेक्सन कमिटी बनाएर गर्दै आइरहेको सन्दर्भमा यस कमिटीले यसपालि कतिवटा अवार्ड र के क्राइटेरियामा सेलेक्सन गरेको छ त्यो सन्दर्भमा अलिकति प्रकाश पारिदिएपछि हामी मृगेन्द्र सम्झना मेडिकल ट्रस्ट ओरेसन अवार्ड को बारेमा हामी अगाडि जान्छौँ। यो सेलेक्सन कमिटी र सेलेक्सनका आधारहरू बारेमा प्रश्न पारिदिनु हुन यस संस्थाका मेम्बर सेक्रेटरी सदस्य सचिव डाक्टर प्रदीप गेवालीज्यूलाई म अनुरोध गर्दछु।
धन्यवाद प्रकाश सर। यस 2 दिने 6औं स्वास्थ्य जनसङ्ख्या वैज्ञानिकहरूको शिखर सम्मेलनको समापन समारोहमा को अध्यक्षता गरिनुभएका नेपाल स्वास्थ्य अनुसन्धान परिषदका अध्यक्ष प्रोफेसर डाक्टर अञ्जनी कुमार झाज्यू, यस संस्थाका उपाध्यक्ष डाक्टर भोजराज अधिकारीज्यू, हाम्रो आजको दोस्रो सत्रको कार्यक्रमलाई प्रमुख अतिथिको हिसाबले हाम्रो स्वागत स्वीकार गरी पाल्नुभएका आजको यस कार्यक्रमका प्रमुख अतिथि नेपाल सरकार स्वास्थ्य जनसङ्ख्या मन्त्रालयका प्रमुख विषयका चिकित्सक डाक्टर रोशन पोखरेलज्यू, नेपाल स्वास्थ्य अनुसन्धान परिषदका कार्यकारी बोर्डका सदस्य तथा नेपाल मेडिकल काउन्सिलका अध्यक्ष प्रोफेसर डाक्टर भगवान कोइरालाज्यू, त्यस्तै गरी नेपाल स्वास्थ्य अनुसन्धान परिषदका बोर्डका सदस्य प्रोफेसर डाक्टर मधु दीक्षित देवकोटाज्यू, अतिथिज्यूहरू प्रोफेसर डाक्टर जीवनबहादुर शेरचनज्यू, डाक्टर सञ्जोग रुईज्यू लगायत उपस्थित सम्पूर्ण महानुभावज्यूहरू, विशेषज्ञज्यूहरू, रिसर्चरज्यूहरू, NHRC का कर्मचारी मित्रहरू र हामीलाई अत्यन्त उत्साहका साथ महत्त्व दिएर नेपालभित्र तथा बाहिरबाट हामीलाई सुन्नुभएका अथवा हाम्रो कार्यक्रममा चाहिँ पेपर प्रेजेन्ट गर्नुभएका सम्पूर्ण प्रेजेन्टर, रिसर्चर र शुभेच्छुक साथीहरू सम्पूर्णलाई नेपाल स्वास्थ्य अनुसन्धान परिषद तर्फबाट म हार्दिक अथवा मेरो व्यक्तिगत तर्फबाट स्वागत गर्न चाहन्छु। अब अलिकति हामीले यो क्लोजिङ सेसन भएको हुनाले एकदम छोटो मिठो हामीले गरेका छौँ र आजको क्लोजिङको मुख्य आकर्षण भनेको हामीले 2 दिनको जुन सम्मेलन गर्यौँ, यसबाट निचोडहरू निस्केको छ र हामीले यो कार्यक्रमभन्दा अगाडि यसको एवार्डको बारेमा विभिन्न निर्णय गरेका थियौँ र हाम्रो अत्यन्त महत्त्वपूर्ण प्रोग्राम पनि हो यो। यङ, धेरै सिनियर लगायतका सम्पूर्ण साइन्टिस्टहरू हामीले एकै ठाउँमा ल्याएर उहाँहरूलाई गोलबद्ध गर्दै उहाँहरूलाई सम्मान गर्ने कार्यक्रम पनि हो। त्यसकारणले गर्दा मलाई व्यक्तिगत तथा NHRC आज जसले हामीले बनाएको क्राइटेरिया एकदम स्वच्छ मूल्याङ्कन गरेर निस्केको निष्कर्षबाट प्राप्त गर्नुभएको छ। म उहाँहरूलाई अग्रिम शुभकामना दिन चाहन्छु। र यति भन्दै गर्दा हामीले यसलाई बिना बास तरिकाले, स्वच्छ तरिकाले विशेषज्ञ सरहरू राखेर, अनुभवी सरहरू राखेर हामीले एउटा कमिटी बनाएका थियौँ। यसको संयोजक गर्नुभएको थियो प्रोफेसर डाक्टर केदार प्रसाद बरालज्यू, त्यस्तै गरी प्रोफेसर डाक्टर गणेश दङ्गालज्यू, प्रोफेसर डाक्टर शङ्करमान राईज्यू, प्रोफेसर डाक्टर चन्द्रकला शर्माज्यू, प्रोफेसर डाक्टर सङ्गरत्न बज्राचार्यज्यू, श्री छवि गौडेलज्यू र कार्यालयको तर्फबाट सदस्य सचिव गर्नुभएका प्रदीप बेलवासीज्यू गरी हामीले 7 जनाको कमिटी बनाएर उहाँहरूलाई निश्चित क्राइटेरिया तोकेर उहाँहरूले पनि पछि क्राइटेरिया मोडिफाई गर्नुभयो। स्वच्छ हिसाबले काम गरेर दिएका थियौँ र यसको लागि हामीसँग भएका एवार्डहरू र थोरै क्राइटेरिया यहाँलाई भन्न चाहन्छु। एउटा भनेको हाम्रो जर्नल अन्तर्राष्ट्रियकरण भइसकेको छ स्कोपसमा। यो NHRC बेस्ट पेपर एवार्ड रहेको छ। त्यस्तै गरी हेल्थ रिसर्च एवार्ड, मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ साइन्टिस्ट रिसर्चर एवार्ड जो मेडिकल डाक्टरको लागि हामी दिने गर्छौँ। त्यस्तै गरी मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्च एवार्डको लागि हामी दिने गर्छौँ। त्यो भनेको NHRCमा कार्यरत कर्मचारीको तर्फबाट। त्यस्तै गरी हेल्थ रिसर्चमा लामो समयदेखि कार्यरत रहनुभएको मानव मध्ये हेल्थ रिसर्च लाइफ टाइम एचिभमेन्ट एवार्डको हिसाबले उहाँहरूलाई हामी सम्मान गर्ने गरेका छौँ। त्यस्तै गरी हाम्रो 2 दिनको कार्यक्रममा 2 थरीका प्रस्तुतिकरण भएका थिए र त्यसमा 32वटा ओरल प्रेजेन्टेसन जुन रेकर्डेड रिसर्च गरेका थियौँ, प्यानल डिस्कसन गराएको थियो र त्यस्तै गरी 54वटा पेपर प्रेजेन्टेसन गरी हामीसँग टोटल 86वटा हामीले प्रेजेन्टेसन गराएका थियौँ र त्यो मध्ये 2टा छुट्टा हिसाबमा बेस्ट पेपर प्रेजेन्ट एवार्ड ओरल, त्यस्तै गरी बेस्ट पेपर प्रेजेन्ट एवार्ड पोस्टर गरी 2 थरीका हामीले सम्मेलनको आकर्षण हिसाबमा गरेका थियौँ। त्यस्तै गरी अर्को NHRCको परिवारको लागि NHRC एक्जिक्युटिभ एवार्ड बेस्ट पर्फर्मेन्स एवार्ड भनेर 2020 गरी हामीसँग टोटल 8 किसिमका विभिन्न विधामा एवार्ड राखिएको छ र यसको नतिजा केही बेरमा प्रकाशित हुनेछ। र हामीले NHRC बेस्ट पेपर एवार्डको लागि दुर्गादेवी गिमालीले यसलाई स्पोन्सर गर्नुभएको छ। यसको लागि 2019मा NHRCमा पब्लिस भएका मध्येबाट इभ्यालुएसन गरी एक ओरिजिनल आर्टिकललाई प्रदान गरिने एवार्ड हो यो। त्यस्तै गरी दोस्रो हेल्थ रिसर्च एवार्डको लागि पबमेडमा इन्डेक्स भएको जर्नलमा विगत 5 वर्ष 2015 देखि 19 सम्ममा सबभन्दा धेरै आर्टिकल प्रकाशित गर्नेलाई एवार्ड प्रदान गरिनेछ। एवार्ड छनौट गर्दा आर्टिकल्समा धेरै अङ्क प्राप्त गर्ने अनुसन्धानकर्तालाई प्रदान गरिनेछ र प्रत्येक आर्टिकलको अङ्कभार आर्टिकलको प्रकार अनुसार कायम गरिनेछ भनेर एउटा क्राइटेरिया बनेको थियो, त्यो अनुसार भएको छ। त्यस्तै गरी मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ साइन्टिस्ट रिसर्च एवार्ड मेडिकल डाक्टरको लागि पबमेडमा इन्डेक्स भएको जर्नलमा विगत 5 वर्षदेखि 15 देखि 19 सम्ममा सबभन्दा बढी आर्टिकल प्रकाशित गर्ने 40 वर्ष मुनिका चिकित्सकलाई यो एवार्ड प्रदान गरिनेछ। एवार्ड छनौट गर्दा आर्टिकल्समा धेरै अङ्क प्राप्त गर्ने अनुसन्धानकर्तालाई प्रदान गरिनेछ र प्रत्येक आर्टिकलको अङ्कभार आर्टिकलको प्रकार अनुसार कायम गरिनेछ भनेर यो क्राइटेरिया बनेको थियो। त्यस्तै गरी मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्च एवार्डको लागि पबमेडमा इन्डेक्स भएको जर्नलमा विगत 5 वर्ष 2015 देखि 19मा सबभन्दा धेरै आर्टिकल प्रकाशित गर्ने NHRCमा कार्यरत कर्मचारीलाई एवार्ड प्रदान गरिनेछ। एवार्ड छनौट गर्दा आर्टिकल्समा धेरै अङ्क प्राप्त गर्ने अनुसन्धानकर्ता कर्मचारी मध्येका पनि अनुसन्धानकर्तालाई प्रदान गरिनेछ र प्रत्येक आर्टिकलको अङ्कबार आर्टिकलको प्रकाश अनुसार कायम गरिनेछ। हेल्थ रिसर्च लाइफ टाइम एचिभमेन्ट एवार्डको लागि आजीवनभर सबैभन्दा धेरै रिसर्च आर्टिकल प्रकाशित गर्ने 60 वर्ष उमेर पुगेको अनुसन्धानकर्तालाई यो एवार्ड प्रदान गरिनेछ। त्यस्तै गरी अघि मैले भने बेस्ट पेपर प्रेजेन्ट एवार्ड ओरलको लागि उत्कृष्ट प्रस्तुतकर्तालाई सम्मेलनकै समयमा मूल्याङ्कन गरी एवार्ड प्रदान गरिनेछ। त्यस्तै गरी बेस्ट पेपर प्रेजेन्ट एवार्ड पोस्टरको लागि उत्कृष्ट प्रस्तुतकर्तालाई सम्मेलनकै समय मूल्याङ्कन गरी एवार्ड प्रदान गर्ने हाम्रो कार्यक्रम रहेको छ। र त्यस्तै गरी NHRC एक्जिक्युटिभ एवार्ड चाहिँ को लागि अब यो अलिकति मैले मोर साइन्टिफिक बनाउने कोसिस गरेको छु। त्यसको लागि हाम्रो उपाध्यक्ष डाक्टर भोजराज अधिकारीज्यूलाई संयोजक कि प्रोफेसर डाक्टर योगेन्द्र प्रसाद सिंह र म आफै सदस्य सचिव रहेर एउटा हामीले कमिटी गठन गऱ्यौँ र त्यो कमिटीले सर्टेन क्राइटेरियाहरू अब हामीले सकेसम्म मोर साइन्टिफिक बनाउने कोसिस गरेका छौँ र मेरो लागि सम्पूर्ण स्टाफ साथीहरू मित्रहरू अत्यन्त काम गरिरहनु भएको छ। एउटा मात्रै प्रदान गर्नुपर्ने हुँदा हामीले एउटा मोरभन्दा मोर साइन्टिफिक बनाउने कोसिस गरेका छौँ र यसमा चाहिँ सर्टेन क्राइटेरिया राखेको थियो। यहाँ भन्न चाहन्छु सेल्फ इभ्यालुएसन उहाँहरूलाई हामीले आफ्नो इभ्यालुएसन आफै गरौँ, तपाईँहरूले किन चाहिँ यसको लागि दावा गर्नुहुन्छ भनेर हामीले एउटा क्राइटेरिया बनाएको थियौँ। त्यस्तै गरी एक्जिक्युटिभको तर्फबाट एकदम थोरैभन्दा थोरै नम्बर राखेर पर्सनली पनि मैले 4-5 जना जति चिने साथीहरूलाई त्यो एउटा मूल्याङ्कन राखेको थियो। एटेन्डेन्स उहाँहरूको अहिलेसम्मको हाजिरीको अवस्था कस्तो छ वर्षभरिको त्यो खालको हेरिएको थियो। स्टाफको तर्फबाट एकले अर्कालाई कम्तीमा 3 जनालाई तपाईँलाई चाहिँ लाग्ने अत्यन्त उत्कृष्ट लाग्ने साथीहरूलाई 5 जनाको 5वटा रिजनसहित दिनुहोस् भनिएको थियो र त्यसलाई हामीले हेरेका थियौँ। त्यस्तै गरी सुपरभाइजर इभ्यालुएसन आफ्नो अन्तर्गतका मुनिका स्टाफहरूको उहाँहरूले इभ्यालुएसन गरी एचओडीहरूले नम्बर दिनुभएको थियो र अर्को सिनियरिटीको हिसाबले हामीले पनि महत्त्व दिएका थियौँ र त्यस्तै गरी यसलाई टोटलमा 100 मानेर यसको चाहिँ निष्कर्ष निस्केको छ। र यति भन्दै यी सम्पूर्ण एवार्ड प्राप्त गर्नलाई हामीले कुनै पनि हिसाबको बास गरेका छैनौँ जस्तो लाग्छ। त्यस्तो भएको छ भने पनि यहाँहरूबाट हामी सुझावको अपेक्षा गर्दछौँ। र यति भन्दै सम्पूर्ण एवार्डेड वैज्ञानिकहरू कर्मचारी साथीहरू लगायतलाई NHRC पुनः अग्रिम शुभकामना दिन चाहन्छ। यति भन्दै यो हाम्रो कार्यक्रम अत्यन्त उत्साह साथ सुन्नुभएकोमा हामीलाई लागेको छ यस्तो खालको हिसाब लाग्छ जाएको थिएन। धेरै साथीहरूले बाहिरबाट लाइभमा सुनिरहनु भएको छ, धेरै चाहिँ राम्रा कमेन्ट आएका पनि छन्। केही टेक्निकली हामी नयाँ भएको हुनाले थोरै समस्या भएका हुन सक्छन् र जुन जति हाम्रा समस्या भएका छन् र पुनः अर्कोचोटि हामी सुधार्ने बाचासहित यहाँहरूले सुनिदिनु भएकोमा हामीलाई सहयोग गर्नुभएकोमा सम्पूर्ण सहयोग र पत्रकार मित्र साथीहरू सम्पूर्ण जसलाई हामीले चाहिँ हाम्रो चाहिँ यसलाई महत्त्व दिएर राखिरहनु भएको छ लाई पुनः धन्यवाद दिँदै म मेरो मन्तव्य यही टुङ्ग्याउँछु। धन्यवाद।
धन्यवाद डाक्टर गेवाली। अवार्ड कसरी सिलेक्सन भयो, के क्राइटेरिया थिए र कसरी हामी अगाडि बढ्यौँ भन्ने सन्दर्भमा प्रकाश पारिदिनु भएकोमा हामी सबैलाई आँखा देखाइदिने मान्छे अगाडि हुनुहुन्छ, हामी उहाँको कुरा सुन्छौँ। तर त्योभन्दा पहिलो यो संस्थाको जन्मदाता र NHRC को इमिरेटस चेयरपर्सन प्रोफेसर डाक्टर मृगेन्द्र राज पाण्डे सर जो अहिलेसम्म पनि अनवरत रूपमा अनुसन्धानमा आफूलाई दिउँसो राति बिहान बेलुका नेपालमा बाहिर हुम्ला जुम्ला काठमाडौँको माइती घरमा जहाँ भए पनि अनवरत रूपमा सक्रिय कटिबद्ध हुनुहुन्छ र म सरलाई आई रिक्वेस्ट यू सर टु have your few words of blessings to NHRC on this August gathering. Please, sir. सरले अनम्युट गर्नु पर्ला, अलि सुनिएन सर। माइक अनम्युट गरिदिनु पर्ला सरलाई। भएन, यताबाट हेर्नु।
Well, in the last decade, I have been watching the whole with great interest, and really, I'm very happy also, because in this difficult time, socially, economically, as well as, well, from the safety point of view also, such a wonderful research work have been done by our young colleagues and their institutions in the last few years, in the last 2 years. So wonderful, you know. I mean, because in Nepal now at this point, because of this, well, you know, everything, this is the main problem is occurring at that time also. I was very surprised and pleasantly surprised that so many wonderful works in the health research field has been done under the auspices of the Nepal Health Research Council. That has given me the greatest satisfaction. I watched everything for the last 2 days and I did not speak much at all because I wanted to listen. Because that should be the thing for the whole country also. I know now at the moment the country also is in great trouble and all this sort of thing. So let us get the spirit of the Nepal Health Research Council and the Nepal researchers to follow it. Well, there may be some grievances, but on the whole, what we have done is really remarkable, and this has got to be replicated in other places in the country as well. Thank you very much indeed.
Thank you. Thank you very much, sir, for your blessings and your advice and continued support. Why I placed sir before Dr. Sanduk Ruit, who is going to give Mrigendra Samjana Medical Trust oration today, and many of us are very much aware about Dr. Ruit, who has opened eyes for many of the Nepalese and others in the Asia, Pacific, and even Africa. An eminent personality who is more known than the institute where he belongs to, Telanganga Institute of Ophthalmology. A personality who is known to have won Magsaysay Award, which is considered as a Nobel Prize of the Asia and Pacific. And very recently, Dr. Ruit is also awarded with Padam Shri of India, which is one of the highest award given to an eminent personality. Dr. Ruit, I now welcome you, sir, to open other scientists' eye in the field of knowledge, although you have opened various people's eyes to see the world. Thank you, Dr. Ruit, please.
NHRC को पदाधिकारी हो डॉक्टर झा अनि डॉक्टर गेवाली सबैलाई मेरो नमस्कार र म यहाँ हाम्रो चिकित्सा क्षेत्रको लिजेन्डरी फिगर डॉक्टर मृगेन्द्र राजको उहाँको ट्रस्टमा बारे ओरेसन दिनु पाउँदाखेरि मलाई धन्यवाद दिनु मन लागेछ र I will try to be short. And I will run you down on the last few decades of eye care in Nepal. If you look at the eye care in Nepal, I would like to divide the eye care in Nepal into 5 decades. The first decade was 1980 and 1990. And one of the most important things that we did under the leadership of some of our very visionary seniors like Dr. Ramprasad Pokhrel was doing a nationwide survey of prevention of blindness. This survey was very important and one of the most important researches done in Nepal. Interdisciplinary, multi-purpose, done to represent a population of 15 million at that time in 1980-81. And the objective was to find the cause and the distribution of blindness in Nepal. And after the survey, we started focusing on infrastructure development in the country for eye care, and of course, into human resources. The next phase of 1991 to 2000 was, again, continuing to develop infrastructure, human resources, quality service, and of course, technology. Then 2001 to 2010, we continued to focus on human resources, service coverage in the country, and sustainability, very important. I'll come back to that again, technology and infrastructure. And 2011 to 2020, a lot of focus was given on subspecialty training, subspecialty services, retina, cornea, glaucoma, plastics, etc. And then research and documentation. And ophthalmology still works very closely with NHRC to do some landmark ophthalmic researches, not only in Nepal, but in the global impact. And monitoring and evaluation, sustainability, and quality assurance. Now, 2020 and 2030, some of my own personal thoughts on we need to develop comprehensive eye care. We have addressed on important causes of blindness like cataract, but we need to address on some of the emerging causes of blindness caused by diabetic retinopathy, glaucoma, and refractive error. Yeah. And then services need to be equitable in the country. And again, with the situation that we are going right now, we need to discuss a lot and do a lot on sustainability and high quality, of course. And then human resource training continues to, and of course, I think after the COVID, we have realized that a lot of emphasis needs to be given on digitalization. We need to make telemedicine very professional and very safe to use, very user-friendly. I'm sure there's a way out. And then, of course, medical insurance. I think that the concept of the medical insurance is already driving very fast, but we need to, I think, let it move forward very quickly. The blindness survey gave us a prevalence of 0.84 in 1980-81. And some of the important cause of blindness was cataract, trachoma, xerophthalmia, and corneal infection at that time. So we needed to have programs related to those. And I will try to focus on cataract blindness, which was the most important cause of blindness. And the barriers to cause, the barriers for giving quality cataract surgery at that time was the cost of high quality intraocular lenses, adaptation of good quality surgical techniques, and cost and complexity of the equipments. And our mission at that time was to make sure that we can do sufficient in terms of numbers, successful in terms of quality, and sustainable in terms of how we can sustain it. Modern cataract surgery in the community. And this is the phase of development. We started working on early microscopes, started fine-tuning the system for quite a number of years, working in difficult parts of Nepal, and adaptation of good quality surgical techniques. It took us nearly 5 years to simplify, adapt it, and test it. And once it was fine-tuned and perfected, we started making it as a training globally and started getting very popular. So we developed standard operating manuals and with international organizations like the Fred Hollows Foundation and the Himalayan Cataract Project. And then we looked at some of the important ingredients, for example, consumables, the intraocular lens, which was very high at that time, if we could make it locally in Nepal. And just to start manufacturing at that time was unthinkable. It was very difficult. We had to face a lot of challenges, but we were able to manufacture lenses for less than $4, which normally used to cost us about more than $100. And that really allowed us to take the quality of surgery to a large target population. And then the surgical technique, the concept of the small incision cataract surgery, and we fine-tuned, we perfected, but we needed to explain it to the international community by doing randomized clinical trial. So a randomized clinical trial was conducted in Nepal, which is still quoted in many parts of the world. And the surgery was done both by the most modern phacosurgeon and the small incision cataract surgery, and the patients were followed up for 1 year, and we found that the results were comparable. But the cost of the surgery was about 20 times more in phacoemulsification and 20 times less in SICS. And that really was one of the trigger to increase the volume of cataract surgery in many parts of the developing world, where people needed to understand the efficacy of the small incision cataract surgery. And you can see that even after 1 year, the results in the two techniques were comparable. Thus, modification of this, cataract surgery, was simple, low cost, and the outcomes were very good. And then we converted that into more like a surgical program, not only in Nepal, but the Nepalese programs were taken out in many parts of the world. And if you see, look at the cataract surgical rate. Cataract surgical rate is number of cataract surgery done per year per million population. If you look at in 1995, it was just about a little more than 500. But now it is more than 4,000, close to 5,000. So we're doing very well, and this is a very good figure in comparing with others in South Asia. And the components of patients receiving intraocular lenses, we had achieved more or less optimum levels in 2002 and 2004. When our neighboring, big countries, the intraocular lens proportion was hanging around 70%, we were here doing about 80, 90%. And the prevalence of blindness, like I said, in the survey showed that it was 0.84. But in 2011, the prevalence of blindness had come down to 0.35%, almost half the prevalence of blindness in Nepal. The surgical training facilities and the systems became very popular, and many countries in the world have adapted it. And we have had people coming from almost close to 50 countries. And if you look at the infrastructure in Nepal, Nepal now has, I would take this with great pride to say that it has covered all the 77 districts with eye care. And there are 29 eye hospitals and 20 eye departments and community eye centers in 105 places, and at least one in each district. If you look at the manpower, our composition of support staff, paramedical staff in ophthalmology is excellent. The optometrists right now are about 850, and ophthalmic assistants are about 1,250. And looking at the number of ophthalmologists is about 364. But the ratio of our main support staffs who are doing a lot of work very efficiently in many parts of the country, and these ophthalmic assistants and optometrists are extremely good. Now, before I finish, I just like to mention a few things about what COVID has done to our eye care. COVID-19 has forced us to look into eye care with a different paradigm shift. And the volume of patients we see has reduced tremendously. And some organizations like ours, depending on sustainability, the cost is very high now. and field activities have tremendously reduced or even stopped in some places. And there is, as you know, there is a disruption in the supply chain, and limited globalization, social distancing, and other COVID issues have made us look into eye care from a different focus. And we need to redefine our protocols. We are looking for models. What models can we come out with where we can do services at this time? And there's a model that we're trying to establish as a community eye hospital. And this is a small, achievable, autonomous, sustainable eye hospital, costing about $2.5 to $3 million. And it is a model which can develop very high quality service at the community, and it's scalable, and 3 to 4 floors of building. The most important thing is quality of cataract surgery and quality of eye care, medical retina, glaucoma, diabetic retinopathy, periodical subspecialty facility, and training facility, community screening, smart refractive error programs, including optical dispensing. And this is something that I like to share with a lot of you. And when we look at, I think we have to go into a concept of sustainability. Now, sustainability will become a big topic to discuss in the future. And quality, how we can develop sustainable, high quality services. It's very important to have governance. How can the Nepal government assure good governance in this hospital? This is a very important thing. Health personnel is very important. Autonomy of the health personnel, I think it's very important. Health financing, medicine and technology, and information. And thank you very much for listening to me. And I would like to say, all of you stay safe, raम्रोसँग बस्नुहोस्, and I hope we can get back to our patients as soon as possible. Thank you very much.
Thank you very much, Dr. Rohit. एकजना यस्तो मान्छे जसले लाखौं व्यक्तिको आँखाको ज्योति बढाइदिनु भएको छ। नेपालमा मात्र होइन, विदेशमा पनि। हामी कहाँबाट धेरै मान्छे विदेशमा जान्छन्, तर उहाँले यस्तो बनाइदिनु भयो कि यहाँ प्रोडक्सन भएको आँखाको इन्ट्राअकुलर लेन्स विदेशमा गएर धेरै मान्छेले आफ्नो आँखा प्राप्त गरेका छन्। र उहाँ यस्तो व्यक्तित्व जसले नेपालमा WHO कोलाबोरेटिङ सेन्टर ल्याउन सफल हुनुभएको छ। र धेरै मान्छेले धेरै किसिमले उहाँलाई चिन्ने गरेका छन्। सबभन्दा सस्तो मोडेलमा आँखाको उपचार गर्ने मोडेल लिएर आउनु भएको छ। डाक्टर साहबलाई धेरै धेरै बधाई। त्यही भएर पनि यो मृगेन्द्र सम्झना चिकित्सा गुठीको ओरेसन अवार्ड प्राप्त गर्ने अवसर पाउनु भएको छ। हाम्रो यो अवार्ड मागेसासे र पद्मश्री जस्तै हामीले ठुलै मानेका छौँ नेपालको हेल्थ रिसर्चको अवस्थालाई हेर्दाखेरि। र यो अवार्ड दिइदिनु हुन आजका चिफ गेस्ट डाक्टर रोशन पोखरेलज्यूलाई म अनुरोध गर्दछु। डाक्टर रोहितलाई यो अवार्ड ग्रहण गरिदिनु हुन अनुरोध गर्दछु। So let's give him a big hand. यहीँ राखौँ अब म्याडम बसौँ। अब अवार्ड पाउने जतिलाई पनि राख्दै जाउँ। ओके, धन्यवाद। धन्यवाद डाक्टर पोखरेल, डाक्टर रोहित, डाक्टर झा, डाक्टर गेवाली, डाक्टर दीक्षित र सम्पूर्ण टिमलाई। नेपालको छोरो जसले संसारलाई आँखा देखाइदिनु भएको छ, उहाँलाई आज NHRC को एउटा अवार्डले हामी स्वागत गर्न पाउँदा हामी सबै गौरवान्वित छौँ। र यसै सन्दर्भमा उहाँले त धेरै संसारलाई धेरै कुरा देखाउनु भयो। त्यस्तै दोस्रो अवार्ड चाहिँ एउटा यङ साइन्टिस्ट जसले मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्च अवार्ड प्राप्त गर्ने मौका पाउनु भएको छ। एउटा यस्तो मेडिकल डाक्टर जो 40 वर्षभन्दा मुनि धेरै कन्ट्रिब्युसन गर्न सक्नु भएको मेडिकल डाक्टर जसलाई यो अवार्ड प्राप्त गर्ने सुअवसर प्राप्त भएको छ। उहाँ हुनुहुन्छ डाक्टर विशाल गेवाली। उहाँ चाहिँ ही इज असिस्टेन्ट प्रोफेसर इन द डिपार्टमेन्ट अफ पब्लिक हेल्थ साइन्सेस and a scientist division of cancer care and epidemiology, clinical fellow department of medical oncology and member health policy council, School of Policy Studies at Queen's University, Kingston, Canada, and affiliated faculty program on regulation, therapeutics and law, Brigham and Women's Hospital, Harvard Medical School, Boston, USA. Dr. Gewali को तर्फबाट अब डाक्टर गेवाली अहिले मलाई लाग्छ यो बन्दको अवसरमा उतैबाट भर्चुअली उपलब्ध हुनुहुन्छ र डाक्टर गेवाली यो अवार्ड पाउँदाखेरि तपाईलाई कस्तो लागेको छ तपाईले भर्चुअली भनिदिनु भयो र तपाईको तर्फबाट यहाँ तपाईको कोही रिप्रेजेन्टेटिभले लिइदिनु भयो भने हामी खुसी हुने थियौं। डाक्टर गेवाली, ओभर टु यु फर 2 minutes. Dr. Gewali, sound, right?
Can you hear me?
Yes, please go ahead.
Okay. Thank you very much. I'm extremely thankful to the organizers and the selection committee, as well as Dr. Mrigendra, in whose name I'm going to receive this award. It's a matter of huge pleasure for me. And I have been, my research focus has been on global oncology, which means cancer care in low and middle income countries like Nepal. And I have been trying to do my best through research to improve cancer research and cancer care in countries like Nepal. Although I have worked for cancer education in other parts of the world, I haven't had much opportunity to contribute back to my own country. But I'm very happy that to receive this recognition, and this will give me more inspiration to continue to work in this field. And I hope we can collaborate with NHRC and try to bring some research projects forward. I have also recently received a grant for supporting oncology education in Nepal from American Society of Clinical Oncology, and have been appointed as a member for the WHO Essential Medicine List, which will be important for Nepal and other countries like Nepal. So I'm very much looking forward to contribute more for my country, and this award means a whole lot to me. It provides me such a big inspiration, and I'm extremely thankful. I cannot express how thankful I am in words. And I'm especially thankful because my parents are there to receive the award, and as a son, I can't expect anything more than to see my parents accepting the award on my behalf. So I do not want to take much of your time. I would like to express my huge thanks, and I would like to request my parents, I have my mom and my dad there to accept the award on my behalf. And I very much look forward to contributing more and to follow the footsteps shown by Dr. Rohit. Thank you.
Thank you. Thank you, Dr. Gewali. अब हामी डाक्टर गेवालीको बुवा र आमा दुईटैलाई उहाँको तर्फबाट अवार्ड र प्रमाणपत्र ग्रहण गर्न अनुरोध गर्दछु। चीफ गेस्टले आमालाई प्रमाणपत्र दिनुहुनेछ भने चेयरम्यानले बुवालाई अवार्डको मेडल दिनुहुनेछ। गेवाली र उहाँका बुवा आमालाई जसले यो अवार्ड पाउने छोरो पाउन सक्नुभयो। धन्यवाद।
Thank you very much, everyone.
Thank you, Dr. Gewali. अब तेस्रो मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्चर अवार्ड। यो अवार्ड चाहिँ नेपाल स्वास्थ्य अनुसन्धान परिषदमा काम गर्ने यङ हेल्थ रिसर्चरले पाउने, अघि डाक्टर गेवालीले प्रश्न पारिसक्नु भएको छ। यो अवार्ड पाउने सौभाग्य पाउनु भएको छ मिस्टर अशोक पाण्डे, रिसर्च अफिसर। बधाई छ अशोकजी। र यो अवार्ड प्रमाणपत्र दिनलाई म प्रमुख अतिथिलाई अनुरोध गर्दछु र मेडल दिनलाई मेम्बर सेक्रेटरीलाई अनुरोध गर्दछु। धन्यवाद। यसपालि नयाँ अवार्डहरू थपिने क्रम जारी छ र आउने दिनमा म आशा गर्छु अरूहरूले पनि यत्तिकै अवार्ड थप्ने र साइन्टिस्टहरूलाई इन्करेज गर्नुहोला भन्ने आशा राख्दै चौथोतिर जाँदाखेरि चौथो दुर्गादेवी गेवाली स्पोन्सर्ड जर्नल अफ नेपाल हेल्थ रिसर्च काउन्सिल बेस्ट पेपर अवार्ड। यो अवार्ड स्पोन्सर गर्नुभएको छ दुर्गादेवी गेवाली र श्रीमान भुवनेश्वर गेवालीले। यो अवार्डको लागि म डाक्टर प्रदीप गेवाली तथा परिवारमा कृतज्ञता ज्ञापन गर्दछु र यो अवार्ड को प्रमाणपत्र प्रमुख अतिथि र मेडल एक्जिक्युटिभ मेम्बर डाक्टर प्राध्यापक डाक्टर मधु दीक्षित देवकोटालाई दिन अनुरोध गर्दछु। डाक्टर यो अवार्ड प्राप्त गर्ने सौभाग्य र यो जर्नलमा पब्लिस आर्टिकलको टाइटल छ मेनोपज रेटिङ स्केल भ्यालिडेसन एन्ड एप्लिकेबिलिटी इन नेप्लिज वुमन। यो मैले तपाईहरुले बुझिसक्नु भयो होला किन मैले मधु म्याडमलाई भने। यो रिप्रोडक्टिभ हेल्थको रिलेटेड अवार्ड भएको हुनाले मैले म्याडमलाई दुःख दिने कोसिस गरेँ। यो अवार्ड प्राप्त गर्ने सौभाग्य पाउनु भएको छ डाक्टर ज्ञानाथ बरालले, who is a professor of obstetrics and gynecology at Kathmandu University, Nepal. डाक्टर बराललाई बधाई। म यहाँ डाक्टर बराललाई देखिरहेको छैन, मलाई लाग्छ उहाँ जुममा उपलब्ध हुनुहुन्छ। हामी भर्चुअली उहाँलाई यो अवार्ड प्रदान गरिदिन हुन म्याडमलाई अनुरोध गर्दछौँ। उहाँको तर्फबाट कसैले लिनुभन्दा पहिला डाक्टर बराललाई म 1 देखि 2 मिनेट डाक्टर बराल यो अवार्ड पाइराख्दा तपाईलाई कस्तो लागेको छ, मलाई लाग्छ तपाई बहुत खुसी हुनुहुन्छ र खुसीका 2 शब्द प्रकट गरिदिनु हुन अनुरोध गर्दछु।
I need to thank Nepal Health Research Council, the scientific committee of its summit, selection committee and reviewers for selecting me and recognizing my publication as a scientific product, and it has carried countries in fact had validated such NHRC scale, so it was very good for us, and we have to do in such research so that we can make our own reference. We don't have to depend on others. Thank you very much for recognizing me.
धन्यवाद डाक्टर बराल। र यो जसको नाउँमा यो अवार्ड स्थापना गरिएको छ हामीलाई खुसी के लागेको छ भने स्पोन्सर्ड जसले यो स्पोन्सर गर्नुभएको छ उहाँ स्पोन्सर पनि यही हामी बीचमा हुनुहुन्छ। हिँड्न सक्नुहुन्छ भने उहाँलाई एकचोटि हामी अगाडि आउन अनुरोध गर्दछौँ। क्यामेरा त्यहीँ देखाइदिए हुन्छ ल ल आमाले त्यहीँबाट नमस्ते गरिदिनु होला डाक्टर बराललाई हामी
नमस्कार
ठिक छ
मैले नमस्ते गरेँ
जता दुवैतिर छ
हजुर नमस्कार हजुरलाई धेरै धेरै धन्यवाद
ल डाक्टर बरालको तर्फबाट कसैले लिइदिनुहोस् पछि उहाँलाई भर्चुअली पठाइदिन सकिन्छ हैन रियली कोही एकजना स्टाफले लिइदिनुहोस् न प्लिज ल ठिक छ थ्याङ्क यू अब यही क्रममा मलाई त लाग्छ म 2 घण्टासम्म यहाँ बसेर अवार्ड अनाउन्स गर्दै जाउँ जसको कारणले स्वास्थ्य वैज्ञानिकहरू देशमा बढ्दै जाउन् रोग कम हुँदै जाओस् तर अब 5औँमा हेल्थ रिसर्च अवार्ड प्राप्त गर्ने मौका पाउनु भएको छ डाक्टर सुनिल मुनाकोमी एसोसिएट प्रोफेसर डिपार्टमेन्ट अफ न्यूरोसर्जरी कलेज अफ मेडिकल साइन्सेस काठमाडौँ युनिभर्सिटी नेपाल यो अवार्ड सर्टिफिकेट र मेडल प्रदान गरिदिनु हुन म डाक्टर मुनाकोमी हुनुहुन्छ ओके उहाँको अवार्ड हेल्थ रिसर्च काउन्सिलमा सुरक्षित रहनेछ उहाँ आएर कलेक्ट गर्न सक्नुहुनेछ लकडाउन खुलेपछि अब नेक्स्ट बेस्ट पेपर प्रेजेन्टेसन अवार्ड फर ओरल प्रेजेन्टेसन मिस्टर प्रतीक खनाल on factors associated with mental health problems among health workers in Nepal during early phase of COVID-19 pandemic, a cross-sectional study. यो अवार्ड प्रदान गरिदिनु हुन आजको चीफ गेस्ट लाई म अनुरोध गर्दछु र अवार्ड माला लगाइदिनु हुन म चेयरपर्सनलाई अनुरोध गर्दछु माला चाहिँ सर्टिफिकेट बधाई छ प्रतीकजी यस्तै गर्दै जानु होला र आगामी दिनमा ठुलठुलो अवार्ड जित्नु होला भन्ने मेरो शुभकामना र हामी सबैको शुभकामना यसै सन्दर्भमा अब पोस्टर थ्यांक यू बेस्ट पेपर प्रेजेन्टेसन अवार्ड अन पोस्टर पोस्टर प्रेजेन्टेसन को टाइटल थियो न्यूट्रिशन स्टेटस एंड इट्स एसोसिएटेड फैक्टर्स अमंग orphan children residing in Nepal's children's home of Pokhara Metropolitan. Award goes to Shiksha Adhikari. I believe these best paper presentation on poster are e-copies and the award is secured at NHRC. She can come at any time and collect her award. Next, Best Performer Award. Best Performer Award यो नेपाल हेल्थ रिसर्च काउन्सिलमा कार्य गरिराख्नु भएका स्टाफहरूलाई दिइने अवार्ड हो यसमा प्राप्त गर्ने मौका पाउनु भएको व्यक्ति 2053 सालदेखि परिषदको आर्थिक प्रशासन शाखामा कार्यरत हुनुहुन्छ र तपाई हामी मध्ये धेरै जनाले उहाँको हातबाट कहिलेकाहीँ मिटिङमा मिटिङ भत्ता पाउने गरेका छौं र नाम छ उहाँको पुकालाल घिसिङ उहाँ एसिस्टेन्ट अकाउन्ट अफिसर नेपाल हेल्थ रिसर्च काउन्सिल पुकालाल जी बधाई छ तपाईलाई र अवार्ड दिनलाई म चीफ गेस्टलाई अवार्डको सर्टिफिकेट चीफ गेस्टलाई र मेडल दिनलाई म अध्यक्षज्यूलाई अनुरोध गर्दछु मेडल डाक्टर Okay, our much awaited award is an award which requires waiting for a long duration. 60 वर्ष पार गरिसकेको स्वास्थ्य वैज्ञानिकले प्राप्त गर्ने लाइफ टाइम अचिभमेन्ट अवार्ड, यो अवार्डको बारेमा घोषणा गर्दा मेरो खुट्टा कामेको छ, किनभने जसले मलाई सानैदेखि यो विषयको बारेमा सिकाउनुहुन्थ्यो उहाँलाई यो अवार्ड घोषणा गर्न गइरहेको छु। त्योभन्दा पहिला उहाँको नाम भन्नुभन्दा पहिला उहाँ यस्तो व्यक्तित्व हुनुहुन्छ जुन त्रिभुवन विश्वविद्यालयको इन्स्टिट्युट अफ मेडिसिनमा लगभग 40 वर्ष ट्रपिकल र इन्फेक्सस डिजिजमा रिसर्च गर्नुभएको छ। रोटा भाइरसको सर्भिलेन्स लेबोरेटरी इस्टाब्लिस गर्नुभएको छ। त्रिभुवन विश्वविद्यालय शिक्षण अस्पतालमा रिसर्च लेबोरेटरी, पब्लिक हेल्थ रिसर्च लेबोरेटरी इस्टाब्लिसमेन्ट गर्नुभएको छ र नेपाल हेल्थ रिसर्च काउन्सिलमा योभन्दा पहिला केही वर्ष पहिला इथिकल रिभ्यू कमिटीको कोअर्डिनेटर शुद्ध भइसक्नु भएको छ र उहाँका कन्ट्रिब्युसनमा सयौं विद्यार्थीले ब्याचलर्स, मास्टर्स र केही विद्यार्थीले पिएचडी गरिसकेका छन्, केहीले एमडी गरिसकेका छन् र उहाँले बेलायतको लिभरपुल स्कुल अफ ट्रपिकल मेडिसिनबाट पिएचडी गर्नुभएको छ र अमेरिकाबाट पोस्ट डक्टरल डिग्री गर्नुभएको छ र उहाँ रिटायर हुनुभन्दा पहिला माइक्रोबायोलोजी विभागको प्राध्यापक तथा विभागीय प्रमुख हुनुहुन्थ्यो। त्रिभुवन विश्वविद्यालय चिकित्सा शास्त्र अध्ययन संस्थान, इन्स्टिट्युट अफ मेडिसिन, महाराजगञ्ज मेडिकल क्याम्पसमा क्लिनिकल माइक्रोबायोलोजी डिपार्टमेन्टको प्रोफेसर रहे। उहाँको नाम छ प्राध्यापक डाक्टर जीवन बहादुर शेरचन। म सरलाई शुभकामना सहित अगाडि आएर अवार्ड ग्रहण गरिदिनु हुन अनुरोध गर्दछु। म यसै क्रममा यो अवार्डको सर्टिफिकेट प्रदान गरिदिनु हुन म चिफ गेस्ट डाक्टर रोशन पोखरेललाई अनुरोध गर्दछु। र अवार्डको मेडल प्रदान गरिदिनु हुन म डाक्टर प्रदीप गेवाली मेम्बर सेक्रेटरीलाई अनुरोध गर्दछु। यो सबै गरिसकेपछि म फेरि जीवन सरलाई दुःख के दिँदैछु भने यो अवार्ड प्राप्त गर्दा, लाइफ टाइम अवार्ड प्राप्त गर्दा सरलाई कस्तो अनुभव भएको छ र अब आउने दिनमा स्वास्थ्य वैज्ञानिकहरूले कसरी विकास गर्न सक्नेछन्, स्वास्थ्य अनुसन्धान परिषदले स्वास्थ्य वैज्ञानिकहरूलाई कसरी प्रमोट गर्न सक्नेछ भन्ने सरको छोटो मन्तव्य राखिदिनु हुन अनुरोध गर्दछु।
थ्याङ्क यू प्रोफेसर प्रकाश घिमिरे। आज मलाई एकदमै खुसी लागिरहेछ र यस अवार्ड कमिटीमा रहनुभएका हाम्रो अध्यक्षज्यू डाक्टर रोशन, त्यसपछि हाम्रो यो एनएचआरसीको चेयरम्यान प्रोफेसर अन्जन कुमार झाज्यू र हाम्रो एक्जिक्युटिभ चिफ अथवा मेम्बर सेक्रेटरी डाक्टर प्रदीप गेवाली तथा अन्य प्रोफेसर मधु घिमिरे अल्सो, र सबैलाई चाहिँ म एकदम हार्दिक नमस्कार गर्न चाहन्छु। र आज मलाई एकदमै खुसी किन लागेको छ भनेदेखि मैले विगत यो नेपाल हेल्थ रिसर्च काउन्सिल इस्टाब्लिस कालदेखि नै मैले काम गरेको थिएँ। जब प्रोफेसर मथुरा श्रेष्ठ यहाँ चेयरम्यान भएर आउनुभएको थियो त्यो बेलामा स्टाफ थिएन र म यहाँ एज ए इपिडेमियोलोजिस्टको रूपमा काम गर्नु भनेर काम गरेको थिएँ र त्यो बेलामा चाहिँ हामीले चाहिँ उहाँसँग सधैँ कोअर्डिनेसन गरेर यहाँ हामीले एउटा नेपाल हेल्थ रिसर्च काउन्सिलको जर्नल पनि निकाल्नु पर्यो भनेर हामीले पहिलो जर्नल खोजबिन मैले नै त्यसलाई चाहिँ काम गरेर खोजबिन भन्ने हामीले चाहिँ त्यो जर्नल प्रकाशित गऱ्यौँ। त्यो नेपाली नाम थियो, तर पछि चाहिँ त्यो खोजबिनको नामलाई फेरि इङ्ग्लिस नाममा संस्करण गरिकन त्यसलाई चाहिँ जर्नल नेपाल हेल्थ रिसर्च काउन्सिल गरियो। तर अब त्यो हाम्रो नेपाली नामको चाहिँ सधैँको लागि चाहिँ त्यसले चाहिँ बिदा लिनु पर्यो। त्यही पनि ठिक, त्यो पनि एउटा सुरुवात थियो, एकदम राम्रो हो। र आज यो रिसर्च गर्दाखेरि मेरो चाहिँ एचिभमेन्ट भनेको के छ भनेदेखि मैले नेपाल हेल्थ रिसर्च काउन्सिलबाट जति पनि रिसर्चहरू सिकेँ त्यो सिकेको कन्ट्रिब्युसनबाट मिनिस्ट्री अफ हेल्थ स्वास्थ्य मन्त्रालयलाई मैले 5वटा क्षेत्रमा चाहिँ मैले ठुलो कन्ट्रिब्युसन गरेको छु। त्यसमा मलाई गौरवान्वित हुन चाहन्छु। एउटा चाहिँ सबभन्दा पहिला मैले सुरु गरेको रिसर्च हो मलेरियामा र मैले गरेको रिसर्चको बेडनेट प्रोग्रामबाट गभर्मेन्ट अफ नेपाल हाम्रो मिनिस्ट्री स्वास्थ्य मन्त्रालयले चाहिँ बेडनेट प्रोग्राम सुरु गर्यो। त्यो मेरो रिसर्चको बेसमा थियो। र सेकेन्ड चाहिँ त्यसपछि मैले माइक्रोफिलारीमा मैले करिब चाहिँ 62वटा जिल्लामा घुमेर मैले रिसर्च अनुसन्धान गरेको अनुसन्धानको फाइन्डिङ्सको आधारमा चाहिँ यहाँ मास ड्रग एडमिनिस्ट्रेसन फर द लिम्फेटिक फ्लेयराइसिस त्यो पनि मेरै रिसर्चको आउटकममा जुन गरिएको यसमा मलाई ठुलो गौरव छ। र अर्को थर्ड भनेको चाहिँ न्युमोकोकल भ्याक्सिन जुन चाहिँ मैले सुरु गरेर पछि न्युमोकोकल भ्याक्सिन पनि आयो 2015मा र अहिले आएर अन्तिममा चाहिँ फेरि मेरो एउटा रिसर्च रोटा भाइरसको मैले विगत 10 वर्षदेखि 2009देखि मैले रोटा भाइरसको सर्भिलेन्स नेसनल सर्भिलेन्स गरेर म पिआईको रूपमा काम गरेको थिएँ। फर्चुनेटली यही बेला भर्खरै बिहिबार असारको 2 गते नै तपाईको जुलाईको 2 तारिकमा नि यो रोटा भाइरसको भ्याक्सिन इन्ट्रोडक्सन भएकोमा मलाई अति नै प्रसन्न अति नै खुसी लागिरहेको छ। यो मेरै रिसर्चको बेसमा चाहिँ यो हुनु भनेको नि मेरो लागि ठुलो एचिभमेन्ट हो। म यसलाई गौरवान्वित ठान्छु र यसरी म हाम्रो अब आउने पीडितहरूलाई चाहिँ तपाईले गरेको रिसर्च खालि पब्लिकेसन मात्र होइन कि त्यसले देशलाई पनि कन्ट्रिब्युसन गरेर देशमा कुनै न कुनै रूपबाट चाहिँ काम उपयोग हुने काम गर्नुहोस् भन्दै म छोटो मन्तव्य यहीँ व्यक्त गर्दै म यहीँ बिदा हुन चाहन्छु। नमस्कार छ।
धन्यवाद प्राध्यापक शेरचन सर। ओके, अब हामी अन्तिममा आइराखेका छौँ। तर अन्तिम भने पनि केही कुरा अन्तिममा अझ जरुरी छ। आजसम्मका यो प्रोग्रामहरूलाई सफल बनाउन यो एनएचआरसीले सुरुवात गरेको छ प्रशंसा पत्र दिने। यो कोभिड-19 महामारीमा समयको प्रवाह नगरी आफ्नो कार्यक्षेत्रमा अनवरत सेवा पुर्याउने श्री मानदोज तामाङलाई प्रोत्साहन स्वरूप नगद रु 15,000 सहित नेपाल स्वास्थ्य अनुसन्धान परिषदले धन्यवाद सहित प्रशंसा पत्र प्रदान गरेको छ। मानदोजी अहिले पनि कहीँ फिल्डमै खटिएको हुनुहुन्छ। मलाई प्राप्त जानकारी अनुसार मानदोजीलाई यो प्रशंसा पत्र र उहाँले पाउनुहुने यो नगद पुरस्कार परिषदमा सुरक्षित रहनेछ। मानदोजीलाई परिषदले प्रदान गर्नेछ। यो भनेर अन्तिम अवसरमा हामी आउनुभन्दा पहिला कुनै पनि समिटको डिक्लेरेसन अथवा घोषणा नभइकन समिट सकिँदैन। यसको डिक्लेरेसन 6 सूत्रीय डिक्लेरेसन, नेपालमा धेरै जसो 12 सूत्रीय हुन्छ, तर हामी अहिले यो बन्द बेलामा पनि गरेर 6 सूत्रीय निकाल्न सकेका छौँ। र यो 6 सूत्रीय डिक्लेरेसनको म पढेर सुनाउने आज्ञा चाहन्छु। Effective and efficient public health care delivery is the skeleton of health system of the nation to deliver quality health care services to the Nepalese citizen. Amidst several other challenges that a country's health system faces, COVID-19 pandemic that has adversely affected health and economy globally also has further impacted the Nepalese health system. Evidence-informed policy via health research in the local context is one of the strongest ways to support and maintain resilience of the country's health system. Interdisciplinary research could be a milestone to address emerging public health issues. Neglecting implementation challenges, cost lives and money are the crucial issues. In this context, we all delegates representing the Ministry of Health and Population, Nepal Health Research Council, professional councils, associations, academic institutions, bilateral and multilateral agencies, civil societies, non-governmental organizations, private sector, and individual scholars collectively commit to the following declarations. Number 1, advancing interdisciplinary and implementation research in health with the involvement of federal, provincial, and local government for contextually tailored evidence to inform policy. Number 2, continue to promote health research networking and alliances among academia, healthcare institutions, scholars, and researchers with different stakeholders in national and international level. Facilitate to enhance knowledge and skills to conduct health research by young researchers and scientists by increasing capacity, building opportunities, and availability of research grants, especially for the provinces. Strengthen the mechanism to promote maximum use of digital technologies in research process, including dissemination. Strengthen translation of locally generated evidence into policies and practice through closer collaboration with the policymakers. Promoting responsible conduct of health research in academic and non-academic research areas. Thank you. यो 6वटा डेक्लेरेसन का साथ आज को यस समिट अन्तिम अवस्थामा आइपुगेको छ र अन्तिममा जानुभन्दा पहिला आजका प्रमुख अतिथिलाई यतिका धेरै स्वास्थ्य वैज्ञानिकलाई अवार्ड दिँदा अब त स्वास्थ्य निकै अगाडि बढ्छ भन्ने पक्कै लागेको छ। हामी उहाँकै मुखारबिन्दबाट अब हामी कसरी जान्छौं र यो स्वास्थ्य अनुसन्धान परिषद र मन्त्रालय बीचको नङ मासुको सम्बन्ध कसरी अगाडि बढ्नेछ भन्ने ओपिनियन राख्दिन हुन अनुरोध गर्दछु।
धन्यवाद सर। यस कार्यक्रमको अध्यक्षज्यू, NHRC का पदाधिकारीहरू, सम्पूर्ण साथीहरू र सबभन्दा ठुलो कुरा त देशका वैज्ञानिकहरू, विदेशका वैज्ञानिकका बुवा आमाहरू। सबभन्दा ठुलो कुरा चाहिँ हामीले यो NHRC 1991 मा स्थापना भएदेखिबाट गर्दै आएको गतिविधि हेर्दै जाँदाखेरि धेरै नै परिवर्तन आएको चाहिँ देखिएको छ। त्यो परिवर्तनले हामी स्वास्थ्यमा काम गर्नलाई एउटा के आधार दिएको छ भने NHRC ले गरेको रिसर्चलाई नेशनल पोलिसीमा ढाल्न पाइयो भने केही न केही देशलाई फाइदा हुन्छ भन्ने कुरा पक्कै पनि प्रश्न देखिएको छ। अब त्यस अर्थमा अहिले हाम्रो प्रोफेसर सेर्चन यही हुनुहुन्छ। उहाँले गरेको रिसर्चको आधारमा हामीले 2 तारिक नै रोटा भाइरसलाई देशव्यापी रूपमा भ्याक्सिनेसनको रूपमा सञ्चालन गर्न सक्यौं। जुन हामीलाई गर्वको कुरा के छ भने उहाँको रिसर्चलाई हामीले नीति तथा कार्यक्रममा ल्याएर नेपाल सरकारले त्यसलाई अपनत्व गर्न सक्यो भन्ने हो। यही चाहिँ चीज NHRC ले दियोस् भन्ने नेपाल सरकारको चाहना हो, ताकि भोलिका दिनमा हामीले अन्यलाई फलो गर्नुभन्दा पनि देशकै साइन्टिस्टहरूले दिएको आधारलाई मानेर राष्ट्रिय नीतिहरू बनाउँदा पाउँदाखेरि हाम्रो जस्तो मुलुकलाई आर्थिक र प्रशासनिक र HR ह्युमन रिसोर्सेसको हिसाबले धेरै सजिलो हुन्छ भन्ने बुझेको छु। यस अर्थमा NHRC लाई धन्यवाद दिँदै यस मौकामा मलाई केही शब्द राख्ने मौका दिनुभयो र यो वेबिनार 2 दिनको वेबिनारमा जति पनि साथीहरूले जति पनि पार्टिसिपेन्ट र इन्भल्भमेन्ट देखियो त्यो चाहिँ हाम्रो लागि भोलिका दिनहरुमा अझै अगाडि बढ्ने हौसला प्रदान गरोस् भन्ने शुभकामना सहित धन्यवाद भन्दै मेरो 2 शब्द यही टुङ्गाउँछु। धन्यवाद, नमस्कार।
धन्यवाद पोखरेल डाक्टर। अब हामी करिबन अन्तिममा आइपुगेका छौं। लामो अनवरत विदेशमा बसेर रातभरि जुममा, फेसबुकमा प्रेजेन्टेसन र सुन्नुभएका, देख्नुभएका पार्टिसिपेन्टहरू स्वदेशमा जुममा, फेसबुकमा बसेर अथवा फिजिकल्ली यहाँ आएर प्रस्तुत गर्ने प्रस्तुतकर्ताहरू र भर्खरै प्राप्त जानकारी अनुसार करिब 80,000 व्यक्ति 80,000 पटक यो हाम्रो सिस्टममा लगइन भएको देख्न पाइएको छ। भनेपछि श्रोता, दर्शक र साइन्टिस्टहरूको कमी नेपालमा छैन। नेपालीलाई शुभचिन्तन चिताउने साइन्टिस्टको हेल्थ साइन्टिस्टको कमी छैन र यसो भनिराख्दाखेरि यो सबै सम्भव बनाउने अहिलेको भर्चुअल वर्ल्डमा बेला बेलामा आवाज ठुलो मेरो जस्तै अथवा रोशन डाक्टर साहबको जस्तो सानो सुनिए पनि हामी किनभने टाढा डिस्टेन्समा टाढा नजिक भएर सानो ठुलो सुन्न सकिन्छ। यो सबै सम्भव बनाउने आईटी टिमको टिम लिडर विकास भूषालका साथसाथै सम्पूर्ण आईटी क्यामेरा र सम्पूर्ण ठाउँका सहयोगी साथीहरू, यो सबै व्यवस्थापन गर्ने एनएचआरसी का तलदेखि माथिसम्म दायाँदेखि बायाँसम्म सबैका स्टाफ, विभिन्न क्षेत्रबाट कन्ट्रिब्युसन गर्ने साथीहरू सबैलाई धन्यवाद गर्दै म यो सभाको सुरुको सत्र सुरु गर्दा र अन्तिम सत्रमा अन्तिम गर्दाखेरि अब कसरी जान सकिन्छ होला, अब के गर्नुपर्छ होला भन्ने मार्गनिर्देशनका साथ सभा अन्त्य गरिदिनु हुन यस सभाका सभामुख तथा यस एनएचआरसी का चेयरपर्सन प्राध्यापक डाक्टर अञ्जनी कुमार झालाई अनुरोध गर्दछु। डाक्टर साहब प्लिज।
धन्यवाद डाक्टर प्रकाश, राम्रो बोल्नुभयो, मिठो बोल्नुभयो, अलि लामो बोल्नुभयो। आज यहाँ उपस्थित हाम्रो यस समापन कार्यक्रमका प्रमुख अतिथि, प्रमुख अभिभावक अतिथि भन्न अलि मिल्दो रहन्छ, हामी डाक्टर रोशन पोखरेलज्यू, अवार्ड पाउने डायसमा बस्नुभएका प्राध्यापक डाक्टर जीवन शेरचन्द लगायतका हाम्रा मित्रहरू, बोर्ड मेम्बर प्राध्यापक मधु देवकोटा दीक्षित मैडम, हाम्रो अनुसन्धान परिषदका सदस्य सचिव डाक्टर प्रदीप गेवालीज्यू, आज एवार्ड स्थापना भएका हाम्रो प्रदीप डाक्टर साहबका बुवामा आदरणीय बुवामाज्यू र एवार्ड पाउने हाम्रो आमा छोराको आमा, आज उहाँको लागि ठुलो गौरवको कुरो हो। कुनै पनि आमालाई आफ्नो छोराले अवार्ड पाउने त्यो सुख अर्कै सुख हुन्छ र यहाँ उपस्थित सबै व्यक्तित्वहरू र भर्चुअल मिटिङमा एकदमै बढी सङ्ख्यामा लगइन गर्ने नम्बर भन्न त मलाई पनि डरै लाग्यो, 80,000 हो कि होइन, तर सबैजनालाई यो समापन कार्यक्रममा म उपस्थित रहनु भएकोले आभार व्यक्त गर्न चाहन्छु। यो क्षण सबैको लागि महत्त्वपूर्ण हुन्छ, तर विशिष्ट गरेर कार्यकारी अधिकार लिएको व्यक्तिलाई बहुत महत्त्वपूर्ण हुन्छ। कुन बेला सिद्धिएला, प्रदीप डाक्टर साहबले त राहत पाउनु हुनेछ, न राति 12 बजा छ 7 बजा चाहिँ के गरेको पनि थाहा हुँदो रहन्छ। मेरो पनि 2-3 वटाको अनुभव चाहिँ छ। कतिजनाले यो भएन भन्छन्, कतिजनाले त्यो भने भन्छन्। अनुसन्धान परिषद हेर्दा सानो भित्र महाभारतै हुने ठाउँ, यस्तो बेलामा कार्यकारीलाई यो कुन बेलामा यो समिट सिद्धोस् भन्ने चाहना हुँदो रहेछ। फेरि अब अध्यक्षलाई र अध्यक्षता गरिरहेको व्यक्तिलाई छुट हुँदो रहेछ, लास्टमा बोल्ने, बोलेको कुरोले कसैले प्रतिवाद गर्न पनि नपाउने, अनि बोले पनि जति बोले पनि हुने। तर चिन्ता नगर्नु होला, म धेरै बोल्दिनँ। बोल्न मैले बोल्दिनँ र यो अनुसन्धान परिषदमा हिजो पनि मैले भनेको थिएँ, अब यो 6 वर्षको यो भयो, धेरैजनाले यो नेपालमा अनुसन्धानको कल्चर डेभलप भएको छ। पहिले अनुसन्धान भनेपछि यो ठुलो ठुलो विद्वान प्रोफेसर, धेरै डलर पाउने, धेरै बजेट हुने मान्छेले मात्र गर्ने जस्तो मलाई पनि लाग्थ्यो। तर वास्तवमा अनुसन्धान हाम्रो जीवनको प्रत्येक क्षणमा यसको उपयोगिता हुँदो रहेछ। एकाडेमिक साइडमा होस् या व्यावहारिक साइडमा होस्, हरेक क्षण हरेक एक्सपेरिमेन्टलाई अनुसन्धानको रूपमा परिवर्तन गर्नुपर्छ र त्यसलाई पब्लिस गर्नुपर्छ। यदि पब्लिस गरिएन भने त्यो अनुसन्धानको खासै महत्त्व रहन्छ, तर इतिहासले अरूले कसैले हेर्न पाउँदो रहन्छ। त्यसले गर्दाखेरि अनुसन्धान गरिसकेपछि त्यसलाई पब्लिस हुनैपर्छ। नेपाल हेल्थ रिसर्च काउन्सिलको जर्नलका टिमले राम्रो गरिराखेका छन्, भोल्युम र सङ्ख्या पनि बढ्दै गएको छ र पब्लिकेसनहरू आर्काइभ भइराख्यो भनेदेखि लामो समयसम्म यो चलिरहन्छ। त्यसले गर्दाखेरि यो 2 दिनका जति पेपरहरू प्रेजेन्ट भयो र राम्रै भयो, भर्चुअल मिटिङबाट भयो। म आज पनि भन्छु दिस इज ग्रेट। अलिकति यो कोठा अलिक ठुलो चाहिँ हुनुपर्छ। मधु म्याडमलाई एकदम दिक्क भइसकेको छ, कतिजना एउटै सानो कोठामा हो, मलाई पनि दिक्क भइसकेको छ। मास्क पनि निकालिहाल्ने, के गर्ने, अब बोल्नै पर्यो। त्यसले गर्दाखेरि अर्को अलिक ठुलो हलमा गर्नु पर्ला, तर भर्चुअलै गर्नुपर्छ। बडा आनन्द छ, न झोला बाँड्नु पर्ने, न भात खुवाउनु पर्ने, होइन, न चिफ गेस्टलाई बोलाएर छुट्टै कोठामा अतिथि सत्कार गर्नुपर्ने, टाइममा आउला कि नआउला टेन्सन। 3 चोटि भयो, 3 चोटि 2 घन्टा कुराइदिए चिफ प्रमुख अतिथिले, बडा तनाव हुँदो रहेछ। बहुत राम्रो, यही नै कन्टिन्यू गर्ने मेरो। हुन त म अर्को पटक यसरी उपस्थित रहँदिनँ होला, तर तपाईँहरू जस्तै कतैतिर बसेर सुन्छु। तर चाहिँ के भनेदेखि यो भर्चुअल मिटिङ इज द बेस्ट। अब आज रोशनदास साहबले बडो राम्रो छोटोमा बोलिदिनु भयो। मलाई छोटो बोलेपछि सन्तुष्टि नै हुँदैन, अलि मात्र बोल्छु। हिजो मैले भनेको थिएँ, आज एउटा कुरो हाम्रो अलि सल्लाह भएन। लास्ट टाइम जुन हामीले डिक्लेयर गरेका थियौँ, डिक्लेयर गरिसकेपछि त्यसलाई पनि छोट्याएर हामीले मन्त्रालयलाई ह्यान्डओभर गर्छौँ र मन्त्रालयसम्म पुर्याइदिने हाम्रो काम हो र त्यसलाई इम्प्लिमेन्ट गर्ने नगर्ने मन्त्रालयको काम हो। लास्ट टाइमको समिटमा हामीले दिएका रिकमेन्डेसनहरू मन्त्रालयमा कति इम्प्लिमेन्ट भए कति भएनन् भन्ने पक्कै पनि के अरे प्रेजेन्टेसन भयो कि भएन म सुन्न सकिनँ। तर यसपालि कमसेकम यो जुन आजको यो समिटको रिकमेन्डेसन 6 बुन्दे रिकमेन्डेसन र यसपछि केही समयपछि मन्त्रालयलाई ह्यान्डओभर गरिने जुन हाम्रो रिकमेन्डेसन हुन्छ, त्यसलाई इम्प्लिमेन्ट भयो कि भएन त्यो पनि मन्त्रालयतिरबाट आउन जरुरी छ। मन्त्रालयतिर आउने कुरो यही नै हो। मन्त्रालयमा धेरै कामहरू छन्। मन्त्रालयमा डिजी बनाउने, डाइरेक्टर, डिजी सरुवा, सचिव, देशकै के अरे स्वास्थ्य क्षेत्र, यो धेरै कुराहरू गर्नुपर्ने हुन्छ। उहाँहरूले यो अनुसन्धानतिर इच्छा त गर्नुहुन्छ, तर उहाँबाट त्यो पार लाग्दैन। त्यो एनजिओ आइएनजिओ बोलाएर अनुसन्धान गराउनु भन्दा बरु अनुसन्धान परिषदले नै गरेको ठिक छ, होइन प्रमुख अतिथि? यही ठिक छ, अनुसन्धान परिषदले नै अनुसन्धान गर्नुपर्छ। त्यो बेकारमा त्यो मन्त्रालयतिर गएर डाइल्युट हुन्छ। मैले हिजो पनि यो कुरा हो, हिजो पनि गरेको थिएँ, अलिअलि बिचबिचमा बखेडा हुँदो रहेछ। त्यही भएर मैले प्रदीप डाक्टर साहबले भन्नु अलि मिल्दैन, किन एक्जिक्युटिभ पावरहरू मसँग त लिने नै केही छैन, त के फरक पर्ला भनेर सत्य कुरा बोलिदिएको हो। किनभने रिसर्च भनेको एउटा कल्चर हामीले डेभलप गर्न खोजेका छौँ समाजमा। मन्त्रालयमा हेर्नुहोस्, अनुसन्धान परिषदमा पनि रिसर्च कल्चर डेभलप भइसक्यो। कस्तो कल्चर डेभलप भयो? म एक ठाउँमा गएको थिएँ, संस्कृतको विद्वान थियो, उसले पालेको सुगाले पनि संस्कृतमै बोल्थ्यो। अनुसन्धान परिषदमा यहाँका रिसर्चरले मात्र अनुसन्धान बोल्दैनन्, यहाँका प्रशासन, लेखा, स्टोर जो छन् सब अनुसन्धानै बोल्छन् है। आज त हाम्रो पुकाजीले पाउनुभयो, कति राम्रो बधाई छ। धेरै दिनदेखि उहाँले पनि केही गरौँ जस्तो लागेको थियो, बल्ल भयो। झन्डै यो पनि फुत्केला पनि टेन्सन थियो। जे वस्तु अब अनुसन्धान परिषदमा कस्तो रिसर्च कल्चर डेभलप भएको छ। सबजना रिसर्चतिर एकदम आकर्षित छन्। सब रिसर्चतिरबाट आफ्नो काम अलि पेन्डिङ पारे पनि रिसर्च चाहिँ ठिकसँग हुनुपर्छ, यही नै खोजेको हो। र देशभरि नै हाम्रो यङ जेनेरेसनमा यस्तो किसिमको कल्चर डेभलप होस् भन्ने हाम्रो चाहना हो। त्यस्तै गरेर र कम खर्चमा होस्। 1 करोड 1.25 करोड खर्च गरेर यो समिट गरेर उपलब्धि के भन्ने कुरा अब उपरान्तमा यसमा पनि हामीले हिसाब किताब गर्नै पर्छ। यत्रो जनशक्ति, यत्रो समय, देश विदेशका वैज्ञानिकहरूले प्रेजेन्ट गरे, अल्टिमेटली नेपाली जनताले पाए के त? बोर्डमा जहिले पनि कुरा हुँदाखेरि, युनिभर्सिटीसँग एग्रिमेन्ट गर्दाखेरि लास्टमा बिस्तारै बडो मिठो गरेर मधु म्याडमले भन्नुहुन्छ, यसबाट नेपाली समाजले पाउने के? अब पाउने के हो? यही नै बडा गाह्रो, एन्सर दिन नसकिने। त्यो एग्रिमेन्ट गरे बापत 1-2 चोटि विदेश त जान पाइने। उपलब्धि के हुने त्यो त अब बुझ्नै गाह्रो। त्यतातिर हामीले जोड दिनुपर्छ। त्यतातिर हामीले रिसर्च गर्नुपर्छ। सम्झौता गऱ्यौँ उपलब्धि के, एग्रिमेन्ट गऱ्यौँ उपलब्धि के, NHRC को नाउँ कसैलाई हामीले दिन्छौँ उसलाई फाइदा भयो, नेपाली समाजलाई फाइदा के, यो कुरो अब उपरान्त हामीले सम्झौता गर्ने बेलामा ध्यान पुर्याउने विषयहरू यिनै हुन्। मितव्ययी हुनुपर्छ। प्रदीप डाक्टर साहब आएदेखि 2-3वटा कुरो बडो राम्रो भएको छ, एकदम हुनुपर्ने। वास्तवमा उहाँलाई त म पहिलेदेखि नै चिन्थेँ, तर पनि उहाँ आइसकेपछि बडा क्लिन कट प्रश्नवादी र अनुसन्धान परिषदका धेरै समस्याहरू मितव्ययी र सायद मलाई लाग्छ भित्रको कुरो त मलाई थाहा पाउने इन्ट्रेस्ट पनि छैन। सुरुमा अलिअलि गरियो क्या, लफडा लाग्यो, साइड लाग्यो, त्यो गर्नु पनि हुँदैन। उहाँले एकदम राम्रोसँग गरिराख्नु भएको छ, मितव्ययी रूपमा गर्नु भएको छ। कतिपय कुराको त बिल मैले पनि तिर्दिएको छु है प्रदीप डाक्टर साहब, होइन तिर्नुपर्छ, त्यो राम्रो कुरो हो नि त। अफिसमा गर्न पर्दो रहेछ त्यस्तो कुराहरू, राम्रो हुन्छ त्यो कुरा आफूले पनि त्यस्तो पालन गर्नुपर्छ। मितव्ययी भने हो, कहिले काहीँ त शङ्का लाग्छ क्या कोठामा छिर्दाखेरि मितव्ययी हो कि होइन, तर जे होस् राम्रै छ। यस्तै गरेर कन्टिन्यू गर्नुहोस् डाक्टर साहब। आगामी दिनहरूमा पनि रिसर्चमा फड्को मार्न जरुरी छ। आज रिसर्च काउन्सिलमा हामीले मृगेन्द्र डाक्टर साहबले दिनुभएको अवार्ड, मेगासिस पद्मश्री अवार्डीलाई हामीले नेपाल हेल्थ रिसर्च काउन्सिलबाट अवार्ड दिएका छौँ। उहाँले स्वीकार्नु भएको छ हाम्रो मूल्याङ्कन NHRC को महत्त्व धेरै अगाडि माथि पुगेको छ। सम्माननीय प्रधानमन्त्रीले सम्बोधन गर्नुभयो, मुख्यमन्त्रीले सम्बोधन गर्नुभयो। आज हाम्रो बिचमा एकजना एउटा टावरिङ पर्सनालिटी प्राध्यापक जीवन शेरचनज्यू, उहाँसँग मैले धेरै वर्ष काम गर्ने अवसर पाएँ। के अरे NHRC मा इथिकल बोर्डको चेयर हुनुहुन्थ्यो। उहाँको मनोबल, उहाँको इनर्जी हेरेर म पनि कहिलेकाहीँ दिक्क लाग्छु। उहाँभन्दा म जुनियर नै हो, तापनि उहाँको फुर्तीफार्ती हेरेर त आफूलाई त कहिलेकाहीँ म पनि बडाङ्ग अलिअलि दौड्न लाग्छु त्यही उहाँलाई हेरेपछि। उहाँ जस्तो व्यक्तित्वले आज नेपाल हेल्थ रिसर्च काउन्सिलमा सक्रिय हुनुहुन्छ। उहाँले हाम्रो अवार्डलाई स्वीकार्नु भएको छ। यो नेपाली हेल्थ रिसर्च काउन्सिल निकै मर्यादित भएको महसुस मैले गरेको छु र म नेपाल हेल्थ रिसर्च काउन्सिलको परिवारको तर्फबाट म यहाँहरूप्रति म आभार व्यक्त गर्न चाहन्छु। आदरणीय, त्यसले गर्दाखेरि अब निश्चित रूपमै अन्तिम समय हो, अन्तिम क्षण हो, डिक्लेरेसन पनि गऱ्यौँ। अब मैले लामो नबोलौँ, अब धेरै बोलियो भने फेरि कता जिब्रो चिप्लेर र फसिएर अहिलेसम्म ठिकै भएको छ। यति भन्दै म यो सबभन्दा बढी धन्यवाद दिन पर्ने ग्रुप भनेको यसपालि जुन च्यालेन्जिङ थियो, मलाई पनि लागिराखेको थियो के हुने हो, त्यो हो IT ग्रुप। म कसैलाई पनि चिन्दिनँ, तर IT ग्रुपले फर्स्ट राउन्डमै मेरो विचारमा तपाईँहरूले फर्स्ट डिभिजन त पाउनुभयो। डिस्टिङसन अहिले नदिइहालौँ, केटाकेटी जस्तो हुनुहुन्छ क्या, अलिक मेहनत अझ गर्नुहोस्। तर चाहिँ के भनेदेखि जे होस् तपाईँहरूले यो च्यालेन्ज, यो जुम मिटिङ, यो यत्रो मान्छे लाइक गर्ने, अब यो जुम यो धेरै कुरा त मलाई थाहा पनि छैन, जानेको जस्तो गरेको मात्रै हो। तर यो चाहिँ जो सफल तपाईँ IT टिमलाई म सबभन्दा बढी धन्यवाद दिन चाहन्छु। पछि लास्ट टाइम अरूहरूलाई धन्यवाद दिन्थेँ, यसपालि अरूलाई दिएर काम लागेन क्या, तपाईँहरू ठिक हुनुहुन्छ। त्यसले गर्दाखेरि तपाईँहरू एकदम ठिक, यसलाई कन्टिन्युटी दिनुहोस् र जुम मिटिङबाट नै हुने किसिमको वातावरण बनोस्। तपाईँहरूको पनि अब राम्रै पेसा पनि हुन्छ, यो बेरोजगारीको बेलामा राम्रै खेती हुन्छ यो। त्यसले गर्दाखेरि तपाईँहरूलाई धेरै धेरै के भनेदेखि के अरे भन्छ धन्यवाद दिन चाहन्छु। बाँकी सबै सक्रिय रूपमा भाग लिनुभयो, जो जहाँबाट लिनुभयो सबैलाई धन्यवाद छ। अनुसन्धानकर्ताहरूलाई पनि धन्यवाद छ। मेघनाथ डाक्टर साहबको त मुख निनेउरो छ, खोइ के परेको थाहा भएन, तर जे होस् बाँकी सबैलाई धन्यवाद दिँदै प्रदीप डाक्टर साहबलाई विशेष धन्यवाद। म अध्यक्ष भएर पनि यो बोल्ने बेलामा मात्र आइयो क्या, बाँकी कुरा सब उहाँले नै गर्नुभएको हो। त्यसले गर्दाखेरि प्रदीप डाक्टर साहबलाई विशेष धन्यवाद दिँदै यही पेसमा काम गर्नुहोस् भन्ने मैले चाहिँ विश्वास लिएको छु र मेरो इच्छा पनि छ। अब 2-4 महिना बाँकी छ, अझ राम्रो गर्ने हेर्न पाऊँ, यति भन्दै म बिदा लिन्छु। सबैलाई धन्यवाद। थ्याङ्क यू भेरी मच। ल अब यो सभा विसर्जन भएको घोषणा गर्दछु। थ्याङ्क यू भेरी मच एभ्रिवान।